The program is being streamed live on YouTube. The link is there shared in the group. Kindly share it with your friends and colleagues who want to join in online. We have collected some good study material which would be useful for you during your exams and later practice. It is being shared through a QR code. It is named as Ready Reckoner. The QR code is there outside. You can scan and then you can access the material through a Google Drive. I would like to request all of you to speak into the mic. The mics are there are plenty of mics, because if you are speaking away from the mic, then nobody would be able to listen to you. So please speak into the mic and clearly, and stick to the timing. It is organized in such a way that each session will have 2 cases which can be discussed. The case which you have examined will be for an hour, and then for the next half an hour we'll discuss a case capsule. I would like to request the faculty to stick to the timing and give equal importance to all the parameters. I would like to invite Dr. Pradeep to have a few words with you.
Good morning, everybody. This is the 14th year we have been conducting these clinics. So every year we're conducting it, and this is now under the aegis of the IISG. We're conducting now these clinics. And at the outset, I would like to thank all the faculty who took their busy schedule and spared a couple of days for you people. So all the exam going students should make use of this opportunity to interact with these faculty. And this is I found even many clinics previously also, I find only few people talking or answering the questions, and most of them keep quiet. This is the time you should come out. Don't worry about what others think if you commit mistakes. You can afford to commit mistakes now, but not in the exams, right? So don't worry about what others think. If you have any doubts, you clarify. And not only during the clinics, even after the clinics, I am sure all the faculty will be happy to clear your doubts. The intention of this clinics is how to present your case in the exams. So it will help you to go through the clinics easily and smoothly during the exams. And I would like to thank Professor Nageshwar Reddy, Professor G.V. Rao actually for their efforts to make these clinics success every year. So, and this will be recorded and it will be transmitted live, so that you can ask one of our friends who could not make it to these clinics can go through online as well. And thank you all the faculty and the residents who came for these clinics. Thank you. So, Mahesh.
We'll start with the first session. I would like to request Dr. Piyush Sahni, Dr. Jashwant, Dr. T.D. Yadav, and Dr. Venu Madhav to come on to the dais. The first group will join on to the... Yeah, please. You can take the chairs. Sir.
Morning.
Speak into the mic. Please pull the mic closer to you.
Morning, everybody. So, can we start? Good. Thank you.
Shall I start the case?
Would like to start.
A very good morning, respected seniors and all colleagues. Today I will be starting with the case. Our patient is a 51-year-old male, resident of West Bengal, who has come with the chief complaints of difficulty in swallowing foods since the last 1 month. On inquiry, the patient was apparently asymptomatic 1 month ago when he developed sudden onset of difficulty in swallowing both solids as well as liquids after consumption of a heavy non-vegetarian based meal. This was associated with vomiting of undigested food material. On further inquiry, there has been no history of hematemesis or melena. There is no history of back pain. There is no history of cough when the patient is swallowing. There is no history of chronic cough with fever. There is no history of hoarseness of voice. There is no history of halitosis. Patient is a chronic alcoholic, has been consuming 90 ml of alcohol per day since the last 20 years. He's a chronic cigarette smoker, which is 40 pack years. He also complains of chronic epigastric pain, which is associated with retrosternal burning pain since the last 2 years. There is no history of ingestion of corrosive as given by the patient. On further inquiry, for the same, the patient was initially treated at a local hospital in West Bengal, where he was treated conservatively and then referred to AIG Hospital for further management. Here, the patient says that he has undergone an endoscopic procedure followed by biopsy, and based on these results, which patient is not aware of the exact diagnosis, he has received 9 sessions of radiation therapy and 2 sessions of chemotherapy, following which, at present, when taking history, patient is able to swallow both solids as well as liquids with no difficulty. On examination,
So, is there anything else you want to find out from this person? Before you get to examine him, are you interested in anything else? Any one of you?
Similar complaints before.
In the history, do you want to ask any other question to help in your diagnosis?
Is there any history of similar complaints in the past, or is it the first episode? Secondly, any past surgical history, any history of any oral malignancies in the past history? And
So surgical history, what specific thing are you looking for? Which is going to help you? So you can ask lots of questions. You're in an exam and you're a defined time, and so you're questioning the patient within a defined time. And you're therefore looking for some focused questions and some focused answers. So there must be a purpose behind those questions. Okay? So what surgical thing that you think is going to help you? What kind of history is going to help you?
actually, this was intended as a part of general past history. So,
We've got a patient who's got difficulty in swallowing for 1 month, followed, he tells you he consumes alcohol, he smokes, and he's also got a history of retrosternal burning. You therefore are already thinking in your mind of a certain possibility. What are the specific questions that, other than what he's already asked, that you may be interested in asking? Yeah, go ahead.
I forgot to mention two
About
important
the
points.
respiratory complaints, if he had anything like during the history, whether he had any cough with fever, probably because of a reflex of the food.
So how fever is going to help in your diagnosis?
Any nocturnal symptoms? Any like is he having a regurgitation? How's his sleep? Is he having any regurgitation? Nocturnal symptoms?
He said he had some pain in the epigastrium.
Yes.
any the site of food getting impacted.
So I would ask you, why did you say that he was after taking non-vegetarian diet? How does it make a difference in the diagnosis? Is there something related to non-veg and vegetarian?
It is So now, based on the history itself, we are assuming that this patient is a case of mechanical obstruction and there must be significant luminal compromise while taking a big chunk of food or probably bone associated with it. This is when it must have got stuck and he has now presented with symptoms which he may not have otherwise, until there was more significant luminal compromise.
So based on your history, what are your possibilities? Of course, the history of chemo radio. Okay, no problem. But what are your possibilities? What are you thinking about based on the history in this
My
patient?
first differential diagnosis will be malignancy of the esophagus, and second, as a second differential, lower down I'll keep peptic stricture also as one possibility.
Peptic stricture with history of chemo radiotherapy. So we are taking that history also.
That's malignancy. There's no other.
Malignancy of esophagus. Where exactly? Based on history, can you go? Only C esophagus is where?
Because it could be mid esophagus or lower esophagus. Lower esophagus because there are dyspeptic symptoms as well. Mid esophagus because he has chronic smoking and chronic alcohol consumption, and he's belonging to a slightly lower socioeconomic strata.
Carcinoma of gastroesophageal junction proximal.
Possibilities are carcinoma G junction with dysphagia. It can happen dysphagia also, and lower third esophagus. Okay. How do you differentiate between these based on history?
So first, basically history of etiology will help us in discerning the cause. So if patient gives his patient
This patient we are talking,
Any
which is more
previous,
likely, isn't it?
dyspeptic
dyspeptic
symptoms go in favor of G junction tumor or lower esophageal
So
malignancy.
this patient had dyspeptic symptoms prior,
Since the last, yes,
chronic reflux symptoms causing, is it?
yes.
Patient had vomiting, what does it suggest? You said patient had vomiting. Is it vomiting or
It's
regurgitation?
regurgitation.
What is that?
Undigested food particles.
No, you said vomiting, no.
That was what the
Is it vomiting or regurgitation?
regurgitation.
What is regurgitation?
Regurgitation is spontaneous, undigested food particles which are
Effortless expulsion of undigested food particles.
and vomiting is forceful,
Vomit-
partly
Forceful.
digested
Forceful.
food particles.
One is effortless, one is effortful.
Yes.
So based on history also, we can come to reasonable conclusion what we are doing because history of chemoradiation is there.
There was one important point that I missed. A patient gives history of unintentional loss of weight of 13 kgs over the last 1 month. From 72 kgs, the patient now weighs 59.
That you didn't mention in your history, that's what.
Is there any role of asking about anemia, history of anemia, which can suggest anemia in these patients?
We can ask for history of easy fatigability and probably
No, does it make a difference? Can it help in your diagnosis?
Plummer-Vinson syndrome.
That would be more of a proximal.
Patient was giving proximal esophageal symptoms like
this is a
odenophagia.
Proximal, what is proximal esophageal symptoms?
Odenophagia or choking of feeling of a choke in the
Difficulty of swallowing in the initial phase. Food in. Upper neck.
Speak into mic and clearly. So what is, we
Yes.
want to know what you are saying.
Yeah. So difficulty in swallowing, mainly during initial phase of swallowing.
So there are certain predisposing factors for the carcinoma esophagus, and there are certain pre-malignant lesions.
Yes.
So by the history, we should try to look into those things also. To exclude or include in your to help in your diagnosis, coming to your diagnosis, because at the end it is either J junction or C esophagus. But if you want to go into these details, then only it helps in to understand that you have gone into details of this thing.
And especially if history of hoarseness of voice, that also points, and history of aspiration or symptoms suggest of tracheoesophageal fistula, those also will pinpoint to some diagnosis, and history of sticking, where exactly where sticking, because if you, so all those symptoms will point to some reasonable conclusion.
So think from the history that you have, if I'm sitting in the outpatient, in 5 seconds I know this is dysphagia and it's very likely to be a malignant lesion. But a good history presentation during an examination covers things like possible risk factors for the occurrence of the disease. And that's what Professor Yadav has been asking you. What are the additional things that you would want to know? Smoking is one, alcohol is another. Are there other risk factors that you could ask for?
Consumption of
Consumption of
smoked fish, meat.
smoked fish. So dietary things.
Dietary choice.
So we didn't hear anything of what his diet was except for the fact that he was a non-vegetarian. Okay. So a little more questioning as far as what his diet was may have given you some other. Are there any other risk factors that you would look for in a person with an upper GI tract malignancy? I'm not at the moment trying to say this is esophagus, this is G junction, this is stomach, wherever it is.
There has been no previous history of dysphagia, regurgitation, or loss of weight.
Okay, so essentially what you're trying to say is when you're presenting, what you need to keep in mind is, one, I need to arrive at a diagnosis. 5 seconds I'm at the diagnosis. Next is, what is the next thing? Get on to examination? No. Stop, listen, think. Are there other risk factors that should ask for? Is there anything else in the history which may influence my management? I can examine and come back and ask for those questions as well. But when I'm presenting, I need to answer those things as well. So loss of weight came later, unintentional loss of weight. Okay. Now that's important. What percentage of weight he is lost is something that may affect how you may be able to manage this patient. Okay. So if he has lost a lot of weight, he may not be suitable to receive certain kinds of therapies. So those are the kind of things that once you start asking those questions and providing those answers during the history itself, people who are listening to you know you've gone into these things. While if your history is just focused to dysphagia and getting to the diagnosis of malignancy and nothing else, you know that you haven't asked these things. Okay? So quickly summarize what you've asked, what you found in this patient, in the history, before you get to the examination.
To summarize, this is a 51-year-old.
And make it a habit. Finish the history before going on to examination. To summarize, this is a 50-year-old man who's got dysphagia for 1 month. He's non-vegetarian, used to smoke, used to whatever. Go ahead. Summarize.
To summarize, this is a 51-year-old male who has chief complaints of dysphagia to both solids as well as liquids, with unintentional loss of weight of 13 kilograms in the last 1 month. And he is a chronic alcoholic, chronic smoker, and has dyspeptic symptoms.
So when you use the word alcoholic, it has a very specific connotation. If I hear the word alcoholic, then I need to know that he's been consuming a certain amount of alcohol for a certain duration of time. My suggestion is, say used to consume alcohol and used to smoke an X number of cigarettes. If he's a cigarette smoker, it's an X BD smoker, X number of BDs for X number of years. Okay. All these things have a relevance. Yes or no? Yes. Okay. So when you summarize, give us information which is useful. Okay. Non-specific information or little information is not useful. Okay. Can we move to the next person to go on to the examination? No? You'll do the examination? Somebody else will do the examination? We want all of you to speak. We don't want one person to speak. Anybody else prepared to do the examination? Okay.
On examination, patient is conscious, cooperative, well-oriented to time, place and person. He is examined with due consent. He is averagely built and nourished. Height is 165.5 centimeter. Weight is 60.2 kgs with a BMI of 22.1 kg per meter square. His vitals are: pulse is 82 beats per minute, BP of 120 by 80 millimeters of mercury, oxygen saturation is 96%, breath holding time is 35 seconds. There is no visible muscle wasting. There is no evidence of any pallor, icterus, clubbing, cyanosis, lymphadenopathy including supraclavicular lymph nodes and neck nodes. There is no evidence of pedal edema. Back and spine are normal. His performance status was 1. ECOG performance status was 1. Oral cavity examination, mouth opening was adequate, 3 finger breadths. There is no evidence of any mucosal lesions and the tongue movement was normal. There was evidence of nicotine staining and as well as the oral hygiene is poor, and there were multiple absent teeth. Abdominal examination. On inspection, abdomen is flat, umbilicus is central and inverted. All quadrants are moving equally with respiration, and there is no visible fullness. There is no evidence of any scars, sinuses, enlarged veins, pulsations, peristalsis. Hernial orifices are normal, and there is no renal angle fullness. On palpation, abdomen is soft and non-tender. Liver is palpable for 3 finger breadths below the costal margin. It is non-tender, smooth surface, rounded border, which is soft to firm in consistency. Spleen is not enlarged. There are no other palpable lumps. The external genitalia and hernial orifices are normal. There is no renal angle tenderness. On percussion, the upper border of liver dullness is in 5th intercostal space in mid-clavicular line, and the liver span is 16 centimeter and it is increased. There is no evidence of any free fluid in the abdomen. On auscultation, normal bowel sounds were heard. No bruit or venous hum was heard. On per-rectal examination, the per-rectal examination was within normal limits. Respiratory system examination. On inspection, the trachea was in midline and was not deviated to any side. Bilateral chest movements were equal. On palpation, the trachea was central and tactile vocal fremitus was normal. There was no evidence of any tenderness in any area. On auscultation, bilateral normal vesicular breath sounds were heard. There were no added sounds. Cardiovascular system and CNS were within normal limits on examination. So to summarize, my only positive finding on examination was he has a hepatomegaly and the liver span is increased of 16 centimeters on examination. The rest of the
Any
examination was
significant negative findings that you would want us to remember? So when you summarize positive as well as important negative findings, what you looked for and did not find?
on negative examination, sir, there was no evidence of any neck nodes, any supraclavicular lymph nodes, any rectal, as well as there is no evidence of free fluid in the abdomen, and
what is the nutritional status?
there is no evidence of any muscle wasting. BMI was normal, sir,
Bilateral pedal.
and no pedal edema as well.
So BMI alone is a very good marker of
No, sir.
nourishment.
No,
The
sir.
patient had lost about 13 kg.
Yes, sir.
So what are the things you would like to look? In what duration that 13 kg has been lost?
In 1 month, sir.
So is it very significant or not?
Yes, sir, it is
So
significant.
what are the things you would like to see while preparing the patient for the further
We
management?
would like to do a subjective global assessment for the patient for nutritional assessment, which includes looking for muscle wasting, pedal edema, as well as history of any recent change in food intake, loss of weight, as well as any.
There is a change. There is a change in the food intake. He is not
Yes.
able to take. Then
Yes.
so if you try to quantify the risk assessment,
Yes.
how do you do that?
So, as for nutrition.
Nutritional risk, you know, no?
Yes,
There are certain tests we can do in the ward. Certain things you can ask biochemical.
Yes, sir.
What are the tests you can do in the ward?
We have one in the physical examination and history. We can do subjective global assessment. Second is we can do must scoring for risk assessment, as well as we can for biochemical analysis. We can do albumin levels and pre-albumin levels.
Sir is asking in the ward.
So,
Can you do some simple test to assess the nutrition?
Mid-arm circumference,
mid-
triceps thickness as well as mid-arm circumference.
So many things are available nowadays to say the muscle strength, sarcopenia.
yes,
Is
sir.
it relevant to see?
Yes.
Are you not doing in the ward that certain things which can be done in the ward to look at
Any
the
walk test?
Yes, yes. Hand grips.
Hand grip test, get up and go, and
5-minute
flight of stairs,
walk
is he
test.
able to climb 2 flights of stairs.
So there are certain things, that's what sir is
And
asking.
calculating for sarcopenians, if you're doing CT at the level of L3, we can calculate psoas muscle volume. And
It's on
Word. It's all word. I think what is important is when you are answering a question to be focused and to remember what you're supposed to answer. You divert somewhere else, somebody will come and interrupt and say, we didn't ask you this.
certain
Clarity is important.
can
Clarity
be
is
done in the ward to see the muscle strength.
So hand grip strength can be done. Muscle mid-arm circumference can be checked. Then 5 minute walk test can be done. Chair stand or can be done.
Where is this 5 minutes? We read about 6 minutes. Is there any difference?
Sorry, 6 minute walk test.
So something which is written already documented. If you are saying, then say correctly.
Sorry, sir.
So how do you do 6 minute walk test?
We ask the patient to walk for 6 minutes continuously, and we calculate the number of steps he has taken and approximate distance he has traveled for.
How much distance is, if he can walk in 6 minutes, is okay for you?
Sorry, sir, I'm not aware.
So you should be aware, no?
Yes,
Nowadays, we are doing all major surgeries. We have to do all these things. Otherwise, our results won't be that good. Very operative, seeing all these things are very important, especially in a patient where you are saying his diet has changed, he is not able to take proper diet, then his weight loss has been so significant that, and he is a smoker, then he is has taken alcohol, his liver is palpable. So if you don't do all these tests, then you are not going to have an appropriate outcome.
If you are the consultant, I am the resident presenting to you, and I say a 51-year-old male who's lost 13 kg in 1 month has a normal BMI. What are you going to do to me? Are you sure? Isn't that the response on the word from you to me as the resident? No?
No, I will not accept that answer.
You won't accept it, no? So why should we accept you then?
Yes, sir.
No? So I think in the history you've got to remember, he's got a 1 month history of dysphagia, but he's received 9 sessions of radiation, 2 sessions of chemotherapy. So we've gone far beyond that 1 month, and we are all confining ourselves to that 1 month. So therefore, what we are examining today is a person who is now able to eat a bit better than in that 1 month. So has he regained any weight?
No, sir.
He hasn't regained any weight. So the worrisome thing then is that he has a normal BMI. So was he overweight and obese before that?
Yes, sir. Yes, sir. He was saying he was slightly overweight.
Okay. So that's other extra information that we want to. So based on the history and the examination, what is your opinion on this patient? Can we move on to somebody else?
Sir, because he has regained his ability.
No explanations. What is your opinion? We'll ask you for explanations as to why, what is 1, what is 2, what is 3. But tell us what is 1, what is 2, what is 3.
I'll keep my first differential as carcinoma esophagus or carcinoma GJ, because he has regained his ability to eat following. He has responded to chemo and radiotherapy in this time. And
so what is 1, what is 2? What is G junction is 1 or
so carcinoma esophagus will be 1, sir.
Okay, esophagus is 1, G junction is 2.
Yes, sir. These would be my differentials, sir. These would be my differentials, sir. Like I'm not.
So why is esophagus 1 and why is G junction 2?
Sir, because it is more prevalent here in our and also he complains of during the.
So is prevalence the only thing that will make you put something as 1 and something as 2?
So one thing that goes in favor of adenocarcinoma, possibly GEJ, is his previous history of GERD and.
So should we put at 1? Now that is the only thing that you can think of at this moment.
Thinking of adenocarcinoma, not squamous carcinoma. Thinking of adenocarcinoma only. Thinking of adenocarcinoma.
Sir is asking you, are you thinking of adenocarcinoma only or are you thinking of squamous cell carcinoma?
Sir, I will consider squamous cell carcinoma first and then adenocarcinoma, because both can respond to.
Why is squamous cell carcinoma?
Sir, because of his history of smoking and mainly because of his history of smoking, alcohol is not, but smoking history goes more in favor of squamous cell carcinomas.
Adenocarcinoma?
So adenocarcinoma because of his history of GERD, and I was thinking of that. And during history, he also gives history of food sticking in the middle of his chest. So so that would mean that the obstruction is a little more distal, so it would be lower thoracic or GEJ.
So does the level of where you get the sensation of sticking correlate with the level of the growth?
No, sir, it's generally more distal, but it is not always accurate.
So it's not accurate.
Yes, sir.
So I can't use that as a very strong reason
Yes,
to decide one or two.
Yes, sir.
So you told chemo is given both the conditions,
Because
both squamous cell carcinoma and adenocarcinoma. Where it is given more often?
So chemo is more for adenocarcinoma, sir. You would consider either FLOT for adeno.
That's okay. So you are considering squamous cell carcinoma, adenocarcinoma, esophagus or OG junction.
Yes, sir.
That's okay.
Okay. So how do you want to evaluate? Suppose patient came to you with this history and examination. How do you proceed with evaluation?
Sir, blood investigation. I would like to do a few blood investigations and then proceed to imaging, sir. Blood investigations, I would want to get a complete blood count and liver function test, renal function test, PTINR. Following that, I would like to get an upper GI scopy and an ultrasound abdomen and a chest X-ray, sir.
I think it's a good idea. This is my approach. Others would have different approaches, but it's always a good idea in an exam to be a little more focused. To make the diagnosis, I would like to do these investigations, and to assess the general fitness of the patient, I would like to do these. So liver function test, kidney function test not going to necessarily help me in making a diagnosis at this point. Okay. While there are other investigations which are more specific, which are going to be very useful for me to make a diagnosis.
Yes.
CBC, complete blood count, may not help me very much. Okay. So,
Can we have the laptop feed?
okay.
Yes, sir.
So investigations, what all do you want? We'll show you those investigations. You can
yes,
keep
sir.
interpreting them.
With regards to diagnosis, I would like to first go for an upper GI scopy to rule out if there is an intraluminal or extraluminal compression, or is there.
This person, when he developed dysphagia, lived in West Bengal, correct?
Yes, sir.
He lived in a village. He went to his local village doctor,
Yes, sir.
who said, you'll have to go 500 kilometers to get an investigation done to make the diagnosis. You are the next village doctor, not the village where he lives. Can you advise him a simple investigation? that
Barium,
can be
sir.
done?
Barium study, barium swallow.
Okay, and how does barium swallow help?
Sir, it will help us with mapping. It can tell us where is the level of obstruction, if there is, and if it's
So
intraluminal.
A, it will tell you whether there is actually an obstruction, and B, tell you the level of obstruction.
Yes, sir.
All right. Nobody does a barium swallow today. Why?
Sir, because we have.
Because if I ask Mahesh just now, show me a barium swallow, he'll tell me no barium swallow done.
Because if we.
So why don't people do barium swallows?
It masks the other investigation that is to be.
Masks which investigation?
Then if a CT is done.
Why? Barium's not going to keep sticking there for
We can take a
days
biopsy.
together.
anyways, to stage the disease, we'll be doing a contrast enhanced CT scan of the chest and abdomen with oral contrast, which will give us the same information and probably more
So
than
most
what a
people
barium
would
score.
not do a barium because the information that you obtain on a barium is always a little less than you obtain on an upper GI endoscopy, and which is you can see the growth and take a biopsy, which you
Yes.
can't do on a barium solo. And therefore be absolutely sure of what the diagnosis is. That's why most people don't do a barium solo. But there are circumstances where a person, he's got a neck node, he's got liver metastasis, he's got an enlarged liver. Why should I send him 500 kilometers to AIG to get a diagnosis made? Unfortunately, people are sent. So that's the reason I'm saying you must be aware of the circumstances in which you work and the investigations available to you.
Yes,
All of you work in large big centers where you train, but when you work, you don't necessarily work at a center where all the investigations are available. Okay? Must be very acutely aware of this condition, this scenario that most of our patients face. Okay?
When you'll do a barium swallow in the current scenario, in the case of esophagus?
Sir, if there is a complete obstruction and we are not able to,
Suspected
long segment obstruction stricture.
if there is,
Long segment obstruction, long segment stricture is there. I mean, suspecting. If the scope is not, we are not able to pass.
Suspect
fistula, sir?
esophageal fistula.
One is suspected tracheal fistula, and when you don't get when patient is having history of motility disorder and biopsy is negative, that time also places the stricture, the length of stricture. So those are 2-3 conditions. Still, we do a barium swallow in the current scenario. Okay, proceed. Which investigation you want to do now?
Upper GI endoscopy first.
So read, interpret.
it's esophagus is nodularity with the edematous.
Can we get someone else from the group now?
Upper GI scopy, esophagus shows nodularity with edematous mucosa, mild luminal narrowing in mid esophagus, 27 to 33 centimeters from incisor. Scope negotiated with mild difficulty, solid food residue seen. Stomach few polyps in fundus seen. D1 submucosal nodule with superficial ulceration on anterior wall of D1. D2 is normal.
Interpret.
So from this report, the growth seems to be in the mid esophagus region, and from this there is evidence of obstruction distal because of food residue, and the length.
Polyps in the fundus. Polyps in the fundus of the stomach.
Polyps in the fundus, they are not described.
Sir, he's
It can
having
be hyperplastic polyps.
So you want more information. What more information do you want?
Sir, he has history of PPI intake for 2 years, and it could be caused hyperplastic polyps can occur secondary to
So
that.
2 years of PPI will cause hypoplastic polyps.
I wanted to see any other additional findings of Barrett's esophagus or any
No, that's
varices.
Nothing.
What-
Nothing is mentioned about polyps or no
I would
size.
like
You don't
to
want
know.
to see the size. How is the ulceration? Is it?
Size of the polyp, whether
No, no.
pediculate,
Based on
non-
that, do you want additional information about the polyp, or you are happy with that few
we
polyps?
want additional information of the
3
polyp.
centimeters polyp is different from less than 5, isn't it?
Yes,
So that's
sir.
what sir is asking.
Hyper.
Given information is given, what more you want? Because that itself is more, no?
Okay, so you see this endoscopy report sitting in your clinic. What are you going to do next? Do you do your own endoscopies? One head is nodding very doubtfully as to whether or not he should nod more vigorously.
We do, sir.
So is it a good idea for you to do your own endoscopies?
Yes, sir.
Okay, and why don't you do them? You never learned how to do them. Huh? Anyway, so what do you want to do now? You've seen this report in the endoscopy report in your clinic. What do you want to do now?
I want to know the biopsy.
Next is what? Biopsy.
Biopsy findings.
So endoscope, biopsy, and they miss the OE junction. length of the esophagus, the level of the OG junction.
Yes, sir.
What level is the esophagus? What is the level of
27 to 33.
Huh?
27 to 33 centimeters.
27 to
Yes,
33
maybe-
centimeters is the growth. What is this question on?
We have to calculate from cricopharynx.
How do you classify? Okay, there's general question. How do you classify cervical, upper, middle?
So from incisors, we measure 15 to 20 centimeters is cervical, 20 to 25 is upper.
What is cervical?
Sir?
What is cervical esophagus?
15 to 20 centimeters is cervical at the level of manubrium sternum. Then from 20 to 25 is upper mid thoracic, and then 25 to 30 is lower mid thoracic, then lower esophagus from 30 to 40 centimeters.
Anybody can better.
So 15 to 20
Any
is.
landmarks are also there to classify.
Esophagus vein and inferior pulmonary vein.
Based on that, what is cervical esophagus?
Sir, cervical is up to the from 15 to 20, so up to the suprasternal notch, and from there till the lower border of the azygos vein is your upper thoracic. From lower border of azygos to the lower border of inferior pulmonary vein is mid thoracic. From there to the lower extent of the G junction is the lower thoracic.
Okay, now
And also and measure based on the centimeters from esophagus also.
Yes.
It's also.
so what will you do? Biopsy is there.
Metastatic work.
We would like to do, sir, CCT, neck, chest, abdomen, along with DOTA-TET PET CT.
And also if the NET is Ki67 index as well, if it is there, well differentiated, it's mentioned. But
So where are we going now? Where are we going? You got a moderate to poorly differentiated squamous cell carcinoma. You want to do a DOTA-TEC. You want to ignore the moderate to poorly differentiated squamous cell carcinoma.
Sir, NET is well differentiated.
So the NET is more important or the squamous cell carcinoma is more important?
Squamous cell carcinoma.
So what is more important for me?
Chest. C.
I have 50,000 rupees with me. You want to treat me, you treat me, otherwise I'm going back home.
No, FDG PET CT, one investigation we can do. Sir.
So signal investigation, FDG PET.
Yes.
You don't want to do anything else.
Hematological investigations are done by now.
So that they said they wanted to do, but we said we'll focus first on the.
Creatinine and all also.
Serum chromogranin.
So I think what you've got to remember here is you've got two conditions, but one condition is causing the major problem, the symptomatology for the patient. So our focus has to be on the squamous cell carcinoma. NET is something that we can look at and see what needs to be done for. Most probably nothing will need to be done for it, but that's a different issue altogether. Do we need to work up for the squamous cell carcinoma and treat the squamous cell carcinoma, or is NET priority for us?
Squamous cell carcinoma is the priority.
Squamous cell carcinoma is priority for us, so the investigation that we wish to do here is not on priority at DOTA-TEC. Okay?
so
Agreed?
other lab investigations
We'll do lab investigation, so we need to make we need to first make up our minds as to what we want to do. Head, neck, chest, abdomen CT, or a PET CT, or both.
First, I would like to do CT, neck, chest, and abdomen first, sir. With oral and IV contrast.
I have 50,000 rupees.
So why you said first you said I will do FDG PET scan, then you are now changing to chest and abdomen and this pelvis CT scan. Any reason for that?
So NCCN advises first, like that is the reason, neck, chest, abdomen, CT.
No,
So NCCN is for people who live in ideal worlds,
Okay, sir.
not real worlds. So you have to be able to understand what NCCN tells you and to interpret and use it for your circumstances. I have 50,000 rupees. And to treat me, you treat me, otherwise I'm going back home. I die. That's the reality. You don't see it every day.
Yes, sir.
So let's clarify. You are going to do CTs, chest, abdomen and the
CT.
thorax with the PET scan, or you are going to do PET
So
scan?
your
alone?
hemoglobin is 6.4, total count is
Single
5,900.
investigation, sir, then I would like to do FDG PET CT, sir, only.
So every PET CT, they have a CT scan until unless you want to see the vascular anatomy very clearly and all those reconstructions. The general CT scan is done in the PET CT also. So you can go and see the pictures and try to correlate. So which one you would do now?
FDG PET CT, sir.
Why not CT, chest, abdomen and thorax? Which you said first. If you choose both of them one, then you are going to do FDG PET. We agree. Why? But what are the extra edge to do FDG PET scan over the CT scan?
Extra, it will rule out and metastatic disease, sir, FDG PET CT.
That can be done in this thing, but is there any superiority in any particular area?
So we'll be giving a new adjuvant treatment if you're
Response to
considering for a locally advanced
First
or
tell
response.
what are the advantages in making a diagnosis, then go talk the later on what is going to happen. What are the advantages of PET scan over the CT scan in terms of deciding your management? I mean to say staging the disease and planning the management.
First advantage, if it is not on FDG PET CT, if it is a regional disease, we can plan a neoadjuvant chemotherapy, sir, which we
And
cannot.
what are the things you see better? Are lymph nodes seen better in CT scan, in PET CT than the CT?
FDG PET CT better,
Yes.
sir.
Then nodal status and pulmonary metastasis. Small pulmonary mets, are they better seen on PET or better in this thing? Any bone metastasis which can occur, are they seen better or no? So staging is better. Then you go and see.
So my answer to Dr. Yadav is, sir, PET CT scan will upstage the disease in X percentage of patients, and therefore I would prefer to do a PET CT if I have to do a single investigation, because my management plan may change based on the PET CT scan. Finished. Story over. Now the rest of the questions can come. But you've given me an overall picture as to why you're clear in your head now as to why you want to do a PET CT.
Second reason is invariably they will go for either neoadjuvant chemotherapy or radio chemotherapy. To answer the response, we need PET CT.
So what is PET CT and what is PET CT split with CCT combined, and what is CCT? You have to have a clear idea, because you are ordering just like that. PET CT doesn't mean anything, because as I said, nodal staging, but local staging and all, and local implantation you can't find in PET CT. Again, you want to do, some centers are there where they can get very good quality image with PET and CT scan, but not all, depending on your center expertise. But if you are telling one-stop investigation, you have to be clear in mind what you are going to do: local staging, T staging, N staging, and M staging, isn't it? And you should not forget to tell the basic hemoglobin and hepatomegaly is there.
Yes.
Simple ultrasound should all those things should have come. Creatinine before telling CT scan. Though they are asked for diagnostic investigation, creatinine, without creatinine patient is vomiting, dehydrated, and without telling creatinine you are going for is not acceptable. And when you are telling the investigation also, you should be very specific at what you are doing and why you are doing that investigation. In various scenarios, resource limited settings, and when everything is available also, and what are the part guidelines. All those things you should modify. That's it.
Why do you think there is hepatomegaly? Patient has hepatomegaly, no?
Yes, sir.
Why? What's the reason?
He's a chronic alcoholic, sir. He's a chronic, he's habituated to alcohol. and I saw.
Okay.
Initially, patient says that he is slightly overweight, and despite
Right, okay.
losing 13
That's
kgs, his
sweet.
BMI is normal. Probably he may be having a fatty liver. That could grade 2 or 3 fatty liver. Hepatomegaly could be one possibility. But he has a
Can be underlying meds, can be underlying liver disease also because of obesity or alcoholism. Right. So now, chemo 6.4, TC 5090 ml, platelets 2.4 lakhs. So what's the interpretation of LFT?
His total bilirubin is elevated, so 2.6. Direct is only 1.2, but there is albumin, one nutritional status.
A little louder, we can't hear you clearly.
The nutritional status of albumin is more than 3.5, so nutrition is okay, but the enzymes have mildly elevated, so both the ASTs, transaminases were elevated, and with the bilirubins are also elevated. So we'd like to with this, but INR is fine. The synthetic function of liver is okay, but we'd like to get
In a nutshell, what are the status of the liver? Not that this is fine, this is not fine. What do you think the liver is? Status of the liver is? Is it before chemo or after chemo? That is also important to know. Did you try to look into this? This liver is this status of this function is it before chemo or after the chemo? So there are so many things in this liver function. What is the global level?
4.3.
And what is albumin level?
3.7.
Is it
Reversal.
normal?
Reversal.
You said that albumin is okay, so I am this thing. So don't read one investigation. There may be controversies about reversal of the ratio, but here is a clear cut. Not only reversal, there are transaminisemia and there is a raised bilirubin and there is a reversal. So do you think this liver is normal?
No, sir, this is not normal. There is
So-
some amount of.
So what are the possibilities you tell?
What are the possibilities?
Drug-induced, chemotherapy-induced damage to the liver.
So if this investigation is pre-chemo? So these are pre-chemo investigations.
Alcoholic hepatitis.
Then alcoholic liver disease.
So what should I do now? So I'm a surgeon. I treat esophageal cancer. I therefore close my eyes to all this, give him neoadjuvant chemoradiotherapy and go ahead and operate surgery. Go ahead and operate him because that's what I do. The rest I don't understand. Yes? No?
Based on
No, sir.
So what should I do now?
We have to optimize the patient, sir.
So how are you going to optimize this patient? Take him off alcohol, which he's been consuming for 20 years on a regular basis. You can give him advice, he may not listen to you. Put the fear of God in him, alright. But what do I do with these investigations? I have to treat this fellow.
Based on these investigations and the clinical examination findings, this mostly looks like CT. If there is cirrhosis, there's a CTPA. So next, I would like to do liver stiffness measurement.
How do you know cirrhosis? Ultrasound you should have asked how is the echo texture in inaudible arteries and can you saying liver span is increased, esophagus endoscopy is done, there is no varices. So much of the information is already given to you. You should interpret. In this patient, you are going to interpret.
First, I would want to do an ultrasound of the abdomen, and based on those, also look at the liver stiffness if there is evidence of cirrhosis.
So do we have an ultrasound report? Do we have an ultrasound report? No? We have. We have 6 minutes more to discuss this case. So you can take as long as you want reading the ultrasound report and
Signs. Because he's got splenomegaly along with increase in liver and parenchymal ecotexture.
interpret.
So I feel there is portal hypertension, sir. Signs
You
of
feel
portal.
there is portal hypertension.
Yes.
Okay, so what should I do now? Measure his HPG. He has no varices.
Yes, sir.
So portal vein is normal, varix is not there. Only thing is the increased size of the liver with those liver functions. Platelet count was also
We need to
normal.
move on.
Splenomegaly.
So spleen is right. I am saying. So if spleen size is increased, but you want to see other things also. Are there features of portal hypertension present in this patient?
No, sir.
Portal vein is normal. At least there was no varix. So what are the things we should look into more?
Ecotexture is increased, it suggests you have fatty liver and
Fatty liver or liver because of the
Steatohepatitis.
changes are there. So what are the things we should like to do now at this stage? Upper GI already done.
would like to see the CT scan, sir, stage the
The
disease.
CT is a very good investigation to see status of the liver.
For liver, because
You
there is
can
no
do a
portal.
fibro scan
Yes, sir, fibrosing.
at this stage to see what are the status of the stiffness of the liver, and then decide.
Do we have a CT scan?
What are we seeing? Can you please go on describing?
So there was thickness of esophagus noted at the left, just below the carina near. So it's more. So it is mid thoracic esophagus growth. There's thickening of esophagus, and it all the way down to beyond the inferior pulmonary vein also. Below this thickening started. Below the level, near the level of carina where azygos vein.
This is a contrast
Yes,
enhanced CT scan of the chest, neck and abdomen. Which is the venous phase. We can see that there is probably a tube in C2, and the esophagus above the level of carina is dilated. There is thickening seen. Can we go up? There is thickening seen from the level of carina downwards. Can you go down? The fat planes with the left bronchus were doubtful, sir, and the angle of contact with the aorta is less than 45 degree. Go down. Can you show the GE junction?
What does less than 45 degree indicate?
Sir, that the probability of esophageal, the aortic involvement is very
Less than 90, no? Why suddenly 45?
Yes, there are grades of.
So less than 45 means 0, less than 90 means 5%, more than 90 means 15%. Is that so?
More than 90 means 80% chance of infiltration.
Sorry, didn't get you.
So when the pike is, the angle is more than 90 degrees.
So 45% means what?
So 90-degree means there is 80% probability
So
of.
why get into difficulty? There's a convention, use the convention. You say 90 degrees, less than, more than, finish, story over. How does it matter whether it's 45 or 30 or 20 or 15? Moment you say something which I haven't heard, I want to know from you, what is this additional thing that you're giving me? It's an exam, no? Keep the examiner happy, simple. And how is the examiner happy? By listening to things that he or she has listened to day in and day out. So suddenly don't start overthinking. Okay, so based on this CT scan, what are you going to do? What do you think he has? Mid-third esophagus?
Yes.
Mid-thoracic.
Mid-thoracic esophageal.
What?
Squamous cell carcinoma.
Squamous cell carcinoma.
Which is the clinical T stage appears to be maybe T3, more than T3, and can you show the nodes?
More than T3, less than T4. What is that?
Sir,
what is more than T3? I can't understand.
Sir,
It's either T3 or it's T4, no?
I think it
What
is
is more than
T4.
T3?
T4, sir.
Okay, why do you say it's T4?
The fat planes with the left bronchus were doubtful for me.
So based on fat planes being doubtful with the left bronchus, you'd say it is T4.
T3 and 0, sir.
Yes, sir. T4.
Okay.
Clinical T4, and I'm not seeing any enlarged nodes, sir, as such. So N0.
Okay.
And there's no. I would like to see the lung window for
Lung window. Good. Okay, lung windows, please. Okay, presuming there is nothing in the lung windows, what do you want to do next?
Like,
Since the tumor at the carina, we would like to do the upper bronchoscopy as well.
You want to do an upper
Yes.
GI? You want to do a
Bronchoscopy.
bronchoscopy as well?
Yes.
Okay, all right. That bronchoscopy doesn't show anything. Now next. I'm past 2 minutes of this case. I'm eating into
we would like to
cases time.
prehabilitate the patient, optimize him, and plan for a neoadjuvant.
So I don't understand these words. Explain to me, what are you going to do?
Would like to.
What are you going to tell the patient? Telling these words to the patient is not going to mean anything. What are you going to do? What are you going to do?
Since it is completely luminal obstructing growth, we would like to take care of the nutrition of the patient also.
Okay, so what are you going to do?
Feeding jejunostomy, sir.
You do a feeding jejunostomy. Why not put in a nasogastric tube and feed him?
So already you are saying there is a tube has been put which is going across, it is coming from the stomach.
The endoscopist told you that they could go across into the stomach, and he even told you there is an NET in the duodenum because they took a biopsy from there.
Already tube is there.
That NET also you didn't see.
Yes.
You should have seen in CT also. It's a very small thing, but still you have to mention.
Okay. So you have to close this case. Tell us quickly.
Like to advise
Leave
him
it
on
halfway.
stop alcohol de-addiction, smoking cessation, nutritional optimization with tube
So
feeding.
you will de-addict his alcohol. How
Yes.
long is going to take that? How long is that going to take?
It will definitely take around a month.
So around a month. That's very good, excellent. Go to a psychiatrist friend and ask them how long it takes to de-addict people who consume alcohol. They'll tell you never. Okay. Now what do I do?
I think we have gone 30.
Anyway, quickly, now what do we want to do? You want to tell him to advise him to stop smoking and drinking. All right. What else? Improve his nutrition, put in a nasogastric tube, feed him. So what are you going to tell him to feed himself?
We're going to give plan a
Send him to a dietitian to plan his diet.
nutritionist counseling. Yes.
No.
How much calorie you want to give at
What
this
do you
stage?
want
You have
tell
seen
him
the
to
liver.
do?
How much calorie, how much protein?
25 to 35 kilocalorie as per his body weight, as well as 1 gram per kg protein for him, and plan his tube feeding accordingly.
1 gram is a normal requirement.
2 grams per kg.
1.5.
In a patient who has lost weight, you want to improve his nutrition, you should go for low carbohydrate and high protein, so that is and if possible some walking and exercises, so
Yes,
that
sir.
liver becomes a little bit better with the time.
Yes.
These are the things which are very
Do you
important.
want to operate him up front?
No, sir. No, sir.
Why? Why not? I'm a surgeon, I'm trigger happy. Take it out. Then give him whatever you want to. I give him chemotherapy, I give him radiotherapy, he won't tolerate anything. He'll become moribund. I can't operate, I can't get my money. What is the point?
As per the current evidence, we should plan for neoadjuvant chemoradiotherapy in locally advanced carcinoma esophagus. So in this case, we should go for neoadjuvant CT.
Why do they say you should give locally advanced people?
Because as per cross trial, it improves the rate of R0 resections, as well as there are chances of complete clinical response in some patients as well, and it improves overall survival.
By what proportion?
I'm not sure of the exact proportion.
Should be.
Yes, sir.
Small, big? Any idea?
Significant.
Improvement in R0 section from small to big?
I didn't get the question, sir.
So the improvement in, you said improvement in survival and you said improvement in the rate of R0 resection.
Yes, sir.
So survival you said you didn't know. I said improvement in R0 resection, small to big. Small improvement, big improvement.
Significant improvement was there, sir. As per
So when I was a resident, I was taught, remember a few percentages. 0 and 100 you always know. Remember 15, 30 and 70. It fits in all situations as long as you have a broad idea of what is happening. Okay. So that's my suggestion to you. Keep a vague idea of what is happening. No idea is not a great idea. Okay. So we give him neoadjuvant chemoradiotherapy. He's comes back to us. When do you want to operate him?
After 6 to 8 weeks, I further reassess and restage the patient with a PET CT.
Prefer, okay, PET CT.
Yes, sir.
So suppose I hadn't done a PET CT in the beginning, I had done only a CT. He had limited amount of funds, no?
Yes.
So doing 2 PET CTs was not possible. What should I do now?
Still, sir, we can assess with the CT.
So we assess with the CT again, or should we do a PET CT now?
No, sir, no PET.
If we have done a CT, we can go. We can go ahead with the PET CT. It may show if there is a reduction in the metabolic activity, but we don't have a previous metabolic activity for comparison. Still, we can assess the.
So maybe better.
Can you assess with the PET CT or CT scan? That is the simple question. You did a PET CT, or you can get away with the CT alone.
We can get away with the CT as well.
Okay, we'll move on to the next case. Sorry, Mahesh.
No issues.
Tried to hurry up as much as I could.
Next case capsule. 40-year female resident of West Bengal, homemaker, lower socioeconomic class, has G complaint of difficulty in swallowing for past 5 months. Patient was apparently alright 6 months back when she had alleged history of impulsive suicidal consumption of bathroom cleaner. On June 2024, she had consumed around 100 ml of liquid bathroom cleaner, following which she developed severe pain, diffuse abdominal pain with 4 to 5 episodes of the vomiting, which was dark brown in color. History of burning sensation in throat, no history of hematemesis, no history of chest pain, cough, difficulty in breathing, no history of hoarseness of voice. Patient was immediately taken to a nearby hospital. She was admitted in ICU and was given IV fluids and IV medications. Rise tube was placed and patient was kept NPO. Patient was kept in hospital for 10 days, discharged with RT in situ. RT was removed 1 week later, following which patient started having complaint of dysphagia to solids. Patient is able to tolerate the liquid. No history of odynophagia. History of the loss of weight 20 kg in 2 months. Patient was evaluated at tertiary center where she underwent the endoscopic following by surgery to gain the feeding access to intestines. Patient was started to feed and discharge. Currently, patient came with the complaint of absolute dysphagia with inability to swallow saliva too. History of the loss of appetite and loss of weight present. Patient is taking the Abjafit daily. No history of nausea, chest pain, abdominal pain, hospitalization in last 4 months. No history of cough, hoarseness of voice or difficulty in breathing or fever. No significant past personal and family history. In the general examination,
So anything more that you want to know on the history? Are you okay with this?
Can you show the history, please?
Any more questions you want to ask?
You're happy with the management done so far?
Would one of you like to summarize this? A lot of people sitting in the audience, short attention spans, distracted here and there. So maybe they'll benefit from your summary.
This is a 40-year-old female who has alleged history of suicidal consumption of a corrosive.
Okay.
The corrosive being acid toilet cleaner around 100 ml, following which her immediate symptoms were vomiting and painful swallowing, for which initially she was treated conservatively and has now undergone a feeding jejunostomy, is on feeding jejunostomy feeds. Initially she had grade 4 dysphagia and now she has grade 6 dysphagia, and she has come for further management. I just would want to know if she had undergone an endoscopy previously on probing. And
So did she undergo an endoscopy previously? Unlikely. If she had, they would have told.
No, sir.
So she didn't undergo an endoscopy. So would you want an endoscopy done in all patients who come to you?
During the acute presentation. I would want to know if an endoscopy was done during the acute presentation.
So you'd like to do an endoscopy during the acute presentation in all patients who came to you? That's my question. Or in some patients?
So in those who are hemodynamically stable with no evidence of any perforation or pneumomedia, subacute emphysema or guarding rigidity.
Those with manifest, except for those with manifest evidence of perforations, you would like to do an endoscopy in all other patients. Are there any patients in whom you would not like to do an endoscopy? One you said is those who have perforations, any other?
Suspected tracheoesophageal fistula.
Suspected tracheoesophageal fistula. Wouldn't develop so early, no? Acute phase, 48 hours.
Pharyngeal stricture. In patient having complete pharyngeal.
Patient having acute phase. We're looking at acute phase endoscopies.
After
So stricture is not going to develop in 48.
3 days
So
after-
so suppose a patient came to you on day 7 following the ingestion. Would you do an endoscopy?
No, sir.
Up to
So
72
up
hours.
A, we need the time.
Up to
Anything else?
72 hours.
3 days to 3 weeks is the within 72 hours we can.
Okay, some people say 48, some 72 hours. Okay, you'll do an endoscopy. Anything else? Any other condition you need along with that time? So no evident perforation. He or she's already got evidence of subcutaneous emphysema, pneumomediastinum on the chest X-ray, abdominal signs of perforation, peritonitis. You obviously would not do. Any other reasons?
Stride or respiratory difficulty you won't do.
Any other?
Alkali consumption.
Alkali consumption you won't do. If it's acid consumption you do, but alkali consumption you won't do. What is the purpose of doing the early endoscopy?
To grade the severity of.
So alkali consumption you can't grade severity, acid consumption you can.
Alkali more likely to penetrative type of injury.
So you can't grade in alkali?
We can grade, sir, but risk of perforation will be higher in alkali.
No, I think you are wrong.
First time I've heard of alkali consumption, you should do
have.
endoscopy.
This is a
You
short
don't do
case,
endoscopy in alkali
get
consumption?
confused. There is nothing difference like alkali and alcohol conjunction, we don't do. The indications are same, timing is same. So here was a rise to put when patient came without endoscopy. What is your opinion about that? In this patient, did you listen carefully? That patient came and the injury and the rise tube was put, and then after some time it was removed.
Blind insertion should never be attempted in a case of acute corrosive injury.
No, 2-3 people are speaking simultaneously. Should we put rise tube when patient comes immediately, or we should try to, after resuscitation, we try to do endoscopy, then think about rise tube if somebody is interested, or what? What is protocol?
Rise tube never be inserted blindly. The scopy should be done by experienced endoscopists, and if during completion of endoscopy, patient requiring long-term feeds can be considered, especially low Zaga 1 and 2A patients, we consider RT insertion.
When a patient comes with acute corrosive injury, what will you do? What patient has come to the ER and so how will you assess and how will you proceed? Just quick summary.
We'll assess airway, breathing, circulation of the patient first, hemodynamic status of the patient first we'll assess. After that, we'll put the IV cannula, resuscitate the patient. Then we'll keep the patient nil by mouth. No antiemetic agents, no any neutralization agents. After that, we'll do the assessment of the patient. If the patient is hemodynamically stable, there is no evidence of clinical any perforation, then first we will have to do OGD scopy and to assess the grade of the injury. And the further management will be as per the grade of the injury, sir.
Any role of CT scan, contrast enhance in these patients, other than examining clinically?
CT can also be used to stage.
CT will give the additional information if we are not able to assess the esophagus completely or not able to assess the stomach. The CT will give an additional information regarding the stomach as well. And there is also a CT grading of the injury.
We are talking about, we don't know what are the extent of injuries.
If late presentation is like after 72 hours where endoscopy is contraindicated, CT can give better information regarding the extent of injury, whether stomach is involved or not.
Why are you always worried about stomach? CT is there to help about stomach or extent of involvement?
Extent as well as additional information.
So you do a contrast enhanced CT scan. Can you see the esophageal wall enhancing or not enhancing?
Yes, sir.
Yes.
So there is some role of CT scan also when clinically patient is, as you said, the patient is stable and that you are not able to assess. CT has a very good role in assessing the extent of injury, whether wall is necrosed, getting necrosed, or all these things can be found on CT also. Yeah. And even impending perforation, all those things can be seen on CT scan, good CT scan.
So endoscopy you have done and you have identified Zarga 3B in esophagus, upper esophagus. What will you do? Will you complete the endoscopy or stop? Or what is 3B?
3B is sir, extensive necrosis. It's transmural basic.
Endoscopy we are telling. How do you know transmural?
Sir, it's extensive necrosis. 3A is focal, sir. 3B is extensive.
For Zarga 3B, then we would want to do a contrast enhanced CT scan.
You stop there or you want to proceed?
We wouldn't want to proceed further because there's high risk of perforation in these cases. So then the next step would be to assess the severity of the injury. In these cases, we should be doing a contrast enhanced CT scan. Both investigations are complementary. So if there's Zarga 3B, then we'll do a contrast enhanced CT scan of the chest, neck, chest and abdomen. And based on different grading systems like the Shirka or the Rayu's grading system, grade
so with the recent advance in endoscopy and we have to see all the gentle endoscopy, minimal insufflation expertise available. Some people are still, some centers are still assessing the entire thing, but you should be very guarded and should know about the indication. So if possible, you can assess the stomach also, but you should be very guarded, isn't it? So we'll have an assessment. Then when you are not able to assess again, then CT scan definitely has a role, and based on that you have to proceed. So complete the examination.
On examination, patient is sitting comfortably in bed with the bowel bedside her and was spitting saliva frequently, moderately built and poorly nourished, BMI 17.3, no pallor and pilar edema, performance status is 1, oral cavity, healthy mucosa of oral cavity, tongue and visible part of pharynx, no scarring, other portion is normal. Per abdomen examination on inspection, FJ in situ, otherwise vertical midline incision for this FJ, and another examination finding is normal. In the percussion and auscultation also is normal, no positive findings, and other systemic examination is also normal.
So quickly summarize and tell your plan of management, both history and examination.
So this is a 40-year-old female who has history of suicidal consumption of toilet cleaner and has undergone feeding jejunostomy previously and now has presented with grade 6 dysphagia to us. So the first investigation that I would want to do is a barium swallow for this patient.
Can we have the barium swallow?
Based on these barium swallow findings, sir, it seems like there is a complete cutoff and there is no distal flow of or minimal distal flow of barium.
See properly and then interpret. What is cutoff? There is definitely a streak of contrast going down, isn't it?
There is a barium film with anterior and lateral view. Suggestive of barium, the proximal stricture is at the level of around C4, and there is a thin streak of barium passing distally, suggestive of a long segment stricture.
What is the level of stricture?
Level cervical esophagus around C4.
When you assess the pyriform on barium, on which barium you will assess?
Frontal view. PAP.
So anterior posterior view you have to see, but it's
not
after emptying it has been taken. So you have to see the real time imaging. Is it? Are the both pyriform fossa free? It appears to be high stricture. So what is your plan for this patient after seeing this?
Based on these findings, sir, I would want to do a cervical, after having explained the nature of the disease to the patient and the current findings, I would want to do a cervical esophagostomy in this patient and do a dilatation of the proximal segment in preparation for a pharyngocoloplasty or a esophagoplasty.
Why do you want cervical esophagostomy? What did you say? I could not hear. Is it cervical esophagostomy you said?
Yes, sir.
How it is going to help you?
So we can do both retrograde. We can do a retrograde dilatation then, and
so retrograde means from where will you start?
Have you seen a cervical esophagostomy?
Yes, sir.
Being done for a corrosive?
Yes, sir.
For purpose of retrograde, antegrade dilatation?
Yes, sir. This is
But
above. This is a pharyngeal stricture.
Are you seeing the whole esophagus, very small, very thin streak of the barium going lower down? How whatever cervical esophagus is left might help in future for your this thing? You are put a tube there and start dilating. Is it possible? Anybody else agrees with this?
If at all you want to dilatation, when you want to start? If at all normal only, you want cervical endoscopic dilatation also. What is your plan if patient is coming, this patient only, so you have discharged this tube, how will you assess this patient?
After 3 weeks,
3 to 6
we
weeks.
start dilatation.
This patient is now 6 months,
This is now 6 months.
isn't it?
So we don't know the status of the stomach. In order for CT scan, direct laryngoscopy or interlaryngoscopy, in ureoscopy you know what the status of the pharynx, pyriform fossa, you have an idea, stomach is there or not.
No, that was a very wrong, means after barium swallow
You assess
immediately,
completely.
anybody can take over after barium swallow, what further you want to do?
I'd like to assess the nutritional status because if we have to plan for any surgical, like how is her albumin, how is her, how is the sarcopenic, is she?
So you want to assess the disease is as such, whatever has damage has happened. What are the things you would like to know? Already you have feeding jejunostomy, so you can modify the feed.
Yes, sir.
But are you ready for the surgery? So first of all, very limited evaluation has been done.
Yes, sir.
So you want to first do the proper evaluation so that you know what is the status of the injury, damage which has already occurred. It's not only barium. There are other damages which occur in the corrosive injury.
Indirect laryngoscopy.
So that is very important. You see the oral examination and then laryngoscopy, oropharyngeal. Yes, see the.
Sir, this is normal, sir. So, but we will have difficulty in assessing the stomach because we don't have.
Would you like to do endoscopy?
No, sir, because it seems fully cut off. So we'll have difficulty in doing endoscopy to assess the stomach.
Endoscopy done or not?
Endoscopy.
So you got the idea. Now the post-cricoid area.
Post-cricoid, yes.
Pharynx normal. Is it important or not?
Yes, sir. The level at which.
To assess the rest of the mucosa also, is there any fibrosis, isn't it a healthy mucosa? All those things can't be told on barium alone, so you will definitely like to do a endoscopy as well. So, and then indirect laryngoscopy to assess the larynx, hypopharynx, entire hypopharynx examination. Because your planning and future patient modalities depends on all these examinations, isn't it? How is the upper pharyngeal airway, how far it is from, does the patient require tracheostomy or not, all those things you have to assess.
Yes, sir.
Next you want to do CT scan. You want to do CT scan next?
Yes, a CT angio or like to do.
Do you CT angio?
Sir, that
Angio
is
what?
if we plan for surgery.
Sir is asking CT angio of what? Angio is
A CT angio of mesenteric vessels of the colon, sir. To look for
So you already planned for coloplasty.
Yes, sir.
What is the status of the stomach here?
The stomach is okay, you don't want to take up the stomach.
Sir, we cannot comment on. It will be hard to assess the stomach because.
So do you always need to do an angio to assess the mesenteric vessels?
We need not do angio, sir. If the patient is.
You've never done an angio. You've done a few hundred corrosive pull-ups. You've never done an angio to assess the colon. So some people say above the age of 50 you should assess. Some people say above the age of 60, but we haven't done even when people who were older. We can assess intra-op, no?
You also haven't done so far.
Not done, no?
No.
If at all you have to justify in which patients you will do colon. Which patients, if at all you justified assessment of colon, there's some colonoscopy or CT. In which patients you want to assess?
If they have history of any
Laptop feed, please.
peripheral vascular,
Huh?
any atherosclerosis.
If patient had old age, diverticulosis you are suspecting or previous surgery, or ischemic, so those rare conditions on routinely it's not required. Many centers they don't do.
Colonoscopy is also not required routinely in patients and all, unless you suspect something. Colonoscopy is one complication. If you perforate, that's gone.
So this is 6 months only. So are we ready for the definitive surgery in this patient? Or we have some idea about the disease progression to certain extent? What is the timing when this start more progression stops usually, so that you don't go earlier than that?
6 months, up to 1 year we can wait to see if that and fibrosis and
In the meantime, are other ways to look, have an idea of the stomach, esophagus, stomach? Because dilatation doesn't seem to be possible in this patient.
We cannot
but
comment
nothing
on-
is going. So I don't. I'm sure they must have tried guide wire, putting guide wire also. And it's because of the length of the stricture, it might not have been possible.
it will be hard to assess stomach without dilatation. So
Hard to assess.
the stomach if it's contracted, sir.
So you decide to assess intraoperatively and decide what you're going to take up, the stomach or the colon. You open
Yes.
up the abdomen and you find that the stomach looks nice and healthy. And the colon looks fine. What are you going to take up?
Prefer colon, sir.
Prefer colon. Why?
So because it
Pros and cons of colon versus stomach.
as because of acid.
So I ask you one question, you won't answer. The other way I ask you, you'll answer because there's a table made in some textbook which you've read. Correct? No? So tell me, pros and cons, stomach, colon, table hai.
Sir, the chances of stomach has more.
Try and get hold of GI Surgery Annual Volume 1 or 2, I think. Professor Anand Krishnan has written a beautiful chapter. Nothing additional in the literature even after 25 years. Somebody is nodding his head very vigorously. He's read it probably. That's why. Anyway, I think Dr.
5 more minutes, sir.
Close.
5 more minutes, sir.
5 more minutes?
Yes.
Okay, good, good. Sir, 5 more minutes. So stomach versus colon, 5
So
more
one is
minutes.
blood supply. Stomach is more. Stomach is more durable as a conduit, sir, and but it
More
has
durable.
because
That
of
means after 10 years I need to replace it.
one
Don't
is
have to replace it with the colon.
stricture
Colon I
rates.
have to replace with stomach.
Colon
So
will
durable
have-
means, what do you mean by durable?
So the blood supply is
Blood supply is?
one is the stricture rates and
So remember, there are a certain defined set of cases that you will get as short cases, long cases. You want me to give you a list? I'll give you a list of 30. 99.9% you won't get anything beyond that. For these defined 30 cases, there are 95% of set questions that you will be asked. So if you got a corrosive, you will be asked stomach versus colon. There's no way you will not be asked. Alright. So these are standard questions which will be asked. So be prepared before you go for an exam. Okay. Alright. Now here is a patient, you've decided to do a pull-up. You don't know whether the such stomach is suitable or not because pre-operatively you cannot assess. Intraoperatively you have the choice of colon versus stomach in a high pharyngeal stricture. What are you going to choose?
we have the
Colon.
advantage of length in colon, sir.
You have?
The advantage of length.
So colon can probably go to the base of the tongue, but the stomach can also go to the base of the tongue. Just need some additional maneuvers. Okay? So I plan to take up the colon. Which side of the colon do you want to take up and why? These are standard questions. I'm not giving you answers. Go back and read. I'm just giving you the questions.
Right side, if we take, we can take with ileocecal valve, sir, which can help.
I'm saying what will you take, right side or left side? I'm not saying whether you will take with the ileocecal valve or not take with the ileocecal valve. You don't know the answer, say I don't know the answer, I'll move on to the next
So
question.
we'll prefer left side colon.
You prefer left side, why?
If left fails, we have right to come.
If?
If left fails, If you,
So if left fails, why should left fail, Baba?
like ischemic necrosis.
First tell the advantages of the left side, then go to the all these things.
So negative,
robust blood
negative,
flow.
negative and negative. I am absolutely negative.
Robust blood supply, reliable blood supply is there, and adequate length can be achieved for
First tell
mobilization.
which side blood arcade is consistent. This is the
Left
answer.
side
Left
artery is
side.
consistent.
What about the size of the tube? Esophagus vis-a-vis right colon, left colon. Which colon will have less foreign body in the chest?
Left caliber matches with the esophagus, and
So consistent arcade, and then very huge cecum will be there in the chest when you are taking this, and it creates discomfort sometimes. But what are the advantages of the right side?
prevent reflux because of ileocecal valve, and the
That is
anastomose what we use, the ileum, is easy to anastomose with the esophagus.
Not easy, you can say the size maybe
Maybe
more
because we
closer to-
anastomose the neck, instead of anastomosing the bulky colon, ileum can be anastomosed easier compared to colon, if you prefer right side.
So if you anastomose the ileum, where will be the cecum?
Cecum.
In the neck or behind the mediastinum or in the
Upper mediastinum.
chest? How much ileum you will take
Yes.
to make it to the pharynx, high pharyngeal structure? So it's very easy. See, from the acute corrosive poisoning, you should examine thoroughly. Certain conditions you don't have to do any endoscopy when patient is very sick and even unstable or respiratory problem and all. And you examine the mouth, oral cavity. If there is already grade 3 burns, you don't do endoscopy and all. Or you go steroids since after patient is having respiratory distress, you give steroids. Here you get no antibiotics, you don't neutralize the patient. The patient took an acid in the background of after food or on the empty stomach, that decides the nature of the gastric injury also. And you do endoscopy. Some people may feign this one to threaten their parents or relatives. They may say there may not be any findings at all. They have been taken in. So this acid at all. You discharge the patient. You do endoscopy, you can assess the mucosa. There is pharyngeal case normal. You can plan early surgery in the case of corrosive stricture, esophagus. All these things you can assess. And during doing feeding jejunum, you assess the stomach. Some people may, based on the augment the blood supply also, you can ligate the artery to augment the blood supply later also. Do everything. The assess later the stricture, the endoscopy, ureoscopy, variant solar, CT scan, have an idea what to do and all. The right colon, left colon, mid colon, it is based on the ascending left colic artery or middle colic artery or supercharged. Some you will to plan the anastomose the neck also. These things should know. Free general graft, flap, everything should know. How to anastomose in the pharynx. You will do a tracheostomy or not. When you do tracheostomy earlier, then wait and go for coloplasty. What are advantages? Very high pharyngeal structure, earlier you do tracheostomy so that patient will be accustomed with the tracheostomy. You don't have to do both together. Patient comfortable with that. You will tolerate the coloplasty easier. And how long it will take the patient to eat? What type of anastomosis? So many things are there.
Can we close, sir? Yeah. Quickly, if anybody has any doubts or questions to ask, you can ask. Otherwise, we'll move on to the next, sir.
The same way previous case, LFT is raised. In alcoholic hepatitis, AST will be more. Here ALT is more, there will be AST will be more. Any underlying viral disease or not, you should look for. Alcoholic and smoking patient will have increased incidence of hepatitis C or B. And if the globulin is raised, you have portal hypertension or cirrhotic patient or some chronic infection will be there. justify that.
Piyush sir, sir here.
Sir.
On behalf of the residents, I want to ask one question.
You can't ask on
Yes,
behalf
sir.
of the residents.
Yes, sir, please.
Kindly clarify regarding the role of PET in initial pre-op evaluation of CA esophagus. Second question is, up to what level of esophagus will you do neoadjuvant CTRT followed by surgery, and you will not do, you will go for chemoradiation as a definitive treatment? Level wise, 22 or 24, what's your?
So I think mid-thirds, it's good to do neoadjuvant chemo-RT. The data suggests that chemo-RT works well for them. Very early lesions, which we don't see, are patients in whom you can go up and do upfront surgery. For many years, we did upfront surgery in patients with squamous cell carcinoma of the esophagus. In some of them, at one point in time, we used to do pre-op radiotherapy alone. And this is based on the experience of the Japanese who were doing radiotherapy alone at that time. Unfortunately, there was no randomized controlled trial, and we never ended up doing a randomized trial to see whether pre-op RT was good enough. But pre-op RT used to do one very good thing, and it used to make transhiatal esophagectomy, which is what we used to do, much easier if you did it the right time. If you delayed it too much after the RT, then it used to make life a little more difficult. PET scan. So I would prefer to do a PET if possible before and after. If I haven't done a PET before, then I would prefer, and I have a CT only for comparison. I prefer to do a CT only later on because comparison becomes easier. Some people would say I would do a PET CT even if I haven't done a PET CT before later on, to distant metastases may have come up. I won't argue with them and fight with them on that, but I would prefer to do a CT before and after if I haven't done a PET CT before.
So cervical esophagus always involve the patient also. Definitely chemo RT. The middle third, lower third, squamous cell carcinoma of course, priority chemo RT, and again discuss with the patient, old agenda, definitely chemo RT. Now always preferably PET CT than CT scan because you can upstage the disease, you will know the metastasis, because since we are planning almost always pre-op chemo RT, we can see the response also. That's why I prefer chemo RT. In the case of lower esophageal junction or OG junction growth, majority will be some 20 to 30% kind of full deficit carcinoma. They may not be PET avid. In that case, we can maybe avoid.
Sir, in a examination, when we are asked the question regarding the evaluation, imaging, the first imaging for the CA esophagus after endoscopy and biopsy proven, the first imaging, what shall we say in examination? CCT, neck, chest, abdomen with oral IV contrast or FDG PET CT?
As I told, no? PET CT scan.
PET CT.
Nowadays, yes.
Okay.
Otherwise, you have to do CT scan, again go for PET CT because nowadays we are always planning pre-op chemo RT. It has two purposes. So you can diagnose meds also and response rate to chemo RT also. Easily access.
Thank you, sir.
The trial is there, no? What trial? I'm not getting the name.
Munich on study.
That time,
Thank the faculty.
Thank you, sir.
We move on to the next case. I would like to request Dr. R.A. Shastri, Dr. Soumitra Rawat, Dr. Venkatramana Reddy, and Vinay B.N. The next batch, can you please come and take the chairs? Next batch, please settle down quickly. So we can start.
Good morning all. My patient is a 65-year-old male.
Before we start, can we just have a kind of order? Say instead of being a free-for-all, since 6 of you are here, and since most of the discussions would be, say, 3 parts, the clinical assessment, the investigative assessment, and the treatment planning and the execution of treatment, you can divide yourselves into 3 groups and maybe follow. Of course, if 2 cannot answer, the other one can chip in. So that would avoid confusion.
And also the 3 parts should have equal timing. You know, we don't want to carry on with history for more than half of the time, okay? So 1/3 history, 1/3 investigation, and 1/3 management. Agree? Yeah.
Sure, sir. Shall I start?
Yes.
Yeah, you can start. Please speak into the mic, closer to your mic. Yeah.
My patient is a 65-year-old male, watchman by occupation and resident of Assam. He presented with chief complaints of vomiting since 2 months, loss of weight and appetite since 2 months. Patient was apparently normal 2 months back, then he developed vomiting. Vomiting episodes were insidious in onset, non-bilious, non-projectile, occurring 1 to 2 episodes per day, large volume, containing previously eaten food particles. It was undigested and partially digested food particles occurring 4 to 5 hours after food intake. There is history of postprandial fullness which relieves partially on vomiting. There is no history of early satiety. Patient also gives history of loss of weight of 4 kg in past 2 months. It is associated with loss of appetite. Patient also gives history of blackish discoloration of stools 14 days back. He had similar 2 to 3 episodes in last 14 days. There is no history of pain abdomen at the present or recurrent episodes of pain in the past. There is no history of jaundice. There is no history of postural dizziness, syncope, fatigue or shortness of breath. There is no history of, no previous history of dyspepsia, no previous history suggestive of dyspepsia, no history of abdominal distension, respiratory discomfort, blackout, headache or seizures. There is no history of back pain or bony pain. Patient doesn't have any medical risk factor, no significant past surgical history. Patient consumes both vegetarian and non-vegetarian diet. Sleep is not disturbed. Regular bowel and bladder habits. Patient is a known tobacco chewer since past 40 years. Patient does not consume alcohol. There is no contributory family history. Shall I summarize, sir?
Yeah, go ahead.
65-year-old male, tobacco chewer with no comorbidities, with features suggestive of gastric outlet obstruction since 2 months, with history of melena, loss of weight and loss of appetite, without history of pain abdomen in the present or in the past, and with no history of jaundice. I want to keep a differential diagnosis of gastric outlet obstruction, most probably malignant, sir. My differential diagnosis would be carcinoma distal stomach, first one, and second I want to keep carcinoma gallbladder also.
Yeah, why carcinoma gallbladder? Anything to suggest in that history?
No, sir. I was thinking malignant causes of gastric outlet obstruction, and this patient is almost all features suggestive it is a CS distal stomach, sir. But I want to keep CA gallbladder because patient is from Assam, where the incidence of gallbladder is more, and elderly male.
Is that the second cause of gastric outlet obstruction in the malignancy? I mean,
No,
even
sir.
if you want to keep it something else apart from stomach.
CA head of pancreas comes before.
That's what, no? How
but
often have you seen CA gallbladder causing?
It's very rare, sir.
So a slip like this can damage all the good work you have done so far.
Even if you are not
Your
given second
history has
option.
been very focused. I thought you were going in a right path, but the diagnostic possibility has pulled you down.
I think put the common thing common?
So it's more
CA
of CA pancreas,
head.
something like that. Okay.
Because CA head causing obstruction without jaundice is very rare. I didn't keep it, sir.
Yeah,
as
no
such.
pain also, of course.
Yes, sir. No pain as
Yeah.
such. If at all I want to keep, I just told, or else everything points towards CA stomach, sir, in this patient.
But sometimes, periampullary carcinoma, large one, it can.
Even
Gastric outlet, it'll cause a obstruction there. Yeah.
without jaundice,
Periampullary, sometimes, you won't have a jaundice. Okay. You won't have a jaundice.
You can also
Sometimes there may be an objection if you say only one possibility.
yes.
And such cases, when there is, it's almost a black and white kind of situation, you would say the most possible cause or diagnosis here, and would add that I would also like to keep the other malignant causes of gastric outlet obstruction, which would include all the surrounding organs. Without any specific pointer to any of them, I don't think you can point to say CA gallbladder or periampullary. That would be too much of a kill.
What do you think if you are thinking about gastric outlet obstruction due to distal CA stomach? From the symptoms, do you think it's going to be a very advanced disease or starting disease, or
I would not.
Regarding the symptoms,
Yes.
which symptom will come first? And then what is the symptoms you will see it later?
Mostly
in
it
cases
will
of
be
distal.
mostly it will be weight loss, anorexia, melena, and vomiting, sir. Initially, pain abdomen comes in the. In advanced cases there
Advanced
will be
cases, yeah.
associated pain abdomen.
So is dyspepsia early satiety? That is the initial symptom.
Recent
Fullness.
onset.
That is early symptoms. Vomiting, once it happens, that means that is the next step, next stage. Then once you start having a pain, that means it's advanced. It is advanced. And regarding melena,
yes,
is bleeding more common in the cancer or in GIST?
It is more common in GIST, sir.
Why?
GIST will be more vascular compared to malignancy.
Yeah.
And malignancy, it will be always low grade bleeding, sir.
Yeah. So this is what you need to understand, that in malignancy it will be, small amount of bleeding causing gradual anemia. Okay.
Yes.
Could be vomiting, but it'll be small amount. And if you have a melena, small amount. In cases of GIST, it's a big amount. Okay. Why non-bilious is important? You mentioned non-bilious.
It tells about the location of the obstruction. If it is distal to the ampulla,
Yeah.
it will be bilious vomiting. If it is proximal to it, it will be non-bilious usually.
And how come non-projectile? You were focusing non-projectile.
Projectile vomiting occurs in medical causes.
So how exactly you take the history of the projectile?
In projectile vomiting, usually there will be no associated nausea. Patient vomits without any signs of nausea. In non-projectile, usually it will be preceded by nausea followed by vomiting.
In a benign gastric outlet obstruction, what kind of vomiting will you have?
I think it's non-projectile only. Not sure.
In malignant you get projectile?
No, sir. In both it
Then
will
why
be
did you say that?
non-projectile.
And in a situation like this, just a suggestion, a 65-year-old person and with a significant retention vomiting, he may be an early candidate for surgery. So a hint about comorbid situation in the history itself would go, it will show that you are thinking of one step ahead. It's important to consider a patient as a whole and consider all the options of management.
Sure.
You have not mentioned anything about his other coma.
Comorbidity, sir?
I think you just
I
summarized
mentioned
no medical, something like that. Okay.
Sorry, sir. I didn't.
I think you just said no medical something. Like
No
that.
medical risk factor.
Yeah, that's what you just mentioned. One word. Okay. Okay.
Go ahead.
What are the examination?
I will be proceeding with examination, sir. Coming to general physical examination, my patient is conscious, cooperative and well oriented to time, place and person, sitting comfortably on the examination bed. His BMI is 17.1 kg per meter square, height being 160 centimeter and weight being 44 kgs. He is thin built and poorly nourished. He is dehydrated, his tongue was dry and he has decreased chin turgor. His ECOG status was 1. Pulse rate was 96 per minute, BP 100/66. Respiratory rate was 14 per minute. His afebrile breath holding time was 34 seconds. On examination of oral cavity, he had dental caries. There was loss of dentition with normal mouth opening and there was no ulcers. There was no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy or edema. There was no palpable supraclavicular lymph nodes. On examination, he also had a nasal feeding access, which was a feeding tube in situ, which was probably a nasojejunal tube or fracas tube. Coming to abdomen examination, on inspection, his abdomen was flat with umbilicus centrally located and inverted. There was no scar, dilated vein or skin lesions. All quadrants were moving equally with respiration. There was a visible peristalsis was seen, which was left to right, and there was no visible pulsation. There was a lump around 10 into 8 centimeter in the epigastric region, which was extending from right mid-clavicular line to left mid-clavicular line in horizontal axis, and 6 centimeter below the Ziphy sternum to supraumbilicus in the vertical axis. And the lump was moving with respiration, and there was no renal angle fullness, and there was hernial orifice was intact, external genitalia was normal. On palpation, the abdomen was soft and non-tender. There was epigastric vague lump around 10 into 8 centimeter, which was soft in consistency with ill-defined margins, smooth surface, and it was moving with respiration. There was no organomegaly, liver and spleen was normal. Hernial orifices was intact, and there was no renal angle tenderness. On percussion, the liver dullness was seen in upper border of 5th intercostal space in mid-clavicular line. Liver span was 13 centimeter, which was normal. And there was tympanic note over the lump, and also the rest of the abdomen was resonant. There was no evidence of free fluid in the abdominal cavity. On auscultation, normal bowel sounds were heard. There was no bruit. Succussion splash was not heard. On digital rectal examination, perianal skin was normal. Normal sphincter tone was there. No palpable nodules or deposits were felt, and glove stains with yellow colored stools. Respiratory examination, there was a normal air entry and no added sounds. And examination of central nervous system and CVS was within normal limits. Should I summarize, sir?
Summarize yours. Yeah,
after my history and examination, a 65-year-old gentleman with no comorbidity, with addiction of tobacco since 40 years, presenting with features of gastric outlet obstruction with recurrent non-bilious vomiting since 2 months, associated with loss of appetite and significant unintentional weight loss since last 2 months. On examination, he is thin built, poorly nourished, with BMI of 17.1 kg per meter square, ECOG status 1, with signs of dehydration and nasojejunal tube in situ. On abdominal examination, he has distended and palpable stomach, with visible peristalsis. So after this, my differential diagnosis will be first gastric outlet obstruction due to malignant etiology, mostly carcinoma of distal stomach. Second, I will like to put gastric outlet obstruction due to benign etiology. And my rare other possibility will be gastric arterial obstruction due to gastric cyst.
So on examination, this patient, his BMI is 17.1.
Yes.
And he's got a NJ tube in.
Yes.
And he's got a lump, isn't it?
Yes.
How often do you see a lump in distal CA stomach?
Actually, the course of disease is less and it is within 2 months only. So stomach doesn't have time to be distended in mostly the malignant cases. So it is more common in benign gastric outlet if a distended stomach is seen.
So the lump you described 10 by 6 centimeter.
Yes.
You think it's a lump or it's a
Distended stomach. Distended stomach, sir.
It is a distended stomach.
Yes.
With the food residue.
Yes, sir.
Okay. Okay. And you didn't have any other positive finding. There was no supraclavicular lymph node.
Yes, sir.
And you specifically mentioned about PR where you were looking for a nodule or lump.
Yes.
What you were looking for?
Drop Blummer shelf drop deposits.
What is Blummer shelf?
Sir, it is like in the carcinoma stomach, in the peritoneal cavity pouch of Douglas, there are drop deposits if it is a metastatic disease which can be felt on DRE.
And what sort of a route does Blummer shelf develops? Tell me the routes where CA stomach will go to.
Can be, sir, hematogenous route.
Sorry?
The spread of the disease can be hematogenous, lymphatic, or peritoneal.
So let's go one by one.
Yes.
One is, you said hematogenous.
Yes.
Okay.
Hematogenous
to which organs?
Can be
common.
to liver and lungs.
Okay.
And lymphatic to the nearby lymph nodes. And peritoneal drops can be Kuchenberg tumor.
Lymphatics.
Yes.
You mentioned about supraclavicular lymph node not present.
Yes, sir.
So when you are feeling for supraclavicular lymph node,
Yes, sir.
is it hematogenous or lymphatic spread?
Lymphatic, sir.
Lymphatic spread.
Yes.
Why left? Why not right?
So because thoracic, after the cisterna calli, the thoracic duct drains into the left side of the near the internal jugular vein.
Okay. So hematogenous, lymphatic. What is the third? Direct involvement.
Peritoneal route means direct involvement through the peritoneal route. Direct extension through the peritoneum.
Transcoelomic.
That is, see, this is the word I wanting you to say.
Yes.
That is a transcoelomic, okay? And direct invasion of which organs?
Kuchenberg tumor can be seen bilateral ovarian deposits, Blummer shelf deposits.
That is transcoelomic. He's already said it.
Yes.
I'm talking about the direct involvement of the surrounding structure.
Yes. It can.
Is it direct involvement?
Yes, sir. Direct.
The ovaries.
No, sir.
Is it direct involvement?
Transcoelomics.
So,
yes.
Keep it to, you need to understand, why we are asking.
Yes.
When you talk about direct involvement and then you are talking about ovarian deposit, that is not a direct.
Yes.
So direct involvement is which organs?
So it can be to duodenum, pancreas.
Duodenum, pancreas.
Left lobe of liver.
Yeah.
And colon, transverse colon.
Yeah, transverse colon and spleen. So, this is what you need to look at. Diaphragm can also get involved if it is a fundal one.
Yes.
And spleen if it is on the greater curve.
Yes.
So, you need to think in a broader way. Okay?
Yes.
Think in a broader way. So, do you think there will be an involvement of any of the organs, or what kind of stage you are looking for? If you feel that it's a distended stomach, then it's okay. But if you feel it's a lump due to the tumor, what kind of tumor you are thinking about?
Palpable lumps are always usually advanced disease, sir.
Uh-huh.
And
Do you think when you feel a lump which is not a distended stomach, what should go in your mind? Can it be a large cyst or large lymphoma, or whether it'll be a cancer?
depending on history.
Normally, do you feel stomach cancer on examination?
If the patient is thin, usually we don't feel, sir, but if the patient is thin built and it is advanced disease, then we can feel, sir.
But then also, if you're feeling a lump, you should have lymphoma and cyst in your mind, because they are the one where you will feel the lump.
Yes.
You will feel the lump.
Incidentally, in your examination description, so you should remember that it is customary not to say a distended stomach as a lump. When you say a lump, it's generally a solid lump. Although you said soft, it will invite a lot of unnecessary questions. A soft lump, gastric lump, what are the soft gastric lumps? That's all totally unnecessary, and it will deviate to areas, where you can have multiple arguments, and it's not right. So be careful with your wording.
See, when you talked about visible peristalsis, so was it a part of the visible peristalsis due to the distended stomach, or was it a lump? Because when you talk about lump, then it's different,
Yes.
That is what sir is saying.
So what is your second differential that you said apart from CS stomach?
Gastric outlet obstruction due to benign etiology, sir.
Why did you put that now?
So because stomach is usually distended in benign etiology, but age factor and other factors favors malignancy, but this examination finding only points towards benign etiology, distended stomach.
So the only positive thing is distended stomach.
Yes, sir. And visible peristalsis more common in benign etiology.
What kind of malignant obstructions can you have? Visible peristalsis and a largely distended stomach.
If the patient has chronic dyspeptic symptoms, peptic ulcer disease since long, and it is turned into malignancy, we can have long-standing
Location of the tumor?
antropyloric growth.
Type of tumor, what are the different types of stomach tumor, like proliferative, ulcerative, infiltrative, or diffusely infiltrative?
Yes, sir.
What is that classification called as? Or
So Japanese or the Borman classification?
Borman, yeah.
Yes. Extrude,
So which one do you think this would have?
ulceroproliferative type.
So it will be ulceroproliferative. So that is Borman what? Type 2.
Yes, sir.
When is ulceroproliferative? Yeah.
What is the type?
Type.
Ulceroproliferative. 1, 2, 3, 4.
So first is protruding type.
One
Next,
is protruding.
extravert.
Second is
extravasating side.
Excavate.
Extravasated. And third is surface lesion. Fourth is linitis plastica.
Third is infiltrative.
Infiltrative type. Yes.
Infiltrative.
Surface.
Okay.
Superficial
Fourth is
type.
linitis plastica. What is the hallmark of linitic plastica?
So it will be having small undistendable stomach with the.
Does it normally present as gastric outlet obstruction?
No, sir. Early satiety, less.
So that is why, when I was asking about the types,
yes,
most likely this would be type 2. Okay?
Yes.
Type 2. It will be ulceroproliferative, where because this patient has got a melena, isn't it? So it is ulcerative.
Yes.
And plus it's causing a obstruction. So it's ulceroproliferative.
What is the tube that you said it is there in place?
So nasojejunal tube, sir.
Why do you think it's nasojejunal?
Because he gives history that he uses that for feeding purpose, and plus it was like Freycine's tube on appearance.
I think in your differential diagnosis you should also could have added lymphoma, GIST. This can also cause,
So more than benign, I think that would have
benign,
been
yeah. Because if
better.
you are thinking about malignancy, you could have said that, first diagnosis is cancer, second could be lymphoma or a GIST, especially when you said there is a lump also, lump on examination.
Again, lump as
Lump as,
not as you were thinking, but
yeah.
real lump.
Yeah.
Okay.
What findings in your what examination findings refute that it is a lymphoma? You said something. Mass, does it move with respiration or something? You said does it move with respiration?
It moves with the respiration. It is intraperitoneal. Evening fever, can lead to query of lymphoma, constitutional symptoms of lymphoma.
Can we go to investigations? Yeah.
So, how do you proceed now? Yeah, please.
So me,
Next
yeah, please go ahead.
Investigation.
Yeah,
Whoever
next,
is
third person.
So patient is dehydrated, and I will admit the patient, resuscitate the patient. Simultaneously, I will send for blood investigations. And once the patient is stabilized, then to confirm the diagnosis, we will do upper GI endoscopies.
So what investigations, what blood investigations you would like to do it?
Complete blood count, kidney function test, serum electrolytes.
We
liver
have
function test.
values? Yes. Yeah.
He is anemic, sir. Total counts and platelets are normal limited.
Okay, next.
Urea creatinine is normal. Electrolytes also, potassium is lower limit of the normal value. Sodium chloride is normal.
So what abnormalities you can get in CA stomach like this? Electrolytes?
What
What
electrolytes
yeah.
abnormality in gastric outlet obstruction?
You said it's 3 months.
Hypokalemia
Sorry,
and
2 months.
hyperchloremia.
Metabolic
alkalosis, sir. Liver function test, bilirubin, total bilirubin slightly elevated. Enzymes are
In this
vastly
one,
elevated.
in this blood test,
Yes, sir.
what concerns you? What will concern you, and what is a good thing you would think about this blood test? What is bad thing? What is good thing?
Bad thing is enzymes are elevated, sir.
Yeah. So enzymes are elevated. It's a bad thing.
So
What is a good thing?
Yeah. All enzymes are elevated. Transaminases.
What is a
albumin.
good thing?
Albumin is 3.7.
Yeah.
INR is 0.8.
Otherwise, patient for 3 months, you will somehow will think that albumin will be somewhere between 2.5 and 3. It is 3.7, so it's a good thing. Bad thing is why his liver enzymes are deranged. What do you think? Why?
Yeah, how do you interpret this LFT with the current condition of the patient? See, there is something, ALP is raised.
Yes, sir.
You have enzymes are all raised, SGOT, PT. So do you think it's something different from your current pathology, or you can correlate with the current pathology? What you are thinking now?
See, when you are having a look at LFT, connect the dots, What do you think? ALP is significantly raised. Bilirubin is not that much raised. Yes or no?
Yes, sir.
And then SGOT, SGPT is raised, but not as much as alkaline phosphatase.
See, the smartness in examinations and interviews is you lead the discussion. You don't let the other person lead. It's a very important.
Rather than me asking you, you should be
have,
saying.
see, it's so clear.
Yeah. And if you would have added that, like what I said, sir, there is a good thing, serum albumin is normal, but bad thing is this. That means, you are involved, you are looking with the wider frame of mind.
And even in the
not
enzymes,
a narrow
even in the
frame of
enzymes,
mind.
It's alkaline phosphatase is also raised. So you could have brought it out yourself.
And,
So that will give you extra points.
even when history you were taking, if you just mention one line, that patient can climb 2 flights of stairs without having a breathlessness, that means he is pretty much fit for surgery. These are the very, very small things. You can always ask, can
anyone
you
else would
climb
like to answer
2 flights of stairs without having to
Mild
rest?
cholangitis due to some obstructive jaundice due to metastasis.
Could be porta-hepatis node
Yeah, there is no
compressive.
jaundice, no? There is no jaundice. Okay. So what did you say? Metastasis.
Yes, sir. Lymph node metastasis, there is compression on the
One
Porta-hepatis
possibility.
node compressing causing elevation of the
Even it can be even not only at the hilum, it can be even
porta-hepatis.
liver mets also, no?
But
So
it
it's-
should be a bile or multiple mets to cause such a tearing.
Yeah, it could
So
be
if you want to
liver
correlate,
mets, could
yeah.
be a lymph node there in porta.
So if you want to correlate, that's the way, no? CA stomach with liver mets and probably you have lymph nodes even at the port.
Or it could be like, you were talking about CA head of the pancreas. You were saying
Maybe
that
still there is a
patient
possibility.
would be jaundice. So you never know. Keep your options open, okay?
In uncinate process
Don't
growth,
leave silent
because
gaps.
LFT
They
is
can
not
be
much elevated.
Damaging, yeah. What is the next test you will do?
Do a
Eh?
endoscope.
Upper GI endoscope.
Upper GI endoscope in this patient.
Now this
Upper
is over.
GI.
Your okay, blood
Okay.
investigations are done. Okay.
Yes. In stomach, there is a large ulcerated growth in antrum and incisura with significant food residue. Scope is not passed beyond. Yeah.
See, this you knew it from the history. Vomiting, and that is why I was saying it would be ulcerative growth. That is what you need to think. Patient was anemic, have got a history of,
Melina.
black stool. So obviously it will be ulcerated and it will be situated in antrum and incisura so that, it's causing a full obstruction and scope not passed beyond. What will you do now? You are an endoscopist, you have taken biopsies.
Take biopsy, yes.
And
Biopsy and
after the
confirm
biopsy is moderately differentiated adenocarcinoma. Okay?
Yes. So now-
Against the background of chronic active gastritis.
Is that important?
Why a background of chronic active gastritis? What is the etiology of stomach cancer?
H.
What are the-
pylori. H. pylori.
H. pylori is one of them. What else?
Smoking,
environmental
factors.
gastritis.
Atopic gastritis.
What else?
Pernicious anemia.
Pernicious anemia. What else?
Menetrius disease.
Menetrius disease. What else? What else?
Hereditary gastric.
Mutations.
Hereditary gastric.
Hereditary gastric cancer.
Okay. What else? Any previous surgery?
Yes.
Which one?
Previous
See, you have been born in an era where you haven't seen that kind of surgery. When I was in medical school doing my PG, 30-40% of surgery was truncal vagotomy, gastrojejunostomy, isn't it? 30% or 40% PPI came, finito. So after previous surgery, you can have. Okay?
So what next?
And staging.
Staging.
Contrast enhanced CT.
Are you worried you cannot pass the
What did you
scope beyond?
What did you say now?
Staging investigations. Next.
Staging
And
investigation.
from your assessment, what were you thinking like LFT and all?
What is a simple test you
Do an
would do?
ultrasound.
You
Abdomen
know,
and pelvis.
First
that
thing
is
that
the
you do,
next
no?
one.
Whether like diffuse metastasis or
Yeah.
not. What is that, this thing?
Liver is normal,
Liver is
sir.
normal.
Pancreas normal. Gallbladder normal. So there is a hypercake lesion around 6 centimeters near the antrum of stomach with asymmetrical circumferential thickening with over-distended stomach with significant fluid residue. No lymphadenopathy. No free fluid in pelvis, sir.
So what do you think cause of his abnormal LFTs?
Maybe the lymph node compression might be causing.
Anything
but
else?
normal.
CBD is normal.
CBD is normal.
CBD is
No
normal.
HBD.
So that, you know, if you got a obstruction somewhere, there will be intrahepatic biliary radical dilatation.
Viral markers to look
Eh?
Viral markers.
Viral marker. See, that is what. He could have a overlying, you know, having a hepatitis A, E. So, you know, it's important. You need to think laterally. Although it is significantly high. Yeah. It's not the one which you can take it lightly. It's not just double. I think it's raised 6-7 times. So viral marker, hepatitis A, E, just to rule out that he doesn't have any underlying. So what are the other investigation for staging?
Contrast enhanced CT, abdomen, pelvis.
IV and oral.
We have the viral markers. Viral markers are negative.
Negative, yes. Contrast enhanced CT. See, does the radiologist, you know, sometime when you want to, you don't do an endoscopy, you do a CT scan, there is not like bang door gastric outlet obstruction, but you are suspecting something. Is oral contrast better or the normal CCT better for CS stomach?
Oral contrast.
Oral contrast will be better.
Better. Why?
What contrast?
Negative contrast.
Negative contrast. Water based.
So give water, okay. So,
Negative contrast, yeah.
If we continue the argument from the previous case, why not do a PET CT here for an adjacent organ?
The patient is affordable, we can do a PET CT to upstream the disease and change in the management in 15 to 20% of the
Have
patients.
a look at the CT, otherwise, you know, you will miss out. It's going through. Have you got a pointer? Can you show us what is what? And keep on talking while, you know.
This is a contrast enhanced CT abdomen scan, sir, venous phase.
The liver is normal, sir. No SOL of the liver, no IHBAD is present. Stomach is grossly distended.
With the
Food residue is present.
institute.
Got a mass.
There's a thickening.
Yeah,
in the
keep on talking.
antropyloric region.
Ready? Tell me, what is it? See, you can't carry on seeing again and again and again. Twice is fine, maximum 3 times. After that, you need to stop. And the important thing is, carry on talking while you are having a look.
That's a heterogeneous mass lesion is present at the pyloric antral with thickening and the fat plane seems to be preserved in the pancreatic head. There is no SOL of the liver, no IHBRD. Stomach is grossly distended with food residue. Perigastric lymph nodes are present. No ascites, and also we have an celiac axis node also looks like. I'm able to appreciate it.
Fine. So, what order you would like to see the CT scan for the stomach, cancer? What should have in your mind?
First will
while
be
you
the
are-
T stage of the disease.
Yeah.
To look for the extent of the disease, any infiltration into adjacent organs.
See,
And-
this is common with all the cancers, isn't it? So for stomach, specifically, you want to rule out liver met. That's the
Liver
first
mets.
thing. Second thing, you want to see whether the tumor is resectable. Resectable means there is a good plane between the pancreas and the stomach. Good plane, if it is situated on the greater curve, there is a space between the tumor and the spleen. Okay. Transverse colon is safe. There is a good plane. That is what you need to see for local. And if it is situated above, close to the fundus, whether it's involving the diaphragm. This is broadly, isn't it? And then the lymph nodes. Whether it's significant size, where exactly the lymph nodes are, whether it will come in your dissection, whether it's in the range of D2, D3, what range is it? D1, D2, D3. Isn't it? This is broad concept. So what do you think in this CT scan? What do you think? On the criteria which I have told you. No distant mets.
No distance.
No distance.
Second thing is locally, how advanced the tumor is, can you take it out? That is second. Third is lymph node involved or not. Why it is important in this case is because he's got a gastric outlet obstruction.
Seems like a T3 lesion, sir. T3 lesion
Uh-huh.
and N plus and no distant metastasis M0.
What is T3 lesion?
T3 it's involving the subserosal layers.
Okay. T3 or D3? T3, yeah, T3.
T3
It's not involving any adjacent organ.
Okay, good. T3 and
N plus.
N plus. Which lymph nodes you are seeing?
From celiac axis lymph nodes. It seems-
Celiac axis. Is it celiac axis or along the left gastric?
Perigastric.
Left gastric. Perigastric.
Why it makes a difference? What are the station number
If,
of left gastric and celiac?
Left gastric becomes a D1 lymph node station. D1.
D1.
And celiac, it is the station
Left
number
gastric
7.
becomes
D1, sir.
D1. Left gastric.
D2.
Or D2. What is D1?
D1 is perigastric.
D1 now
1 to
is
6.
1 to 7.
1 to 7.
1 to 6.
1 to 7 is D1.
1 to 6 or 1 to 7?
1 to 7, sir.
1 to-
SS Japanese classification.
1 to 7 is?
D1.
So, left gastric is station number? 7. 7.
Seven.
Celiac is?
9.
9. Okay. What is 8?
8
Common hepatic. So, you think it is D1. It will come out in D1. Okay. So, ready to go for the surgery or anything else?
T3 you're saying, and it's a antropyloric. Supposing it's extending into the duodenum, what stage would it be?
It does not change the
T3
stage of
only,
disease.
it will not change the
The
stage.
lymph node dissection might change. We
have
have
to
to
take
see.
the-
It doesn't change at all, or if it
It will definitely change the
Change
plan
the surgical management.
surgical plan.
But-
Distal resection, whether it is possible or not, we have to check.
T stage.
T stage will not.
T stage won't change.
If it is
sir.
direct
Stage won't
spread,
change, sir.
If it is a submucosal spread, yes,
Will
it
not
doesn't change. But if it is a extraserosal spread, it
Then
would
it will
change.
But the trouble is you haven't seen the distal limit of the tumor on endoscopy. What from the CT scan can you see the distal and of the tumor? Sir, concern is, you know, if it is going into the duodenum, for how long?
Yes, sir.
Is it involving D2?
D2.
Because you go in there to do a distal gastrectomy
Land up
and
in
you
Whipple's.
can't go
We cannot.
to the distal edge of the tumor. See, he's talking about the practical thing which you all are forgetting.
Duodenum looks free, sir.
Normal.
So
Duodenum
it
is
is
normal,
important to see the distal. So show me where the tumor is, whether it's going into D1, D1 proximal or D1, D2 junction or D2. Is there any other test you could do to find which was suggested?
Can you scroll up slightly?
In the earlier
Can you
case.
scroll up?
It's a tumor, no?
Yes, sir. That
There
is
is a tumor.
tumor.
Yeah, okay.
In upper cuts, you can.
Can you show the duodenum? Where is the duodenum?
Duodenum.
Yeah, here.
Hmm?
Here.
Is it involved?
Duodenum looks free, sir. It looks like pylorus.
Yeah, it's okay. Hmm.
So it's ending at pylorus. Okay.
So you said celiac lymph nodes. Can you show me that?
No. Yes, this one. This one. This one.
Can we have a look at the report?
Okay, of the report. The PET CT. Yeah, tell what you are seeing there.
Heterogeneously enhancing lesion involving body and antrum of stomach.
Okay.
And FDG avid lymph node is there in, along gastrohepatic and perigastric region. Mild pelvic fluid is there. Cross-fused pelvic ectopic kidney in right renal pelvic region is there. And no distant metastasis here.
Okay.
So now is action time.
Do you justify PET CT?
It can confirm whether lymph nodes are actually positive, so it can.
See, if you were having a choice,
it will.
After the CT scan, if you had a choice between staging laparoscopy or the PET scan, which one you would have preferred?
Staging laparoscopy.
Do a PET scan.
Staging laparoscopy.
Sorry?
No, there is a difference of opinion. One said PET scan, the other said.
PET scan is non-invasive.
It is non-invasive. It can avoid an non-therapeutic laboratory.
It can avoid surgery.
Gastric
So we can
tumor.
avoid the anesthetic
What are the
complications.
shortcomings of PET scan and what are the clear indications for PET scan in a CS stomach, distal CS stomach?
PET scan will not be useful for mucinous tumors. They will poorly differentiated tumors and mucinous tumors. And signet carcinomas will not uptake PET. That will be the disadvantages of doing a PET.
See, once you have done a CT chest abdomen, what extra benefit PET scan will give you?
It will pick up less than 1 centimeter nodes in the liver. It will pick up less than 5 mm peritoneal deposits.
Is it going to make any difference surgically if it picks up a 4 millimeter node?
It picks up peritoneal deposits, then you can avoid, and it will be a metastatic.
Is it good in peritoneal deposit picking up PET scan?
No, sir.
What size
PET will
of
be more than 1
lesion
centimeter
will
only
pick up?
You
More than
already
one.
agreed staging laparoscopy is better. In any case, you are going to do that. So is PET going to be a redundant investigation in this
See,
case?
in this patient, what will be your
Staging laparoscopy.
plan?
Do a staging
Staging
laparoscopy.
laparoscopy.
Staging laparoscopy you will do. In staging laparoscopy, you don't find, I will give you two scenarios, okay? You put the laparoscope in one scenario, no liver mets, nothing, no peritoneal deposit or omental deposit. That's also laparoscopy picks up, which is difficult. Small peritoneal and omental deposit you won't see on a CT or PET. In 20 to 30% of the time, laparoscopy, if patient is not having a gastric outlet obstruction, you put a laparoscope in, you see multiple peritoneal deposit or omental deposit, or there is a ascites which you send it for cytology and it comes out malignant. So in 20 to 30% of the cases, you stop there. Okay. In this patient, you go in one scenario, no peritoneal deposit, looks pretty good. What surgery you will do?
We'll go for a laparoscopic D2 gastrectomy, distal gastrectomy.
Okay, laparoscopic D2
Distal
gastrectomy.
gastrectomy.
Okay. Second scenario, you go in, you find there is a significant ascites, there is a peritoneal mets.
We have to do a palliation of his symptoms. Patient is having a gastric outlet obstruction. We'll do a laparoscopic GJ or a feeding jejunostomy.
So you won't take the tumor out. Will you do a palliative distal gastrectomy or you will just do a gastrojejunostomy?
There is no role
Six
for
of you, what you will do one by one?
No role for an palliative resection or R2 resection.
Okay, fine.
A patient who had melena and some bleeding tendency from the growth.
Yes, sir, there we can do resection.
See, in this patient, what's his hemoglobin was?
8.6. You can do one hemostatic RT
Hemostatic
also for
RT.
this patient.
Sorry?
Hemostatic RT can be given also for bleeding tumors.
Is that a single value or he had any multiple transfusions? That also you should be looking into that.
Depends on the drop in hemoglobin.
Just
or-
8.5 may not be that active bleed or something. Okay, if you had multiple transfusions before, then you know that tumor is bleeding too much. Then only comes the...
See, even in lymphoma, where you don't normally do surgery, but you do surgery for bleeding and obstruction. So you need to see how much bleeding, how many times patient had transfusion in the past. And if it is easily resectable, palliative resection should be.
This patient is obstructed and but the nasojejunal tube is passed and the nutritional problem is temporarily resolved. What is the role of any preoperative treatment in this case?
The preoperative neoadjuvant treatment can be given, sir. Chemotherapy we can give on the basis of a perioperative protocol we can start. Based on plot regimen.
Is it better in distal or G junction?
More of
More in
G
G
junction.
junction tumors.
More of G junction.
But it can assess the tumor response and even especially in young patient, if we're planning surgery, better to assess.
But that is in the patient where gastric outlet obstruction
not.
is not present, isn't it?
Now the laptop feed.
Any questions from the faculty sitting here? Sir, any questions, anything?
Move on to the case capsules.
This is a case of a 51-year-old female resident of Hyderabad, homemaker by occupation, who came with chief complaints of passing black colored stools since 2 days. The patient was apparently alright 2 days back when she developed complaints of passing black colored tarry, foul smelling sticky stools. Patient also had complaints of dizziness and headache. There was no history of hematemesis, abdominal pain, jaundice, fever, loose stools or constipation. There is no history of dyspepsia, bloating. There is no history of loss of weight, loss of appetite, for which patient was admitted elsewhere and she received 2 units of blood transfusion, and following which she came to a higher center for further management. Past history, she has complaints of multiple episodes of large quantity bloody vomitus followed by passage of black colored stools 1 year back. She was admitted elsewhere and resuscitated with 3 units of blood transfusion and supportive care. She was advised to go ahead with upper GI endoscopy, but patient deferred it and has been asymptomatic till last 2 days back. She had history of LSCS and ectopic pregnancy surgery, but there is no significant personal or family history.
Yeah, can you summarize, or you want any extra history from this? Anything you want to know? You go to the next slide. Okay, from the history, like, you want to know anything else?
That previous episode, you have large quantities of bloody vomitor.
Yes.
So what exactly was the clinical situation? We can like to know the history that time.
It's given there, no? She was resuscitated, she was given 3 units of blood, supportive care.
Any other investigations done there?
She was advised upper GI will be not done.
So what is going through
This
your
patient is
mind?
vomiting.
What are the
vomiting,
things you want to rule out before you focus on what it is?
So what do you think it is? Like,
Upper GI.
1 year back, similar complaints are now. In between, I think she was all right, nothing was there.
Yeah, no complaints in between.
What do you think patient has? What are the things you will keep in your mind?
What can present like that?
Quick. It's a case capsule. We need to finish.
Something,
Gist.
something like
Some
a gist.
mucosal.
Just
Okay.
with ulceration on the mucosa.
What else?
What else? Yeah.
Probably peptic ulcer. We will ask for history of recurrent attacks of
What
pain or
else?
barbell.
No pain. I
What
think.
else?
There was no pain at all. Okay.
Variceal bleed.
Variceal bleed.
Yeah,
Variceal
very
bleed.
important.
But there is no history such.
No such
History of-
history.
and
Any
she's
other
a
vascular
female
thing you
and
can
young.
think of apart from varices? Any other vascular lesions you can think of?
Angio.
Angiodysplasia.
Like something like Dulophi, something.
Pseudopoise. Corrosive
Can have, no?
gastritis.
So you should have everything in mind. Although there is no history, but you know, patient haven't had any test done.
It's obviously a GI bleed.
GI bleed.
It's obviously
So
an
you need
upper
to
GI
have
bleed.
all the things
So what are
in
the
mind.
commonest causes of upper GI bleed? Is it that difficult? And relating to this particular patient who has a frank bleed 1 year back and now it's a slow bleed. So what are they, how does it narrow down to? This is the way you have to think logically.
You know, it's not a malignancy.
So what test you will do first?
First.
Upper
GI scopy.
Without doing the blood test.
Hemoglobin.
Come on.
Hemoglobin.
Come on. You will do straight away upper GI without doing any blood. Suppose if his hemoglobin is say 4, 5.
We'll transfuse first, then on.
So you have
And
to
you want to make sure LFTs are okay, PT-INR is okay, you rule out CLD, yes or no?
Yes.
So think na.
any examination findings, anything?
Examination was non-specific.
Even the, you know, if you refer to
Normal.
gastroenterologists, they won't.
Completely.
Examination is normal. Pallor, anything like that?
No pallor detected at presentation here.
Okay. So what do you want to do now?
CBC,
Blood
complete
test,
test.
yeah.
Complete blood picture.
Neurology.
Coagulation profile.
So carry on saying hemoglobin is 9.3. I was expecting bit low. Platelet is good. You know, chances of having a CLD is
Cirrhosis.
less. So keep on talking, keep on talking. Yeah. Next.
What do you want next?
What do you want next?
RFT, LFT, RFT.
LFT and RFT.
RFT and coagulation profile.
Yeah, you want coagulation? No.
Urea creatinine normal, sodium with hyponatremia.
Liver function?
Low albumin, but rest of it is not.
Okay.
Rest is okay. Yeah.
Your coagulation profile, of course, INR is normal.
Normal. Yeah.
Okay.
Now,
Go for upper GI.
upper GI endoscopy. Yeah. Wow. You know, just having a look, tell me what is it?
What is that?
Submucosal,
submucosal
bulge.
lesion.
Submucosal bulge extending into the lumen.
Huh?
Submucosal bulge.
Submucosal
bulge
lesion.
Which is extending into the lumen.
Yeah.
With a smooth appearing mucosa.
Most probably cyst.
What
Most
do you
probably
think
cyst.
it would be? What do you think it would be?
Gastrointestinal.
Gastric
Just. If I say, why not lymphoma? So tell me, endoscopy picture difference between the lymphoma and gist. Which layer gist comes out from? Which layer?
Submucosa just comes from submucosa.
So,
Muscularis
mucosa.
Muscularis mucosa or muscle?
Where does it arise from? What
See,
is the origin of
they-
this?
Interstitial
when you
cells
do
of cancer.
endoscopic ultrasound, there are layers. How many layers you know about?
5 layers.
Ah.
5 layers.
So which layer gist comes from, which layer lymphoma comes from? My question is very simple. I am not talking about submucosa, subserosa, this, that.
Yes.
You know which layer?
Muscularis.
Anybody else? Commonest.
Third layer, submucosa for lymphoma. Sir.
Third or fourth?
No, lymphoma or you are talking about gist?
Lymphoma. Sir.
Lymphoma, third or second?
Lymphoma from?
Lymphoma from second and
Second, yeah.
The third is,
from third.
third is muscle, no?
Yeah. Gist is fourth, most common,
Third and
lymphoma is second. So, on endoscopy, what are the features which will sort of differentiate?
In gist, there will be umbilications will be there,
Yeah.
sir.
Okay, what
And
else?
mucosa will be normal.
Is covered
Covered.
because fourth layer. Okay,
So what will you do with this now?
Sir, this we will do further investigations.
what further investigation?
Contrast analysis.
Will you take a biopsy?
Yeah, that's what I want.
Biopsy, sir, if the patient is physically fit and in contrast.
Endoscopy
is fit, no?
cannot pick biopsy from.
Sorry?
Bleeding chance is there, sir. There may be bleeding and
If you
we
are
can
take
go
biopsy for just US guided FNA from the
Yeah, US
US guided FNA we can.
Yeah. Will you take it or no?
If it is
For a
resectable
micro, for just less than 2 centimeter where we want to follow it up, we can take it.
If it is
differentiate.
resectable, no.
See, listen
For
to
this
me.
lesion,
Where
no.
exactly this gist is situated? Do
This
you know?
lesion not required. Biopsy is not required. for
No,
this
no,
lesion.
no. Where this gist is situated? What are the condition of the gist where you would like to have a biopsy?
already when there is mucosal ulceration, we can take a biopsy of the gist.
Uh-huh.
If size is less than 2
If
centimeters,
the gist is unresectable or metastatic, we are planning unresectable or metastatic gist. We are planning for
See,
neoadjuvant.
if you got a large gist close to the esophagogastric junction, will you do a total gastrectomy? Would you like to shrink it?
Yes.
Neoadjuvant.
Neoadjuvant
Yes.
imatinib.
So, size of the gist, location of the gist is very important. I had few patients close to the gastroesophageal junction, largest, gave it for 24 to 26 weeks, shrunk, saved the stomach. Otherwise, patient would
We'll go
have
for
had
total gastrectomy.
total gastrectomy. So this is the thing I would expect from you guys. You are not a MBBS or MS student. You are a MCA, you are going to finish MCH or DNB. And if you are saying you will not do at all, in all the cases you won't do. Or will you do? That is why I said you need to look at the endoscopy, you need to look at all the pictures, where exactly GIST is situated. If it is situated on the lesser curve, is difficult. On the greater curve, no problem. You don't need, you can just 1 centimeter margin, sleeve, done. On a lesser curve, gastroesophageal junction, if GIST is, going into the capsule of the pancreas, then also you would like to downstage it before you do the surgery.
So it's not the fitness that matters there. So it's the resectability and
the possibility of a preoperative treatment.
So if you want to give
whatever is the
preoperative,
condition, whether it is close to GE junction, the size of the tumor, very bulky tumor, or a involvement of the surrounding organs where you want to shrink it. See, all these would come under if
and
there is a
shrink it for how long you need to have in your mind. When will you do the first CT scan? After how many weeks? So as to see whether it's working or not working. You don't want to carry on giving without doing the scan, say after 1 or 2 months, and if it is working, then what is the ideal time?
6 months.
Ideal time
6 months.
6 months. It's 24 weeks to 30 weeks. Because if you carry on giving after 24 weeks to 26 weeks, it won't work. So these are the things, we thought we will get a knowledge from you. What is the current? What is the latest?
once you decide about biopsy, then you can think whether it's endoscopic or US guided. So it again depends. Okay. Fine.
Can I have the laptop feed?
Keep
what are
on
the saying?
talking,
What are they saying?
keep on talking. Where is it? What is it?
So where is the lesion?
In the
Lesser curvature, greater curvature.
Lesser curve.
Huh?
Fundus probably
Fundus.
originating from fundus of the stomach.
Greater curvature fundus.
Greater
But in
curvature
the
fundus of stomach. Greater curvature.
It's greater curvature.
Yes.
Okay. How much from this thing? G junction you can make out? Because you have seen in the endoscopy.
It is away from G junction.
Away from G
Away
junction.
The heterogeneity is there. Probably necrosis.
It's coming from lesser curvature, no?
Lesser.
Is touch.
No, sir.
No, sir.
Origin
It
from
is-
lesser curvature and going towards the initial.
Now go up. Yeah, okay.
It's peduncular.
Peduncular. So okay, from the greater curvature, it's greater curvature. Okay. So what and all you want to see? When you have seen the
Local,
lesion, the site
organ.
of the lesion, okay.
Any other site in local organ involvement?
Local organ involvement is there?
No.
Doesn't
No,
appear
it's
to have any
completely
local
free.
involvement.
Fat planes with other organs are free.
Okay.
And we can see whether we can resectability. or any distant metastasis.
Yeah, in a distant metastasis we have.
We can't. Liver seems free.
Notes?
Are you interested in nodes? Lymph nodes?
Just lymph node metastasis, less common.
Less common.
Do you take the lymph nodes out when you are doing a GIST surgery?
If they are not visibly enlarged, no need to do.
Can we have a report?
Next slide.
Anything else you would like to do? What is your further course of action? Whether investigation or straight to theatre, or you will discuss with anyone?
Anything.
What is your...
A tiny hypodense lesion they have mentioned. We have to discuss further what is the size of the lesion and what is the
size you can see 85 into 62 no sorry
liver.
Okay. Tiny hypodense. Okay.
So you have seen, no? What do you think it is? It's a cyst, I think it was, no? Okay, it's okay, fine. Go to the report, final impression. Can you just show the impression?
Final
impression.
Conclusion. Yeah.
Conclusion. Next slide.
Next slide. Yeah.
Conclusion was of gastrointestinal stromal tumor only.
Okay. The liver lesion, anything they might?
Liver non-specific. We evaluated with ultrasound.
It looks like cyst only.
So
nothing.
ultrasound was small cyst. Okay.
Fine.
So how do you proceed with this?
The one thing which I am, constantly seeing is hesitation.
Yeah. So what will you do next?
When the CT is shown,
It's already a large size tumor, more than 8 centimeters.
Okay.
So I would like to see the other high risk features.
So what high risk features you are
that
thinking?
mitosis.
How will you see now?
Biopsy. So previously when I was talking about biopsy, you were refusing it.
Is it resectable or not resectable?
Resectable, sir.
So then why do you need to know the high risk features now?
Is the size only
fitness
criteria?
assessment.
It's a pedunculated kind of
Surgical
tumor.
fitness assessment and plan for surgeries. Fitness assessment, surgical fitness assessment, and then plan for resection, sir. Wide local excision of features.
Fastest gastric. If it is right, left, non-critical.
So you want to do this thing, biopsy now?
No, sir.
No, not required.
The resectable patient, we can go with.
Go ahead with.
Did you do biopsy or not?
No, we went ahead with surgical extraction.
Okay.
So biopsy is not required, no? It's a resectable one.
Resectable lesion.
You'll get post-operative, you'll get the histopathology.
That will show mitotic.
What surgery?
What
you will
surgery?
do? And what should be in your
You
mind
said wide local
when you are
excision.
doing
What do you
the
mean by
surgery?
that?
With sleeve
Partial sleeve gastrectomy involving the, if it is
Can
from
you
the.
do sleeve if the tumor is situated posteriorly?
And
This is not on the greater curve.
And
Is
it's
it in
more
the
of-
greater curve?
More of endophytic, they said.
With 1 centimeter margin.
1 centimeter margin.
So what you do is a 1
1
centimeter
centimeter.
margin, and sometimes all is good. You put an endoscope, and put a 1 centimeter margin around, and you can put dye so
Tattoo.
that
Tattoo the
surgeon will
margin.
get an idea. That is one. Number two is posteriorly sometimes, if it is a big tumor, because you got a left gastric artery and vein, if it goes medially, then you have a trouble. Then you'll end up doing the distal gastrectomy rather than 1 centimeter margin. So you need to have all the things in your things, okay?
okay.
Laparoscopy, the drawback of this one is handling the tumor. You don't want
Tumor
to
rupture should
perforate.
not occur.
Because if perforates, then the stage is totally changed, okay?
Okay.
So you need to handle, not to hold it, just gently lift it, okay?
So what will you do after resection? Okay, you are now resected.
We'll see the biopsy, sir.
So what you want to look in the biopsy?
Do we have a biopsy?
Look, the
Number of mitosis.
Patient was just operated 3 days back. We don't have.
Now you tell what you want to see in the
And
high risk factors.
what
you
surgery
want to
was
see.
done?
Number of mitosis.
We excised it laparoscopically with endoscopic guidance once and posterior suturing was done.
That is what endoscopic guidance important, especially for the posterior tumor. If it is on the greater curve, you don't. You just pull it, staple it.
And endophatic, you will not be able to properly see even outside.
Because after the exam, you will start practicing, okay? So it's important.
So pathology you look at?
We'll do a CD117 c-KIT
So you
mutation.
need to get the IHCs also done.
ISC along with that.
FGFR dog
Okay.
And we have DOG1 dog 1 mutation.
Okay.
platelet derived growth factor.
So what will you do post-operative after that?
If high risk features are there, we will.
No, you are seeing. Does the size
Imatinib.
matter?
Imatinib. What is the high risk?
What is the high risk?
High
Does this
risk?
patient has high risk features or not?
No,
More than 5 centimeters.
Is there no?
Yes.
Okay. So the mitosis and all comes next.
Yes.
But already there is a high risk features for this patient. What will you do next?
You adjuvant
Imatinib 400
imatinib
milligrams.
for 3 years.
For?
3 years.
3 years.
36 months.
At least 3 years.
36 months.
At least 3 years. Okay.
Based on the exon mutations.
5 minutes.
Okay. Any questions from the faculty, or you want to throw questions to any one of us, or you throw a question, we will try to answer.
Is it same
as-
high risk factor size everywhere? Just
No, sir. Stomach.
Intragastric type.
Non-gastric is 5.
Non-gastric location there is
Why? What is the size there? Non-gastric.
less than 5 centimeters also if the mitosis is in between.
What is the high risk feature in non-gastric?
See which one you
stomach
are
is at
using.
five.
Yes,
Is
sir,
it
for
the
that
arm force one
less than
or
5
is it-
centimeter, but 5 to 10 in mitotic count, non-gastric location is considered
Small
high risk.
bowel, what is the high risk feature as a size?
Any size, sir.
See which one you are talking about. Is
2
it
to
the
5
armed
centimeters.
forces one or
2 to 5 centimeters.
2 centimeters. Okay. Sir wanted. Sir.
In the first case which you discussed, malignant gastric outlet obstruction, my thing is, if you do a diagnostic lab and gross peritoneal metastatic disease is there, I tend to avoid a gastrojejunostomy, particularly if there is gross ascites, and send the patient for endoscopic stenting, or if the jejunum appears relatively free, I'll do an FJ and come out, not do a GJ.
fully taken the point, yeah. Especially if there is a significant ascites and diffuse peritoneal mets, okay?
Yeah, please come to the mic. Use the mic.
Regarding taking biopsy, sir, lymphoma of stomach also can present as submucosal lesion, and the management of lymphoma is not surgery. The primary treatment is chemotherapy. So we should take biopsy now, sir.
See, I normally go for biopsy, but then a lot of institution and surgeons, if it is resectable, they don't do it.
Sir, lymphoma can also present with the same clinical features.
You are talking about first case or now?
Second case.
This cannot be a lymphoma.
Unlikely lymphoma.
Single exophytic, endophytic lesion like this, pedunculated, endoscopic, it won't be.
Unlikely.
Very unlikely.
Sir was only asking how do you differentiate it,
Unlikely
sir.
on gastroscopy, unlikely on CT scan.
And you don't see that free mucosa, what it is, what you have seen here, it's a lymphoma. Okay. And of course, you take a biopsy. You can take a deeper biopsies. What is that? Biopsy again, same place. You take a deeper biopsies. You can get the same. And surgery, chemotherapy depends again on the stage of the disease.
See, for me, if it is a small gist, at a position which is favorable to the surgeon, I may not do it. But if it is a large gist, at a unfavorable position, I will always get a endoscopic ultrasound and biopsy. That is what my normal.
See, if the same size tumor had a large base, then definitely probably you would have taken a biopsy. It's a pedunculated.
It's a small base, so that is the reason. Even before they said what they did, I said you need to put an endoscope in, and it should be a guided resection, 1 centimeter margin, and close it.
Sir, and role of
And they didn't do stapler.
In first case, sir, role of PET-CT in carcinoma stomach cases. According to NCCN guidelines, only esophagus and anus they are advocating PET-CT.
Yeah, I think sir asked the question, it was not answered actually. Sir, was any specific indication for PET-CT in CS stomach? Okay. So it's actually like if you have, so in this case probably the CT what I have seen, probably we would not have gone ahead with a PET-CT. But if you have some lesions which you think it can be metastatic, like a distant lymph nodes or something, where you want to know whether they are metastatic or not. So in such cases, actually the PET-CT helps. Otherwise, as a routine in a CS stomach, we don't do it.
It is locally advanced and you want to plan a neoadjuvant PET-CT.
You should not be diagnosing lymphoma in this case. The classic case of GIST only. If you haven't seen lymphoma and all, please go and see the endoscopy atlases. About all the stomach conditions and all.
Okay. Any more questions?
Good morning, sir. Regarding first case, in history, I heard there is non-projectile vomiting without nausea in cases of gastric obstruction. But I read it vice versa, sir. I just want to clarify. And second question is, what is the explanation for deranged LFT in that patient? Is it because of dehydration status and cachexia? That is my second doubt. And third doubt, in a case of antropyloric thickening, how to identify whether it is extending into D1? What is the landmark for D1 identification in cases where pylorus is thickened?
The LFT thing, I think even we don't have a clear picture.
Yeah, LFT, this was outside reports, and once we repeated it here, after he had come to us, then there was a normal.
So, of course, they did only, I think, hepatitis.
Lab error, that's one. And second was D1.
Yes.
So, sometimes if it is, you cannot pass the scope, then gastrographin is also good, so that it will pass and see the distal part of duodenum.
Now you are asking how do you evaluate or what you consider duodenal
radiological
extension?
landmark in cases of antropyloric thickening, whether it is extending into D1 or not.
The one you can follow on a CT scan, you can follow the gastroduodenal artery. Beyond that is the duodenum, when you can see anything properly.
Should we take like duodenal bulb air shadow or GDA?
GDA, beyond the GDA.
GD.
You won't in a distal gastrectomy, you don't do it beyond the gastroduodenal artery.
But that passes midway between the D1s.
See what happened when you are doing a surgery for CS stomach. Normally pylorus, it doesn't go through the pylorus, and normally you will leave 2 centimeter of the margin where your tumor is, isn't it? And 5 centimeter proximal, 2 centimeter distal. So if it is involving the pylorus and going into exactly there, you give a 2 centimeter margin. So you go half of the way.
Regarding
So 2 centimeter margin, that is what you need to take. And before you do the surgery, like I said, on a CT scan, like he showed, that duodenum was normal after the pylorus. If it is normal, then there is no problem.
And regarding nausea and projectile vomiting in cases of goo.
Yeah, what you want to know in that? What did you ask?
There is non-projectile vomiting without nausea in cases of gastric outlet obstruction, but I read it vice versa. Study. Gastric outlet obstruction is associated with projectile vomiting with nausea. This is what I have read, sir, but I heard reverse.
Sorry, I can't
understand
your question.
Okay. What projectile, what non-projectile you are talking?
No, sir. Gastric outlet obstruction, will it present with non-projectile vomiting or projectile vomiting? Or will it be associated with nausea or without nausea?
No, we consider non-projectile only. And there will be, most of the times there will be some nausea will be there because there is bloating sensation and all that. Patient will have some nausea before vomiting.
But I read, unless there is the neuronal infiltration, these patients will have projectile vomiting.
Generally speaking, the benign gastric outlet obstructions where the stomach motility is not disturbed, you may have a projectile vomiting. And generally it is projectile. Whereas in a malignant disease where it is an infiltrative problem, projectile vomiting is uncommon. Large vomits are also uncommon, except in prepyloric growths, which may mimic a benign obstruction. Otherwise, the nausea is not uncommon. Vomitings, short bouts of vomitings are not uncommon, but large retention vomitings are uncommon with infiltrative malignant problem. So if you understand the why a projectile vomiting, why not a projectile vomiting, you will have the answer.
See, like sir has said, if it is enteral, to close the whole thing to cause a gastric outlet obstruction, tumor will be big. If it is prepyloric, it's a small. If it is small, it will mimic as the benign ulcer. So it will have a projectile. But if it is a large tumor which is there at antrum, then because if it is infiltrative type, it will be non. Okay.
Thank you, sir.
Can we close?
Can I say?
Thank you, sir. Thank the faculty. Yeah, sure.
Sir, one question.
Regarding this LFT, not only hepatitis B and C, but vitamin A and E are now common. 10 people and now.
Sir, one question.
Viral negative doesn't mean other causes of viral hepatitis, other causes of viral hepatitis. And you should ask about the drug history also. Regarding the involvement of duodenum, of course, gastroduodenal artery is there. Yes. Sometimes it will project into the lumen. It will appear as duodenum is involved. You can take other markers also. Retroduodenally, you go this one, portal vein and bile duct, the first part duodenum and all. Also, you can take it as a marker and all. It will project into the lumen and appear as involving the lumen. It won't be involved actually.
Sir, I have one question.
Projectile vomiting, any patient has some vigorous peristalsis, they will have projectile vomiting. You can interpret it like that.
Sir, I have one question.
Yeah, please.
Sir, in case of CA stomach, if there is no gross ascites, is there any role for peritoneal lavage cytology?
Yes.
In all cases, we should do?
All cases, if you are doing a staging laparoscopy,
yes, sir.
like some of the center, they will do the staging laparoscopy first, send it for cytology, wait for the result, and then do the definitive surgery.
Yeah, okay. Yes, sir. If it comes positive, sir, should we go for surgery or we should treat it as a metastatic disease?
If it comes positive, what will it be? Will it be? So, do I have to answer this question?
Okay. Thank you, sir.
Excuse me, sir. Morning. I have one question regarding the gist.
Good morning, everybody. I am Dr. G.V. Rao. Actually, I head the Department of Surgical Gastroenterology at AIG Hospitals. On behalf of the faculty staff of AIG Hospitals and the Asian Institute of Gastroenterology at Somajguda, and on behalf of the entire IASG Executive Committee, a warm welcome to all the faculty members and all the students. We are glad that actually this is the 14th consecutive edition which has been going non-stop for the last 14 years. This idea was conceived by two people, Dr. Piyush here and Dr. Surendran, actually who is yet to join here. This was conceived almost about 15 years back to make sure that all the students who are going for the examination make their presence and then try to interact with the faculty across the country. Because it never happened actually, and the association also supported this concept. And subsequently the association also has shown that this interaction has helped the students to get through the final exam very successfully. So this has been documented, put on paper during the IASG meetings actually, and very thankful to Dr. Piyush and Dr. Surendran for this entire concept. We thank the industry partners, J&J and Sun Pharma, who supported this meeting very generously to make sure that the students and the faculty come here and have a good 2-day interactive session. I also take this opportunity to thank our operations team led by Mr. Capri and his team, who have done humongous work to make sure that the entire thing is coordinated. It looks very simple, but the amount of coordination that is required is very huge. And also I have to make a mention about Mr. Satya and his team of the academic cell, who have been coordinating with all the faculty, the students and all the other things that are happening. So thank you so much, Mr. Capri, Mr. Satya and all the teams for this entire coordinating effort. And I also thank my team actually who have been working almost the last 15 days actually to make sure they collect the cases and make sure that they're interacting with the students. A brief formal inaugural ceremony, we don't call it inaugural ceremony, basically it is a ceremony just to make sure that we felicitate some of the people. We have our Vice Chairman here, Mr. PVS Raju, who has been the backbone of this institute. Dr. Reddy is not here today. Mr. PVS Raju has been the backbone, has been supportive. And in fact, we call him the Dean of AIG Hospitals. He understands more medicine than most of the clinicians and the surgeons here in the hospital. Anything that he takes up to his mind, he makes sure that he reads up the entire thing, and he's got better understanding of the subject than most of us have. So can I request Mr. PVS Raju to come onto the stage, and can I request Dr. T.D. Yadav, Dr. Piyush to come here, and we have the President of the Society, Dr. Subhash Gupta, and the Secretary, Dr. Sujoy Paul, who are joining us online, and I also request Dr. Pradeep to come and join for the lighting and ceremony, please.
रिकित सिंह, ये भी AK शर्मा से ही पूछ रहे और उनको एक बार फोन करके पूछ लेना, मेरे से बात कर रहा
आरोग्यं धनसम्पदं शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदं शत्रुबुद्धिविनाशाय दीपज्योतिः.
We also take this opportunity to felicitate the senior members of our who have been associated with these clinicals right from the beginning. Dr. Surendran was supposed to join us. Piyush, can I request Mr. Rajgaru to felicitate Mr. Dr. Piyush Sani, please?
So I might have just shown an idea at some point in time, but GV Pradeep, you executed it to perfection in over 14 years.
लैपटॉप नहीं है प्लीज को पुट टू ज्वाइन कर लो जरा.
As I said many times, it is very difficult for a non-clinician to talk about any on a subject of medicine. Dr. Jivraj told me, this is a sort of a preparatory course for the MCH and DNB students before they take their final exam. So let me say a small anecdote. In our family, my maternal uncle was the first clinician. He did his general surgery, MS from Kurnool, and then he migrated to US. They used to tell me, it was a mandatory rule. In the first attempt, the MS student, you will fail in the exam. How the examiners do it is in a very different way. You have the long and short cases in the examination. So those days it was always, everything was private. In the Kurnool Medical College, the patients used to come with a unique disease or peculiar disease. Then they say that now they will keep them when somewhere hidden. They will ask them to come on the exam day, and it's a completely new case, and even the most brilliant student will falter, and they have an excuse to fail them. So I think by conducting these kind of courses, you are overcoming that problem, and I think now things must have changed, and a lot of people qualify in the first attempt. Wishing you all the best. Thank you.
Thank you, Mr. P.V.S. Rajgaru. Thank you so much for your valuable inputs for this. Actually, in fact, what started as a 25 students, actually, Pradeep will know that actually initially we didn't have much funding. So we could just get 25 students for the first batch of examination conducted 14 years back. Subsequently, the number started increasing, and this is a time when we have 100 plus students. Actually, almost all the students who are going for the exam have come here. Okay. Thank you so much again for all the faculty and staff. We have the president, Dr. Sujay Paul, who is the secretary of Indian Association of Surgical Gastroenterology. Sujay, you are online, Sujay. Sujay, just give us a minute. I think you're muted, Sujay.
Sorry. Thank you, Dr. G.V. Rao, for allowing me to be a participant in this function, albeit online. I apologize for not being there because I am committed to go to another program shortly. And I wish you and your team, I applaud your efforts. I congratulate you for pulling it off for 14th consecutive year, and I wish all the delegates and the students happy learning at the clinics. Over to you, Dr. G.V.
Thank you, Sujay. Thank you so much. Your presence would have made a lot of difference, but I know that you are held up with some other meeting. We have the president of our society, Dr. Subhash Gupta. Subhash also was unable to come because he's tied up with some work there. Actually, Subhash, you are online, Subhash.
Yeah, I can hear you clearly. So I think yet another sort of achievement by AIG Gastroenterology and patient students education, and I'm always proud to see the great work being done, and I'm sure this will go a long way in education of young students, and I wish you the very best. Thank you so much.
Thank you so much once again, Subhash. Again, for all the people who have come here, actually, we don't have a formal, this is the only place where you have this 100 plus students of your batchmates are meeting together. a month from now, you'll all be qualified surgical gastroenterologists. Suppose you want to have a reunion of this batch, it will be very, very difficult. So I think we'll have a photograph of all of you together sometime tomorrow. Maybe it will act as a big thing in the years to come, but I'm sure that you'll all pass out, you'll all become qualified surgical gastroenterologists next month, and you'll get into practice. And from all the faculty and staff, we wish you the very best. And yet take this opportunity to interact with the faculty. The faculty are very, very friendly. Please don't think that they have anything grouse against you to fail you in your exam. Absolutely, they're all very friendly with you. And the other thing that happens in this clinic, actually, Dr. Pradeep, who has been very supportive of this, actually for our entire academic work, actually, if you see, the academic work at AIG is being totally done by Dr. Pradeep. So can I request Dr. Pradeep to come and say a few words, actually, what has been his experience, and subsequently we'll just break for a short tea break, and then we'll have the next session going on.
So thank you, Dr. GV and Dr. Reddy, who made this possible for the last 14 years. The initial objective of this was like we had a meeting with Piyush and Surendran. Actually the whole thing started suddenly when I was an examiner at Chennai Apollo, because few students asked me that they wanted to come to AIG before the exam. So I said, why do you have to have this thing? So I said, some of the institutes, they are not having a regular program, teaching program, we wanted to have this. So I said, if it is your objective is only that how to approach the exam, then we discussed with Piyush and this thing. So why not we have at least before the exam, some sort of clinics where we cover all the cases which they probably will face in the exams, and interact with the senior faculty across India, because most of them have the experience with their local faculty, but they don't have an exposure to the outside their hospital. So that is the idea with which we started this, of getting them before the exam, because that's the right time, because they would have read the theory, they would have known, so they can comprehend quickly what is the approach, what are the controversies, all these things. So with that in mind, we started this 14 years back, and we had a feedback after 4 years or 5 years, we had a feedback from the national board. So then it was, whether it might be attributed to this or might be some other factor that the students are much brighter nowadays because of the competitive exams, but we found the pass rate definitely has improved, and then after that we continued this every year. And I'm sure now SGPGI is coming out with another. Initial plan was that we conduct 1 clinics in the North India and 1 clinics in South India. The reason was that because the disease spectrum is different in both areas, so the South Indian students can go to the clinics being held in North India, and the North Indian students can come down to South India. This is the concept with which, unfortunately, we couldn't get a good institute at that point to actively participate. And from now on, I think the IASG team has, the secretary and the president are proactive, and the first clinics we had from All India Institute, GB Pant once, I think when Piyush was there. So after that, we didn't continue further. We had missed out on few occasions, and I think again, Rajneesh has restarted that, and I hope that this 2 sessions of clinics will continue in future as well. And all the best for you for your exams. Thank you.
Thank you, Pradeep. Very rightly said, because there are about 130 students who are taking exam every year. So we're trying to see the associations trying to see how the students can interact with the faculty. So there's been a great effort, and the second session of this will happen in SGPGI. Dr. Rajneesh is doing it actually 2 weeks from now. Again, I'll fail in my duty if I fail to acknowledge 2 of my people who have been doing this entire job, the great job. So all the credit of this organizing thing goes to Dr. Mahesh Shetty and Dr. Shreyesh Modak. So all the credit is theirs, and whatever lacunae that you have, myself and Dr. Pradeep will take. So kudos to both Shreyesh and this thing. Actually, the other staff members are also helped actually, but these people are the ones who have been interacting with the students continuously to make sure what is required is being translated. Thank you so much once again. I can have a break for a quick 10 minutes and then join us back for the next session. Thank you so much once again.
Thank you, sir. That's a great encouragement. We'll have a quick 10-minute break. I want everybody back into the hall in 10 minutes. Thank you.
Check. Hello, check 1 2 3. Check mic check 1 2 3. Hello, check. Check. First didi. Hello.
ప్రవీణ్ ఇది టూ నుండి వస్తుంది చూడు, ఇది టూ కదా,
మైక్ చెక్ 1 2 3.
ఒక్క నిమిషం చెక్, ఇది చూడు 1 అంటే పెడర్ల దాంట్లో 2, దాంట్లో 2 చెక్ 1 చెక్ 1 2 చెక్ check 1 2 mic check 1 check 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 1 2 1 check check 1 2 mic check 1 check check 1 2 3 check mic check check 1 2 1 check check 1 2 1 check check mic check 1 2 3 check 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 1 2 1 2 3 check mic check 1 2 check 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 1 2 check 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 1 2 check mic check 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 1 2 1 check 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 Mic check 1, check, check, check. Check 1 2 check. Check 1 2 1 check, check. Check, check.
Hey, 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 check, check. Hey, hey, hey. Hey, 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 check. Hey, 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 check. Hey, check, check. Hey.
Check, check, 1 2 1 check. Check 1 2 1 check, check. Mic check 1 check, check.
Check, check, 1 2 check. Hello, hello, check, check 1. Check, check. Check, check 1. Hello.
Check 1 2 1 check, check. Mic check, check, check 1 2 check. ఇంకా లైట్గా వస్తుంది. Check 1 2 1 check, 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 check. ఇట్లుండను ప్రవీణ్, ఇదే ఉండను. చెక్ మైక్ మళ్ళీ పోయింది. చెక్ చెక్ మైక్ చెక్ 1 చెక్. ఇది ఉండను ప్రవీణ్ ఉండను. ఇది చెక్ చెక్ మైక్ చెక్ 1 చెక్. మళ్ళీ చెక్. ఇంతకుముందు బాగుండే. ఓకే, ఇది ఓకే, మామూలుగా మాట్లాడడం అంత అందరు చిన్న కానీ
చెక్ చెక్ చెక్. హలో,
అవి మనం కట్ చేసుకోవాలి. స్పీకర్లు అవి ఫిక్స్, అవి చేంజ్ చేసి
చెక్ 1 2 3.
అది చేసేసినాం లేదు కానీ వాళ్ళు మాట్లాడరు ఎక్కువ. అది
చెక్ 1 2 3. హలో,
చెక్ 1 2 1
చెక్. ఇది తక్కువ వస్తున్నట్టున్నాయి బాగా. అసలు వస్తుంది, ఇది వాయిస్ వస్తుందా స్పీకర్కు?
ఏ స్పీకర్?
ఇది
వస్తుంది, మాట్లాడండి. నీకు వినపడదు.
1 2 3. హలో,
మాట్లాడుతుంది.
చెప్తున్నా మీకు
గట్టిగా మాట్లాడు, నీకు వస్తుంది.
హలో, చెక్ 1 2 3. హలో, మైక్ చెక్ 1 2 3. హలో, తక్కువ వస్తుంది బాగా.
తక్కువ అంటావా? అప్పుడు పెంచుదాంలే.
ఇప్పుడు గెస్ట్ ఇంత గట్టిగా మాట్లాడరా? ఏం నార్మల్గా మాట్లాడదాం.
పెంచు ప్రవీణ్. 11 అనుకుంటా చూడు.
13 ఇది.
ఏది 13?
ఇందులో 13 ఉంది. హలో, చెక్ 1 2 3.
13 కానీ ఫెడరల్ 11 కానీ
1 2 3. హలో, చెక్ చెక్ చెక్. హలో, చెక్. నాయిస్ వస్తుంది చూడండి.
అది అక్కడి నుంచి కోడ్ చెప్పండి. నైస్.
చెక్ మైక్ చెక్ 1 2 3. హలో హలో హలో, చెక్ చెక్. పెంచాలి బ్రో. హలో, చెక్ 1 2 3. హలో, చెక్ చెక్. ఇది ఓకేలే, ఇది ఓకే. కొంచెం తగ్గించుకున్నా పర్లేదు, ఒక్క నిమిషం. చెక్ 1 2 3. హలో, 15 చూడు ఒకసారి. 15 ఇది 15. చెక్ 1 2 3. హలో, వస్తుందా? బాగానే వస్తుందా? ఏదో బాగానే వస్తుందా? ఇది చెక్ 1 2 3. హలో హలో, చెక్ చెక్ చెక్. మైక్ చెక్ 1 2 3. చెక్ 1 2 3. చెక్. హలో, చెక్ 1 2 3. 14 ఇది. చెక్ చెక్. హలో, check, mic check, 1 2 3. Hello, hello, check, check. అదే హమ్మింగ్ లాగా వస్తుంది కొంచెం. చెక్ చెక్ 1 2 3 మైక్ చెక్ 1. అంత గట్టిగా అలా చెక్. వాళ్ళ గెస్ట్ ఇంత దగ్గరకు వచ్చి మాట్లాడదు కదా మామూలుగా. ఇప్పుడు మన ఈ లెవెల్ నుంచి మాట్లాడతారు గెస్ట్. హలో మైక్ చెక్ 1 2 3. హలో చెక్. ఓకే, టైం అయిపోయింది, వదిలేసి.
Session 3 students are requested to sit on the front seat.
Small request, please keep your phones in silent mode and please don't take calls inside the hall. For this session, I would like to request Dr. Nagesh, Dr. Venugopal, Dr. T.D. Yadav and Dr. Pradeep R. Dr. Nagesh and Pradeep R will join shortly.
Should we start or we should wait for both of them?
They'll be here in a minute, sir. We can start. And please speak into the mic so that other people can hear you.
Good afternoon, sir. Shall I start, sir? So, please start. Who is going to take the case?
I am presenting history, sir.
Okay. So, start, please.
Good afternoon, sir. My patient is a 47-year-old female who is a resident of West Bengal, homemaker by occupation. She presented with, she was apparently all right in till October 2024, where she developed an episodes of hypochondriac pain for which she was evaluated and found to have cholelithiasis. She later underwent laparoscopic cholecystectomy on 24th of October 2024 in local hospital at West Bengal. The duration of surgery.
What was the date of surgery you told?
24th October 2024. So the duration of surgery was about 2 hours. There was no history of any intra-op transfusions, and she was told about an intraoperative injury which was repaired laparoscopically only. So the drain was kept and later she was shifted to ward. On post-operative day 1, greenish output was noted from drain, which was amounting to about 300 to 400 ml per day. On progressive days, there was an increase in drain output, and on post-operative day 4, she also had fever with abdominal pain and abdominal distension. And she was transferred to ICU, and a call was taken for an emergency laparotomy. The emergency laparotomy was done on post-op day 5, and wash was given and 2 drains were placed. So the initial output from both the drains were greenish in color, amounting in total to almost about 400 to 500 ml per day. So she was monitored in ICU, given IV medications, and was later discharged after 10 days when her symptoms subsided. At discharge, she only had vague abdominal pain. About 10 days later, there was spontaneous expulsion of the right drain, and followed by 4 days later, she developed an episode of fever with chills, and she also noted an yellowish discoloration of eyes. She also noted her stools to be whitish in color and also high colored urine. With these complaints, she was referred to a tertiary care center at Hyderabad. Here she was evaluated with blood investigations, and also she underwent few radiological investigations. So here she underwent an ultrasound guided tube placement. So following tube placement, about 1 liter of greenish output was drained, and gradually the output was measured, which was almost about 400 to 500 ml per day. Over the course of 4 to 5 days, there was symptomatic improvement with decrease in yellowish discoloration, and gradually her fever also subsided. So she was now discharged with the drain in situ, and gradually her symptoms subsided. At present, she does not have any yellowish discoloration of eyes. Her stools are yellow in color, and she has occasional itching at night. She does not have any fever. There is no history of GI bleed, no history of any abdominal pain at present, no history suggestive of any dry eyes, decreased night vision, and no history. There was almost loss of weight of about 7 kgs in the last 2 months. She was initially 63 and now it is 56 kg. And there is a history of loss of appetite as well. Moving on to past history, she is known hypothyroid, now thyronine about 100 microgram per day. She has underwent history of laparoscopic cholecystectomy on 24th of October and laparotomy and lavage on 30th of October. She was told of about biopsy report of gallbladder, which was negative for malignancy. There is no history of similar complaints in past. Personal history, she consumes mixed diet and her sleep is not disturbed. Bowel and bladder habits are normal and regular, and she has no history of any addictions. Family history is not significant. So summarizing my case, she is a 47-year-old female who underwent laparoscopic cholecystectomy on 24th of October for symptomatic cholelithiasis. And she was informed of an intraoperative injury which was repaired laparoscopically. But on post-operative day 1, she noted bilious output of drain was noted, and gradually which increased in quantity, and she also developed symptoms suggestive of peritoneal sepsis, for which she was underwent laparotomy and lavage on 30th of October, and followed by which there was continuous drain output noted. And following spontaneous expulsion of drain 2 weeks later, she developed symptoms suggestive of obstructive jaundice with cholangitis, for which she was evaluated in tertiary center with radiological investigations and few blood investigations, for which a tube was placed under ultrasound guidance, which drained about almost 1000 ml of greenish output. Is possibly a percutaneous drain, PCD, and followed by which her symptoms resolved. At present, she is anectoric and not having any fever, and she is passing colic stools. and does not have any feature suggestive of sepsis at present. So my diagnosis would be a post-cholecystectomy biliary injury with controlled biliary fistula with good liver function and not in sepsis.
You did not tell about what is the this PCD. So you said some percutaneous tube has been placed.
Yes.
How much is the output at present?
Sir, at present it has gradually decreased, sir.
No, decrease means what? It is 100 ml. It is 200.
No, sir, at present it is not draining anything. The output is nil. It has been clamped when I examined the patient.
Tube has been clamped.
Sir,
clamped.
Yes, sir. It has been clamped.
Okay.
Nil since how many days?
Nil since almost 4 days. 4 to 5 days, sir.
So, is it the same? Suppose if this patient you would have done the lap chole, you will proceed in the same way, or you will manage it differently?
No, sir. I would have given a good wash and then kept a drain and then referred to a tertiary center which will have facilities of an expert HPB surgeon available and also intraoperative cholangiography available.
So that means all biliary post-chole biliary leak, you have to explore and do a lavage?
No, sir. So I would agree with the initial period where they observed for 4 days to see the quantity of drain output. But later on, once she developed fever, I would have repeated one more imaging, especially ultrasound, to see for any undrained collections, and then I would have inserted a PCD instead of going directly for laparotomy.
So your decision for laparotomy depends on?
So it depends upon the general condition and also on vitals.
Okay.
So if she's hypotensive and unstable, and then in that case only when there is peritonitis evidence, then we go for lavage, and it can be done in laparoscopy also. So laparoscopic lavage is also possible.
Before going for the laparotomy, what are the things you would like to know? It was day 4.
Yes, sir. So
why are you saying a patient is unstable? Day 4.
Sir, but with what I've asked, she was transferred to ICU, sir. Before taking into the surgical theatre, she was transferred to ICU. Maybe with that I can infer she might have been unstable before being shifted to the ICU. But I would have seen CBP, LFT, and also observed the vitals and then the drain output, the amount of drain output over the course before taking the decision.
What type of imaging we would like to have before contemplating for the exploratory laparotomy? You know, the number of operations make the further final operation much more difficult. So what are the type of investigation you would like to have in your armamentarium before contemplating laparotomy?
During that time, sir?
Yes.
I would have gone for ultrasound, sir. Simple ultrasound to see for any undrained collections, because the concern of that was to control the sepsis.
I think you have an interesting history here, if I'm right. You said the lavage was done, drain was placed, patient had increasing bilirubin,
Sir?
increasing jaundice.
Yes,
after the first drain, then the patient came here, they put a pigtail and then...
No, sir. She underwent lavage and 2 drains were placed. So initially the output was gradually decreasing. But on about 10 days later, spontaneously drain
slipped out.
It came out. 4 days later, she then noticed yellowish discoloration of eyes with fever.
Because you give an interesting history of clay-colored stools,
yes,
high-colored urine.
Yes,
Why do you think? What do you think the reason there is?
So she was told of an intraoperative injury. I am thinking that partially
we're talking about
partial injuries.
We're talking about after expulsion of drain before PCD.
Yes, sir.
Patient developed jaundice, clay-colored stools, high-colored urine, and all that.
Yes.
So what do you think the reason could be?
There are 2 possibilities, sir. So first, it might be an bilioma. It was a controlled biliary fistula when the drains were in situ. The bile was being drained out. But once drains were expelled, since the fistula is not formed at 10 days, the bilioma might have formed, which might have compressed the biliary duct. And second possibility is the stricture might have progressed, which was initially partial.
But jaundice is gone. After putting PCD, jaundice is gone.
Yes, sir.
So I mean to say, how many cases you see a collection causing clay-colored stools and high-colored urine? So you have to be very careful when you're asking history and presenting. This is examination, isn't it? So you can't be more theoretical. So I don't think we have seen any bilioma causing clay colored stool, high colored urine and all that. You don't have to be very so specific. Okay, now patient had bilioma, increasing jaundice, then we have drained, it has come down. Okay, yeah.
So what about, since the beginning you were talking about greenish discharge?
Yes.
How do you think it is possible? Are we missing something or what? Greenish discharge, what is the color of the gallbladder bile and common bile duct bile? Gallbladder is gone now.
Yes, sir. Gallbladder is gone, so it's probably infected bile which has collected in the abdomen. That is greenish in color, but the hepatic bile will be golden yellow in color, sir. Since it is now collecting into the abdomen, it might have got secondarily infected, and that's why we are missing that golden yellow bile.
But infected bile should not be green. Green, there has to be some region the bile gets activated to
maybe there is some enteric injury also, bowel injury.
Now summarizing your history now, with all this history you told me, what could be the reason? What is the type of injury you are looking at in this patient?
So there is possibly a transection of extrahepatic biliary tree.
Then why the drain output has come down? It is dry.
So that is, it was initially transection and now the stricture has formed, sir.
And you say there is no bilirubin, there is no rise in bilirubin, there is no jaundice.
Internal fistula might have occurred, sir.
Sorry?
Internal fistula might have occurred.
Number one, then?
Or it might be a partial biliary injury with internal continuity, which has been there.
Number two, then?
Segmental ductal injuries.
Or it can be a segmental injury.
So it is very difficult to accept partial injury leading to complete disappearance of the jaundice, because there is a stricture, even a small amount of bile goes. There has to be recurrent, if not jaundice, there has to be recurrent fever or recurrent pain abdomen little bit and low grade fever. That is what we call it, that more dangerous for the liver because of the recurrent fever, and it is neglected because it's not that progressive jaundice. So partial injuries are internal fistulae. Both are dangerous in a way that it damages the liver without jaundice getting higher.
Yes.
So in the first instance, as you said, there was a re-exploration, and in the beginning also there was some repair was done and a drain was put. So you don't know what repair was done. That repair was done laparoscopically only.
Yes, sir, laparoscopically only.
So that repair was done laparoscopically. So yes. what that was Sir was asking, what would you do at that time?
Sir, if the expertise is available, and then since it is recognized immediately intraoperative only.
No, you tell what you will do.
I would have sought a second opinion and do intraoperative cholangiogram, then look at where the site of injury is and what is the extent of injury, and then accordingly plan later on, sir. So if it was a small duct, subvesical duct, or it was which was a small injury, less than 1/3 of circumference of the bile duct, then primary repair would have been suitable in such cases. But if it is involving more than 1/3 or
no, it's not that straightforward. You are making it very simple looking. Intraoperative identification of the bile duct injury.
Yes.
First of all, is everybody competent enough at your stage to do a cholangiogram laparoscopically?
No, sir.
So at your stage, all of us, everybody would like to listen that I would first convert, assess the area. I try to look into what are the thermal damage done all around, what are the extent of injury, it is a total transection, is it some avulsion, as you said, it's not very easy to go and try to find out right duct injury or sectoral duct injury. So you can only see bile coming.
Yes.
Then you have to put a tube, do a good cholangiogram, open this thing, and then comes the question of expertise available or not. So first and foremost important thing is proper evaluation of the injury at the time of the surgery. Then only you will take a decision. So whether somebody is available or not available, then your assessment and the documentation. So intraoperative bile duct injury management had lots of spectrum. It's not so easy that laparoscopically. So I wanted to know for everybody, for all of you in the exams, if you tell that, sir, at my stage, I will go and convert and try to properly evaluate. Convert with not a small incision. So we always tell everybody that when you are converting, generous incision should be given, so that you do a very proper evaluation. Don't be miser about the incision. So you first go and inform the patient, take a consent, tell them that there is a problem, we are going to handle it. And then if you are asking about calling the colleague, proper identification of the injury, do a cholangiogram if there is no transection, complete transection, and try to see for the injury. Cholangiogram only required when you are not seeing the transected duct. Usually it is a main duct injury. So you need not to have a cholangiogram that time. But if bile is coming, you are not able to see from where and what is the extent of injury, then you do a cholangiogram. And then all the question comes whether I should repair primarily or not primarily repair. So this is very, very important at your stage at the time of the exam, proper evaluation. And then you proceed. Sir?
Would you like to talk to the primary surgeon? Because at this point of time, patient has come to you. If yes, what are the things you would want to know?
Sir, I would like to know what was the pre-operative imaging done, if any, and what was the indication for surgery. And then
you told indication that she had a pain abdomen. You only told, na?
Pre-operative investigations I would like to see.
What investigation you would like to?
So what was imaging done and what was the LFT report?
Ultrasound was done. There is a few stones, a thick wall gallbladder, and CBD is normal. Now?
So then I would like to ask about intraoperative details, sir. Or any
So
video,
the
video
better answer is that I would like to review the video.
Video.
This is the answer. So for a small answer, you don't try to make a history. I would, if available, you can ask the surgeon, but request him to see the video so that you can clearly see. See when you are seeing second time, like everybody said, see your own video so that you can assess at what point of time you were rude. So you go and see the video. Video will tell you whether this type of injury occurred. Most of the time, whether some intestinal injury also have occurred. It's not only that only bile which occurs. So if in the first go there is a bile which is coming, activated bile, then there may be a chance that there is a bilioenteric injury, which is not uncommon. Recently only we have operated 2. One is sitting in the ward. Acute injury, ileostomy has to be done.
So primarily you should say, I would want to know the level of difficulty the surgeon faced during the surgery, and also was there any confusion about anatomy of the biliary system. Third thing is, was there any associated vascular injury which they were trying to, most of the times apart from primary injury, to control a vascular injury, they would also do bile duct injury. Okay, these are the things you should know, and the color of the bile, and these are the things, duration.
So, and you said that you would do an ultrasound before you decide for the exploratory laparotomy for a drainage.
Yes.
I think ultrasound is not a good investigation in a post-operative abdomen on day 5. CT is a better investigation for planning your laparotomy, right? Because you said you are telling...
She was unstable at that time, sir. She was unstable at that time.
Yeah,
bedside
but ultrasound is not a good investigation to this thing. CT is a better investigation. Nowadays you can do a CT, so that will give a better... because post-op abdomen is very difficult to do an ultrasound. So one is ultrasound would be the better for planning your exploratory laparotomy. And ultrasound of course is operator dependent. The other thing you said is when you explore, it is at your stage from exam point of view, you should say, I don't attempt any repair, you just toilet and drain and come out. So what are the situations where you can do something even if you are not experienced? Is probably a cystic duct leak, if you can see clearly,
then we can
you can just ligate that cystic duct, but nothing to do any type of repair at your level. You should be safe in the exam by answering this. I won't do anything at day 5, right? Day 5 you are going in, right? So you don't operate and try to repair and all at your level. You should be tell the examiner that I'll just do a toilet and drain and come out.
Not only that, even at day 5, even there are multiple, you must read all those articles, different trials, different trials where it has been clearly shown that the early repair is not good. It's excluding intraoperative. Intraoperative is different thing. It's cost effective and this thing. But when it goes to 24 hours and beyond, then should not be operated. Our aim is to make a control
the sepsis.
That is what is the control fistula. So all of you should answer the question. You are only one person answering. So there were multiple things. Then what do you think that second tube was placed? You are saying that there was a cholangitis. The second tube which was placed was what?
It was PCD, sir.
So PCD.
Yes.
So PCD was placed because there was a slipped out this thing, which
Yes,
can
sir.
also produce the fever with the chills and rigor.
Yes.
So doesn't
Infected bilium.
it's not something that once there is a person is having fever with chills, it is only cholangitis. If a person where there is a drain which has slipped out and patient starts having fever with chills, the first important thing is
Infected
go and
bilium.
examine the abdomen.
Yes.
And then our diagnosis, everybody's diagnosis would be that this is a undrained collection which has collected because of the slip drain.
Yes.
And that's why probably PCD was put, and then drainage has occurred and the patient has these problems have gone.
So one more thing, as Nagesh and me were discussing, your past history, again you started telling about the gallbladder surgery. See, whatever is connected should be in the present history only. You won't get again a gallbladder surgery because it is in the present history. Because sequence of events, the present problem is related to that only. So why again you got the past history? It does not come here in the past history. Past history, if anything unrelated to this you want to bring in, yes, you can bring in. Right? All of you should know that.
How would you proceed now?
Examination.
I would like to do examination. On general examination, she is a middle-aged female, moderately built and nourished, well oriented to time, place and person, conscious and cooperative. Height is 160 cm, weight is 56 kg, BMI is 22 kg per meter square. And patient
Come
was
closer to the mic.
Patient was examined in supine
Just
position.
Pull the mic towards you. Pull the mic towards you.
Patient was examined in supine position. There is no pallor, no icterus, no cyanosis, no lymphadenopathy, no pedal edema. Vitals, pulse is 80 per minute and blood pressure is 110/70 measured in right upper limb in supine position. Respiratory rate is 18 per minute and saturation is normal. There is no stigmata of chronic liver disease, no signs of dehydration, no signs of any scratch marks. No signs of any malnourishment. And on perabdominal examination, on inspection, abdomen is flat, central and inverted umbilicus, and percutaneous tube is noted in the epigastric region, which is currently clamped, and there is yellowish green color tinge over the tube. And midline laparotomy scar is seen with standard laparoscopic cholecystectomy port side scars in the right subcostal margin. And then there is no visible fullness. All quadrants moves equally with respiration. No visible or engorged veins seen. And groin and renal angle looks normal. On palpation, abdomen is soft and non-tender. Liver and spleen are normal. There is no organomegaly and no palpable cough impulse. On percussion, liver span is 12 cm in mid-clavicular line with upper border in the 5th intercostal space. Rest of the abdomen is tympanic. There is no evidence of any free fluid inside the abdomen. Auscultation, normal bowel sounds are heard. On digital rectal examination, perianal skin looks normal. No fissure or fistula. Normal sphincter tone. And gloves stained with yellowish colored stool, colic stools, and there are no evidence of any growth or deposits.
So do you suspect growth deposits in this patient?
No, as
a protocol?
As a routine.
It's not required. Actually, it's not required. It's a cumbersome procedure. Nobody would like to have it. When in the setting where he has already told that the histopathology has come to be, I think you told that
Yes,
it is benign disease.
Yes, sir.
So just did you ask for stool color? He said she's passing yellow color stool. So all the more reason that you don't want to confirm that there is a stool which clay color or not.
Okay.
Huh?
So you should not mention liver and spleen normal.
Yeah.
It is words you should use is proper words, right? Spleen not palpable is what you can see. If you are not liver not palpable, you can make a decision. Or if you do liver span, you just say no hepatomegaly, right?
Yes.
So how do you know it is normal? Right? You should say it's palpable or not palpable. So when you use these words, you should be very careful in what you mean, right?
Yes.
So now would you like to, everything is fine with the patient as of today?
Yes, sir.
Would you still like to evaluate further? What's the patient present complaint or problem?
She has right now she said she's having drains, like tube is placed and it is clamped.
That has slipped out, no? You said?
No, the drain, nothing is coming out. He said 5 days, there is nothing coming out. Patient asymptomatic, normal colored stool. That's what he is absolutely right in asking. So patient is perfectly all right now, but nothing is coming to the drain, he says.
Drain is there, but nil.
Nil. So you can just pull out the drain, no? Why do you want to evaluate or you don't want to
I
evaluate?
want to evaluate, sir.
Why? That's what he's asking.
Post injuries, there can be stricture and
Clinically, there is no ictness, isn't it? Yes, if you want to evaluate, do what?
specific
Why do you want all that?
investigation. I want LFT, sir, and PTINR to look for liver any coagulopathy or not.
Yeah, before that you want to do anything? Like
Sir,
said to see the video,
Sir,
anything else you can
complete
check?
blood count I want, because I want to see look for total counts. If she
No,
is
first you should go
Counts
through
normal.
all the reports, previous details.
Yes, sir.
You want to see? You want to see?
Yes, sir.
No, why do you want to evaluate? First we justify that. Patient is asymptomatic, you said. Tube, nothing is coming out of the tube. You did a parectal examination, you said normal colored stools. Are there any symptoms now, right now, patient?
No symptoms right now, but
Yeah.
this indicates it possibly of
So
internal
there is no
fistula.
symptoms, he says. So why should you investigate is what the question is. First you decide that, why you want to investigate, then we'll go further.
Minor stricture, if it is there, then it can lead to cholestatic cholestasis and
minor
then
stricture is what?
cirrhosis of liver.
Is there something described as minor stricture?
So there was clear in history of biliary injuries, and it was probably
All
she
those things
has
we
an
know.
internal
We want
fistula.
to know from you that why you want to evaluate now.
So she
Don't
can
go
be
in back history.
asymptomatic.
You don't tell other people. You should answer. Why you want to evaluate?
Sir, in this case, by history, there is a bile duct injury. We have to further evaluate to grade the injury and what is the clinical course of the disease. So it can cause complications.
Though the clear-cut documented bile duct injury, so I want to know whether the continuity of the bile duct is improper. And in this case, there is no jaundice. There may be internal biliary communications also there. So I want to know the clear-cut picture of the anatomy.
Okay. You please.
Sir, though the patient is clinically asymptomatic, but subclinically there may be some course of the disease will be progress, and later presentation will be advanced presentation. To rule out that, to evaluate and
you.
I want to look for any associated vascular injury.
The patient is asymptomatic, man. No jaundice.
Now you are thinking about vascular injury.
To plan for surgery.
Why would like to do surgery in a normal patient?
Basic.
First, we have to evaluate for the grade of the injury. Sir.
No, why? He is asymptomatic. No itching, no jaundice. Everything is fine.
Long term,
Sinus come
patient
down.
may develop later.
Basically, you will have to document.
So very important that I was asking him how many days now it is that tube is clamped. So still there may be some collection pending there, and as everybody is saying, you cannot send this patient home without documenting that what type of damage has occurred. So is there a bile duct injury, or still we are dealing with the intestinal injury because of the pigtail has done everything? Probably they repaired duodenum. That time we don't know. We are just contemplating everything. Everything is conjecture. You don't know anything. Either you talk to the surgeon, what repair did you do at the first time? Then he can tell you that I put some sutures. Suture usually in bile duct not give away. It can later on form stricture. So it goes in more a favor of some associated intestinal injury where suture can give away after on 5 days. Bile duct usually suture may not give away, but patient might develop stricture later on. And in the drain, from day one something should come. So something is not fitting very clearly. So that's why we must document. We cannot send patient home and tomorrow problem. And more importantly, 3 to 4 days just after the clamping. So we should first rule out that is there something collecting. There may be some clinical disparity. As she said rightly, we should do TLC, liver function test, TLC count, and other parameters of inflammatory markers. Try to rule out any pending collection. Do a clinical local examination, abdominal examination. If everything is fine, then obviously we have to go further. And then what investigation.
So what is the
best
objective of
answer.
your investigation? What is the objective of your investigation?
The best would have been to say to document number one, and the next best answer you can give is, you can always go back
Laptop
and say,
feed.
sir, I would like to review all the previous investigations done in the course. Isn't it? These two will determine whether how
Can
to
I have
move
the laptop
forward
feed?
and when to forward.
So how will you, what is the objective? You want to ask investigation, what is behind, what is in your mind? So one he has already told you, because it's clamped only for 3 days.
To see whether the whether there is any undrained collection and
One, okay.
and to see what is the grade of injury and what is the, since it is the 6th week, so whether it is intrahepatic biliary dilatation is there or not, or whether
So you want
there
to
is
evaluate the
atrophy.
biliary anatomy.
Biliary
right?
anatomy.
And you want to see the collection is
Collection.
there. These are the two objectives, right?
Yes, sir.
Okay. So how will you approach now? What investigations are you going to ask now?
So, first, after reviewing the all previous investigations, I will like to do the initial blood investigation, sir. CBP, RFT, and LFT to see the TLC.
So you said you,
Yes.
Nagesh has asked what are previous operative findings. You want to review the investigation.
Yes.
Do you have a pre-operative, I mean the previous investigations, intra findings and post-operative pre-cholecystectomy. You wanted someone asked.
Yes.
Can somebody read? Interpret it, not the read.
Pre-surgery.
Pre-surgery. This is pre-surgery.
Yes.
Yeah, with this finding,
Yes.
if the patient would have come to you,
What will you do?
you would have operated on this patient with lap chole.
With this,
Sir, again, I will ask the history, sir. What is the onset of pain? Whether it is like less than 48 hours or it is first episode, acute episode. If it is acute cholecystitis more than 72 hours, then I would have, I will treat it conservatively and plan for the surgery, interval cholecystectomy.
Patient is not improving.
Then we can go, if there is signs of emphysematous or
Here's the findings.
Yes, sir. In this case, if more than 72 hours, then the pigtail drainage also, percutaneous cholecystostomy we can do, and next interval cholecystectomy we can do, sir.
So I think this is the best answer you have given, that is patient is not improving in this condition. Usually people don't talk of percutaneous cholecystostomy. This is one of the life-saving procedures sometimes. And no need to jump into the surgery. You have to, suppose there is empyema gallbladder improvement, or some collection is there in the gallbladder, it is going to be infected bile, then you put a pigtail and start antibiotics. First broad spectrum, then you can taper, you can just go and see the specific antibiotic after seeing the culture and sensitivity, and hydrate and do everything, manage the patient, and then later on you can do whatever interval cholecystectomy, whatever you terminology you call it.
Yeah, I think what you told is correct exactly. Like with these findings of edema, minimal free fluid, it is not advisable to operate in this patient, particularly when it is beyond 3 days, right?
Yes, sir.
So I think you should follow after you become a GI surgeon as well, because nowadays we are seeing, because of the competition in the private sector, people are operating, and then you'll end up in such a situation, right? Okay, so what you told is exactly right, that this patient should have managed conservatively. If it doesn't improvement, you do percutaneous cholecystostomy, wait for 6 to 8 weeks, and then go for an interval cholecystectomy. Is an ideal, as per the Tokyo guidelines as well.
Yes.
Okay, next, operative findings. You have operative findings?
So with these intraoperative findings, it looks like more of bile duct injury, sir, rather than enteric injury, because in intraoperative there is a bile leak noticed from the callots area, and therefore the enteric injury here we can rule out, and also the intraoperative findings suggestive of difficult lap cholecystectomy. So it goes in the favor of bile duct injury, sir. And
that you cannot be sure, but if calyx is frozen, same as duodenum goes and stuck, so it's not, you cannot be sure, but Yeah, okay. And what is most important thing here? You are doing laparoscopy and you
Blood
see a
loss.
bile.
Blood loss.
Then what has happened?
Critical view of safety not
Where?
Attempted to repair. Yes, sir.
Can you be you be sure after seeing that some bile is coming and go and start repairing?
No, sir. We should not directly attempt to repair, sir. First, we have to stop the
So
dissection.
this
First,
particular problem we have already discussed. What will you do at this stage if you are operating?
Sir.
I think that question is already we have discussed, answered. Huh?
First
so
we
we
have
can
to-
go further. What more?
sir, first we have to stop the dissection. We should not further dissect and.
No, that question is done. No wastage of time. Go. What more you want to do next?
Next investigations.
We don't have the older investigations.
Yeah, okay.
So
Now,
go,
The
now we
investigations
At
are of
present, I will
presentation.
first investigate with the blood investigation, sir. CBP, RFT and LFT to assess the TLC 9990 normal, sir. And platelets also normal.
next.
So TLC is toward the higher side. You can say towards
Yes.
the
11,000 is-
higher of the normal. Toward the higher side of the normal. It's like child.
Yes.
Huh? So you cannot say
Higher.
okay.
And urea creatinine appears to be normal and with
How
the
can
normal.
you say 1.05 creatinine in the 34-year lady or 40 normal?
Sir,
It's normal by
usually based on the laboratory values. Usually
Even then?
1.1.
So you should make some caveat, make some
Yes.
red flag that seems to
Higher normal level.
in a
Higher
patient.
level of
Yeah.
Higher normal level.
In a patient who is already suffering, so you cannot directly say that this creatinine is normal.
Okay.
Patient
Higher-
is not hypertensive.
Yes.
Next.
And the total bilirubin 1.3 with direct 0.6 with SDOT, SGPT raised 261 and 474. ALP is 890 and albumin is 4.3. This suggestive of subclinical cholangitis features, sir, with no obstructive feature.
Why no obstructive?
Why no
Alkaline phosphatase.
ALP is right, sir, 890. But total bilirubin and direct bilirubin is normal.
Would you like to add any other component to this to differentiate between cholangitis and obstructive pathology?
Sir, there will be synchronous elevation of total bilirubin with the raised enzymes, SGOT and
No,
SGP.
apart from these parameters, would you also like to add any other parameters to this?
Syriac.
GGT.
GGT, yes, sir. GGT.
5 nucleotidase and GGT both are available in our labs nowadays.
Yes, sir.
But the question
It
is,
is more.
what is your interpretation of transaminisemia? One you said that
Subclinical cholangitis, sir. And ALP is also raised.
Counts are normal, no temperature, no tachycardia, 9,000 counts, only OTPT raised. You think it's subclinical cholangitis or something else?
There may be ongoing
Or-
hepatocyte
Ongoing liver injury also can
Hey,
be
is there
caused.
any cholestasis or no cholestasis?
Sir, whether if it can be a segmental injury which in which part
Question is not, is it cholestasis or no cholestasis?
no cholesterol.
Interpretation of LFT is very important, isn't it?
Yes, sir.
So I would not accept the answer of cholangitis because counts are normal, no temperature, no tachycardia, no collection. Why that OTPT is raised?
Raised. Because
Apart from cholangitis, what else that could be?
Hepatocellular injury can be hepatocellular
Liver
injury.
injury.
hepatocellular injury from where? Hepatocellular is not something that you go and injure. There has to be some. Are you talking about vascular injury? Why hepatocellular injury?
It's because of there is ALP is also raised, so
Uh-huh.
the pressure within the biliary system will be high.
So you mean to say that bilirubin is causing injury, but bilirubin
Cholestasis,
higher
sir.
is only 1.3.
Direct is 0.6.
with the background of the history and with this liver enzymes, mostly it can be a segmental injury which is the undrained part of the liver which is undrained. In that the hepatocellular injury may
Don't go into microscope.
going on.
What we are saying is, it's very simple. Direct bili is normal, counts are normal, no signs of sepsis. Why OTPT is raised along with alk-phos? Albumin is normal, INR is normal.
So when one of your argument I take it that you can think of a segmental injury also where one part is now closed and maybe probably because of that you are having this type of symptom. But the question is only this thing that alkaline phosphatase is also raised. So sectoral duct injury is a possibility in this patient because of the type of the transaminasemia we're seeing in a normal bilirubin. So other part maybe probably intrahepatic connections, something is draining. So that is one. Second,
Can partial obstruction can produce IALP?
Yes, sir. Yes, sir.
Without bilirubin going up?
Bilirubin. Yes, sir. It can cause.
so that is
Internal
second.
fistula.
One is that, third is internal fistula. So these are the in a, you come in a sequence manner. So one is that segmental injury, another is partial obstruction, third one is internal fistula. Internal fistula, the presentation is same like this.
Jaundice will be, but
Very
then because of partial block, ALP goes up. Okay, now what do you want to do? Synthetic functions are good, right?
Yes, sir. Albumin is 4.1 and INR is no.
Now what do you want to do now?
So further, I will first I will look for the I will do ultrasound to see whether there is any undrained collection or not, sir.
So we start ultrasound. Always it is a good habit to start ultrasound from above. When you practice this habit, you will never do something wrong in the exam. You don't want only collection. Collection part is almost taken care of. We are not finding anything suggestive of collection in the TLC. We are saying almost normal, little bit higher side, toward the higher side. That's all. Then you cannot think of collection now. You start ultrasound in a bile duct system where we are suspecting bile duct injury. Ultrasound, what ultrasound finding we expect to be there. Then only we will say, I will see this.
Yes, sir. In the ultrasound first I will look for the any intrahepatic biliary dilatation is there or not.
So I will see size of the liver first. Then I will see the echo of the liver first. Then I will see IHBR. So it is a better way of saying, or what you see is a better way of saying.
Yes.
You don't only want to see the liver. So many things you want to see on the ultrasound. So go and now describe what are the things you want to see.
First I will see the liver, sir, whether there is any atrophy, hypertrophy is there or not, or whether there is intrahepatic biliary dilatation is there or not, or any like evidence of mass or like cholangiolytic abscess or collection is there or
Don't
not.
repeat them.
That atrophy, hypertrophy and its significance.
Sir, in previous bile duct injury, if it is associated with any vascular injury, then there will be atrophy or hypertrophy, or if it is a segmental injury also, the particular segment can go for atrophy, sir. So I will look for, and liver echo texture also I will see, since it is already 15th week of post bile duct injury.
For a surgeon, why is it important, this atrophy, hypertrophy?
Sir, intraoperatively, that because the hilar structures will change the positions in the atrophy and hypertrophy complex, sir. So the atrophy hypertrophy complex is in
So you are saying that you want to see the echo of the liver, you want to see the IHBR, if possible, what is the status of the common bile duct, the collection as you said, which less likely. Hypertrophy, atrophy, yes, you can still think of, because it is October only.
Yes.
So hypertrophy, atrophy will occur if there is a usually vascular associated. If not, then it's too less a period for the bile duct stricture itself producing atrophy of the particular segment which is not draining.
Yes.
Yeah. So these are the important aspects we should look into that, and to go down also. Go down in that area. Is there something below? Towards the duodenum, anything in the abdomen, all those things needs to be seen. Though chronic, the histopathology has come, chronic cholecystitis, but from where it has been done. That is also important, because you told a very significant weight loss.
Yes, sir.
So I have a patient which was referred to us for the bile duct injury, and we found that this patient had a this Lal pathology report, chronic cholecystitis, but ascites fluid which we aspirated. There was ascites, it found to be there is an isotype type of cells, and then slide was reviewed by PGI and it was adenocarcinoma. So don't close your eyes. Eyes has to be open, because now this decision is making further progress of the patient life. She cannot go to third place. AIG is the final. So anywhere you are coming to, your mistake at tertiary care center is going to deal with the whole life of the patient. So we should not be losing anything. So you have keep an eye, even gallbladder pathology, I especially, we always review. We always review. Not even a single time we are believing in the outside. We call it and review. This is where we have burnt our hands. So,
Yes. What next?
What next?
Next, imaging investigation.
Ultrasound, we don't have it.
Ultrasound, please.
Ultrasound, I don't have the report.
Not done.
Not done.
No.
Right now, we have not evaluated. We had an MRCP which she brought.
Okay. So next, what will you do?
Sir, MRCP, sir.
Yes, paper is out. So let us see the MRCP picture.
Can I have the laptop feed?
In this patient,
Yes, sir.
how do you decide between an MRCP and a CT scan?
Sir, if there is a undrained collection and all is there, then MRCP, if you do, then it will it will not give the proper picture, sir. In such conditions, CT scan, the advantage of doing CT scan is we can see the vascular injury also, portal vein and hepatic artery and liver architecture.
But one thing I don't agree that MRCP won't show you the collection. Same bile is present. MRC is
Yes.
what? MRI and MRCP you do it.
Yes, sir.
Some fluid which is not
MRI.
moving, that can be
Yes,
picked
sir.
up. The bile can be picked up, bile collection in that's why in acute injury we always try to suggest our people that don't rush for the by MRI and MRCP, because at this stage if you are doing it, lots of collection will just overlap and the shadow and very difficult to see any type of bile duct. So at your stage, your answer should be very clear and it should not be immediately question should not write. So be very careful. There has to be some tag when you are saying MRI, MRCP at this in this patient at this juncture we are not suspecting also collection, but collection can be seen on MRI. Whatever
Collection.
vascular you said, in a good MRI today there is a software available for MRI angio. In a good MRI, but lots of effort is required. That's why people don't do it. You can see all the vessels, all artery, all veins, but you have to add the software and do some extra effort. It's not that easy. But CT scan is easily done, less time, and vascular reconstruction can be done in the same software. So there is a difference. So here we are talking about. So just read it, please. So show the MR picture, please. Don't see MRCP first. Plus show the MRI. MRI must have been done. Yeah.
Somebody read this.
This is situated.
You can use the pointer on the desk to point.
You can ask them to stop if you want, wherever you want him to
Yes.
stop, or you can ask them to go up or down.
Okay, sir. From above. This is a T2-weighted image coming from the cranial to caudal. The liver appears to be normal, and there is no evidence of any atrophy or hypertrophy complex, and there is no evidence of any mass lesion or no evidence of any intrahepatic collection, and the intrahepatic the ductal system whereas go down and there is evidence of some perihepatic collections. Collection, and then I will like to see the MRCP reconstructed.
What
pictures.
about bile duct? Bile duct you are seeing there. There you are seeing bile duct. There are some black structures seeing
Yes.
posterior to bile duct. What is that structure in that?
Portal vein, sir.
So
Not able to trace the distal CBD here.
what about the radicals you are seeing? Are they? You have to tell whether they are grossly dilated, they are not dilated. All those things you have to tell.
Yes, sir. The right hepatic ductal system is prominent, sir, compared to left ductal system. But Once I will see the reconstructed picture, again I will correlate and.
What happens to confluence here? Because you are seeing a collection in this patient,
Yes,
even in MRCP, you can't make out confluence in an MRCP. So we'll have to look at this in this picture only. So what happens to confluence?
Yes,
That's
sir.
how we have to interpret.
At this section, the left hepatic ductal system and the right ductal system confluence is not seen, sir. The confluence is not seen, whereas the if we go down, the distal CBD is appears to be normal.
Where are you seeing distal CBD?
Here from the pancreatic head, if it raise upwards.
MRCP picture, please.
MRCP.
You are talking about hypertrophy. Atrophy is there?
No, sir.
There is atrophy
Okay.
of left lobe is there.
Sir, here the left ductal system is seen, and the right ductal, right anterior and right posterior sectoral duct is seen, but the confluence of right ductal and left ductal system is not seen, and also the confluence of right anterior and the right posterior ductal system also is not seen, sir.
Why that is something is hooking and coming and joining this vertical duct? What is that?
Sir is saying there are two types of collection seen.
Yes, sir.
Their intensity is slightly different.
You show that duct also. You see the anterior usually vertical. And what is that duct coming and hooking and joining that?
Posterior sectoral duct.
So there is another duct.
Yes.
See, this is a biliary anomaly also.
Yes, sir. Inferior to that of right posterior, anterior and posterior, there is one more duct joining the confluence, sir. But all the ductal system are separate and the confluence is not seen, sir.
Yes.
And distal CBD is normal, appears to be normal, and there is a collection in the peri-CBD region and in the perihepatic region on the lessers, mostly.
What did I tell you in the beginning that only three days has been passed after clamping? So clinical medicine is like interpretation. If you properly listen and interpret it, patient is the most important thing. If you listen to him and see the clinical scenario, then you will understand. Otherwise, you say something has happened. This issue you are saying the collection to a big collection. Then now what is your next step? And what type of bile duct injury it is now?
Sir, this is the complex E5 injury, sir.
Which type of-
Strasberg-Bismuth E5 injury, sir.
So now what?
And also for the documentation purpose, I have to see for the vascular injuries also.
This MRCP is done on 19th December.
It's before.
See the right side.
Yes, sir. 12/19 December. Almost 2 months, around 8 to around 8 weeks back, sir. So I would like to do again the MRCP.
You want to repeat in a left and then do an MRCP or straight away do an MRCP?
Before MRCP, you have to rule out the undrained collection, then drain the collection, then we'll do the basic investigation, then do MRCP.
It's December.
Most probably this must have been taken care of, but yes, you have to review and see. But my question to you is, suppose in December this was the MRCP and you do today, what do you expect? It is going worse to be worse, it is going to be better for a surgeon?
It will. If the main is the clinical, in the clinical course, it can go for fibrosis, sir. So more intrahepatic biliary dilatations we can expect in.
What about extent of injury, extent of stricture? It can
Sir.
go higher or it can go remain same?
It can be higher, sir.
So that's why I always say that within 1 month we should do one MRCP when you are going to operate. You don't believe in 6 months or 3 months, 4 months before done. Obviously 1 month is a period one can think of 1.5 months. If there is something and nothing change has occurred during that time in a clinical picture of the patient, then one can go ahead. Otherwise, we need a fresh CT scan, fresh MRI to document properly that what type of injury it is. And then you are saying something more.
Or is this collection obscuring the confluence? Because December MRCP, you have a pigtail in place now. Probably this is done before the pigtail. And this pigtail could have drained all the abscesses. If this should have been a type 4 injury, patient would have had itching, jaundice, obstruction, all that in type 4, which is not there.
Yes, sir.
So we would interpret this as a pre-drainage collection.
Sure.
And we would not jump to the conclusion of saying type 4 injury. Your collection is obscuring the
Yes, sir.
this thing. So how would you proceed now?
Now, again, I will reassess with the MRCP, sir.
Say you would want to repeat an LFT,
LFT.
isn't it? Because in spite of that now there is no jaundice, only OTPT raised.
OTPT.
So do a repeat in LFT.
LFT.
In examination, I'm telling. Yeah.
No, sir, no further investigations.
So this LFT was done when?
This was done on 3rd of February that we have written.
Yeah,
Latest
this
LFT.
LFT
That was the
same
3rd
year,
of February.
MRCP
That was
without collection.
MRCP was before intervention. This intervention was done. The reports are current.
Recent LFT, present LFT.
LFT is current LFT.
Yeah, with this LFT, current LFT, with the same MRCP findings without collection, what you will do?
Without collection. Yes.
Now the clinical scenario is very simple. He is saying LFT has raised OTPT, normal bilirubin, raised alkaline phosphatase. The MRCP doesn't show any collection. So what would be your management?
Sir, in this case,
We can see the dilated drug. If we are able to drain, then can
We have the MRCP except the collection.
PT.
Except the LFT findings, MRCP is same picture, almost no HBRD, no collection. So what would you do in this patient?
No or mild IHPRD, like what is seen here.
I want to know how the biliary system was draining, sir.
We discussed, no? During interpretation of LFT, we said it could be a sectoral duct, it could be a small collection, or it could be an internal fistula. So our question is pointing towards an internal fistula right now.
The
HIDA scan.
I want to investigate further to see
What investigation you want to?
HIDA scan
HIDA
to
scan
see
to-
the any internal communications.
HIDA
HIDA
scan.
HIDA scan at this stage is of no use. Let me tell you.
Last 3 years, how many HIDA scans have you
You
seen?
can't see for the leakage, and after MRCP has been done, you are seeing the good duct. And at this particular time, there is no role of HIDA scan unless you want to do a extra thing like SPECT you want to do to see the hepatic function and all those things. That is different. At this stage, HIDA is of no use. Please be very clear. We want to see the anatomy now and further management. The question is about what further management you want to do.
Sir, in this,
Our time is.
We are
time
given
for the-
straightforward situation saying that this patient has an internal fistula. Okay, our question is as simple as this is a straightforward internal fistula, altered OTPT, persistent raised alkaline phosphatase, no ISBRD, no clinical sepsis, your bile is normal. So how would you manage this patient?
sir, first we can plan for the PTBD, sir, first year.
Why, boss?
For, sir, since it is a high grade injury in this case, before the surgery, PTBD will help to identify.
Don't go back, man. The question is straightforward. This is a case of bile duct injury treated in the best way. Now patient has an internal fistula. There's no obstruction. There's no ISBRD. Okay, no hypertrophy atrophy complex to suggest any vascular injury. Patient is with an internal biliary fistula. But bothering situation is OTPT is raised, alkaline phosphatase is raised, bile is normal. So what is your management? Question can't be more than straightforward as this.
Will you operate or will you wait and watch? Is the question.
Wait and
Why? Why not operate? This is where you can make mistakes. After 1 month, you can't make a mistake.
Because the TLC and all, it is normal, sir, here.
Sorry?
TLC is normal and there is no any tachycardia
So
or
if it
any
would have been
other
sepsis,
sense
you would
of
have gone and
infection.
did some surgery, you meant to say.
No, sir.
Then?
Since she is not in any sepsis, the surgical management can, we can.
So you accept that raised alpha as 800 and altered SGOT.
So what is the interpretation of raised OTPT and alkaline phosphatase with an internal fistula in this patient with normal ISBR?
Sir, when there is internal fistulization, there is chance of always cholangitis.
By surgery also you are creating internal fistula only, no?
is also internal fistula.
Yes.
Isn't it? Bilioenteric fistula.
So already nature has done it.
But spontaneous fistulas are not wide enough, so they are not enough for drainage of liver.
So the drainage which is taken care of by this is not adequate enough to drain the system wholly, and maybe one of the system might not be draining, one of the two may be draining. So just because we have very limited time for the next, can we
move on to the case capsule, sir?
Have you last MRCP after this? No, we have MRCP.
No, sir.
That was the last. December 1, huh?
Yeah.
So the question is this patient at this stage, most probably it's a very difficult scenario for the surgeon. And I would still consider doing a CT angio to see, because it is seems to be very high injury, and about association of vascular injury is about in the tune of 40%. See, we have also done our rate 25%, but 45% rate in type 5, type 4 injuries. So that is just to document, because tomorrow if you fail, but it is a delayed repair. If you are going to do it, usually may not this thing, but system is undilated, all the systems are separated. So it's very difficult, and if after some time after treating the patient, if you want to go in, then it's a very wise decision to put 2 tubes just before the operation and do a wide bore anastomosis. Maybe you might need to core some of the liver to get to the duct, but it doesn't seem that it would be very easy. So
the best is you should ask for a fresh MRCP, because it might have changed, the system would have dilated. If the system is dilated, you know exactly where it is the level of obstruction and you would have to plan surgery. Suppose if the system is not dilated, you can argue saying that I'll wait for some more time, but close follow-up of this patient, because it might, again, that if internal fistula is going to close any time. So, but you will be at a better position to, in a dilated system, you can give a better, a wider anastomosis. And if at all you want to operate on a situation, particularly when it is high fistula, high injuries. Low injuries are very easy to operate, high injuries. Suppose if you have to go in and operate for some reason because patient is having recurrent cholangitis or ALP is going up, so then you put a PTBD pre-operatively so that it will aid you in identifying the duct intraoperatively and then go in and operate.
So normally we, as a routine in type 4 and type 5, put routinely at least in the right side, just before the surgery or on the day of the surgery also, early in the first case, because, and then we go ahead because it helps you. So we have also pushed sometimes water. Yesterday
saline too.
Yeah, day before yesterday, propofol also you can push, because right duct identification in an undilated system in this type of injury, even in dilated system, sometimes is a nightmare because of the anatomy of the liver changes. Some hypertrophy occurs, so liver hangs over the segment 4, sometimes hangs over this. The left duct you can start from round ligament, but right duct, the PTBD helps you
and
like
also,
anything.
And also extrahepatic right duct system is very, very small compared to. Okay. These are the points you should tell in answer.
So how long we can wait for the, suppose in these conditions if ALP is persistently rise without cholangitis, how long we can wait if the duct is not dilated?
If the duct is not dilated, nowadays, and the inflammation is subsided, that's the time you can go and operate. But the only trick is that if it is a high fistulas, where ducts are separated, those are tricky situations where you have to have a PTBD when you are going in. But the timing is when the inflammation has subsided. That means the collections have drained. After the collections have drained, usually 4 to 6 weeks is the time where the inflammation has subsided.
In this case, we can put up 2 pieces.
No, we don't know. Do an
MRCP,
do an MRCP and decide this case.
So if MRCP is like this, I will agree with both the tube on both the sides. It is going to help. If MRCP is like this only, and usually it is not going to change much, even that collection is there, but dilatation might have occurred by this time. So preparation, and most important is we should have a backup friend. If you are problem on the table, you should have a friend who should come there as a faculty to help you. This is very important. You might have to resect some sort of liver. So sometimes we resect segment 4 and 4B and 5 to get onto the. So very, very important thing to do. Okay, let's go to the next
other
one.
faculty who wants to.
Yeah. Next time we kar lenge sir, question answer. You can discuss in question answer please. Otherwise,
There is a 60-year-old female hailing from Hyderabad who came with chief complaints of upper abdominal pain since 10 months. The patient had complaints of mild to moderate pain in right upper quadrant and epigastric region, which was intermittent, non-radiating, relieved with medication and not associated with food intake since May 2024. Patient also had history of jaundice in May 2024, which was associated with high grades of fever and chills. Patient was admitted elsewhere and underwent an endoscopic intervention, details of which are not available, following which her complaints resolved. Following intervention, patient persisted to have intermittent mild dull-aching pain in the abdomen, which was relieved with oral analgesics. However, there is no history of other abdominal distension, fever, vomiting, generalized weakness, fatigue, passing clay-colored stools, itching, no hematemesis, melena, postural dizziness, syncope, fatigue, no history of blood transfusion, no loss of appetite, no loss of weight, and no history of altered sensorium or decreased urine output. Past history. There is no other significant past history. History of suspected ERCP with CBD stenting on 15/5/2024. No significant family history, and personal history is also not significant.
Now, what's your thought process? What's your thought process?
Elderly female patient came with the complaints of.
No, you don't have to repeat.
No, that side people have not spoken at all. Please.
What's your diagnosis?
Last but one. And
What are your thought process? What are the possibilities you can consider based on this history?
Patient is having.
No, tell me this thing. I don't want to.
Don't repeat. You tell what is your thought
Simple
process.
initial diagnosis and procedure.
What are the possibilities you are entertaining? You have all the history, right? You don't have to repeat the history.
CBD stones. CBD stones.
CBD stone, ERCP stented. Status.
Any other 60-year-old lady?
Malignant.
Biliary system. Malignant.
Say it louder. I can't hear. Malignancy.
Yes.
What malignancy? Again, we have to ask a question. The exam, the more number of examiners ask you questions, that means you should be very specific in what you are answering.
It can be a gallbladder carcinoma causing.
Don't talk like that. You always say proximal obstruction, distal obstruction.
Distal
Okay, don't go to specifics.
Distal obstruction.
Distal obstruction relieved with.
Anybody else? Any other thoughts?
Biliary stricture.
Cholangio.
Biliary stricture.
Cholangiocarcinoma also.
Don't go to specifics.
See that last sentence, patient continue to have intermittent even after stenting.
It might be an external compression of
oral
CBD.
analgesics.
It might be, she has mild to moderate pain since May. So it might be some external compression over CBD also, which might have
What is that? Any pancreatic cause can have it.
So last year somebody had done ERCP and did not do anything. There is probably stent placed. Then can it correlate person who is doing ERCP? At least you should be knowing the subject. So if you are thinking about malignancy, cholangiocarcinoma, don't you think that the patient person will say that go to the another center, there is no other history of loss of appetite, weight and everything. It is 1 year almost. 1 year almost carcinoma will be as such.
Collider.
He has this, no, person has done ERCP stenting and now again the same problem has occurred. Now what is your thought process?
Stent may be
Stent
blocked.
blockage.
Stent block. Yeah.
So stent block, but what is the disease process? What type of what for which they have done a stent?
Malignant.
Huh?
Yeah. Okay. What do you want to do now?
review the old examination and other investigation.
We are not
What?
able to comprehend what are you saying.
What do you want? Review the old investigation.
Yes.
So what old investigations you want to review?
Yeah.
Whether you have done any ultrasound or any based
No,
on
they have told you what investigation they have told. ERCP they have done, no?
Yes.
You would like to see RCP film?
Findings and films. What
They
the
are
ERCP?
ERCP?
No, details of an intervention were not available. It was as per the
Not
patient's
available.
history.
Okay, then what do you want to do? There is a stent, somebody has done, patient has come to you, now what do you want to do now?
You clinically examine the patient first.
It is all given, no?
Yeah, is सामने है. You are seeing everything.
Everything is available, no, now? What investigations are you going to order now? You can tell.
CBP, LFT, RFT,
Yes,
PTI.
LFT.
So now, assess the clinical condition of the patients. You have to do a complete hemoglobin, LFT, RFT,
Yeah, come.
PTINR.
Because there is shortage of time,
Yeah.
we will
Yes.
interpret.
It's a normal limit.
Normal.
Within normal.
Okay, next.
This is also normal.
Huh?
Normal.
Normal. Okay.
Only alkaline perspective is mild elevation.
What does it mean?
Because of stent, indwelling stent also can increase alkaline
And what does it
phosphatases.
mean? This
Partial
picture shows
obstruction.
Partial obstruction.
Cholestasis.
Cholestasis.
What do you want to do now?
Ultrasound abdomen.
Ultrasound.
Ultrasound. Do you have ultrasound?
There is thick-walled cystic lesion in the left lobe of liver, sir, with the internal cysts and echogenic debris.
Calcification also seen. I have to think about hydrated cystic.
I want to review history about exposure to sheep and dog.
What is your diagnosis now?
Hydrated cystic.
So cyst hydrated alone will not produce all these things. Something more has to happen now.
Sheep, exposure to sheep, how does hydrated cyst come? Just tell me.
Exposure to dogs.
Huh?
Dogs.
Dogs.
Don't dig your grave like this in exam. You're always in the investigation. Try. You can always lead the examiner. Remember, it is not important that you come to a correct diagnosis. The purpose of examination is to know how you arrive at your diagnosis. That's it. Nobody is bothered about correct diagnosis, wrong diagnosis.
Here with the correlation with the history, it looks like the hydrated cyst communicate with biliary communications.
Ruptured hydrated cyst. One line diagnosis. You people are jumping around there thinking about dog and sheep and all those things. Next question nobody will ask you. Let me tell you, if you talk like this in the exam, there is no need of having another question. If you are thinking about this, that somebody has put a stent and said nothing to be done, go my malignancy, you are putting that diagnosis 1 year after stent, another stent has been placed. So why are you thinking? You are simple things you can think. You can think benign diseases, you can think oriented cholangitis, we will accept. You can think ruptured hydrated, we will accept. You can think simple CBD stone, that is accepted. We can sit choledochal cyst with the stone, that will accept it. But you go to cholangiocarcinoma. It's very amazing how your people thinking process is going. Thinking process is, you cannot combine malignancy, benign in everything 1 year after. Please see the history, examination, no loss of appetite, no loss of weight, 1 year patient sitting, and some qualified person doing ERCP. It means something which can be managed by ERCP. Or you say advanced malignancy, metallic stent has been put. That is not clear from the history. So please think some logical. Science is logical. You can put some logic in your thinking process. Now what will you do now? The patient has come again and again a stent has been put. Now
cross section imaging CCT or
Triphasic
CCT.
Stent is not seen in ultrasound.
Yeah, madam, my.
We have CT scan?
If you have to given a choice between CT and MRI, what will you do?
MRI. So having
MRI with MRCP will tell
MRI with MRCP.
Will tell about cystobiliary communication.
More better in MRI with MRCP.
Save money also. Resource. We are the optimum use of limited resource. We are working in a third world country still. So even in the best country, where your investigation should be what is going to help in the best way in the management. Into the cholangiopathitis.
There are actual sections of T2 weighted image of an MR where I can go up. Yes, sir. In left lobe of liver, I can notice a cystic lesion, which is regular.
Can you see contrast in hand pictures of the liver? You are just busy in reading only MRCP. Can you are you seeing something in the liver which can be better seen on the contrast imaging of the liver, please? Not the MRCP T1 image with the contrast.
Contrast images are not.
नहीं है तो ये जो ही दिखाइए whatever is available sir.
T2. This is the T2 weighted MRI image, sir, which shows the cystic lesion in the left lobe of the liver with perilesional edema.
Where is cystic lesion, sir?
Sir, here, sir. And with the perilesional edema and also the prominent left hepatic ductal system pericystic area. There is a prominent left hepatic duct till the confluence. And go down, and the CBD appears to be dilated and stent in situ, and the rest of the liver appears to be normal. The right the liver the size and all normal. The gallbladder is well distended, and there is no evidence. And here at that section we can see the communication with the left ductal systems, little above.
What about the left duct, which is you are seeing normally? What is this?
Dilated.
So it is dilated
and dilated.
And there is a narrowing where the two duct is that 3 and 2 are joining.
So it is dilated beyond
narrowing to be for it to be dilated.
Yes. And the liver appears to be normal. The right ductal system appears to be normal. Little. Even right ductal system also prominent, sir. With dilated CBD, there is no evidence of any filling defect, sir. No evidence of any filling defect. Here, there is an hypo intense is seen within the ducts up there at that section.
So here, why there is a separation? Why there is no continuity? Can you go to the MRCP reconstruction picture, please?
Prominent dilated CBD. With some filling defect is seen at the junction of the 2 and 3 and 4 duct junctions, sir.
Yeah.
And the left
This one,
ductal
this area,
system.
just stop there, please. Come.
Yes.
So you see here.
Yes, sir. Proximal to that, there is a filling defect where the fourth segment duct is joining, and prominent left ductal system dilated, and other sections are to see the right ductal system. So, ruptured hydatid cyst with the communication to the left ductal system with the obstruction at the level of the left hepatic ductal system, sir.
Where is it ruptured? So you cannot say ruptured.
Sir, only
So you should say it's a hydatid cyst with intrabiliary communication.
Yes. And right ductal system is less prominent compared to the left ductal system. Sir? Sir?
There are no multiple filling defects.
He is saying it could be biliary cystadenoma. Why not this be a biliary cystadenoma?
Biliary cystadenoma will be multicystic. Multicystic, and it will be multicystic, and there will be septations.
Even you see septations there also.
In this
even that is cystic.
Neural nodule.
Biliary communication is seen.
Biliary communication is not seen in this.
Some cases seen. Near the hilum, it's most common. Biliary cystadenoma. Near the
Why not in periphery? So what else you'll say? You would have to explain something. Look at daughter cyst.
Daughter cyst, yes.
Okay, you have to talk like that.
One is the biliary cystadenoma usually seen in the middle-aged female, sir, and also the communication with the biliary system, even though it is rare in biliary cystadenoma, it can occur. And in the biliary cystadenoma, there is a internal septations.
In your always while answering an examination, you were talking about hydatid cyst with internal communication. That was your diagnosis.
Yes.
My question was, why not biliary cystadenoma? So you should never talk about biliary cystadenoma so that you will land up in trouble. You should always go back and say why you said it is hydatid cyst.
Yes.
If you say septations, floating things and daughter cyst, then you are still in your territory.
Yes.
Examination is always about pulling the examiner to your territory.
The stent there in that?
Can you go down? In CBD it is.
So when it is done, this MRCP dated?
It was done before 14th.
It is done before. I think it is done before years. It is May 2024 stenting.
Stent is not made out.
Can you see the report? This report?
You have the report?
So what is your plan now? We have 2-3 minutes. We can finish in 2 minutes, then invite other faculty. So what is what should be done now?
If the rest of the liver appears to be
What do you want to do?
left hepatectomy.
What next? Yeah.
left hepatectomy, sir.
You want to do left hepatectomy. Why?
So, because since it is a identity cyst with
You know what
biliary-
is left hepatectomy?
Sir, in this case,
What are
we
the
can do
segments removed in left hepatectomy?
actually 2, 3, 4A, 4B, sir. In this case, it is involved only the 2 and 3. The fourth segment 4 is not involved, so left lateral segmentectomy can do.
So why do you want to do segment left hepatectomy then in this patient?
No, sir. Sorry, sir. It is left lateral segmentation.
You should be very careful before you answer. Frame your answer and then speak.
Not
Before
only
that, I
that,
start
then
the Galvin as well.
multiple ducts are seen defects in the CVD also. That how would you clear it endoscopically?
Yes.
Huh?
Yes.
Yes. First you do ensure clearance, then go and do left lateral, or you are just do left lateral and come and wait for the ERC.
No, sir. First, I will do the ERCP stenting, and also along with that, I will start the albendazole 400 mg before 10 days, and then I will plan for the surgery, sir.
When bile
The
goes in the cyst, does the sport survive?
Calcified bile goes into the cyst.
Cyst.
The spores survive. You meant to say it's
You
a
say 4 weeks, I will give 4 to 6 weeks albendazole. This patient has
Again.
bile.
Sir,
In presence of bile, does this sport survive?
no, sir. But it is
Within the cyst which is seen, within the cyst which is seen, there are few daughter cysts which have been seen.
Few daughter cysts.
And
according-
only calcification seen on the wall.
Daughter
So it might be still
daughter
alive.
cyst doesn't spread it because of the sport. Daughter cyst is one of the presentation of calcification. There is a calcification also.
It is not in diffuse, sir. Only at the wall it is there. So
And
the
also-
cyst
you have to
is
remove
active.
why not a marsupialization with ERCP in this patient? Why hepatic resection?
Because it has a prominent biliary duct communication, sir. If you do marsupialization, there is chance of biliary leakage post-operatively.
Internal drainage?
So, and also the recurrence chances will be more. Handling, it can spill out and it can cause.
We said it is not live. The discussion, what PD sir said is it's calcified, bile has gone in, so it's not live.
Like, sir,
So
actually in
that question
WHO,
is-
based on WHO classification, it will come under CE3A, sir, because it is not completely calcified and this thing, sir. It is an active cyst, which is present within the.
So your, I think your answer of left is okay, and then we have to drain the system also. Or you are ensured before ERCP that all the system is drained, then you can go do a left lateral segmentectomy, because this cyst is very dependent, and if you drain only, then probably biliary fistula will not stop. So flow.
Want to know LFT in this patient? LFT is done by this.
So we have come to the end because Dr. Mahesh is already there. So we can invite any comments and questions from the faculty for the last case and this case also.
So myself, Dr. Rahul. So I want to ask that in this case, can we do pericystectomy with ligation of the communication?
Yes, you have various options. Good risk patients, yes, it's peripherally located. It can do a procedure which is much less morbid. By
Yes.
excision is much more easier than going for a conventional left hepatectomy.
Yes, sir.
Left hepatectomy, I think, is too major a procedure for this.
Yes. Thank you, sir.
Any more questions? If not, then we'll close the session. Thank you, sir.
Thank you.
We'll break for lunch now and reassemble by 2:25.
தெரியும்
Check. Check. Test. Test. Check. 1 2 3 sound check. 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 Test. Check. 1 2 3 sound check. 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 1 2 3. Check. Check. Test. Test. 1 2 3 sound check. 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 Test. Check. 1 2 3 sound check. 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 Test. Check. 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 Test. Check. 1 2 3 sound check. 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 1 2 3 sound check. Check. 1 2 3 sound check. Check. 1 2 3 sound check. 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 1 2 3 sound 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 check. Test. Check. Check. Hey. Check. 1 2 3 sound check. 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 Sound check. Check. 1 2 3 sound check. Sound check. Check. 1 2 3. Check. 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 Test. Check. 1 2 3 sound check. 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 Checks. Check. 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 Test. Check. 1 2 3. Check. Right? Check. 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 దగ్గరకు వస్తలేదు ఇట్లుంటారు. Check. Test. Check. Check. 1 2 3 sound check. Test. Test. Check. Check. 1 2 3 sound check. Check. 1 2 3 sound check. Check. check, test, check, 1 to the sound check, 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 test, check, 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 1 to the sound check, 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 1 to the sound check, 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 1 to the sound check, check, 1 to the sound check, test, check, 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 test, test, check, check, 1 to the sound check, 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 test, test, check, test, check, 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 1 to the sound check, check, test, test, check, 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 test, test, check, 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 test, test, check, check, test, test, check, 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 test, check, 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 test, test, check, check, test, test, check, check, 1 to the sound check, 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 test, test, check, 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 test, test, check, 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 test, test, check, 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 1 to the sound check, test, check, check, test, test, check.
కాపీ పేస్ట్ చేసి కానీ కాపీ పేస్ట్ చేసి సబ్మిట్ చేస్తే కదా చెక్ చేయాలా
Check, test, test, check, 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 1 to the sound check, 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 test, test, check, 1 to the sound check, check, 1 to 3 sound check, check, sound check, 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 check.
इधर कोई बैठा है क्या फिर बाजू में?
Check, check.
Welcome back. We'll carry on with our next session. I would like to request Dr. Piyush Sahani, Dr. Madhusudan, Dr. Vinay, and Dr. Nagesh to come on to stage. Yeah. For this session, we had 2 cases, so they have examined both the cases, so you can present both of them.
So should we do 45 minutes, both cases, because they're going to present, or should we do 1 hour and 30?
We can do 1 hour and 30 minutes, sir. It's your option.
No, we'll do 1 hour and 30, not a problem.
Okay, thank you.
Start, please.
So the patient is a 6-year-old female. In this case, the mother was an informant. They are residents of Assam.
Sorry, 6?
6-year-old female patient.
6
years. The patient presented with chief complaints of multiple episodes of melanoma, followed by hematochezia since the age of 3.5 years. The patient was asymptomatic until November of 2022, when she had her first episode of hematemesis, which soaked a small towel, and which was immediately followed by multiple episodes of black colored tarry stools, followed by fresh bleeding and clots. And this amounted to 6 to 7 episodes per day, and the total amount approximately 150 to 200 ml per day of bleeding was seen, roughly the size of a small ball. Over the next 1.5 years, she experienced similar episodes of passing black colored tarry stools and followed by fresh bleeding. for which she had required multiple hospital admissions and was treated conservatively with multiple blood transfusions and conservative management at a local hospital. During this period of 1.5 years, she underwent one endoscopic evaluation with banding, but the exact date is unknown as per the informant, followed which no endoscopic follow-up was done. In May of 2024, she underwent a surgical intervention which was described by the mother as a procedure in which a vessel was taken from the neck and it was placed in the abdomen. She remained asymptomatic for three months following the surgical procedure. However, she later developed again one episode of hematemesis, which was again followed by multiple episodes of melena and hematochezia. Subsequently, she was evaluated endoscopically and a banding was performed in October of 2024, and she has been on regular follow-up ever since. Despite this, she continued to experience recurrent episodes of melena and hematochezia, leading to her admission here for further management. She has associated loss of appetite, which intermittently improved during the 3-month post-surgical period. She is not on any regular medications for her conditions. She engages in normal activities and plays, but has not been admitted to any school yet. Her height and weight are below the expected range as per the mother. She has no developmental delay of the milestones apart from the growth retardation. She does not have any history of fatigue, shortness of breath, syncope, abdominal pain, abdominal distension, jaundice, fever, gum bleeding, epistaxis, easy bruisability, or hematuria. She had a hospital birth via normal vaginal delivery. She did not have any history of umbilical or abdominal sepsis, no history of umbilical vein catheterization as well. She takes a mixed diet with normal sleep pattern. She has one sibling, one elder brother who is 11 years old. She has a history of abscess drainage on the back at 10 months of age. There is no history of any recurrent jaundice, no significant family history, no history of any consanguinity in the parents, and no altered sleep habits. To summarize, she is a 6-year-old female from Assam with recurrent episodes of melena, hematochezia since 3.5 years of age. She had her first hematemesis episode in November 2022, followed by multiple episodes of melena and hematochezia, for which she required multiple hospital admissions, blood transfusions, and endoscopic intervention was performed once. In May of 2024, she underwent shunt surgery, possibilities of shunt surgery, after which she remained asymptomatic for 3 months. She then developed recurrent episodes of melena, necessitating further endoscopic intervention and hospitalization. She has growth retardation. She is not on any regular medication and has not been enrolled in a school. Past history includes abscess drainage at 10 months of age.
So, impression?
Sir, according to the history, my impression is of a patient with a non-cirrhotic portal hypertension, most likely due to extrahepatic portal venous obstruction, with bleeding, who's a bleeder, and status post possibility of a shunt surgery as per the history.
Okay. And you said most probably. So, what is the other less probable option of non-cirrhotic portal hypertension in a 6-year-old?
Sorry, sir, didn't get you, sir.
You said she was 6 years old?
Yes, sir.
You said most likely cause was non-cirrhotic portal hypertension. So I said most likely, so what is less likely?
Less likely can be non-cirrhotic portal fibrosis, but due to her age, I will
6 years old?
will not keep it as a diagnosis, sir.
So what other possibility would you consider? Because you said most likely, if you said the only possibility is this,
sir, I'll correct myself. According to me, it's the only possible diagnosis in this scenario.
I heard the diagnosis stays in your face. You've got no choice but to accept that this patient has most probably. You're giving a history of endoscopy, you're giving a history of banding, recurrent episodes of GI bleed, all put together. There's very little option unless you say that the diagnosis and treatment to date have been completely wrong. There's very little to look for by way of diagnosis or differential diagnosis. Any questions, any thoughts? Anybody else wants to say something?
Can it be childhood cirrhosis?
Sorry, sir, I cannot.
Cirrhosis.
Cirrhosis?
Could it be cirrhosis?
No, sir. At this age, with the history, cirrhosis.
There are so many causes of childhood cirrhosis.
6-year-old.
You don't get a cirrhosis because
Can't you get cirrhosis in children? You can.
Yes, sir.
So possibility of cirrhosis?
Can be, sir, secondary biliary cirrhosis due to biliary atresia.
So biliary atresia unlikely because
she does not have any history of any jaundice or biliary complaints, sir.
Okay. So never saying minor Budd-Chiari syndrome. There's no history of pain. Sir.
No history of any pain or any abdominal distension or any.
Pain is not an essential feature of patients with Budd-Chiari syndrome. Okay, no abdominal distension.
No
Anything
abdominal
else?
distension.
So when you say Budd-Chiari syndrome, what comes to your mind?
Hepatic venous outflow obstruction.
Hepatic venous outflow obstruction. So hepatic venous outflow obstruction means what to you?
Post-sinusoidal obstruction.
So, but hepatic venous outflow tract obstruction. So what is the hepatic venous outflow tract? Comprises of what?
What are the types of Budd-Chiari, clinically?
So if you understand the hepatic venous outflow, you'll be able to answer Dr. Madhu's question. He said, what are the clinical types of Budd-Chiari that are the
levels of obstruction?
Difficult.
It can be extrahepatic or at the level of osteal obstructions.
Extrahepatic.
Sorry, sir.
So you can have a block at the level of the hepatic vein,
Yes,
you can have a level block at the level of the inferior vena cava.
Yes.
So the hepatic veins which push and load into the inferior vena cava still have a back pressure because no flow is going forward, or you can have a block at both places, the inferior vena cava and the hepatic venous veins. The reason we are asking you that is the manifestation is slightly different. So you may not get abdominal distension in one of these conditions. So what would you look for in that situation?
See, you said most probably variceal bleeding, right?
Yes, sir.
That's why a patient underwent repeated EVL banding. So you know that patient is having a variceal portal hypertensive bleed. So we expect that not only portal hypertension bleed in children, we agree it's a commonest is extrahepatic, but there are causes can be intrahepatic like cirrhotic, NCPF you said, but very unlikely age is. Cirrhotic can happen in children, but there is no other features of decompensation, yes, right? There is a post-hepatic sinusoidal obstruction, that is Budd-Chiari. It can be only involves hepatic veins, it can be involves IVC or both. So clinically sometimes we see like lower limb varicose veins, they may complain, venous ulcers, right? Yes. Yeah. You said one important thing. They may present with abdominal distension because ascites is one of the presentation of Budd-Chiari.
Okay. So if you look at people with inferior vena cava obstruction, adults and children, how are they different?
Sorry, sir.
If I see an adult 50-year-old with inferior vena cava obstruction for whatever cause, and I see a child with inferior vena cava obstruction, a child who is 6 years old, how will the two differ as far as their manifestation, clinical manifestation is concerned? Yes, no, we'll move on. No? Okay, we'll move on. So, examination. So children generally tolerate inferior vena cava obstruction well, especially it happens gradually because they have good collateral circulation that develops. On the other hand, adults don't develop a good collateral circulation even if it develops gradually and tend to develop more significant pedal edema compared to children. Okay? Go on, examination.
The patient was examined in supine and standing position with the mother. In general examination, the patient was conscious, oriented to time, place and person.
Pulse rate was 78 per minute, saturation 98% on room. The height was 102 centimeters and the weight was 12.1 kgs. Both were less according to her age. The patient's mid-upper arm circumference was 115 millimeter. The pallor was present. There was no icterus, sinuses, clubbing, lymphadenopathy or stigmata of chronic liver disease. The oral cavity examination revealed incomplete dentation in the front upper teeth. Breast examination was normal. On the neck, on the right side of the neck, there was a vertical scar along the sternocleidomastoid anterior border, approximately 3 to 4 centimeter in size. Moving on to the systemic examination, abdominal examination revealed a left upper quadrant fullness. The umbilicus was centrally located and inverted. Flanks were not full. A scar of previous surgery was present in the right hypochondrium. It was transverse. All the quadrants were moving equally with respiration. There were visible veins present in the upper abdomen, supraumbilical region. There was no visible lumps or sinuses, no visible pulsations, peristalsis or cough and pulse. Moving on to palpation, there was no abdomen was non-distended, it was non-tender, it was soft, spleen was palpable, it was enlarged, extending midway between the left subcostal margin and the umbilicus with a palpable anterior notch, smooth surface and well-defined lower margin. Liver was not palpable. On percussion, liver spine was 8 cm in the right mid-clavicular line. There was no shifting dullness. Auscultation, bowel sounds were present and normal. Rectal examination was not performed. The chest and the CNS examination were normal. Respiratory examination is also normal. So in summary, we have a 6-year-old female from Assam with recurrent melena and hematochezia since 3.5 years of age. She had her first hematemesis episode in November 22, requiring multiple hospital admission, blood transfusions and endoscopic binding. In May 24, she underwent shunt surgery as per the mother. After that, she remained asymptomatic for 3 months and then had recurrent bleeding, leading to further endoscopic binding in October 24 and hospitalization here in January 25. Examination revealed pallor, a malnourished state, a healed surgical scar in the right hypochondrium and right side of neck and splenomegaly.
So what is positive clinical findings?
Positive clinical finding is splenomegaly, sir, along with
How much size?
Yeah,
Mild, moderate, severe?
Sir, it was palpable below 3 finger width below the left costal margin and reaching midway between the umbilicus and the left costal margin, sir, so moderate splenomegaly.
So apart from that, no other significant?
Yes, sir. She also had pallor, and other significant positive findings were dilated superficial veins on in the anterior abdominal wall, sir, above the umbilicus.
Anterior abdominal wall?
Above the umbilicus, sir.
Okay.
Other findings can be mentioned because of not present, sir. There was no ascites, liver was not palpable.
What was the direction of flow?
The direction of flow was away from the umbilicus, sir. And also her malnourished state.
Abdominal scar, neck scar, not significant?
Yes, sir.
Those are important findings as well.
Yes.
Okay. Would you like to proceed?
Laptop screen, please.
How do you like to proceed? First, I would do a complete red picture. Or would you not like to review the previous surgical reports? Yes, I would like to review the previous surgical findings. There is a shunt surgery. Possibly a shunt. Possibly a shunt surgery. Would you not like to know what type of shunt was on patient?
Yes, I would like to know what type of shunt surgery was done. I would like to.
Do we have previous records?
Previous surgery.
Can you have a look? So, what do you think are the possible shunts that could have been done?
It could have been a mesorection. If the diagnosis, they would have if they suspected diagnosis to be EHPBO, they would have done a mesorection.
Okay.
Or it would have been a mesocaval shunt.
Mesocaval shunt.
Yes.
Why the neck scar? What would
I would have taken used the interjugular vein for the graft, so as a bridge between the two veins.
Okay.
What is the commonest shunt pediatrician will do in a EHPO?
Usually mesorex shunt.
Mesorection is rare. Why not Warren shunt in this patient?
Sir?
Warren shunt?
Warren shunt.
Distal splenorenal shunt.
Sir, I didn't get
Why not a distal splenorenal shunt? That's his question. Why not a distal splenorenal shunt?
One thing is like the most common side of ASP would be splenoportal confluence side. So
Most common, you said something, most common what?
the most common side of obstruction for AHP is at the splenoportal confluence. So DSRS is not the.
So, no. Where do you do the rec shunt? What do you need patent for the rec shunt?
SMV.
You don't need the splenoportal confluence.
We do the SMV too.
So you need the superior mesenteric vein and you need
left portal vein in the rectus.
So left portal vein. So those are two veins that you need patent. For a distal shunt, distal splenorenal shunt.
We need to distal splenic vein to be patent.
And
the
renal. So the renal vein
should be present.
So how does the most common site of the splenoportal axis being blocked impact any of these shunts? Doesn't, no?
That too, the DSRS is a selective shunt which decomposes only the fundal side.
My question relates to the fact that the most common site of block in a patient with extrahepatic portal venous obstruction, which is true, is the splenoportal junction. So the junction of the splenic vein with the superior mesenteric vein, formation of the portal vein, that's the site where the block occurs in over 90% of patients. No doubt about it. But how does that impact doing either of these shunts? So when you started your answer, you said that, and then, so my question related to that. So clarity, these shunts don't get impacted at all. Okay? The rec shunt doesn't get impacted, the distal splenorenal shunt doesn't get impacted. Okay? So possible shunts that could be done is rex or mesocable, and Dr. Madhusudan asked you, why should you consider a distal splenorenal shunt in this patient? Should you not?
I think I should not, because it's a selective shunt which selective decomposes the only right side.
So what are the disadvantages of a selective shunt?
Advantages is there is less risk of hepatic, there is no risk of hepatic encephalopathy.
Disadvantage.
Disadvantage. Ascites, formation of ascites.
Formation of ascites.
Formation
of ascites.
No, they need to do an extensive dissection.
If you have ascites, it may not get resolved. Yes. If you do a distal splenorenal shunt, usually doesn't cause formation of ascites.
Extensive dissection that damages local lymphatics.
So extensive dissection happens in a lot of shunts.
No, we need to dissect.
So if I'm going to do a proximal splenorenal shunt, I do even more extensive dissection compared to a distal splenorenal shunt. So that's not an issue.
Disadvantages can be related to hyper. Generally, any shunts, right? How you classify selective, non-selective, right? And each shunt, advantage, disadvantage. What do you see that? Huh? So rebleed rate versus shunt-induced encephalopathy or progressive liver failure, right? So what we traditionally doing is, what type of surgery we do in AHPO is?
We do a PSRS. We do a PSRS.
Yeah, PSRS, proximal splenorenal shunt. We call as a, what type of shunt that is?
That is a non-selective shunt.
Non-selective shunt. Still, why we prefer that?
Because it takes care of a lot of problems, sir.
No, these patients present with the preserved liver function,
yes,
but more of GI bleeding. So your purpose should be decrease the rebleeding rate. Which surgery will give a decreased rebleeding rate is, we select that way, right? So previously used to do Warren shunt or distal splenorenal shunt. During our time, our pediatric surgery team believes that, but the problem with the distal splenorenal shunt is rebleeding rate is more, but liver preservation of function is less. So that's why it is selectively used for a child A cirrhosis. So not good for a EHPO. You understand? Because it may not adequately decompress the Suji. And there are, if you go more depth, there are so many ways because it selectively decompresses the GE junctional area. It cannot prevent the ectopic sites bleeding. It cannot prevent the other causes like portal biliopathy complication. Whereas if you do proximal splenorenal shunt in EHPO, is ideal for both. And at the same time, we know that liver function is preserved. So that's why when you are choosing a type of surgery, type of the patient is also equally important. Right? Indication in this patient, child suffering with the recurrent episodes of GI bleed with the preserved liver function, clinically at least.
Okay, we got to answer this question. What are we going to do next? Look at the previous report. Can we see the previous records? So, this is pre-surgery report.
Patient has low hemoglobin, anemic, and platelets are low. Counts are elevated. There is some component of myelosuppression along with as a coexistent infection. Myelosuppression along with coexistent infection, sir. WBC 17,000. Platelets are low.
1,000 or 1,700?
But 17,000.
17,000.
Yes, sir.
17,200.
That's coexistent. Some coexistent.
So where myelosuppression?
Platelets are low, sir. Less than 1.5. Hypersplenism.
So myelosuppression. So when you say use the term myelosuppression, what
it's
does it
hypersplenism.
When you use the term myelosuppression, I am worried. What's happening?
It's
So you
hypersplenism.
want to use the term myelosuppression, it means suppression of the
all the three
bone marrow. So if I have suppression of the bone marrow, I am concerned. On the other hand, you say it's hypersplenism, then I am not. Would you get a raised total count in patients with hypersplenism? Usually not. You get a normal or a low count. So how do you define hypersplenism now that we are on to hypersplenism?
Lengths of splenomegaly with decline.
This is MBBS, huh?
Yes.
Lengths of things.
Lengths of splenomegaly with
splenomegaly?
Decline of all the 2 or 3 cell lines.
One or more.
One or more cell
Not
lines.
2 or 3. One or more.
Cell lines.
So a single cell line is also good enough. And
the counts get back to normal post splenectomy.
okay, 3, 4th.
You said no, just
No bone marrow
You
suppression. Bone marrow hyperplasia.
Normal or hypercellular bone marrow?
Hypercellular bone marrow.
Normal or hypercellular bone marrow. So how do you find out whether you got a normal or hypercellular bone marrow?
Bone marrow aspiration.
Do a bone marrow?
Sir?
Do a bone marrow?
Do bone marrow aspiration. Reticulocyte counts.
So that's not there, no?
Yes.
Okay. Urea is fine, creatinine is fine, electrolytes are fine.
Yes. Albumin it seems to be a bit closer. Albumin and globulin seems to be on the lower side. ALP is mildly elevated. Probably due to malnourishment and some component of biliary obstruction.
Yeah. Children ALP, what will be there?
The normal ALP in children?
Yes.
All growth plates before fusion will have a ALP elevated or not? 6-year child. Huh? It's not adult,
I'm an adult GI surgeon. I don't deal with children. Therefore, why should I remember? If you're going to deal with the HPV, you've got to know about children. No?
Yes, sir.
Okay. So what about the albumin? Are you happy with the albumin?
No, sir.
So what do you want to sort out now? Could it be cirrhosis?
No, sir. Patient
Are you confident?
No, we have a suspicion of EHP also. It can be cirrhosis.
Could it be a liver dysfunction which is causing the low albumin? Multiple reasons for low albumin. One of them is liver dysfunction.
INR is also
On the usually liver functions are preserved in EHP.
Huh?
Liver function is preserved in EHP.
So is this, so therefore should we now consider cirrhosis as a higher likelihood than EHPV?
What is the natural history of the disease? What is the natural history of the disease?
Natural history of CHP also. History of any umbilical sepsis, umbilical catheterization.
Natural history is very different from what are the possible etiological agents.
Yes.
Listen to the question. If you're in an exam and you don't listen to the question, you go off on a tangent, you're in difficulty yourself. You get yourself into difficulty. Okay?
Natural history has always been if you don't treat it, if you don't.
Yeah, so, sir, if I may, the natural history of the disease is a young child, 3 to 4 or 5 years of age, presenting with hematemesis or melena, and if followed in a large series, it was followed that all patients, they will die eventually, even after 5 to 10 years of follow-up. At some point of, this signifies that the synthetic function of the liver is although preserved, but it is low. But that is not because of intrinsic problem with the liver. That is because because of the reduced flow towards the liver, the hepatotopic and the growth factors, they are not being synthesized properly.
So that's the way natural history of
So-
EHPV if untreated. Huh?
Sorry, sir.
So extrahepatic portal venous obstruction, have you heard of name Dame Sheila Sherlock?
Yes, sir.
So if you believe in her natural history of extrahepatic portal venous
That it should-
obstruction
it
is
should- they grow out of
every
the
child
disease.
will grow out of the disease.
Yes.
You need to get them to adolescence and they will grow out of their disease. But she also never believed that they develop liver dysfunction. Okay. Adults with liver dysfunction who have portal vein thrombosis usually have underlying cirrhosis. So if this is an adult, you'd say this is probably underlying cirrhosis. It's a child who's having recurrent episodes of bleeding. You need to find out temporally related, the temporal relationship of this investigation to an episode of GI bleed. If you look at that, you could explain the albumin as well as the INR with that temporal relationship to the episode of bleeding. If this is very closely related to that episode of bleeding, that explains it. What we do need to do is to repeat this liver function test before we say that there is no liver dysfunction. With a single liver function test in a patient in whom you are suspecting extrahepatic portal venous obstruction, to say there is no liver dysfunction is incorrect. Can a patient with extrahepatic portal venous obstruction develop liver dysfunction? So I see some heads nodding there. So how about telling us what you think is the possible cause if this group doesn't tell us?
Deprivation of blood, deprivation of portal flow to the liver can.
Sorry?
Deprivation of portal flow to the liver. So
one of the things that we know for sure is that people with extrahepatic portal venous obstruction have been followed up for 20, 25, 30 years, and the vast majority of them don't develop liver dysfunction. So deprivation of portal flow, if that's the reason, then that
is
will
rare.
affect people who live long.
See, liver dysfunction can develop, sir, but that will be a sequelae to the portal biliopathy, sir.
So that's one portal biliopathy, anything else? They receive multiple blood transfusions.
Yes.
And therefore, everybody nodded their head, but blood, so what if they receive
Blood transfusion.
So they can acquire a transfusion transmissible disease which can cause liver dysfunction. But 6 years old, so soon after transfusion, not likely. Okay? So you must know the latency between receiving an infected blood transfusion and the occurrence of liver dysfunction. Alright? So it doesn't happen so soon. Okay, some more investigations. So interpret.
This ultrasonic report doesn't point towards EHPO, rather than it points towards NCPF. There is evidence of intrahepatic portal radical fibrosis, so points towards NCPF.
So what do you want to do now?
No, I would go for.
So this is all pre-surgery. She's not had her surgery also.
Do we
have any records of the surgery?
Doppler.
Do we have any records of what the surgical procedure done was? Do you have any records? No.
No intra findings.
No intra findings. Okay. No up notes. No intra findings. Okay. So we don't know what the surgical procedure is. So this is the pre-surgery investigation. This obviously puts a huge doubt on whether we're dealing with extrahepatic portal venous obstruction at all. Okay. All right. So what do we do now?
So I would repeat all the blood investigations. I would repeat the blood investigations again, along with the ultrasound abdomen and Doppler. Present blood investigations. Platelets are low, sir. Hemoglobin is okay. Counts, there is no infection.
Hemoglobin okay?
No, improved than previously.
Improved from previously, but not okay.
Not so okay. And platelets less than 1 lakh resisting.
Hemoglobin is 10, is it okay?
No, sir.
Hemoglobin is 11, is it okay?
No, sir. 16.
12? What does WHO say?
14.
That's MBBS, no?
Yes, sir.
So you can't forget your MBBS if you come to do a DNB or an MCH. Can you?
No, sir.
So what would you like to rule out in CBC in this situation? What would you try to assess in CBC in these situations?
Hypersplenism like to rule out, sir. Reticulocyte count.
So what is the definition of hypersplenism?
Would like to have a reticulocyte count also along with it. And platelets less than 1 lakh suggesting some clinically significant portal hypertension. Okay. RFT seem to be.
Why do you do creatinine in this patient?
They were dehydration during the AK.
Okay. Is it significant in our scenario? Because it's referred to the GI surgeon, right?
Yes.
What type of surgery, if you are,
Yeah,
if at all you are planning
yes,
as a EHPO, GI bleeder with hypersplenism?
We'll be planning for a spleen stent. So it should be the liver renal function should be normal.
Okay.
ALP seems to be on the still higher side. Albumin is now preserved, sir. Has improved compared to previous investigation. Albumin has improved. INR is the same, still at 1.6.
That's what Professor Sahani sir is saying. No? So previous test probably the low albumin dilution because of GI bleed episode must have contributed that low albumin. So that's why you should wait for that.
Recent ultrasound.
You want to do a?
I want to do a recent ultrasound done without
You want to do an ultrasound?
yes.
Okay. Ultrasound.
You have a Doppler repeat splenoportal axis. You have shown pre-surgery, no?
Yes,
Pre-surgery.
So they didn't want to do ultrasound in the post-operative period.
Would like to.
Why? Why do you think? What would they have done?
They would have done a Doppler.
They didn't do a Doppler ultrasound.
CT. They would have done a CT.
They would have done a
CT.
They did a CT. Why did they prefer to do a CT over a
We can characterize for any thrombus. We can look
thrombus?
The shunt thrombosis can be evaluated. We can assess the patency.
Why surgeons prefer CT over the Doppler?
Yes, Doppler gives only information regarding splenic vein, portal vein. We need to assess the supramesenteric vein. This CT gives information for all the veins.
So Doppler, who says you can't assess the supramesenteric vein? You know, so assess the supramesenteric vein, the inferior vena cava, the hepatic veins, everything can be assessed. So what is the biggest drawback of ultrasound?
So we cannot visualize the collaterals on the.
It's operator dependent. So the person who's doing the ultrasound needs to be familiar with what has to be looked at. If I'm not sure what shunt was done, I may not be able to figure out what the anatomy now is. And therefore it may make more sense to do a CT. Okay, if I do a CT, what kind of CT would you want to do?
Maybe contrast.
Can you tune your CT in a particular manner to get more information?
Maybe contrast CT photograms.
So CT photography could give you more information compared to a conventional contrast enhanced CT. Can you see the CT? So here's the CT for you.
It is a contrast enhanced CT scan of the abdomen portal phase with visualized patent SMV and the splenic vein, sir. With splenomegaly is present, sir. We visualize patent extrahepatic portion of the portal vein, sir.
Now you are able to differentiate. The Doppler which was shown that portal vein was patent, but now it is not there.
Can you see a portal vein here?
Near the hilum you trace
SMV is traceable. Portal vein.
splenoportal axis is there. No?
It's the hilum is traceable. Yes.
Yeah.
So do you see a good normal
Intrahepatic
size portal vein?
No.
extrahepatic portal vein is normal. Going to
Not
the
seen.
Not seen.
Seen, not seen.
Seen distally, sir. Approximately towards the level of hilum, it is not. It is absent.
So where is the right branch? Where is the left branch? Where is the main portal vein?
Is it possible that whatever surgical procedure is done has caused thrombosis of the portal vein? It was actually patent at the time when the ultrasound Doppler was done, or the previous Doppler was done. So there are two possibilities. One, so we can't see a portal vein here, at least none of us can.
Yeah.
Your radiologist probably didn't see it, did they? Did
Yes,
they
sir,
see
there
it?
is no portal vein.
Okay. So their radiologist didn't see it, we haven't seen it. So there are two possibilities now. The previous ultrasound was wrong, or the surgical procedure has caused something. What is more likely?
Previous ultrasound was post-surgical thrombosis.
Post-surgical thrombosis? No, my bet is that the ultrasoundologist made a mistake.
Correct. Operator dependent error.
So they saw a channel which they interpreted as a portal vein, which probably wasn't the portal vein. Probably. Because everything else doesn't fit into it. Okay. But that's my bias against the ultrasoundologist. The ultrasoundologist would probably say, I saw the portal vein, you surgeons caused mistake.
See, trace the caliber from below, from SMA towards the liver, towards the hymen, isn't it? The caliber is lost.
Yes, sir.
Thrombus, you don't lose the caliber of the vein.
So now you got a roadmap of CT portogram, very definitely splenoportal axis. Huh?
Yes, sir.
What else you will see?
Okay, can we move on to the next person, please? What else do you want to see?
The left renal vein diameter.
Huh?
Left renal vein diameter.
Loud, please.
Left renal vein diameter.
Left renal vein diameter.
Sphenic vein diameter.
Okay. What else?
Any thrombus, any sphenoportal axis thrombus, residual thrombus, anything else? And
so there's a thrombus, what are you going to do?
If the entire sphenic and portal axis thrombused, then we can't do surgery again.
So very likely, if I don't see the portal vein, it is very likely that the portal vein is either thrombosed or has been replaced with collaterals. So you were saying you would want to look for a thrombus in the portovenous system. So looking for a thrombus means that there is something that you plan to do for the thrombus. So in the context of a patient with cirrhosis and portal vein thrombosis, or in the context of an underlying prothrombotic disorder and the presence of thrombosis, vis-a-vis extrahepatic portovenous obstruction, what are you going to do if you have thrombosis? Are you going to anticoagulate? So remember, you're in an exam. I am the examiner. What I'm going to listen to is what is going to put let you flow smoothly, because whatever I hear is something that my mind says is all fine. Or I suddenly say, here's something which I don't know. So let me find out now. Like in the morning case, that 45% angle of contact would be. So suddenly I was sleeping comfortably. Here you said thrombosis. I want to look for a thrombus. So I said, what is he going to do with this thrombus? Why does he want to know? What else do you want to look for?
Most important things in a suspected case of portal hypertension. What are the things other than splenoportal axis? What else you will see? Collaterals. Bigger thing. Think bigger.
So I have lots of collaterals. I have very little collaterals. How does it make a difference?
How is the
any finding that you report on, there must be a consequence to that, or an importance for that. So I see lots of collaterals, I see very little collaterals. Doesn't matter. Okay, what else? There's something else he wants you to say.
No, in this patient, liver, how it looks?
You don't want to look at the liver?
No examiner will be happy if you don't tell status of the liver, right? Because it's
you're looking at extrahepatic portovenous obstruction. Some of you are worried about the ALP. So you don't want to look at the liver? You don't want to look at the biliary radicals?
No HBID.
You want to look at any free fluid? There was a low albumin at some point in time. You don't want to look at that? You want to look at collaterals which have no meaning. You want to look for a thrombus which has no meaning. No? Okay.
Liver replacement.
So anything else of importance here?
Splenomegaly is the cause. Right splenomegaly.
What is that bigger structure on left side? Is it normal?
Little louder and into the mic.
Splenomegaly.
You want to look at the size of the renal vein. You want to look at whether you have both kidneys present or not. So I'm not so worried about the size of the renal vein, but I don't want to open the abdomen to do a proximal splenorenal shunt and find that there is what?
Only single kidney.
Congenital agenesis of the kidney on the left side. Okay? So those are the things that are important for you to look at. Was your radiologist able to pick up any shunt on the...
Put it in the mesocaval shunt in the
post-mesocaval shunt, no obvious shunt from SMB to IVC. So status post-mesocaval means somebody must have written there that this is likely a mesocaval shunt. So we are still not sure what shunt was done. We're presuming because the structure was taken from the neck, that's either mesocaval or a rex which was done. Okay, all right. So what are we going to do now? 6-year-old girl, recurrent episodes of GI bleed, one attempt at a possible shunt, which has been done. So what do you want to do for her? Sorry?
Even endoscopy is again not helping the patient.
You want to do an endoscopy again?
No, already multiple endoscopy items were done, and the patient is still having recurrent episodes of bleeding.
What do you want to do?
PSRS.
PSRS.
What is that? Full define.
Proximal splenomegaly shunt with the splenectomy along with the spinal insertion into the lateral.
I have a problem with the splenic vein size.
1.7 mm. It is maybe. Want to know exactly the 1.7 mm is very small.
The splenic vein size it's mentioned 1.7 mm.
It is actually very small.
1.7 mm.
7 mm should be there. More than 7 mm should be there.
What do you think on the image? Did you see the CT image?
It is looks normal. Splenic vein is dilated. Maybe some mistake in reporting. Maybe centimeter 1.7 centimeter.
No. Average shunt size. How much size you will prefer? You want to keep it 2 centimeters size?
1 centimeter.
Huh?
1 centimeter. 1 centimeter should be.
Okay.
What is the ideal splenic vein size for doing a splenorenal
7 mm should be ideal. 7
8 mm, 9 mm, so that you can do a centimeter size shunt. Child is only 6 years old. So for a child, will you be able to get that size of an anastomosis? So what is the smallest diameter shunt that people have reported in the literature?
3 millimeter. 3 millimeter.
4 millimeters. We've done one with 3 millimeters, but the reported is 4 millimeters. And how did they achieve patency in these 4 millimeter, high patency in these 4 millimeter shunts?
Intra dilatation of the splenic veins. Wider anastomosis.
So they did perform angiograms to ensure that they had good flow, and if they didn't, they revised the anastomosis. This paper was from the Smith's group. The first 90 children or something like that was the title of the paper with extrahepatic portal venous obstruction. Okay, so they did 4 millimeter sized anastomosis in small children, but To get those shunts to remain patent, they did intraop angiograms and revised the shunts if necessary. Okay. So generally, the splenic vein to me, it seemed like 1.7 not that small. So if it is 4 to 6 mm, it's okay. But certainly 7 mm is good for do a shunt. Why do you want to take the spleen out?
Because of hypersplenism. Hemoglobin is on the lower side, and the platelets are low.
Total count is fine.
And growth retardation because of splenomegaly, which is causing loss of uptake.
So I have one problem. I still have an abnormal INR. And I still had some mild transaminitis. So what should I do? Go ahead and do the shunt. Should I biopsy her liver? Ignore the transaminitis and ignore the INR.
Bleeding will reduce we were aiming to reduce the rebleeding, so obviously with the shunt there is will be rebleeding chances will be lower.
So if she develops jaundice, bilirubin goes up to 5 in the major post-operative period. But transaminitis increases. Are you worried now?
Yes. Total bilirubin.
So I'm asking you a question. You're going off on a tangent somewhere here. You understand what my question was?
Yes.
Are you worried about the transaminitis?
Yes, sir.
So what should I do? We have two people there at the edge who haven't spoken.
A liver biopsy.
Do a liver biopsy?
Yes, sir.
What do you expect to get in the liver biopsy?
Total fibrosis.
Total fibrosis?
Yes, sir, very total fibrosis.
Huh? What do you expect to see on the liver biopsy, which is going to tell you that you should or you should not do a shunt in this patient? She has recurrent episodes of GI bleed, all well tolerated. She has not had encephalopathy, she has not had any ascites, she has not had any pedal edema, she has not developed jaundice at any point in time, which the mother would have noticed and told you. So she hasn't decompensated during any of these episodes of GI bleed.
I feel on the CT wise, splenoportal axis and splenic vein, reasonably good size. Maybe 1.7 centimeter must have been there.
Yeah.
Because it is definitely side by side renal vein also opacifying. It's almost more only. Renal vein diameter compared to that, splenic vein almost equal or more. So at least 8 to 1 centimeter must have been there. I feel, because I must have done hundreds in shunts and we work with the sir also. This splenic vein is shuntable. So 100% sure it may not be 1.7 mm. What do you say? Yeah, it's a bigger size.
Yeah, we take out the spleen and do a shunt. We would do that. My concern is only the transaminitis and the INR. So what should we do about that? Should we do something about it pre-operatively? Should we? So there are three possibilities. One, we are worried and we go ahead and do a liver biopsy. Second, we ignore it and go ahead and do a shunt. Third, we look for another investigation which could help us. So what is the other investigation which could help us?
Whenever GI bleed due to portal hypertension, we do CBP, LFT, PTINR and most important other blood investigation. Because patient received multiple blood transfusion, no? You don't do any viral markers? You don't do viral markers?
Good idea to do Hep B, Hep C in them. Okay? Most of the blood is good that we get nowadays, but we still can miss out some. So that could be one possible explanation, in which case you could treat the patient if need be at a later date. Okay? All right, we decide to go ahead and ignore the transaminitis, do the Hep B Hep C, which turns out to be negative, ignore the transaminitis and the slightly abnormal INR, and go ahead and offer her a splenectomy and a lienorenal shunt. Okay? You do a splenectomy and lienorenal shunt. Do you want to do anything else intraoperatively?
Liver biopsy.
Ah, very good. So intraop liver biopsy you want to do, because in case you missed something, if you need to do something, you can do it. All right. Anything else? So what is the likelihood of rebleed in this patient following the lienorenal shunt? The reported literature, not guesswork.
20 to 30%.
20 to 30% after a proximal splenorenal shunt. All of us here have heart attacks.
Less than 5%, sir.
We'll need to go to the CCU very soon.
Less than 5%, sir.
5%. Very good. If I can do 5%, nothing like it, I'll be very happy. Doesn't happen.
10%.
Not 8 to 10%.
10% actually.
So told you in the morning, 0 and 100 you remember, 15, 30 and 70. If you had remembered 15, it was okay. You went to 30, that was a little off. Okay. All right. Survival?
95% survival at 5 years. At 5 years, sir.
So what does the literature
Sorry,
say?
15. The literature says 15 years survival is more than 95%.
So there are people who have studied these, followed up these patients post-shunt for as long as 25 years and found that their survival ranges between 85 to 95%. Different series, different numbers, but around that. Okay. Encephalopathy, does it happen?
No, sir. Although minimal encephalopathy has been reported, sir, and recommendations have been given for that.
What are the recommendations for minimal hepatic encephalopathy post-shunt in a patient with extrahepatic portal venous obstruction? So we're not talking about minimal hepatic encephalopathy, any other setting except the extrahepatic portal venous obstruction.
So recommendations were given for for choosing the shunt procedure in light of minimal encephalopathy reported later in series, sir. The Baveno 6 recommendations were made.
So Baveno 6 doesn't talk about extrahepatic portal venous obstruction. That context is totally different. So there are no guidelines as far as minimal hepatic encephalopathy in the context of extrahepatic portal venous obstruction is concerned. People have followed up these patients. They've looked at what they've called subclinical encephalopathy. They've looked at what they've called minimal hepatic encephalopathy. And you find a 15 to 20% incidence in these patients. If you follow these patients up for a long period of time, a small proportion, I can't give you a percentage because I don't have a percentage, a small proportion of these patients, long term means 25, 30 years, some of these patients will develop structural abnormalities in the liver, but there will be no functional abnormalities. There have been an occasional patient who has been reported to develop encephalopathy. Most of these patients have actually developed cirrhosis because Hep B and Hep C was not detected and not treated. So they've actually gone on to develop cirrhosis due to a transfusion transmissible disease rather than because of their underlying condition itself.
What are the indication for shunt surgery? One is GI bleed. When you will do other than GI bleed?
So symptomatic portal biliopathy, sir.
Symptomatic portal biliopathy, yes.
Failure of endoscopic or medical therapy to control the...
That's what's GI bleed, no?
This patient has an indication.
Yes.
Symptomatic growth retardations.
Yes, growth retardation.
Symptomatic hypersplenism. And
Symptomatic hypersplenism.
Anything else?
And if the patient is unable to attend a tertiary care center or the patient is coming from far off.
I will say that you only in history, patient underwent repeated endoscopy. By the time patient reached you, still having a GI bleed, but endoscopy shows no varices. Still there is an indication for shunt or not? Patient is bleeding, no?
Yes.
Yeah, ectopic varices. Sometimes what will happen? Portal hypertensive gastropathy.
Yes.
That cannot be controlled by any of endoscopic person.
Can you manage this patient with endoscopic means?
Preferably not, sir.
Why?
Because even after esophageal endoscopic eradication of esophageal varices, this patient will have the problem itself is not solved. She is still going to have growth retardation. She will have to be under continuous surveillance, and the problem of splenomegaly is not solved. She's having dragging pain and decreased intake.
If you don't get a splenic vein on table, what do you do in this case? Patient is having a recurrent GI bleed.
Makeshift shunt, sir, or makeshift shunt, sir, or
What is makeshift shunt?
or devascularization procedure.
Huh?
Makeshift shunt or devascularization procedure.
What is makeshift shunt? What do you mean by
That
makeshift?
means the shunt is between the collaterals and the systemic veins.
One of the big collaterals you do anastomosis. Then? Yeah.
Shall we move on to the next case? We have one more case, no?
Okay.
I believe they worked up that patient as well. Yes, no? So can we start from that end? We have 17 minutes and 28 seconds, 27 now, 26, 24, 23. The more you think, the less time you have. Start speaking.
Little louder. Yeah.
Closer to the mic.
34-year-old male patient who works in the pharmaceutical industry presented with complaints of abdominal pain and vomiting 1 to 2 hours after meals and steatorrhea since July 2024. The patient had an insidious onset of dull aching moderate intensity abdominal pain in July 2024. Character is dull aching, moderate in intensity, which gradually increases from the first episode till date. Irritation is to the back. Aggravation is postprandial, and it is not relieved with postural changes or bending forward. It was initially managed with oral analgesics and later required IV medications, and it impacted his daily work. He also had persistent vomiting, and which was typically yellow to greenish in color, occurring 1 to 2 hours after food intake, and which was postprandial in nature and relieved after vomiting. An associated history of steatorrhea was also present. He gives history of loss of appetite and significant weight loss. He was 54 kg, now he has lost 14 kgs, which is significant. He was admitted to local hospital and managed conservatively with antiemetics and analgesics. After evaluation was started on oral medications, which he was advised to take with meals, following which steatorrhea was relieved and his appetite improved. By September 2024, he was diagnosed with diabetes mellitus, which is well controlled on oral anti-diabetic medications, but now has been stopped. In December 2024, during which time he required 1 day of ICU admission, and January 2025, he had an acute episode of similar symptoms of pain and vomiting and inability to tolerate solids. Due to persistent nutritional intolerance, a nasal tube was placed endoscopically for feeding in January this year. However, he had another acute episode in January 2025 with abdominal pain and vomiting, following which he was admitted for further evaluation. There was no history of any fever or jaundice or high-colored urine, clay-colored stool, pruritus, dizziness, syncope, fatigue, hematemesis, or melanor or ecchymosis. There was no, the symptoms, additional symptoms present was dryness of eyes, lower leg pain, and loss of appetite and significant weight loss. He used to take alcohol occasionally. There is no similar complaints in the past, no past surgeries. Personal history, bowel bladder habit is normal. He takes mixed diet, no abuse of drugs. Family history is not significant.
Can you summarize clinical history, short, positive history?
a 34-year-old male presented with complaint of abdominal pain and vomiting for the last 6 months, in which he had required multiple hospital admissions, and there was no, without any history of jaundice and high colored jaundice or clay colored stool, but with presence of significant weight loss.
With the steatorrhea and
Steatorrhea.
diabetes, right? And occasional alcoholic. Smoker?
Non-smoker.
Non-smoker. What do you think?
So, it is a case of chronic pancreatitis, but the cause is not worked up with.
So pain upper abdomen, right?
Yes.
Why not it is chronic peptic ulcer?
So the character of the pain, he has a pain that radiates to the back. Secondly, there is history of steatorrhea. Thirdly, there is history of also weight loss. Fourth is there, he doesn't have any history of smoking. So those are things.
Okay.
So pain radiating to the back, posterior penetrating duodenal ulcer.
Yes.
Possible?
Sir.
Steatorrhea, what you are describing as steatorrhea, I say is IBS. IBS-D. Explained. What else is left? Loss of weight.
Loss of weight.
Loss of weight. He drinks a lot?
Not sir, occasional.
Occasional.
Alcohol. Occasional alcoholic.
So can't explain loss of weight because of that. So fear of eating. Fear of eating. That's why he doesn't eat much. That's why he's got loss of weight. We explained all our symptoms. So acceptable differential diagnosis, posterior penetrating duodenal ulcer.
Yes, sir.
With explanation for your so-called steatorrhea and loss of weight.
So differential will be a chronic ulcer disease.
You will consider?
Yes, sir. Differential I will consider, sir.
You'll consider?
Sir, yes. Sir.
I won't consider.
Why not chronic mesenteric ischemia? Pain, more after taking food, weight loss, non-alcoholic.
Mesenteric
What
ischemia.
are the conditions will produce pain after taking food?
What definition? Yes, sir. Mesenteric ischemic one probability, and ulcer disease is another.
What?
Ulcer disease is also another probability. The possibilities which increases, and in pancreatitis also. Is that the?
I feel you got a hint of diagnosing of chronic pancreatitis. Only pain upper abdomen with weight loss. I am doubtful about steatorrhea describing by the patient. Right? Diabetic patient can develop chronic mesenteric ischemia. No history of alcoholism. 30 years fellow. If you say that differential diagnosis, okay. But you are strongly one diagnosis putting as a chronic pancreatitis. Okay, examination. Yeah, proceed.
On examination, the patient was conscious, cooperative, and well-oriented. He is poorly built and moderately nourished. His breath holding time
Positive findings and significant negative findings. What did you look for and not find, and what did you find? Didn't find anything?
Sir, he is poorly built
Poorly built, okay.
The nourishment is average. But the negative findings are he doesn't have any jaundice, any pedal edema, any hepatomegaly, any tendon, local tenderness.
So why were you looking for hepatomegaly in a patient with chronic pancreatitis or a posterior penetrating duodenal ulcer or chronic mesenteric vascular ischemia? Those are three diagnoses we had. So why were you looking for hepatomegaly? And why do you think it is significant that it is not present? So all examiners like to sleep because they want you to pass the exam. You have to dig your grave. We will not help you dig your grave. We have no intention of doing any more work than what we are required to do. You are all now lazy people.
So
Yes.
doesn't
So
have
even Madhu agrees with me.
doesn't have any significant findings except for poor nutrition status.
See, in exam also, you will have a long case, short case, right? Long case, like we have taken a EHPO as a long case, elaborate description. Now in a short case, you will be asked like this only, right? You will be given a short time compared to the long case, and we ask what are the positive findings, what are the negative findings, and how you, right? So think as if we are taking this as a short case, tell me what are the positive findings, and based on that, you want to make a one provisional diagnosis, right?
So on examination, there is as such positive findings are only of poor nutrition. So there are no
Only
positive
poor.
findings.
No
And
local tenderness or
nothing else is there.
Huh?
Sir, to
No
suggest any-
swellings or nothing.
Nothing else. Sir.
Right. So what is your provisional diagnosis in
My
this?
provisional diagnosis still stands with the chronic pancreatitis.
Chronic pancreatitis. Okay.
So you want to try and confirm your diagnosis?
Yes, sir. Sir, I'll do the routine investigations in form of complete blood count and RFT and LFT, followed by an ultrasound.
So complete blood count, LFT and KFT will help you make your diagnosis?
Sir, LFT will help in may help in making a diagnosis. The other
How will LFT help you in making a diagnosis? Tell me.
See, if there is any bilirubin, hyperbilirubinemia or anything
Okay,
else
hyperbilirubinemia explains chronic pancreatitis.
No, sir, but it can
Posterior penetration of the duodenal ulcer into the common bile duct does happen. You haven't seen it, I've seen it. Madhu's also seen it.
Sir, it can cause the chronic pancreatitis can cause biliary obstruction.
No,
But that doesn't help me make a diagnosis. No? Biliary obstruction could be due to 20 other things.
Yes, sir.
Liver function doesn't help me make a diagnosis of chronic pancreatitis.
For the diagnosis part, I will require an ultrasound first.
Okay.
Ultrasound, show me that. You have an ultrasound?
So the ultrasound finding is positive for pancreas having diffuse atrophy with multiple parenchymal calcifications and with dilated MPD up to 3 millimeter with interductal calculi and few peripancreatic and perisplenic collaterals present. The rest of the findings are normal, no changes in liver or any IHBRD, no ascites, no lymphadenopathy in this. Spleen is also normal.
What next investigation you would like to order?
Sir, I would like to do an MRCP in this patient because he had multiple episodes and I need to plan for surgery. So I need to see the MPD dilatation and calcifications.
I say that CT first, based on ultrasound. Why the patient is having multiple dilated collaterals?
So he may have been splenic vein thrombosis. That
Yeah. Okay. So MRCP, what do you want to look in that? In MRCP?
So, MRCP, I would like to look in the.
What do you want to see? What you expecting to see in MRCP?
So I'm expecting parenchymal calcification ductal calculi.
That is there now already.
Yes, sir. But sir, for planning of the surgery.
What surgery? Okay, ductal diameter.
Ductal
You are not doubting about ultrasound. Okay.
So you're not happy with the ultrasound findings? You think there's something wrong there?
So for planning, I will record.
You can't, if you have a dilated duct, you can't plan.
Yes.
You can.
Yes, sir.
Why do you want to do surgery for him?
Patient has had multiple episodes of pain, and
How frequently?
sir, he has had 3 to 4 episodes of pain in the
Only
last 6
in the last?
6 months, which required hospitalizations.
Okay. Can I do something else before I take him to surgery?
Sir, we can do endoscopic.
Can I do something before endoscopy also?
Sir, we can do celiac plexus neural block for the pain.
That's after, before me.
You can't give any medical management.
Medical medications, yes, sir.
No.
Yes, sir.
Most important thing I always feel is this patient is non-alcoholic, right? Occasionally, non-smoker, developing a chronic pancreatitis, young fellow, going into the steatoria, develop diabetes. You doesn't want to work up for other etiology of chronic pancreatitis?
Yes.
Huh? So I thought you are doing MRCP for that purpose. You don't
Yes,
work up for the other etiology of chronic
So
pancreatitis?
you've got a CT in front of you.
Yeah.
Given a choice, would you do a CT first or an MRCP first? MRI first?
He wanted an MRI.
He wanted MR. That's why we asked for CT.
Read the CT now.
So this is a contrast enhanced CT.
If I have given an option as a student, I ask first plain CT. Why?
So to see the calcifications in the pancreas.
Yeah, because ultrasound did not show size of the stones, all these things, no? He's having a big calculi or small calculi. See?
This is a non-contrast phase, an axial view of a contrast enhanced CT showing multiple calcifications inside the pancreas. I don't see any calcification or any lesion in the liver in the non-contrast phase. No ascites, no effusion.
Apart from calcifications, what else you see?
Yeah.
Is an injective.
Time is over? Yeah.
Have another 2-3 minutes. No problem.
Yeah. Okay. So based on this CT, what do you think this is? What type of pancreatitis?
So this is an atrophied pancreatitis. This is an atrophied pancreas, multiple calcifications, ductal dilatation. I would go for chronic pancreatitis in this patient.
Big stones.
Big stones.
So what do you think?
Sir is asking what type of pancreatitis.
You know now types of chronic pancreatitis, right?
So,
One is alcoholic pancreatitis, non-alcoholic pancreatitis, in that hereditary.
it's a hereditary.
And what we see common in
India.
In India, especially southern regions.
Tropical pancreatitis.
What will be their presentation on CT? They develop early diabetes, early exocrine deficiency, and they have a big stones, right?
Apart from pancreatic findings, you also see some other shadow.
Collaterals.
There is a one tube we see
There is a tube.
to, huh?
They've done endoscopic stenting, huh? No?
No.
Yes, no?
Sir,
He is blowing the CT and giving you a clue.
No, sir.
He is repeatedly going to G junction and giving you a clue.
Somebody who's picked it
Sir,
up
sir,
there,
it's
he's got his hand.
it's an NJ tube.
Why do you think they have put an NJ tube here?
Because he couldn't be, he was not taking any feeds, so had to put in a NJ tube to feed him.
So do you think he'll benefit from surgery? Or should I manage him,
Sir,
let the endoscopists,
So you can manage him medically
the
first.
physicians and the other people manage him? If I have a bad result, I'll have a bad reputation in the market. That's all what you think of nowadays, no? Bad result, bad reputation in the market. All market forces.
But sir, this ductal calculi and this dilatation, this would be better managed with multiple calculi.
So I'll show you a patient with multiple calculi,
No pain.
but minimal pain, 6 months, 10 years. He's had the pain. Once in 6 months he gets the pain. Should I operate him just because he's got large stones?
So in the burnt out phase, the operation will not be any more effective. So in the burnt out phase of pancreatitis, so
how do I know it's burnout phase?
so he will not have any more pain episodes in those.
No, he gets pain. He gets it once in 6 months. He's been getting it for 10 years.
The pain.
When do you get steatoria in these situations?
So steatoria is in when pancreatic exocrine insufficiency goes beyond 70-80%.
No, you tell me this patient coming to the hospital with recurrent episodes of pain abdomen, recurrent episodes of hospitalization, right? And non-alcoholic, and presence of this type of CT. What do you want to do it? Is there an indication for surgery? Is there or not?
Yes, sir. Yes, sir.
I don't know the diameter of MPD CT wise, right? But ultrasound wise is 3 mm, but CT wise bigger stones are there.
Yes, sir.
I feel reasonably dilated duct.
Yes, sir. Sir,
You ask the report, radiologist may give.
So early surgery has a role in preventing the exocrine insufficiency, stopping the progression of exocrine.
His quality of life is compromised, no?
Yes, sir.
Recurrent
Already got
episodes of
the
hospitalization.
insufficiency. Do you think that insufficiency is going to get reversed?
So the endocrine, it doesn't affect, the surgery doesn't help the endocrine part, but it may help the exocrine part.
May. What percentage of people does exocrine insufficiency improve?
50.
So 50%. Wow.
I'm not sure, sir.
That's good. So patient comes to you and you tell him, I'm going to do surgery on you. He says, okay, how will I get better after the surgery? So you say, pain will disappear. He says, guaranteed. You'll say, no, not everybody. In some people it will, in others it will not. So he says, how do you know it will improve in my condition? So you say, I can't say individually, but what proportion of patients will get better as far as pain is concerned?
About 80 to 90% patients.
80 to 90%. Must read the literature, must read the books a little bit more, must read journals a little bit more, must be a little bit more up to date on numbers.
Duration of follow-up 6 months, you'll get 90%. Duration of follow-up 10 years, you'll come down to 70%. Okay.
Thank you, sir. Thank the faculty. The next group people can please come forward. I would like to invite Dr. Surendran, Dr. Pratap Reddy, Dr. Jashwant and Dr. Sukumar for the next session.
Who is presenting?
I'm presenting. Good afternoon, sir. My patient is a 42-year-old male who is a farmer by occupation, resident of Vishakhapatnam, who came with the chief complaint of pain in abdomen since 6 months, yellowish discoloration of eyes and fever with chills since 15 days. So my patient was apparently alright 6 months ago when he developed upper abdominal pain, which was insidious in onset, moderate in intensity, dull aching, radiating to back and relieved on bending forward with no relation to food. Patient also gives history of passage of oily, foul-smelling and frothy stool since 6 months, with history of unintentional weight loss of 12 kg, which is about 15% of body weight in 6 months. For these complaints, patient visited a local hospital where he underwent an ultrasound, the report of which is not available, following which he was started on some oral medications, one of which was given thrice daily with meals, with improvement in the symptom of oily stools following that. Now, since 15 days, patient has come with worsening of pain with severe, constant, dull aching, upper abdominal pain radiating to back. Patient also has history of yellowish discoloration of eyes, high colored urine since 15 days, which is associated with a generalized pruritus leading to disturbed sleep. Patient also gives history of high grade fever with chill since 15 days and loss of appetite since 15 days. For these complaints, patient visited AIG where he underwent an endoscopy wherein he says some biopsy was done.
Can we stop with that?
Yes,
and
sir.
with the history, what are all the possibilities you think of?
Sir, he has an obstructive jaundice.
How do you know it's an obstructive jaundice?
Sir, he has a jaundice. There is a high colored urine. So there is also a previous history of pain radiating to back with steatorrhea, which has improved on what is likely to be a pancreatic enzyme replacement. Tablet taken with meals, sir. So a background of chronic pancreatitis with exocrine insufficiency, with two possibilities, sir. One could be a recent malignant change, or an acute episode which is also causing a distal CBD obstruction. Maybe an inflammatory stricture, sir.
Okay.
So with this history, patient came to AIG where he underwent an endoscopy and he says a biopsy was taken, following which a stent was placed. Following the stent placement, he has noticed improvement in the jaundice as well as the pruritus. Sir, on inquiry, the patient also gives history of mild pain in abdomen 2 or 3 times since 2003, which prompted him to visit a local doctor and get oral analgesics. At present, patient does not give any history of vomiting, postprandial fullness or any abdominal lump, no history of any black colored stool or bloody vomitus, any prodromal symptoms like fatigue, loss of appetite preceding the jaundice, or low-grade fever, any dry eyes, dry mouth, bone pain or colicky pain from loin to groin, any history of chronic alcohol intake or smoking. There is no history of recent onset of diabetes, any abdominal distension, back pain, bony pain or breathlessness. In the past medical history, there is no history of any hypertension, heart disease, thyroid disease or tuberculosis, and no history of surgery in the past. The patient also does not have any significant family history of similar abdominal pain in siblings or parents, or any pancreatic or gastrointestinal malignancies.
Can I stop you here?
Yes, sir.
Can you hear me?
Yes.
You said chronic pancreatitis.
Yes, sir.
So, was there any prior history prior to that to
Sir,
come to conclusion it's a chronic pancreatitis?
So on prompting, he is giving
So only short
prior
duration
mild
you think
episodes.
in terms of a chronic pancreatitis?
Sir, on prompting, he gave history of prior mild episodes which were treated with oral analgesics.
So do you think how many months or how many years prior to should be there to come to a conclusion that chronic pancreatitis advancing to a cancer?
Sir, it is a long-standing history.
But this patient did not give any prior history of pain abdomen or anything prior to not more than 6 months.
Yes, there can be a painless progression of chronic pancreatitis in...
You said steatorrhea.
Yes, sir.
So can steatorrhea be in malignant conditions, other malignant conditions?
Sir, exocrine
You
insufficiency
think only
is
chronic
common.
pancreatitis?
No, sir, it is common in...
So what are the conditions you can expect, or you can come to change your diagnosis?
Sir, malignancy, head of pancreas
Can
malignancy
CA
itself
stomach
can
produce steatorrhea?
Yes, sir, because of acid, reduced acid.
It is umpty number of GI conditions that can produce steatorrhea.
Yes, sir.
Not only chronic pancreatitis. Right?
Yes, sir.
Okay. But what the stent, you said stent has been done.
Yes, following recent history of jaundice, a stent was placed, following which he had relief of jaundice and pruritus. Likely to be a common bile duct stent, sir.
Do you think what type of stent they might have done for this patient?
Sir, from history, it is not clear, sir.
It's not clear.
No, sir.
Is only single stent, plastic stent, or a self-expanding stents?
Sir,
It's a permanent one or a temporary one they might have given for this patient? Not from the history, you are not able to, because the short duration, loss of weight and loss of appetite is there.
Yes, sir.
So you like to have some other things from the history?
See, in a super specialty exam, you are treated like a consultant.
Yes, sir.
Okay, so you can talk to the examiner freely, politely.
Yes, sir.
In your history, you said the patient had loose stool or something like a steatorrhea, oily stool, and he has been given some medicine that became all right, or he felt better, he gained weight. What does it tell you?
So likely to be a pancreatic enzyme replacement, which is he's
Deficiency.
taking
Do
with
you
the
get pancreatic enzyme deficiency in a malignancy?
Sir, it can be there in head of pancreas cancer also, but it usually does not present overtly as a steatoria.
How many cases of pancreatic cancer, head of pancreas you have seen with steatorrhea?
No, sir, it usually does not present overtly with
So
steatoria.
common things are common.
Yes,
Don't bring in uncommon things. So when an examiner asks you like this, sir, the patient gives a history like this, it became all right with replacement therapy. So I feel that it could be a chronic pancreatitis. That is how you must tell, explain.
Yes, sir.
When I tell something, don't take it 100%. Like I may probably pull you into some trap,
Yes, sir.
and you shouldn't fall into that.
Yes, sir.
Okay, go ahead.
Tell the findings on examination.
On general physical examination, sir, 42-year-old male is moderately built and moderately nourished with a height of 160 centimeter, weight of 58 kgs and BMI of 22.6 kg per meter square. Is conscious, cooperative and well oriented to time, place and person. With a pulse rate of 76 beats per minute, BP of 110 by 70 millimeter of mercury, respiratory rate of 16 cycles per minute. Patient is afebrile as of now. His performance status ECOG is 0 and breath holding time is 35 seconds. There is no pallor, no icterus, cyanosis, clubbing or generalized lymphadenopathy or left supraclavicular lymphadenopathy. There are few scratch marks noted over the abdomen and upper extremities. There is no pedal edema. There are no signs of chronic liver disease. Oral cavity and back and spine are normal. On parabdominal examination, on inspection, abdomen is flat, umbilicus is central and inverted. Corresponding quadrants move equally with respiration. There is no fullness noted anywhere in the abdomen. There are no surgical scars, sinuses or dilated veins or peristalsis or pulsation. Hernial orifices appear normal. External genitalia appears normal and renal angle appears normal. On palpation, abdomen is soft and non-tender. There is no hepatomegaly or no splenomegaly. No other palpable lump in the abdomen. No palpable cough impulse at hernial sites. No renal angle tenderness or external genitalia is normal. On percussion, upper border of the liver dullness is in right fifth intercostal space with a liver span of 13 centimeter. Rest of the abdomen is tympanic to percus. On auscultation, normal bowel sounds are heard. On perrectal examination, no mass palpable, no deposits or gloved fingers stained with normal colored stools, non-greasy stools. Other systemic examinations are normal, sir.
So at the end of the examination, any change in your possible differential diagnosis?
No, sir.
So according to you, what are the most likely two possibilities?
Most likely a malignant disease over the background of a chronic pancreatitis.
So what makes you think that there is development of cancer or a benign condition?
A short duration of the history, sudden loss of significant loss of weight, sir, and a change in the character of the pain, recent change in the character of the pain.
So what is the change in character which made you think it is malignancy?
Intermittent pain changed to constant radiating pain to the back and increased intensity.
So you think it is long-standing chronic pancreatitis over which patient has now developed malignancy. Okay. How do you proceed to manage this case?
Sir, based on history and physical examination, we would like to proceed with...
Share the laptop screen.
So first of all, we would like to know any previous investigation or any imaging has been done by the patient, and among which I would be more interested to know about the CBC, LFT, PTINR and ultrasound scan. So can you just have the CBC? CBC normal. Can we have RFT? RFT is normal, sir. LFT, please.
This is before the stenting intervention.
So before the stenting, so this is a case of obstructive jaundice with a total bilirubin of 3.8 and direct of 2. ALP is 481 with albumin within normal range and INR of 0.7.
Would you like to know the pre-stenting values of
so
the
this is the
LFT?
Pre-stenting values.
These are pre-stenting.
Pre-stent. Okay.
Pre-stenting values. So based on this, any ultrasound was done, baseline ultrasound for this.
So what is the cause of SGOT, SGPT raised in this condition?
Could be cholangitis.
So you have any other features in your investigation to show it's a cholangitis? What other features you will look into to see it is a cholangitis?
Based on
is there anything in the history it has come?
History, sir, he presented with fever, with chills and rigor.
But in investigation, anything is shown?
Total count is normal, sir.
Normal.
Yeah.
So what will be the total count you will be worried about?
Sorry, sir.
What will be the total count you will be worried about? It is an infection.
So if it is more than 11,000,
Only more than 10,000 you'll be worried about?
like if it is below 4,000 or more than 11,000.
Leukopenia, not worried about leukopenia. So you should be worried about leukopenia and leukocytosis also.
Yes.
Right?
Yes.
So this is normal in this case. Okay.
They want ultrasound.
Ultrasound shows liver is normal, GB is distended, pancreas is atrophic at the body and tail with a 3 into 3 centimeter hypoechoic mass present at the head with a dilated MPD and CBD. No other relevant features. So based on this, since these were pre-stenting laboratory values, I would like to repeat CBC and LFT now, and along with ultrasound, this report, I would like to confirm this finding with a pancreatic protocol CT, sir.
So you are happy with the findings here, but she gave, you gave us chronic pancreatitis. Is there any evidence in the ultrasound to show it's a chronic pancreatitis on the background of chronic pancreatitis?
Atrophic pancreatitis has been mentioned, sir, but there is no calcifications.
So what next do you want?
Sir, triple phase CT, sir, pancreatic protocol CT.
Okay.
Can you have the CT?
CT is there?
Yes.
So what is very clinching? Which phase you are more worried in diagnosing your
Laptop feed.
Which phase you are worried about?
Sir, pancreatic phase, I like to see.
Pancreatic phase? Parenchymal phase.
Parenchymal phase.
At what seconds will be before coming the CT? I am
Share
just
the
want to
laptop
share
sheet.
what is your
40 to 50 seconds.
how much?
40 seconds to 50 seconds, sir. 40 to 50.
45 seconds you want me.
I thought you should be
Later artery phase.
interested in all phases of a
yes, sir.
angio CT, you know.
All the
Otherwise,
phases.
where is the need for doing a triphasic CT?
Yes, sir. So this is a non-contrast CT, sir. It is non-contrast CT shows atrophic pancreas without any calcification, and sorry, there is calcifications are there, sir, in that head regions. It's large size.
You call that calcification?
Is it calcification or ductal calculi in the head region?
So,
You know the difference between a calcification and calculi, right?
yes, yes.
Do you think it's a calcification or calculi?
Chunky calculi in the head.
Calculi, sir, it's calculi intraluminal.
So in a CT scan, what do you look for? Tell me, you suspect a case of head of pancreas malignancy. In CT scan, what do you look for? Why do you want to do CT scan, first of all? Ultrasound showed the findings, no? Why do you want to do CT scan?
So since ultrasound is operator dependence, I would like to confirm the findings of ultrasound with a CT. Along with, if it is a malignancy, I would like to see its relationship with the vasculature, if there is any infiltration, if there is any liver metastasis, and
Liver metastasis you can see better with ultrasound. So spread elsewhere you want to see, okay, then?
And pancreatic atrophy, pancreatic duct diameter.
Okay, ultrasound itself told you that it is dilated duct. Okay.
Any
See, as a surgeon, you are supposed to look for some specific findings
lymphadenopathy, sir.
not given in ultrasound.
Yes, sir. Regional lymphadenopathy, sir. Enlarged lymph nodes, vascular invasion.
Speak a bit loudly and clearly, you know, we are not audible.
Sir, any vascular invasion?
Sir's question was, what additional advantage or additional features you get on a triphasic CT scan of the abdomen over and above ultrasound?
Vascular invasion, sir, number one.
No, that you told.
Yeah.
And what else?
Number two, any local invasion to the surrounding structures.
That is vague. What specifically you want?
Susceptibility of the people. You said invasion of the blood vessels, that's the most important thing, okay? Yeah. But something else, most of the surgeons we miss and then we feel bad on table.
So that solid tumor contact with that SMA or SMV. So.
That comes under vascular.
Abnormal vessels, arterial anomalies.
Abnormal vessels, it's most important is abnormal vessels, which is not detected by ultrasound.
So make it a habit to rehearse this question and answer, you know. Advantages of a triphasic CT or ultrasound abdomen. One is vascular invasion, which again is divided into portal venous, SMA, gastroduodenal artery, common hepatic artery. If it's a large duodenal tumor, including IVC also becomes very important. Next is, are there any vascular anomalies which if we miss can be a disaster on the table? Next is the stage, if it's malignancy, stage of the disease in terms of lymphadenopathy, whether there is any peritoneal or liver mets, you should tell under those headings. Otherwise, there is no point of doing a triphasic CECT abdomen, you know. So, what's the report of this?
So, vascular anomalies. What other things can be made out in vascular anomalies? One, we are bothered about the accessory vessels or replaced vessels. Any other thing pertaining to your carcinoma of the pancreas you will look into?
The involvement of celiac axis.
Yes, that is very important. So celiac, most of our patients are more than 60s, you know, presenting. So we should know the status of your celiac axis, how far the occlusion is there. CT.
So they have done PET-CT. PET-CT shows FDG avidity noted in hypoenhancing lesion arising from the head and uncinate process of the pancreas, causing dilatation of MPT, CPT, and bilobar IHBRD, abutting SMV, which is less than 90 degrees, and the lesion measures around 3 into 3.1 centimeter with a SAV of 7.6. There is a diffuse calcification in the head and uncinate process of the pancreas, and the distal body and tail of the pancreas appears atrophic chronic pancreatitis with non-FDG avid poorly enhancing perilesional and mesenteric lymph nodes noted, query reactive along with distended GV. Liver looks normal.
You have told us the findings. Tell us the complete diagnosis in this particular patient.
So this is pancreatic HCA in the background of CCP with which is like with the abutment of SMV that is less than 90 degrees.
You are describing the findings. Yes, I said, tell us the summary of this report. So you should say
resectable CA pancreas
carcinoma head of pancreas, suspected carcinoma head of pancreas in the background of
CCP.
Chronic pancreatitis, operable, borderline operable, locally advanced, metastatic.
Operable.
Don't let the examiner ask you same thing again and again. You by now you should know what you are supposed to tell in the exam. Operable, if it's borderline operable, what are the borderline operable findings? If it's locally advanced, what are the locally advanced findings on CT? If it's metastatic, where are the metastatic which makes it inoperable? That's how we should practice telling the CECT in a case of carcinoma of pancreas. This is suspected, sorry. So After this, what are you going to do?
So I would like to do an endoscopic ultrasound with biopsy, US biopsy from the head of the pancreas.
Why do you need a biopsy?
If suppose sir says, why do you need a biopsy? I don't agree with your approach. What's your answer?
So it is afferent resectable, sir. So in resectable cases, we don't need biopsy, but since the patient...
No, what did you say? You don't need a biopsy, but... so what does it mean?
It's afferent resectable. Based on the CT, so it looks afferent.
So all resectable lesions, you need a biopsy to confirm before going for management. Is that protocol?
No, sir.
So what is clinching against where you are worried about? Your PET CT has picked up something. Besides Cori.
Sir, reactive lymph nodes.
Yes. Are you worried about that?
Sir, please be loud and clear. You are
reactive lymph nodes mentioned, sir, on the PET CT.
So you are worried about the size of the node?
So but PET CT showing a non-FDG a bit.
Okay. You will take that as this thing and then go ahead?
No, sir. At least one EUS will do, sir.
So if at all you want to do a biopsy, in what conditions you would like to do a biopsy? From the mass?
From that...
No. First clear us this doubt. Whether biopsy you will do or you will not do.
In borderline resectable cases...
In this case.
In this
your
case...
diagnosis based on PET CT is what? Operable, suspected pancreatic head cancer. Will you do a biopsy or will you not do a biopsy?
Sir, I would like to do a biopsy, sir, from the lymph nodes.
So see, you can tell whatever you want, but only thing you have to substantiate.
Yeah.
This is why I do this.
The suspected so-called lymph nodes are also perilesional. Will it make it inoperable?
No, sir.
So, you said you will do a biopsy. Will you do it? Is it necessary?
No, sir. No, sir.
You will not do it. So, what will you tell the relatives?
So it's resectable pancreatic cancer, and we'd like to go ahead with the
But they say
surgery.
you have not done biopsy. How do you say it is cancer? Can it be anything else? Can it be anything else? I say it is focal chronic pancreatitis, calcific. So what do you tell the relatives?
So since the patient is presented with significant weight loss, so
okay,
that
you are suspecting cancer.
Yeah.
So relatives are asking, you are not sure, no, why not do a biopsy?
Like you do tumor marker CA99 to confirm. CA99
and we'll come to that. We'll come to that later. We should decide about the biopsy. Should you do, should you not do?
We should not.
This looks like
Not indicated. Not indicated in resectable cancers. We can see, as a surgeon, you must think broadly. The history said the patient had pancreatic insufficiency. Alright?
Yes.
So when you do a Whipple, when you remove the head, which is the only portion, the rest of the pancreas is atrophied, what will be the patient's nutritional status? Isn't it? So you don't want to do an unnecessary surgery on a nutritionally poor patient. So you would like to confirm by doing a biopsy before going in for surgery. Isn't it a approach which is possible and good for the patient and for you?
Yes, sir.
Isn't it? That is what we expect from you. Think the whole thing background.
Yeah. The other way to think is, because there are two possibilities in this. Carcinoma of pancreas in the background of chronic pancreatitis or focal chronic pancreatitis. So, if suppose in a patient like this, you say biopsy, you argue by saying that by doing a biopsy, I will rule out, if it comes as adenocarcinoma, you will rule out chronic pancreatitis, you are more justified in doing a Whipples. It is easy to convince the family also, if you have a biopsy positive report of cancer, in a patient undergoing very major surgery, which carries significant morbidity and mortality. So you can argue both ways. Operable suspected pancreatic cancer, biopsy is not mandatory, but in a situation like this, where the second possibility is chronic focal pancreatitis also, if a biopsy proves malignancy, it is much easier to convince the family regarding the need for a major risky surgery like Whipple's.
So having said that, in the background of chronic pancreatitis, almost all these symptoms are of malignancy. And SU values less than 4.5 is suggestive of chronic pancreatitis inflammatory mass. More than 4.5 is suggestive of malignancy. The same way, CA99 level, especially chronic pancreatitis. By Ramesh paper, almost more than 300 is almost 100% accurate for diagnosing chronic pancreatitis. If you take Stanley paper, the grossly dilated duct, I think more than 11 point, they haven't mentioned the duct size, but it's grossly dilated. All these things suggest you of malignancy. On the other hand, the sensitive specificity of EUS is less than 70% in the background of chronic pancreatitis because of calcification, all those things.
And the other thing is,
so you can explain all these things.
yeah, when you say biopsy also, you should be ready with the possibility that you attempt a biopsy, but at the end of it, you still can have a situation where it can be positive, it can be negative. Is it going to change your approach in this patient?
No, sir.
So you can take all these things to account and go ahead, diagnose malignancy.
So what's your plan now?
So in this case, we'd like to proceed with Whipple's surgery.
CA99. If grossly elevated, what will you do?
Will you do CA19.9 as a routine or not?
Yes, sir. Yes, sir. We'll do as a routine.
How will it help? Sir is asking role of CA19.9 in a patient like this. Has it got any role? What if it has got some role? What is its role?
Grossly elevated CA19 indicates vascular invasive tumor.
What?
Invasive tumor.
No, you tell the basics first. If it's elevated, what does it mean? How will it help you? Is the level of CA19 point of any relevance?
Sir, in this case, patient had obstructive jaundice first. So in this case, the CA99 will be elevated. So we
Let
have
us
to
assume that bilirubin has come to within normal limits.
So at that time we have to repeat one more CA99.
Yeah.
But since in this case PET-CT was taken
So
and PET-CT
like he
did not-
already said, more than 300 even without biopsy is likely to be cancer until proved otherwise. Any higher than that level is of any relevance? If suppose say it is 1000, is it of any significance in a case like this?
If it is more than 1000, it shows it is a metastatic case or locally advanced disease.
That is considered a relative indication for PET-CT if it is not already done.
Yeah. Yes.
Or there can be a staging laparoscopy that needs to be done before going for surgery.
Okay. So what's your plan now? That's the CA19.9.
So CA99 it's 36. So following this, we'd like to prepare the patient for surgery, look at his nutritional status, and we need to
do a biopsy or not?
Sorry, sir.
Again,
biopsy.
Biopsy is required or not? This patient.
CA1990 36. So will you do a biopsy or is
We discussed it, but sir is wanting to again
now
stress
that
on
you know the CA19 result,
Yes, sir.
will you do a biopsy or not?
Yes, sir. I'll do.
Why?
So. But CA99 is normal, sir, here. But I would like to do biopsy for the same reason, because of to rule out benign etiology, sir, in this case.
To avoid future problems, nutritional problem. The malignancy in a chronic pancreatitis is a pretty bad disease. You may operate, the patient will be all right for 1 or 2 months. After that, he will come back to you with gross edematous leg, needing albumin every week or every once in 2 weeks. So we have to think twice before. As a surgeon, we should know when not to operate. But of course, this is a malignancy. If it comes as, then you need to operate because of the operable, resectable lesion. Explaining the whole thing to the relatives and the patient, that he may become nutritionally bad, that needs follow-up.
So what's the plan and how will you counsel the relatives of this patient?
So we'll counsel regarding the pros and cons of surgery, and we'll prepare the patient.
First thing you have to tell is what is the surgery you are planning.
Yes.
What surgery are you planning?
Whipple's PD, sir, along with LPJ, sir, in this case.
What did you say?
So Whipple.
LPJ. Why LPJ?
Why LPJ?
Sir, because of dilated duct in the body and tail.
So what do you do following after Whipple? LPJ.
Whipple along with LPJ, I would like to do, sir.
Whipple with LPJ you do.
Why
Maybe technically the surgery may be easy. So that's why you are telling that. But there is no need. A dilated duct, either a pancreatic jejunostomy or a pancreatic gastrostomy should be all right when there are no multiple strictures. If there are multiple strictures, yes, in order to avoid pain, you may do a LPJ. Otherwise, there is no need.
It is uniformly dilated, must be 1.52 centimeter.
Your answer would have been correct if suppose there were multiple calculi in the rest of the pancreatic duct. Your answer would have been right. But this is head dominant calculi with suspected carcinoma head of pancreas. A standard Whipple's is good enough. Okay. Only on table, if you find the rest of the pancreas quite atrophic and you feel it's likely to be useless, you may think on the table whether to do completion pancreatectomy versus doing an anastomosis. That's the only thing. But a standard Whipple's is good enough in a situation like this. There's no need for you to do a LPJ along with Whipple's. That is only if you have multiple ductal calculi. More than that, strictures are there in the rest of the pancreatic duct. Otherwise, I don't think it's necessary.
This patient has atrophic body and tail, so eventually in the future he might develop stones. So
It's possible, but
you
you can't imagine based on what is available already with us. Based on the CT, there is a dilated duct in the body and tail with no stones in the rest of the pancreas. So you should not say Whipple's with LPJ. Standard answer is Whipple's with the standard method of reconstruction, whatever you believe in, pancreatico-jejunostomy or pancreatico-gastrostomy.
So don't complicate things. The grossly dilated without any strictures, and it is going to drain it.
Have clarity when you answer questions in the exam.
So going back to biopsy, I will ask you certain things. You said you want to take a biopsy in this patient, no?
Yes.
So what other conditions you are definitely should take a biopsy in a background of hypodense lesion? You should definitely take biopsies. So one is your AAP is normal. I mean CA99 is normal. Then other conditions where you are supposed to do a biopsy.
Autoimmune pancreatitis.
Sir is asking standard indications for biopsy, even though you are not a believer of routine biopsy in a suspected.
But you need a biopsy.
Yeah.
It is, if there is.
One is say CA99 is normal means you are supposed to do. The other things.
Borderline receptor.
So if it is
suspected. Any other systemic disease come to pancreas?
Autoimmune pancreatitis.
Autoimmune pancreas,
Yeah.
you can do IgG4 and find out.
No, but it's given in the textbooks, autoimmune is one of the
If you
indications
are
for
going
biopsy.
for a neoadjuvant therapy,
When you plan neoadjuvant chemotherapy, or
then you definitely need a biopsy to say what is the type of the tumor.
the other situation is when the patient at present is not fit for surgery and you plan to, for that reason you plan to give neoadjuvant chemo RT, then you need the biopsy.
And you suspect lymphoma, right, tuberculosis,
Yeah.
in meds.
Tuberculosis is very common in our country. It can affect pancreas also.
Or you have a differential diagnosis other than malignancy.
Any other
You
tumor
should-
suspect, nodes can superimpose some the pancreas. So many things are.
Okay.
Anything else?
So when you do a Whipple, this simple question I wanted to know, I keep asking in the exams. What steps you take to prevent vascular anomaly problems, the danger to the vascular anomaly problems? What steps you take during Whipples to avoid injury to the anomalous vessels? It's a major issue. It's a very major issue.
So the other way of asking sir's question is, are there any steps where you have not initially suspected an anomalous anatomy of the vessels?
We'll approach
You
through
can
the
do
artery
the
first approach. Artery first approach.
Artery first approach will be for SMA only, no?
But anything you routinely do,
Celiac artery stenosis. In case of celiac artery stenosis, you have to test.
where will you look for abnormal artery?
Anomalies. Sir is asking about anomalies.
What's the most common abnormal artery during Whipples?
Just feel the feel that.
Portal vein, we will be able to
Yes,
feel
it is
the after
posterolateral to the bile duct.
Bile duct.
So that is what you should feel first.
You should
It's a
feel
simple
for-
one, then that will make you suspect, oh, you have to be careful.
in a documented anomalous vessel, or where you have not done a proper triphasic CT angio, you are supposed to look for an anomalous right hepatic artery or an anomalous common hepatic arising from the SMA. Again, the right hepatic will go behind the portal vein and the common bile duct. So that's where you are supposed to look for a vessel.
Anomalous artery, more than 80% will go posterior to the pancreas only. You can safeguard it. 20% will go through the pancreas.
So during Whipples, what are the initial steps of the operation?
Cauterization, the duodenum, sir.
You do a diagnostic lap as a routine, or you straight away open the abdomen, or you do entire Whipples operation minimal invasive?
staging laparoscopy followed by
Be loud.
staging laparoscopy first, so especially in
All
a 3
cases you want to do
centimeter
staging
no,
laparoscopy.
so 3 centimeter head of pancreas lesion is there. So
When you answer like that, that means your answer is going to be diagnostic laparoscopy followed by
Followed by-
laparotomy, or
followed by
irrespective?
laparotomy and
So,
no, sir, we have to
staging
first stage
laparoscopy-
the look for any peritoneal peritoneal or omental metastasis.
So what are the
And based on-
guidelines says when you have to do a lap? All
All
cases of
body
Whipples we are
entails,
opening,
sir,
doing laparoscopy. I don't think
So,
all
body
centers
entails head
doesn't
of
do laparoscopy and then go ahead with Whipples.
NCCN says if it is
there are
more
certain
than 3
indications where you are supposed to do a laparoscopy.
So if it is more than 3
Like size of the
bulky tumors, more than
what is the size?
More than
3
3
centimeters,
centimeter
3 centimeters,
head of
More than 3
centimeters,
centimeters.
head of
bulky
pancreas.
lymph nodes and high
More than 3
CA99
centimeters, you have significant peripancreaticoduodenal lymph nodes,
high
very high
CA99.
CA 19.9 values. You are
So
supposed
you are supposed to do
But
that.
if you are a believer of minimal invasive Whipples, that is anyhow the first step of the operation. This is relevant only if your plan is to do an open Whipple surgery. You understand? Anything else, sir?
Okay. You tell us the complications of Whipple's operation.
Yeah, I think it's relevant.
Delayed gastric emptying is the most common. Delayed gastric emptying, post-operative pancreatic.
So you must come with serious complication. Delayed gastric emptying is not a very
What's
serious
the,
complication.
what's the
See,
textbook,
immediate,
major morbidity textbook
early
wise?
and late.
Early and late.
Post-operative pancreatic fistula comes under ALE.
Okay.
Post-operative pancreatic
Are you
hemorrhage.
not bothered about the hemorrhage? You should
Yes, sir.
tell first.
Yes,
That is most important life-saving procedure you have to do, isn't it? So what do you do when a patient? How do you recognize whichever area that is leaking or bleeding? How do you make sure? Say post-operative day 4. Patient is having blood in the Ryle's tube. So how do you manage?
Day,
first
day 4, luminal bleed.
Intraluminal bleed.
So first you have to rule out whether it is intraluminal or extraluminal. If it is intraluminal,
Give the rails to
12 months.
Yes, sir. So it's-
Luminal, sir has told you very clearly, it is luminal bleed, day 4, post Whipples. How will you manage?
The quantity of the bleed.
You only have to open up your mind. I would have been very happy you have told, I'll revise or I'll see what surgery has been done, whether pancreatic gastrostomy or a pancreatic jejunostomy.
Is that relevant or not relevant?
Yes, sir.
How is it relevant?
Pancreatic gastroscopy has a more incidence of
Correct.
More
So
bleeding.
the incidence of luminal bleed is at least twice compared to
pancreatic jejunostomy.
pancreaticojejunostomy. What's the other importance of knowing that?
We have to grade it, whether it is mild, early mild, or late mild, or late
The
severe.
other important thing is, if suppose it doesn't settle, an endoscopic procedure is more likely to be successful
Yes.
than in a case of luminal bleed following pancreaticojejunostomy.
Yes.
Okay, then you said one is a bleed, another one?
What are the other major
Post-operative.
complications?
Pancreatic fistula.
Pancreatic fistula. Suppose you have a pancreatic fistula by only definition, that is elevated serum fluid amylase more than 3 times the normal or more than 3 times the serum value. Okay, that's the standard definition. What is grade C pancreatic fistula?
It's multi-organ failure and death.
Multi-organ failure.
And death.
Necessitating re-exploration.
Any one of you sitting in the front has seen grade C pancreatic fistula?
Yes, sir. Yes, sir.
Yes.
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 So, what was it following pancreaticogastrostomy or pancreaticojejunostomy?
So it was
Jejunostomy.
following PJ, sir. Yeah.
Huh?
PJ, sir. Following pancreaticojejunostomy, sir.
Pancreaticojejunostomy. How was it managed? What do you think should be the ideal management?
So initially we managed it conservatively, sir, and but because of this grade C POPF that eventually led into bile leak from that AJ, and over a period of 1 month, patient
What is
finally.
the problem in the pancreatic fistula? Why the patient should go in for a multi-organ failure? When a patient goes in for a multi-organ failure, can you just keep quiet? Conservative is okay, but shouldn't you do something? Why should the patient go in for a multi-organ failure?
Your mic is not working, or your speak close to the mic. Why pancreatic fistulas are very severe?
So there is activated pancreatic fluid because bile is also present, which leads to severe.
Agreed. All that is agreed. But the most important thing is there must be some collection inside.
Yes.
Everything is not coming out. So your idea is try to take out the fluid. First a gated drainage has to be done. There should not be any collection inside. If you allow the pancreatic juice to be inside, then next step will be a hemorrhage.
Yes.
The reason I asked management of grade C pancreatic fistula is it's a very morbid, carries very high mortality. One of you tell me what are all the procedures described for management of grade C pancreatic fistula?
Completion pancreatectomy.
Be loud, man.
Completion pancreatectomy.
That is the last thing you should tell.
Re-exploration and virsingostomy.
When you are asked a question like that,
Re-exploration.
options described for management of grade C pancreatic fistula, completion pancreatectomy should be the last answer. What are the other procedures?
Re-exploration and virsingostomy, keeping the exposed pancreatic duct outside, and, letting out the pancreatic juice.
See, when a patient has a pancreatic fistula, should you do some investigation? Will you do a CT scan? I'm coming out openly. Will you do a CT scan or not?
Yes, sir.
If you do it, why? If you don't do it, why not?
CT to localize the collection, to drain it if possible.
Just to see if there is a collection inside. So, when you see a collection, you open and drain the collection?
Percutaneously it can be done.
You have to drain it and see.
So, the answer to sir's question is importance of CT in a suspected case of grade C pancreatic fistula. One is the extent of leak, where are all the collections present within the abdomen. Is there any evidence of post-Whipple's severe pancreatitis, particularly with necrosis? That is where there is role of completion pancreatectomy. If suppose there is no necrosis of the stump, completion pancreatectomy should be the last procedure you should consider. The conservative procedures described are simple drainage, lavage and drainage.
External.
Next is
external stents through the person
putting
who's
up, clean the abdomen, put drains, put an external stent. Next. What is bridge stenting? You read Shackelford or you don't read Shackelford? Bridge stenting. You pass one end of a T-tube kind of stent
between
into the pancreatic duct, one end into the jejunum, and bring it out as a combined
fistula.
External fistula.
Yes.
Okay. Then you also have
Yes, can you make it fast?
Salvage pancreaticogastrostomy or pancreaticojejunostomy. Lastly is completion pancreatectomy. That is only when you have a very inflamed, bleeding, necrotic pancreatic stump. Otherwise, it should be the last procedure in the management of grade C pancreatic fistula.
The patient is otherwise okay, you can get a admitted.
Should all these patients with chronic pancreatitis with post-Whipple's, should we subject this patient to any other follow-up? How do you follow up this patient? Need for any further management in this patient? It's a chronic pancreatitis.
Okay.
So follow-up is according to the pancreatic cancer.
So reviewing the
3 to
biopsy,
6 months.
you are reviewing the biopsy. The biopsy comes as moderately differentiated. So what is your next step?
So
All margins clear?
The TNM stage and the lymphovascular and perineural invasion, the TNM.
Suppose there is a perineural invasion is there.
So there are high risk factors which we need to consider for chemotherapy.
What chemotherapy?
Adjuvant chemotherapy.
Adjuvant.
Yes.
Okay. Sorry, other than adjuvant chemotherapy, this is a case of chronic pancreatitis. So already a burned out pancreas, nothing is there.
So we need to continue PRT, sir, for this patient.
PET therapy is required or not required?
Required in all cases after.
So if at all, how you are going to give PET therapy?
Sir, with small meals 25,000 units, with main meals 40 to 50,000 units. Sir, we have to follow up regarding whether his.
Is it required or not required? When will you start?
It is required, so we have to start in the post-operative period at discharge.
Okay. How will you advise to the patient when you start a PET therapy?
So to be taken with meals, with small meals we give.
You start before meals, in the middle of meals, after meals. What are the recommendations?
In the middle, sir.
So recommendations 50% you start before and during the course of meal they get to take 50%. So different schools of thoughts are there. Follow any one of the thoughts.
Can we move to the case
Yes,
capsule?
next case. You can go.
Yeah.
Laptop feed.
Laptop feed, please.
This is a case of a 25-year-old female resident of Assam, nursing staff by occupation, who came with chief complaints of upper abdominal pain since 1 month. Patient was apparently all right till 1 month back when she started having insidious onset, mild to moderate intensity, intermittent epigastric pain, radiating to back, not related to meals, and relieved after oral analgesics. Patients also gives history of 3 episodes of small quantities of non-bilious vomiting 1 month back. History of epigastric fullness present since 1 month. There is no history of early satiety, no history of hematemesis, melena, or vomiting after 1 month. No history of dyspepsia, retrosternal burning sensation, no jaundice, fever, altered bowel habits, no loss of weight or loss of appetite, no easy fatiguability, generalized weakness, recurrent cough, cold or other infections. No other significant past history, personal history or family history.
Somebody can summarize the positive findings also. It's the last one.
So 25-year-old female with a 1 month history of chronic upper abdominal pain, radiating to back and not related to meals and relieved by oral medications, with a history of non-bilious vomiting and epigastric fullness for 1 month. No other positive histories.
So what do you think about?
So differential diagnosis would be
It's young girl.
younger. Peptic ulcer disease. Chronic
You have to be very careful giving a diagnosis of peptic ulcer disease. She says it is relieved with the oral analgesics. Will a peptic ulcer pain relieved with the oral analgesics? It will be more, no?
Yes, sir.
See that you have to read carefully.
Young patient
Yeah.
Young patient
Pancreas.
with fullness in the epigastric
pain
region.
radiating to back.
Pancreatitis will be the chronic
Possibility is pancreatic
Possible
organ.
pancreatitis.
Anything else?
Any
Mesenteric
So this there
Pancreatic.
is epigastric fullness. So
Why
could
there
be,
is
sir,
fullness?
pancreatic pseudocyst could be one possibility.
Pseudocyst. Then
Okay, tell us the findings on examination.
Significant findings are of mass. The characteristics of mass are firm, non-tender palpable mass with ill-defined border present over the epigastric and umbilical region, which moves with respiration. The lower border is palpable till the umbilicus, upper border palpable 4 cm below the xiphisternum, right border palpable 2 cm medial to right midclavicular line, and left border till the midclavicular line. Leg raising test is negative and left lateral position mass doesn't fall down.
So what do you think so? So patient, young patient vomiting, non-bilious vomiting, 3 episodes, and the finding is there is a mass. So you say what type of mass? Where do you fix the organ now?
Could be a pancreatic.
Any one.
So mostly it's located around the pancreas.
You have a mobile mass in pancreas? What are the mobile swellings in the epigastric region? You should think.
eccentric cyst.
Commoners. What is situated behind it? Stomach, no? Then momentum. What could be what are the 2 structures located? And transverse colon. So these are all 3 structures located in the epigastric. So what is fitting into this?
So it could be a
You want
gist
some
of
other
the stomach, sir.
Yes?
Gist of the stomach could be one possibility.
You'll have vomiting?
So could be because of the size of the mass and any compression. It's possible.
So you mean to say extraneous compression of the mass
could be possible.
producing this. So you want further any clinical examination?
Short case.
So take it for example, pancreas swellings moves with respiration. Pancreas itself moves with respiration. And benign swellings, automatically large swellings can move with respiration.
Colidocal cyst.
Colidocal cyst?
Colidocal cyst.
25-year-old female patient.
Just
Palpable mass lesion, benign lesion, pancreatic lesion. Give the example. PDC.
Acute
Think of common
pancreatitis with a
things.
pseudocyst.
Think of common things.
Acute pancreatitis with a pseudocyst.
Pseudocyst will move freely.
Not freely.
This is freely mobile.
Cystic, yeah.
The pseudocyst cannot move, but the cyst can move.
Cyst can move. Cystic solution.
Cystic neoplasm of pancreas. Cystic neoplasm of pancreas.
What neoplasm?
Young age solid papillary tumors.
Anything else?
Mucinous tumors.
So something in the momentum that can move,
Omental cyst or mesenteric
that is
cyst.
common things. And stomach is a common thing. What you can have an extraneous mass in the stomach, it can move. Transverse colon, anything. Just we are seeing many number of just it
In
can
the
move.
history, they gave a clue that the pain is radiating to the back.
Not falling forward, not falling down.
That's what is taking you to that diagnosis somewhere around the pancreas or
Pancreas.
retroperitoneum. Okay, go ahead. Yeah.
Go ahead.
What are the other
What will you want to do?
Ultrasound of the abdomen first to localize the origin of the swelling.
Ultrasound?
Pancreas well circumscribed, heterogeneous, predominantly solid mass noted arising from the neck and body of pancreas, around 11 cross 8 centimeter in size. Other organs seems to be normal.
Huge. 11. So anyone, what do you think it is based on ultrasound?
Could be span.
Spen. Okay. Why do you say it is spen?
With this, can you give a differential
Differential
diagnosis?
diagnosis, yeah.
Sir, she is a 25-year-old female.
Loudly.
Be loud, man.
25-year-old female, span is the most common differential with the feature of heterogeneous picture. It's more towards span. And usually the large tumor more than 10 centimeter, they have a
So
heterogeneous.
any solid mass, bigger mass is pen.
No, sir. A young female.
Okay, what are the bigger masses that can present in the pancreas?
Pancreatic lymphoma.
Have you seen acinar cell carcinomas?
Yes.
Have you seen lymphomas? Have you seen lymphomas? So acinar cell carcinoma is one of the biggest mass that can present as a worst prognosis. It can also present as a bigger mass. And all type of sarcomas, just all that can present as a bigger mass.
Bigger masses. Irritable tumors.
So don't think always spen. Engage in favor of spen. So always have a differential diagnosis. Don't say spen as a first diagnosis. Have a differential diagnosis.
So after ultrasound, you think it is spen. What next?
I would like to see the CT.
CECT. Huge, very huge. One of you start reading it and describing it as
So
with contrast or without contrast?
Non-contrast CT
Non-contrast.
of the abdomen, axial flames showing bulky pancreas, the heterogeneous lesion with multiple specks of calcification in the neck and body. MPD could not be visualized. No peripancreatic lymph nodes.
Where is the lesion occupying?
It's arterial phase showing the heterodense lesion, mainly in the neck and the body.
Where are those calcification you mentioned?
Calcification, specks of calcification, planes, you could see.
Plainless.
So, vascular structures relation.
Describe the lesion, describe the vessels nearby, describe.
Are you able to
are
make
there-
out normal pancreas?
Are there any lymph nodes?
Normal pancreas seeing the tail.
Is it infiltrating any surrounding structure?
The lesion is well away from the SMA. There's a clear line or cleavage between the SMA and the tumor.
Summarize the CT findings.
Is it your vessel is going inside the mass?
The left gastric artery as well as the common hepatic origin appears to be very close to the
So
mass of
something
the
is
left
seen in
gastric.
that cut? Yeah, that cut. What is it? This cut? Can we go with the CT radiology findings?
CT findings and diagnosis, please.
I feel only the head area, the small mass is there, neck, but part of the head is also involved.
Sorry.
What's the final impression?
So, pancreas well circumscribed, heterogeneous, predominantly solid mass, noted arising from the neck and body of pancreas with small calcification. Post-contrast shows heterogeneous enhancement of solid areas and non-enhancing hyperdense areas within the lesion, measuring 11 cross 7 cross 10 centimeter, extending anteriorly superiorly up to gastrohepatic ligament with more than 180-degree contact with proximal segment of splenic artery closely abutting common hepatic artery and left gastric artery. No evidence of luminal irregularity noted, however. Anterior. Narrowing of distal SMV and proximal portal vein also noted with the loss of fat planes and luminal distortion. Fat planes with celiac axis SMA preserved.
What's the CT diagnosis?
SPEN. According to the CT, we also had a preoperative biopsy done for the patient.
So, what will you do now?
So as per the CT, what is your further plan? So they have gone ahead with the biopsy.
Does not look like resectable, sir. Like to go for
Be loud, man. We can't hear.
So, like to go for neoadjuvant chemotherapy, sir. This patient.
What's the diagnosis?
SPEN.
There is role for neoadjuvant chemotherapy in SPEN.
10% patient they turn to be
Now,
malignant.
where did you read this? In a case of SPEN, there is 10% risk of malignancy is okay. But where did you read this neoadjuvant chemotherapy has a role in SPEN management? This is resectable or not resectable?
So benign or malignant? SPEN is benign or malignant?
So SPEN can be both benign
spectrums are
or
seen.
malignant, sir. So both
Potentially
spectrums.
malignant.
So-
Your answer should be potentially
Potentially
malignant.
Yeah,
That means it's benign.
SPEN is a benign tumor with a 10% potential to turn into malignancy or may later develop metastasis. If CT wise a lesion appears to be operable, surgical resection is the treatment of choice, not neoadjuvant chemotherapy. I don't know where you read this.
So only thing is indication for a bigger mass infiltrating the nearby structures, we can go ahead, give a radiotherapy. Other than that, chemotherapy doesn't have any role for SPEN.
Can the SPEN infiltrate the neighboring structures?
Yes, sir.
Can
Usually not, but it can cause local invasion, sir.
See, the question I asked was, you have to watch the examiner. Can it? If the examiner says no, sir. Will it not? If they ask, yes, sir. See, these are all the small tips you have to take to the examiner.
Metastasis.
It can metastasize,
Metastasis.
it can infiltrate, but they are extremely rare complications of SPEN. So most of the time the indications for surgery in SPEN are pressure symptoms, the fact that it can be potentially malignant, the fact that it may present later on with frank malignancy in 10%. That is the reason why surgery is indicated. Actually, biopsy need not be done. If your radiological diagnosis you are satisfied and it appears operable, the treatment of choice is resection without biopsy.
Based on biopsy, you can rule out malignancy also. See the whole specimen. Very difficult.
Maybe it's malignant, we don't know. Potentially malignant.
Malignant.
Is what we say.
So what will
Actually,
be the...
one of the reasons why it doesn't infiltrate the structure is the beta catenin. That's a molecular pathology of this SPEN.
Time up? Time up?
We have 5 minutes still.
Let them ask.
You ask any
If you have some
questions
you can ask us.
regarding the first or second case, any doubts?
So the
No,
second.
not necessarily these cases.
So
Any
this case,
has all
how it is
multiple
resectable? So
examiners.
like in this case, because it's like a huge tumor, some infiltration into the local abutment and probably a vessel infiltration. So
If the
like,
diagnosis based on CT is SPEN, and even if there is some mild infiltration of surrounding structure, but you think it can be resected, the recommended treatment is surgery, not neoadjuvant in a SPEN.
So clearly SMA is free, SME free, portalin free, common hepatic artery free, celiac axis free.
Any other questions?
What surgery will do for this? Only a local excision or something else? Only very little tail of the pancreas left behind. Will
What-
you leave it behind?
What's the treatment?
Total pancreatitis.
Huh?
Total pancreatitis.
Total. Why total? Head
Only-
is normal, no?
Head.
Head is normal. It is extending from neck towards the body. With
Duodenum, some
with
loss of
splenic-
appendix duodenum was mentioned in CTs.
No,
That is third part.
third. There is
Little
just
portion.
pressure. So what's the treatment for such a lesion?
central pancreatectomy.
You said total pancreatectomy failed.
Distal pancreatectomy.
Central pancreatectomy, you said no. Then
What-
what will you do with the tail?
See, here it is, splenic vein is infiltrated. Splenic artery more than 180%.
See, when
Can
you
you
forego, you have to think all those things. No? You cannot.
So in this
forego
case,
the splenic artery and vein and preserve the spleen and distal pancreas.
in this case, because the splenic vein is already thrombosed with splenic collaterals, the treatment in this case will be distal pancreaticosplenectomy. Okay. If suppose the vessels were normal, you would have had the choice of spleen preserving distal pancreatectomy. Okay. Any other questions?
What is the pathology behind this France tumor?
Genetic.
So what will be, what you will like to hear from the pathologist?
Spindle cell
So there will be
epithelioid.
papillary projections inside the mass. So that is one diagnostic feature of France tumor. solid and papillary, that should be there. And professor said beta-catenin related, that's why you got a bigger mass. So we should think of always a bigger mass. One I said is acinar cell carcinomas, right? That one, and lymphomas. So whenever you get a bigger mass, think of all these things. Differential diagnosis: sarcomas, lymphomas.
Neuroendocrine tumors.
Your question, please.
Sir, if you have please ask.
So if we have a patient with chronic pancreatitis with suspected mass and US has shown the negative report, no malignancies in the mass, then can we do phase procedure for that patient? If the mass is there and
as a standard answer, if CT or US have raised a doubt of suspected CA head of pancreas in the background of chronic pancreatitis, you are supposed to do Whipple's, not phrase.
So even if the
biopsy is negative.
Then sir,
What given us a hypodense mass lesion.
Yes, sir.
So in your CT has given us hypodense mass lesion. Then no question of doing phrase procedure in this patient. 3 centimeters hypodense lesion.
Suspicion is raised, treat it like malignancy.
CT is the multilobularity, doctor is preso, that will show inflammatory mass. When there is, you take IV contrast, the progressive enhancement, it is the malignancy. Early, late washout will be there in benign mass. Early washout in normal pancreas. Very late washout, persistent die in the case of malignancy. All these things.
In a pancreatic head mass, if it's benign, Whipple's is acceptable. But if it's malignancy, phrase is not acceptable.
What is the role of frozen section biopsy in that condition? When you have a suspected mass,
yes, sir,
you want to avoid surgery. Is that a role for a frozen?
No, sir.
No?
Why not?
So because if we are doing phrase procedure and we have done the
frozen section biopsy, not phrase. Suppose you do 2-3 frozen section biopsy and says no evidence of malignancy.
Yes. So if we are rupturing the tumor from the peritoneum, then we have already did the metastasis. There is no need for.
No, there were times where we say that pancreatic head mass does not require a biopsy, but that gone in for some kind of a legal problem. And now that endoscopic biopsy is available, endosonogram is available, there are so many advances that have come. So I think you better say.
So inflammatory mass also present like the same thing. Then what will be the indication for phrase then? And every patient with head mass we have to do.
No, not necessary.
It is not every case with phrase. Every case with head mass.
When you take the patient for a surgery, should you do phrase or should you do a Whipple? That's it. Why do you take chronic pancreatitis for a surgery? Because of severe pain. Pain is the indication.
Yes, sir.
When you do it, when you also see a head mass, so at that time should we? So there are so many other procedures. You tell us whatever answer you want to do, but you should substantiate. Why
No, sir, if we say Fippers, then you say that why not phrase. If we say phrase, then you can say why not
No,
Fippers.
that's exactly what
So, sir, it is difficult to.
Why
sir,
not phrase
you know?
means when suspicion of malignancy is raised in a head mass, a negative biopsy will not rule out malignancy completely. That is why you better overtreat by doing a Whipple's rather than do a phrase.
No, sir, but
and
Whipples
cut through
has
the
its own
tumor.
complications. Then, if we are doing US, then we should not do US. If we are not changing the management, then we should not do US.
This is a controversial topic. You tell Whipple why you do Whipple, we agree. You tell phrase why you say phrase, we'll agree. But you should argue sensibly.
See, why do you do Whipples? Yeah. Here, listen. Wait. So, the treatment options available for even for chronic pancreatic intractable pain, America they do Whipple's procedure. Got the point?
Head dominant.
Europe they do head resection.
Yeah, head dominant.
You do this
chronic-
phrase procedure.
Yeah, head
When you
dominant
got all the
chronic-
points for suspect malignancy.
Okay, sir.
Head
The only
dominant-
problem is patient is having long-term nutritional deficiency.
So it's a controversial thing,
Yes, sir.
even among examiners, even among many surgeons. In US, they do Whipples for a chronic pancreatitis. They say the results are better. when compared to even phrase. But in Europe, they don't do Whipple, they do only phrase procedure because nutritionally they become bad once you do a Whipple.
Sir,
You cannot
already
correct
patient
it.
is having
And all those countries, the patients are getting free medicine. All this, the Creon and all those things, very expensive. I don't know whether you know the price. The patient will commit suicide if you say that you have albumin every week and take Creon lifelong and all those things.
What
So
should
you
be the
have
answer,
to-
sir? My
you
final
have to
answer.
decide.
Final answer, yes.
You have to decide.
When you
And then
suspect,
explain, tell us why you decided like that.
when you see, you have all these points for malignancy.
Yes.
You explain to the patient. So you have to go ahead with this procedure available, you can do. People, you are not going to develop the pancreatic fistula and chronic pancreatic.
So that's why literature has given us the evidence. When you have recent jaundice, recent diabetes, so all there are, loss of weight is more. So all these things head towards you have to do a definitive procedure like
You
Whipples.
prepare the patient for.
Literature can support you in some way. So they are investigating, still investigation. Contrast-enhanced ultrasound is being done, spectrometer is being done to early diagnose whether malignancy is there or not. Still it is on research purpose.
Yes, sir, but question arises when we have asked, whenever there is a mass, we usually do EUS, normal protocol.
Now,
that
when the
EUS is
diagnosis is
vaccine.
given a hypodense lesion, then you want to argue that they want to do a phrase procedure.
US, the sensitive specific less than 75% of the background of chronic pancreatitis because of calcification and all those things.
Yes, sir.
So it is also observer dependent. Then you have to bring AII, then you have to bring molecular study, then you have to bring contrast enhanced, then fibroscan, everything you have to bring in. You go on. There are so many things.
There will be no solution.
Yes, and
So a lot of investigations are in the lineup.
See, the Whipple's procedure in a chronic pancreatitis, is it an easy procedure or a very difficult procedure?
So is it easy?
Much more difficult when compared to a simple Whipple's procedure. So if I were to be in your position, I will say, sir, Whipple's in a chronic pancreatitis and a malignancy is a very difficult surgery. I will refer him to my senior. Okay, who has got much more experience. I think that's a very valid statement. Examiner will agree. In fact, they will pat your back and say, yes.
Safe surgeon. So the thing is, early post-operative period, you have to nutritionally rehabilitate. What diet to be taken, median chain triglycerides, early PRT therapy, all these things to be done as early as possible. Don't wait for that, that's all. Keep the gut healthy. The abscess will be proper. You understand when I say keep the gut healthy.
Okay, sir, thank you.
Any more questions? Otherwise, we'll wind up this session. Thank you, sir.
Thank you.
Good evening. Actually, as I told you, actually, this is more a friendly atmosphere than we trying to argue. Actually, you're taking a super specialty exam right now. You're not taking an MS General Surgery exam now. So whatever you do, I think you should argue and defend yourself in a very friendly manner with the examiners, and I don't think you should have any problem. Again, actually, me coming onto this podium is to honor a person who has been very kind to us. He has been a big support to the surgical department, surgical gastroenterology department at AIG right from the time it started. Me personally, I owe a lot to the gentleman, Dr. Surendran from Chennai. Can I request Professor Surendran to come onto the dais? And actually, my entire team wanted to be here to facilitate him. I said, yes, of course, actually, the entire team can be here. The surgical gastro team can come onto the thing, actually. So he's been a great support to the entire department. I thank Surendran for this honor.
Thank you, Rob. I think.
Yeah, please, Surendran, you can just talk to us a little.
Probably I'm the oldest man in the crowd. That's why they have honored me. So I think it is an honor to be here with AIG team, Nagi, Rao, and the entire team. I should say we had been following them for years together. And to be very frank with you, nearly about 15 years before, the result of a DNB exam used to be 10%, 12%, 15% like that. And now it has become much, much better. It's around 60, 70% because of the training like this, given by AID and other things, the CMA program. There are three things we wanted to tell you in this kind of meetings. One is, exam is not a very big thing. It is simple, like Rao said, you talk like a consultant, talk like friends, discussion. Provided you know the subject, analyze and then tell. That is number one. Number two, never even think that the examiners have come here to fail you. No. Every examiner would like you to get a pass and come out with the flying colors. They would like to know how much you know to give you more marks. They are not here to tease you. Okay. And these are the things, and thirdly, you get to see all the prospective examiners, their thinking process, and all those things will come very, very handy during the exam. Okay. I think it's a great thing AIG is doing for the 14 years continuously. And I was told that almost all the gold medalists in the DNB examinations have participated in this kind of meeting. That's what the people used to say. I'm sure you all will do well, come out with the flying colors. All the best for you. And thank you, Rao, for I never expected this, and I really don't know why I was honored. I think you should have been the person who was to be honored. Thank you. Thank you.
Thank you, sir. We break for a short tea break. Please come back and reassemble in 15 minutes time.
hey, 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 hey.
Request everyone to settle down quickly. Welcome back. For this session, I would like to request Dr. Saumitra Rawat, Dr. Venugopal, Dr. Venkatram Reddy, and Dr. Upendra Rao to come on to the dais. Sir.
Yeah. Presenting.
Good morning, sir.
So again, the same thing, 1/3 time for your presentation, 1/3 investigation, and 1/3 treatment modality. So start.
Good evening, everyone.
Yeah.
64-year-old lady, resident from Hyderabad, homemaker, presented with chief complaint of yellowish discoloration of sclera and high colored urine since 4 weeks, loss of appetite and weight since 3 weeks, pruritus since 3 weeks, Malina 1 episode since 2 weeks. Patient was apparently well 4 weeks back when she self-noticed yellowish discoloration of eyes and high colored urine since 4 weeks, which was insidious in onset, progressive in nature, not associated with pain abdomen, not preceded by any prodromal symptoms, associated with passage of pale colored stools. Following 4 days of jaundice, she developed low grade insidious onset, intermittent fever with chills, 2 to 3 episodes per day, lasting for 5 days, for which she was advised admission, which she denied, and was managed conservatively with IV fluids and medication on OPD basis. Following which she developed pruritus, which was generalized, present throughout the day, disturb her lifestyle and sleep. She gives history of loss of appetite and significant loss of weight of 5 kg over a duration of 3 weeks. This was associated further with passage of black tarry stools 1 to 2 times per day since 2 weeks, for which she was admitted and underwent conservatively managed and underwent an MRI and further referred to tertiary care hospital for further management. Patient underwent some endoscopic procedures with biopsy and placement of tube, following which she had decrease in pruritus, but her appetite is still not good. There is no history of recurrent episodes of abdominal pain, no history of nausea and vomiting, no history of abdominal discomfort, respiratory discomfort, hemoptysis. There is no history of headache, seizures, blackout, back or bony pain. And there is no history of any postural dizziness, syncope, fatigue or shortness of breath. She gives history of diabetes mellitus since 6 years. She is undertaking metformin. There is no history of recent deterioration of her glycemic control. She gives history of hyperlipidemia since 6 years, taking rosuvastatin. There is no history of any hypertension, asthma or tuberculosis. She gives history of right tibial fracture, underwent some surgery which was uneventful 6 years back. Her family history is not contributory. She consumes veg diet, sleep is disturbed, her bowel and bladder habits are regular, and no history of any alcohol or smoking. So she is a 64 years old lady
with history of diabetes mellitus and hyperlipidemia controlled with medication, presented with painless progressive jaundice since 4 weeks, with troublesome pruritus since 3 weeks, with significant loss of weight and appetite, with a history of resolved episode of cholangitis with melena, with history of some endoscopic intervention with biopsy. I'm suspecting it to be a case of surgical obstructive jaundice, possibly due to some neoplastic etiology. The order in which I'm thinking, it can be a periampullary carcinoma, a carcinoma head of pancreas, a hilar cholangiocarcinoma, and lastly a CHGB neck.
So, okay, you said obstructive jaundice, that's fine. So how did you put your diagnosis, I mean the probability order, how do you substantiate the order that you have given?
So first I'm thinking in terms of periampullary, since this is a painless progressive jaundice. She gives history of one episode of melena which lasted for 5 days, although she doesn't give any history of decrease in jaundice following the episode of melena. Secondly, I'm thinking carcinoma head of pancreas because...
Is there anything else positive for that ampullary one in your history, what you have said?
Sir, the age, sir, the presentation, painless progressive
also
jaundice.
Some intervention, you said some biopsy was done.
Yes, sir, and also one biopsy. Yes.
So that also gives
Yes,
some
yes.
evidence, okay?
Yes.
But the ampullary lesion.
Yes.
Okay.
Secondly, sir, I'm keeping carcinoma head of pancreas, although mostly present with painful progressive jaundice, but 1/3 patients don't have associated pain, but they can infiltrate the duodenum and can cause associated melena. She is having a significant history of loss of weight, which is approximately 5 kg, she's telling herself, since over a period of 3 weeks. So taking, there is more CHOP is associated with more history of anorexia and loss of weight. So I'm considering that to be more common, and seeing that this part of the country, CHOP is also more common.
What is the cause of pain in cases of carcinoma head of pancreas? What is the reason?
Sir, one reason is, sir, due to the neural infiltration. Another reason is due to the stretch in the capsule.
Is it more common, the pain in periampullary or CA head pancreas?
Sir, carcinoma head of pancreas has got more pain.
More chance.
Yes, sir.
But first diagnosis, you have put periampullary because pain is not there.
Progressive jaundice she had, sir.
Okay. Suppose there was no tarry black stool.
Yes, sir.
Would you have put your differential in different order?
Still considering the painless progressive jaundice, sir, first I would like to keep periamp only. Then I would like to keep.
What are the chances of cholangitis in periampullary? Is it high, low?
So relatively
compared to
yes.
cholangio which you have put, which of the two has got higher chances of cholangitis?
Sorry, it's exact figures I don't know, sir.
No, which one?
Which one out of the two got a higher chances of cholangitis?
Hilar cholangio has got
Hilar
more
cholangio.
chances, sir.
Why?
Why?
Sir, because higher level of block.
See, in periampullary, you can have a fluctuating jaundice as well sometimes. So it's not totally blocked.
Yes, sir.
So, you know, if there is a partial drainage, the chances is comparatively less. I'm not saying that, you know, it doesn't happen. But since we were talking about pain more in head of pancreas than in periampullary, so that is why I was asking which one has got more chances of cholangitis.
Yes, sir.
Okay.
So when do you say hilar cholangiocarcinoma as your primary, like if you put it the top in the order? The history, anything more specific?
Sir, most of the hyalocholangiocarcinomas, they proceed with pruritus followed by jaundice, and most of the time they have percutaneous interventions more commonly to relieve the jaundice and cholangitis in comparison to the distal blocks.
Is diabetes mellitus, see, she's 64, okay?
Yes, sir.
Is diabetes mellitus of any significance?
Yes, sir.
So what does it take you to? Contradictory.
Sir, onset of diabetes after the age of 50 years, or if patient is already having diabetes history and there is recent change in the glycemic control which is getting deterioration, it points towards the carcinoma head of pancreas.
Head of pancreas. So, that becomes bit significant. She developed diabetes 6 years ago.
Yes.
So,
yes,
that also you need to take in. But normally it's the recent onset rather than 6 years. Okay. So you have presented the history. So can we go for any other questions?
You said black tarry stools.
Yes, sir.
So what is the typical description like? You have clay colored stools with melena.
So mostly patients will present with clay colored stools with the passage of silvery stools.
It will not be more blacky.
Yes, sir, it will be like more of a silvery stools they will complain of.
Okay. So, okay, I think you can go for the examination.
Examination, yeah. Sorry, can't hear you. You need to put it closer, yeah. And be louder.
Patient is an elderly lady, averagely built and nourished.
Sorry, can't hear.
Am I audible, sir?
Yeah, bit louder, yeah.
Okay. The patient is an elderly lady, averagely built and nourished, height of 162, weight of 65 kgs.
You have anything like averagely built, anything like that?
Averagely built.
What do you mean by averagely built?
Sir, she's not obese or she's not thin. I mean, malnourished.
I mean, I expect something like moderately built, something like that.
Moderately built.
Okay. Fine. Go ahead. Okay.
Height of 162 centimeters, weight of 65 kgs, and BMI of 22.9 with breath holding time of 38 seconds. Patient is conscious, cooperative, and well oriented in time, place, and person. Lying comfortably in bed, appears well hydrated, afebrile, pulse is 78 per minute, regular, normal volume. BP is 100 by 60 millimeter of Hg, respiratory rate 14 per minute. Icterus present, no pallor, clubbing, cyanosis, or edema. There is no cervical axillary or inguinal lymphadenopathy. There is no supraclavicular lymphadenopathy. Oral cavity is normal, and nasobiliary drainage tube is present, draining golden yellow bile. Scratch marks present over extremities. There is no stigmata of chronic liver disease, and performance status, CCD performance status is 1. Abdomen on inspection, abdomen is flat, umbilicus is central, inverted. All quadrants are moving appropriately with respiration. No abdominal fullness, no visible lump, no visible peristalsis, no visible scars, sinuses, engorged veins, or pulsations. There is no visible cough impulse in the groin. Scratch marks present over abdomen. No renal angle fullness. On palpation, abdomen is soft, non-tender, non-distended. There is no guarding rigidity or rebound tenderness. There is no hepatosplenomegaly. Gallbladder is not palpable. There is no palpable lump in the abdomen. There is no groin hernia, no renal angle tenderness, no spinal tenderness. On percussion, upper border of liver dullness is present in 5th intercostal space in mid-clavicular line. Liver span is 13 centimeters, and rest of the abdomen is tympanic on percussion. Auscultation, normal bowel sounds heard, no bruit or hum heard. Digital electrical examination was not done because patient did not consent for the examination. Cranial CNS, there was no focal neurological deficit. CVS S1, S2 was normal, and respiratory system breath sounds were literally equal. So to summarize, on history and examination, my patient is a 64-year-old female resident of Hyderabad, housewife, who presented with chief complaint of painless progressive obstructive jaundice, with loss of appetite and significant loss of weight of 5 kgs for approximately in a period of approximately 4 weeks with one episode of melena, with past medical history significant for diabetes, with no recent change in glycemic control, with preserved functional status, with history of endoscopic intervention 3 days back, with examination significant only for icterus and nasobiliary drainage tube present in situ. So my differential diagnosis will be periampullary carcinoma first, second carcinoma of the pancreas, and hilar cholangiocarcinoma.
Why do you think that nasobiliary drainage is placed in this patient?
So to indication.
What is the other form of drainage?
So this we can do stenting, we can put a nasobiliary drainage, or we can do a PTBD drainage.
Okay.
Internal.
So one is nasobiliary, second is PTBD,
Yes, sir.
and third is
internal stenting. Sir.
internal stenting.
So which is easier
So
to the
in terms-
endoscopist,
What
which
is
is
the
comfortable to the
advantage of nasobiliary
Yes, sir.
over the internal,
Yes, sir.
and what is the disadvantage? Which is better?
So
See, it depends from center to center. Japanese, they will prefer nasobiliary. Europeans, they will have a internal stent.
So
It
internal-
depends from center to center. So what is
So internal
the
stent,
presumed advantage of either one of them? Yeah.
So internal stenting, so decompression is preferred whenever the advantage of nasobiliary NBD drain, NBD tube is it does not get blocked easily. We can flush it. So if the patient has active cholangitis, then we can do external biliary drainage. But the problem with NBD is we cannot send the patient home with NBD. There are high chances of patient pulling it out. So if we have to send the patient home, then we may have to put a stent or do a PTBD.
So it's a temporary.
Temporary, yes, sir.
And when you talk about nasobiliary or internal stent,
Yes,
rather than PTC, which condition will require PTC more? Periampullary or pancreatic or hilar cholangio?
So hilar cholangio will have a higher chances of failure of ARCP guided intervention, and
So
PTB.
these are the tricks in the exam.
Yes, sir.
You can think about. So as long as you can justify, that is important. Yeah. Okay.
Did you mention about the ECOG?
Sir?
ECOG status?
Yes, sir.
You mentioned?
Yes, sir. One,
Okay.
sir.
What is that? ECOG?
One.
1.
Yes, sir.
Okay.
You talked about significant weight loss. What is the significant weight loss?
So it's more than 5% in 1 month, and
Sorry?
more than 5% in 1 month and 10% in 3 months of the weight. 10 to 6.
Anybody can say definite?
Sir, more
What
than
is it?
10% in 6 months. Significant weight. More than 10% 6 months, 5% in 3 months, and 1 kg in 2 months. 2 kg in 1 month.
Okay.
Okay, you said PR examination, you didn't do that, no? So what exactly you want to look in the rectal examination in this case?
So one is color of the stool. So patient color one is color of stool, and second is if there is any metastatic deposits or in pelvis is present, then we can palpate those deposits.
Okay.
So in this, what do you expect color of the stool?
Sorry, sir.
In this, did you do DRE?
So patient did not consent, so
What do you expect?
I did not expect. Because patient.
No. If at all, if you would have done, what is your for your diagnosis? What do you expect?
She had melena, no? Anything?
Melina, she had the episode pillar. Currently, she is not having any melina right now, sir.
It
2
will
weeks
be a
back,
colic stool or a colic stool?
pale colored only, sir. But only thing which improved after endoscopic intervention is pruritus.
Okay, so based on your exam, yeah.
On the examination, was the gallbladder, could you palpate?
So, after NBD or after stenting, it shouldn't be palpable.
It shouldn't be palpable, yeah.
So based on your examination now, what's your differentials now? How do you want to keep?
So I want to keep periampullary carcinoma still and see ahead of the pancreas and hilar cholangiocarcinoma.
Why do you want to put hilar now again?
Because sometimes
you said your NBD has decreased and your gallbladder is not palpable.
Yes, sir. So hilar
still wants to keep hilar as a differential.
So hilar cholangio.
Yeah, some of the hilar you can put NBD. But that will be very early, isn't it?
So how many endoscopy procedures are done in this patient?
So,
only one.
Yes, sir.
So have you seen any patient being done periamp ENBD placed?
Periampullary, sir?
These 3 years, have you seen any periampullary patient, CA patient placed ENBD?
On NBD?
For obstructive jaundice, ENBD?
Yes, sir.
Like your center, any other referred patients, have you seen ENBD placed for periampullary cancer?
No, sir. So I'm
not seen. Okay. So you can rule out CAGB. It was your differential one more.
So after examination, ruled out CAGB because CAGB to produce jaundice, obstructive jaundice, it should be there was no palpable mass in the abdomen. So very unlikely to have a big gallbladder mass.
Do you always feel a mass in CAGB?
No, sir.
Eh?
No, sir.
That's what.
But
and how did you rule out?
How do you rule out? Because you are so definite that you can't find the mass, so there is no CAGB.
But patient to have gallbladder cancer patient to have obstructive jaundice, the mass should be sufficiently large. Plus, patient should, in the history also, patient does not have any pain. So
but usually in this case you would have felt if it's CAGB,
yes,
either the mass itself or distended GB, if it is at the heart mass. Okay.
Yes,
so you are not feeling so unlikely to have that.
Yes.
Okay.
Okay. What investigations you will start?
Share the laptop feed.
At time so that you know we can. Yeah.
Sir, first I would like to review the previous reports what has been done because already procedure has been done. So they might have done at least a liver function test. Or
yeah.
What exactly you want? You want
so
about the
patient would have had a blood test and MRCP, isn't it? That is what patient had. Okay.
Yeah,
okay, you ask for whatever you want, what you would have done.
And while you are having a look, keep on commenting. Yeah.
Sir, hemoglobin is normal.
Close and loud. Can't hear.
Hemoglobin is within normal limit. Counts is within normal limit. So there is right now no picture of cholangitis. Platelet is normal. That is on higher side.
Next, what do you want?
Electrolytes, blood urea, and creatinine, everything is normal. Next, any like before they have done endoscopy intervention. So before intervention, any ultrasound imaging they have done, I would like to review.
You don't want to know the LFT?
So I would like to figure.
Oh. So if you're looking at preoperative, I mean before procedure, you should know LFT what it is.
So now you know why they put a stent in.
Yes, sir.
So what it is?
Bilirubin is 21.7.
Bilirubin is high, sir. Along with that, SGOT, SGPT is elevated. So there is some evidence of biochemical cholangitis. Plus ALP is elevated.
What did you say? There is some evidence of
biochemical cholangitis.
Okay.
Albumin is on the lesser side. INR is normal. So synthetic function is intact, and patient is showing some biochemical cholangitis in the background of obstructive jaundice.
Okay. What
so
else?
with this finding and periamp, imagine it's a periamp malignancy, and there was no cholangitis. Just imagine. Would you prefer surgery?
Operable periampullary
With
with
this jaundice.
bilirubin of 21.7, no cholangitis. That is what, isn't it? So, what would you have done?
So nutritionally patient is poor, albumin is 3.3, so I want to improve nutrition before going to surgery.
How much you want?
Sensible, sensible.
Good. How much you want to expect?
So that you have not gone into the argument of bilirubin more than 15 or nothing. See, that is a smart one, smart move. Yeah.
Okay, then I will tell albumin if it would have been 4.
In that sense, sir,
Close
generally
to the mic, a
our
bit loud,
center preference is if bilirubin is more than 15, generally will like to drain before going for surgery.
Why is it preferred 15? What is the evidence?
Why do you want to drain?
Based on what you have kept it as a mark? 15. Why it is kept it?
Some people will say that, if you put a stent in, there is a source of infection.
Yes, sir.
So, but then this lady, if you
Then,
think
then, see, it's not about bilirubin.
Yeah.
If you look at all other marker.
so why do you think they have stented this patient? Is it for the nutritional purpose or something else?
So patient had a fever, so he had episode of cholangitis.
So that's for cholangitis, no?
Yes, sir.
Then you said with this LFT, you said it's for some other reason you wanted to stent.
No, sir, I asked.
I want to
There
revise.
should have been no cholangitis.
cholangitis, okay.
So what level you prefer to stent? Jaundice level. So it means what I asked.
See,
Yours
passed-
is 15, you said.
Center wise, we do.
Why it is kept as 15? Why not 14? There should be some reason, no? Yeah, it is right. It's acceptable your answer, but why?
Is there any papers or any literature you will quote that, this was done and it was found so and so?
No, sir. Sorry, sir. I have no idea.
Is there any guidelines?
No guidelines.
Based on the same paper.
Okay, so this is LFT and what else you want?
Any ultrasound imaging is
Okay.
done. This is post procedure or pre procedure?
See, second last line, what does it says?
Pneumobilia is there.
No, second last. Pancreas visualized portion normal.
Oh, so he's asking another
this is
question
other-
here.
Okay.
Third line it is there, stent in situ.
No, from the bottom. Second.
No, sir. He's asking this ultrasound is.
It's a
before
post-stenting.
endoscopic
You can see,
procedure.
I don't know, it's written CBD stent in situ.
Actually, pre procedure any imaging is done. I want to know.
Yeah, you want to.
Is there a pre-procedure ultrasound?
Patient presented to us with the outside MRI. We have that.
Okay,
Yeah,
okay.
outside
Can we have a
MRI.
look at outside MRI before the stent?
Till he opens up, what are you interested in on that
Yeah, what do you
MRI?
want to see in MRI? They'll show you MRI, what do you want to know in MRI?
Sir, main thing I want to know the level of block and the etiology of the block, and along with that.
No, it is there for you, yeah. See, that's the good thing, when you are sitting there, you can ask for anything and it's been made available.
Sir, there is this is T2 sequence, axial section. I can see dilated intrahepatic biliary radicals with cutoff at the level of hilum. I could not appreciate distal CBD here.
Where is the cutoff? Can you appreciate? on a MRCP. Now it's better. Okay.
Sir, I could see dilated right anterior, right posterior system. Both are connected in the right side. Left side system is dilated, but there is a discontinuity between the left and right system. And distal CBD is not undilated, and there is a discontinuity at the level of hilum.
Okay.
So looking at a MRI, what do you think would be?
And another,
What
what is
type?
the other finding which is not visible there?
Gallbladder is not visible.
Gallbladder.
Considering the MRI, it is looking like a block. There is no mass lesion I could appreciate. It like it a type 4 block, hilar block.
Type 4. So what is type 4?
Sorry, sir, it's a type 2.
So what is type 2?
Type 2 is block at the level of hilum.
Tell us all the types, you know.
Yeah, now we tell
So
all
that-
4
so
what it
that-
is. Yeah.
Sir, type 1 is hilum is intact. Type 2 is hilum is involved. Type 3A, 3B is there. 3A is the block is extending into the right system. Type 3B is block is extending into the left
So,
system.
right system up to where?
Not beyond secondary.
Secondary ducts are
biliary
involved or
radical.
not involved?
Not involved.
Sure. Okay. So then what is 3B?
3B is extending into the left system.
What is
No-
4?
4B is extending into the both left and right system.
Where?
Up to the second order.
Okay. If on one side, if on the right side, if there is secondary biliary radicals are involved, what do you state that as?
3A.
But you said it's not. 3A is only, does not involve the secondary biliary radicals. What you said, no?
Here it is intact.
No.
It is not extending up to the second
No,
order.
we are asking what is
type
bismuth?
A, B, and
When I
3A,
asked
3B, and
when I
4.
asked 3A, you said, I asked till where it's extending to say it's a 3. You said not involving the secondary biliary radicals.
Why it's important to know what is our criteria of
Receptivity. To decide the surgical plan.
Yeah.
So 3A and B were involving the secondary biliary radicals, no? It's going up on one side. 4 means it's on the both sides.
Both sides.
So 2 is already, hilum is gone, means it is extending partly into the right or left hepatic duct. Okay.
Yes, sir.
So otherwise it doesn't make any difference, no? Okay. So now this is type 2? Or
Type 2.
okay.
So now I would like to repeat the blood investigation of the patient. I would like to see the total counts, complete hemogram. Along with that, I would like to know the liver function test. And as the patient is already trained, I would like to see the tumor markers and kidney function test. I would like to see.
We have, no?
Would you like to see any other test? Any other investigation?
Viral serology also I would like to see. Sorry, sir.
What is the intervention then?
What intervention has been done? Nasobiliary
Yes, sir.
catheter has been inserted, isn't it?
Yes, sir. Yes, sir.
So would you like to see that report?
Yes, sir. I would like to see that report.
Yeah.
Is it better than the short picture? Like cholangiogram?
Yes, sir. It will be better than the MRI report.
So this is the ERCP what they have done.
Is it nasobiliary or plastic biliary stent placed?
So the report wise, it is plastic biliary stent they have mentioned.
Yeah, that's what. So
it's
not the NBD
It's
alone.
not nasobiliary. It's a plastic biliary stent, and after dilating with Titan balloon, isn't it?
Stent is placed in right anterior and also an NBT.
Yeah, that's what. So there is another stent also has been placed.
NBD.
Okay. Okay, next what do you want? No, you wanted to see the current
blood
investigation. We have that? Current investigations?
So with this investigation, what level of bilirubin you expect to stent or to, for a surgeon, what you expect jaundice to be?
Sir, I would
If
like
it
to
is operable.
I would like to decrease the bilirubin less than 3 gram percentage before going for any surgery.
Today's LFT report is bilirubin of total is 9, direct is 4.8, SGPT is 68, SGOT 58, alkaline phosphate is 378.
So it's coming down pretty good, no?
Yes, sir.
Albumin is 2.2.
Albumin is
2.2.
2.2.
It's also coming down.
That is also coming down. That is a good part. This is a bad part.
Okay. So hemogram is normal? CBP is normal? Okay. Fine.
So what do you think? Bilirubin is coming down, but albumin patient stented, double stented.
Hemoglobin of
albumin is coming down. What do you think may be happening?
Maybe some ENBD is there, sir. External drainage is there, so maybe patient is losing bile. That's why some malabsorption component is there. That's why albumin is going down.
See, you are the consultant in charge. What will you do from here? Tell us.
Sir,
This is your patient.
At this,
you got all the details now. I would like to know what is your next step.
Sir,
You still want to evaluate something? You want to do something further? Or?
Definitely, I will evaluate for resectability of the tumor. Accordingly, I will plan for my further management, and side by side nutritional improvement also I will try to correct.
Okay.
If I am planning for surgery.
So it means to say that if the patient is inoperable, you won't build nutrition. You will only build up the nutrition if patient is operable. You won't build the nutrition if she is inoperable.
I'll build nutrition, sir.
In both the things, isn't it?
So how are you going to assess your resectability? What are the things that you are going to look at now in this patient now?
Sir, already MRCP is done, so level of involvement we have already seen. So now I would like to do a CT scan to see the vascular involvement of the tumor.
Okay, what vascular involvement?
Sir, hilar structure like portal vein and common hepatic artery.
Not into right hepatic artery? Left, by only common? Everything,
Sir,
no?
already-
Right, left.
See, if it is unilateral block, here is got bilateral, and if you got a involvement of either of the artery, will it be easy?
You want to look at the vascular involvement.
Vascular
What else?
involvement.
What else?
Plus any atrophy, hypertrophy complexes there I would
Yeah,
like to see.
okay.
Any
That is
evidence
other-
of nodal metastasis, any extra-regional nodal metastasis.
Okay.
So, along with that, any distant metastasis also I would like to see.
See, before you go to distant, would you like to see the portal vein? Is there an encasement of portal vein?
So you said vascular
know-
involvement, okay.
Yeah. Okay.
Then what else?
Sir, first I would like to first rule out the metastatic disease, then I will see for resectability.
Sure.
Okay. So resectability only that one? Vascular involvement and then?
Vascular involvement and then atrophy.
Okay. Anything else?
And
you said lymph nodes.
lymph nodes plus volumetry also I would like to see,
Volumetry.
because it is a hilar cholangio, so patient may land up in a major liver resection.
Okay. So regarding vascular involvement, when do you say this is unresectable?
Sir, if
This is now you said it's more type 3A.
Type
That's
3A.
what I think they have mentioned, no? So in this case, when do you say which vascular involvement you say that this is unresectable now?
See, if the vessel on right side involved becomes unresectable or left side becomes unresectable. That is what he is trying to.
Left side will be unresectable.
Unresectable. So contralateral vascular involvement. So you need to be very specific with the words.
And
Contralateral.
And common hepatic artery.
Common hepatic artery.
Okay. Fine. Okay, so what do you want to do to assess that resectability?
So triple phase CT, triple phase CT I would like to do.
Triple phase CT. Okay. We have a triple phase CT.
Yeah.
And any tumor marker you are interested?
Tumor marker is already
it was
3000.
Shown actually.
Yeah,
3400.
So what do you think about that? Tumor marker, that
drained
value.
system, still tumor marker is disproportionately high. So suggesting there might be a metastatic component.
But still it's not completely normal. So, okay. But still it's very high.
So this is a non-contrast axial section of CT showing dilated intrahepatic biliary radicals. There is no ascites. Liver. Can I see the left lobe?
It can be portal vein also, no?
Without contrast, sir.
That's what. It's a hypo. What are you seeing? Why did you say dilated biliary radicals?
Why not portal vein?
Why not portal vein?
Sir, portal vein will not appear hypodense in
Without contrast, how does it appear?
isodense to liver. Not safe.
You are happy? You want us to move to the next phase?
Yes, sir.
So this is the arterial phase.
So you want to know whether it's before stenting or after stenting? Did you see in the plain CT whether there is anything? You could make out any stent in that?
No, sir. Sorry, sir. I missed it.
This is before stenting, sir? After stenting?
Yes. Before
stenting.
Before stenting.
There are no
Before
stents in-
standing.
So before stenting he even had CT also. Okay.
Come up little. Sir, this is arterial phase, classical arterial anatomy. Right hepatic artery, I can see there is some discontinuities there. There is encasement of right hepatic artery, but no mass lesion or anything I could appreciate here.
So first of all, where is the lesion that you put out? Did you identify the lesion where it is?
No, sir, I could not appreciate the lesion.
Then how did you say artery is infiltrated?
So there is a discontinuity in the right hepatic artery.
But you can see the distal artery very well, no?
Yes, sir.
In the now exact there, can you see any lesion?
Yes.
There.
They just.
You have a pointer in front of you. You can use that.
Tell us,
Here-
yeah.
But I would like to see the portal venous space to delineate the lesion better.
Okay.
Okay.
Can you come up?
Yeah, it's gone. Yeah, there.
There is just one section up. Here, sir, some portal vein narrowing, right portal vein narrowing, I could appreciate.
Left side vein is okay?
So right side vein, you think it is narrowed? In that way, if you take left one, seems to be more narrowed.
So there seems to be a lesion in hilum extending to
Right side.
Right side.
More towards right side.
More towards right
Okay.
side. There is no nodes. I could appreciate, sir. And liver looking normal. I could not appreciate any atrophy or hypertrophy complex.
How do you say atrophy?
There is no crowding of biliary radicals.
Okay.
Plus, there is no contracture of volume. No volume contraction is there.
Yeah, usually crowding of the biliary radicals. Okay. So it's not there. Okay.
It is not there.
I think we are
Yeah.
time
Okay.
wise. Can we have a look
Can
at the
you
report? Yeah.
No
comment on the
reports, no nothing is
association
there.
of
Okay.
gallbladder with the mass?
It's taken up. Okay. Can you show the report, sir? You have the report?
this. Sir, excuse me. This stenting was done here in this center.
Yes, sir.
I think then albumin we can't comment. It is decreasing. I think it should increase now.
Okay.
Sir, what happens is when they are in the pre-op area, they are usually
No, I understand,
dehydrated.
but I think it will improve in future.
It's usually a matter of dilution. They are admitted, they are being given fluids.
Initially,
So, yeah, initially the first one is done in OPD basis.
Dated CT was 4th of February. So stented late. It takes time for albumin.
The half-life of albumin is 2 weeks, so it doesn't come down so quickly. So it is a matter of dilution.
Okay. What is the report? You have this CT report?
So it's
looking like a hilar.
encasing the portal vein bifurcation.
Yeah.
Okay. That's all? You have next anything is there? Okay.
Okay. Can
Fine.
we have a look at the
Yeah.
CT report as well? This is a PET scan.
No, I think this is the same thing.
Same
sir.
thing, PET
Yeah,
combined.
yeah.
Okay.
Okay. So, but anyhow, I think the portal vein, even though they said it's abutting, but still it looks to be fairly okay. But right hepatic artery is infiltrated. Okay.
But,
So, what's your plan? Huh?
What do you think?
So, what do you think it is now with the
hilar mass with
hilar cholangio?
hilar cholangiocarcinoma with right portal vein and right hepatic artery involvement. So I would like to go for a my surgical plan will be right hepatectomy.
Now, what you will do now today?
Oh, that's
You
your
plan
initial,
for-
that's
you
your
will go
plan?
for surgery?
Right hepatectomy? That's your final plan?
Final
With
plan will be right
with the
hepatectomy.
albumin of 2.2, or you will sort of improve the albumin?
That is the plan, sir. Right hepatectomy. So at the same time, I would like to see the volumetry. How what is the FLR?
Only right is enough?
Caudate lobe has to be removed, sir.
It requires that also, no? It's partly it's infiltrating, it's going into the
maybe extended right with caudate lobectomy.
So actually this patient will require extended right with a caudate lobectomy because it's also partly going into the left, even though it's not extending up to the second order this thing. Okay. So to get R0 you need to get extended right with caudate lobe. Okay.
So that's what, sir. After seeing volumetry, if volumetry is adequate, I will go with.
So that's your plan.
Okay.
If you have to do a curative resection, that's your plan. Okay. Now to achieve that, what you are going to do now? You'll straight away go with resection, or you want to do something before that?
Now, sir, I will not go for resection. Already bilirubin is 9, so I will like to wait till the bilirubin is below 3. At the same time, I will do nutritional improvement, and I will look for volumetry of the liver. If it is not adequate, then I will.
But volumetry you have seen, no? You have seen the CT.
Volumetry you have right lobe without main hepatic vein 52%, left lobe with main hepatic vein 47%, right lobe with main hepatic vein 60%, left lobe without main hepatic vein 39%, left lateral is 18.9%, caudate lobe 3%.
So if you do right extended, how much is left?
18% is there.
18%.
18%.
So FLR is not adequate, sir. So I have to do some augmentation procedure before going for final surgery.
That's not how do you prepare this patient now? So now you said you want to improve the nutrition, wait for the bilirubin to come down to 3. Okay. Then
I would like to go for liver augmentation procedure. I would like to do a portal vein embolization of the right side to gain hypertrophy of the left lateral segment. Along with, if I am planning extended right, then at the same time I will embolize the segment 4 also.
segment 4.
Portal vein embolization also I will do to gain more hypertrophy in the left lateral segment.
Okay. They won't decompensate. What the risk of decompensation in that case?
I'm not sure.
So you have to be careful. No? Only 18% is left. You trying to block in a patient who is having bilirubin of 9. Okay, you should think about that also before blocking all the vessels.
When will you do portal vein embolization?
Yeah.
Will you do it now, or you will wait
Not
for
now, sir.
bilirubin to come down?
After bilirubin will come down, then I will go for embolization.
What level? When will your intervention radiologist will say the patient, I can do it safely now? Even if you send it to intervention radiologist now, they won't do.
But then regeneration will not be adequate because already bilirubin is high. So regenerative function will not be good in a hyperbilirubinemic state.
That is what I'm saying. At what level you will
Less
send
than
it
5
to your
generally.
intervention
Less than
radiologist?
5.
You like it to come down to 5. Okay. Suppose if it's not coming down with your stent, what will you do? You waited for 4 weeks.
You can
It's
do
not coming down.
Then we'll
do
do
the
the
PTBD on the left side.
Other side.
Other side.
Okay.
Sorry, you will?
Residual side. A PTBD on the residual side, remnant liver side.
So this is, do you think this stent is going to help you for your bringing out, see what are you trying to drain, which segment you are planning to drain?
FLR.
FLR.
With the future remnant liver. Are you draining with the stent which they have placed? Is it going to
ENBD
improve your,
ENBD they have placed on the left side, sir.
Which one?
ENBD.
It is on the left
drain,
side.
they have placed on the left side.
Left side it is.
Endoscopic stenting they have placed on the right anterior.
Okay, but that may not stay for longer time. Okay, you can't keep it for 4 weeks or 6 weeks. Okay. When you need to drain the one which is.
If bilirubin is not coming down, sir, again I will do imaging and I would like to see the on drain segment why it is not coming down. Then I will plan my intervention accordingly.
Okay. Anything other than portal vein embolization that you have options?
Alps. Alps.
Alps. Okay, what is that?
So, associating liver partition with portal vein ligation for staged hepatectomy.
And what are the drawbacks of ALPS and what are the advantages of ALPS?
So ALPS gives more rapid hypertrophy of the liver and in a shorter time, but the infective complications are more sepsis.
Yeah. So will you think about doing a ALPS when there is a history of cholangitis?
No, I will prefer not to do it.
ALP has got quite a lot of morbidity.
Yeah.
Quite a lot of morbidity.
Now it's rarely done for hilar
It's
cholangium.
rarely done. I think few centers, our center also, we did few ALPs. That was 6-7 years ago. But complication rate is very, very high. And not where the remnant is 18%. Yeah. So what's the final plan so that we can conclude
Yeah.
this?
So now you have achieved and the patient is going for surgery, like you have adequate liver remnant. So what will you do now? You said right extended.
Extended right hepatectomy with Roux-en-Y hepaticojejunostomy.
Okay.
And you will take out caudate lobe. Okay.
With lymphadenectomy.
How much margins you will look for? So you will do minimal blood loss. Second is a margin. Third is a lymphadenectomy.
So we can do intraoperative frozen biopsy, and if the margin
That's
is
what-
negative, then
Yeah. How much margin you want to achieve?
even 1 or 2 millimeters is acceptable.
Any negative margin is fine.
Negative margin is fine, but ideal is 0.5.
Do you do lymphadenectomy?
0.5 centimeter.
Yes, sir.
What lymph nodes will you take?
So HDL clearance and posterior superior pancreaticoduodenal nodes.
See, you have done right extended or hepatectomy on day 5. Your INR is high, bilirubin is high. What do you think is happening?
Post-hepatectomy liver failure.
What is the criteria of post-hepatectomy liver failure?
So
And
50-50.
how will you sort of try to avoid
Yeah.
it?
What is 50-50?
So on post-op day 5, the bilirubin level is more than 50 microliters.
No, it's not that. 50 doesn't mean that.
No, it's 2.9, more than 2.9 milligram per deciliter, and INR is more than 50% raised than
Raised from?
from the prothrombin time, the normal. So
What is that criteria for?
Sir, Belgati's
Belgati
criteria.
criteria.
Belgati. But that is not the 50-50 what you said.
See, you are the surgeon, you are taking a consent for extended right hepatectomy. What will you tell patient? You know, CA 99, it was 2 or 3,000 and you got a liver volume of 18%. What sort of morbidity and mortality you are going to tell the patient, and what sort of a 1-3 year survival you will quote on this particular patient? You will discuss, isn't it?
the morbidity is generally around 15 to 30%. Average.
Morbidity.
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 15 to 30.
15 to 30, you mean to say is less than Whipple's? Whipple's morbidity is 30-40%. 30% morbidity. Am I wrong? Any one of
See, you are doing extended right.
Yeah.
morbidity won't be so less.
You are doing extended right on a
on a
jaundice.
18% liver remnant with a previous history of cholangitis with CA 99 3000, and you are saying 15% morbidity.
30 to 40%.
So obviously you need to be absolutely honest with the patient, because if you don't consent him properly on day 5, when she goes into liver failure, they will be running after you. Doctor, you didn't tell me this. So how much percent of liver failure you will say?
30 to
And
40.
mortality. So morbidity, we are agreeing 30 to 40% you said. Chances of post-operative liver failure and mortality.
I'm not sure.
What are the risk factors?
Can we move to the-
post-operative
Okay,
liver
let's
failure?
go to the
Let's
next
do.
one.
Okay, fine.
So this is what you need to be careful about. Okay.
Next case.
Case capsule, yeah.
A 37-year-old female resident of West Bengal came with chief complaints of pain in the right upper abdomen since 1 month. Patient was apparently alright 1 month back when she started having complaints of intermittent abdominal pain, which was dull aching in epigastric region, non-radiating and spontaneously relieved with no aggravating or relieving factors. No history of nausea, vomiting, fever, no history of jaundice, no GI bleed, no history of altered bowel habits, loss of weight or loss of appetite. Past medical history: a patient was diagnosed to have hepatitis B in 2016 but did not follow for any treatment anywhere. No surgical or family or personal history significant.
So, any other history you would like to know in this patient, or you are happy with that?
Sir, very short history with a young patient having only abdominal pain. It's very difficult to localize the source of pain. Typically, there can be various causes. The only significant history here would be a hepatitis B, which was diagnosed but is not treated at all.
And it's almost like 9 years, 8-9 years
Yeah.
duration.
8-9 years.
Okay. So from the history, what do you think it is? Anything roughly you can think something?
It can be any pain pathology relating to the gallbladder, to the stomach, right from GRD as well, or even peptic ulcer disease.
What did you say? Peptic ulcer.
Peptic ulcer disease.
Will we be talking about peptic ulcer with hepatitis B here in the exam scenario?
Just a differential, sir, because there's a very vague history. I mean, there's no localizing sign as such.
Okay. But
anything else here, like
see,
the peptic ulcer, anything else?
you need to go on a trick. It's hepatitis B, not
forget both and then
hepatitis
look
C.
at that.
What is the difference between hepatitis B and hepatitis C of patient developing SCC? What is the difference?
The pathogenesis, sir. The pathogenesis.
What's the difference?
As in hepatitis C related tumors occur in hepatitis C related cirrhosis, whereas hepatitis B
So
they don't
in
need
hepatitis C, you will have 100% cirrhosis, and then SCC.
Yes.
Hepatitis B, you won't have a cirrhosis, and then also you can develop SCC.
HCC.
Why?
The mutation, the insertion mutagenesis of the HBV virus into the hepatocytes. That is the reason for tumorogenesis. While in HCV it occurs in the background of cirrhosis.
Sure.
So with this background now, what can you think? Leave the peptic ulcer.
There can be a liver SOL as well.
So that's one possibility.
So it
no?
can be liver SOL, isn't it, without having cirrhosis?
Yes, sir.
You can have that, no? Liver cirrhosis. Maybe something else, we don't know.
Maybe something else, but you need to see dull aching epigastric pain with past medical history of hepatitis B.
So putting together, you can think
Putting
of that.
together.
Yes.
Putting together.
Okay.
And with this, you are saying peptic ulcer. Good.
Okay.
Okay.
Examination.
Examination findings were not contributory.
Not contributing.
There is no significant inspection, palpation, finding were not significant.
Liver span. 14. Okay. Okay.
Okay.
So,
what are the first tests you will do?
As a part of extension of examination, I would like to do a non-invasive test of ultrasound to see the pathology and
Any blood test?
lefties and
And obviously he is hepatitis B, you will do the other viral marker.
other viral marker.
Okay. And since he's got a hepatitis B, you will like to add on
so
tumor marker.
You don't write only ultrasound and send the patient, no? You write some other investigations also when it comes to OP.
Because
What
when
will
you are
write?
sitting in the clinic,
You can't write one investigation.
you write, blood test and ultrasound, isn't
Together.
it? So blood test may.
What do you write? What blood investigation you would like to have here?
In case I was thinking if we saw any liver SOL on the ultrasound, then we would go for tumor markers as well, AFP and PIPCA.
Oh, you left the basic things.
But even if patient doesn't have a SOL and patient got a hepatitis B for 8 years, won't you do a tumor marker AFP?
Yes, we'll do.
Yes or no?
Yes, sir.
What is the surveillance about the hepatitis B? How often you do the ultrasound and how often you do AFP?
Yearly.
So this patient has got a hepatitis B for 8 years and you are not interested in putting a tumor marker.
6 months?
Yes, sir, will do.
So you will?
Yes.
Okay.
Surveillance is 6 months or yearly?
6 months.
6 months, no? Surveillance is 6 months you have to do. Okay.
It depends on if it is
Yeah,
a high risk
yeah.
group,
Yeah.
then it's different,
Okay.
You want
You'd
the
like to know
ultrasound
about the
or the tumor
hemogram and
marker?
all that? You don't want? Maybe some underlying cirrhosis, we don't know. Okay. So this is the ultrasound?
Yep. Lobulated heteroechoic.
5.8 by 5.6 centimeter, internal cystic spaces, minimal vascularity, no IHBRD, and rest parameters normal.
So you got ultrasound now, what will you do?
What do you interpret from the description of the lesion that they are given? So heterogeneous, heteroechoic, with internal cystic spaces. What do you think it can be?
It can be a HCC, sir. HCC.
Can be HCC?
Yes.
Okay.
And one criteria it fulfills is more than 2 centimeter. Okay?
More than.
That is one of the criteria.
Okay.
And is there any this thing in that explanation? Anything you need more in that explanation?
Actually, the vascularity they said it's minimal.
Minimal
It's
vascularity.
not mentioned which lobe.
It's
The site of the tumor,
I
exactly.
don't know, it is typing mistake or there. Okay, we'll go ahead.
Okay, what next?
So AFP, PIPCA is high, 235. So the next I would like to go on.
Is AFP normal?
No, both are high, sir.
Both are high.
Both are high. AFP and
Both
PIPCA both are high.
But
So,
is diagnostic?
It's we'll go on imaging for diagnosis. Next imaging for diagnosis.
AFP, does it say something? It's high, but
Specificity is high, sir. So sensitivity is less, but specificity is high.
This value? Okay, next what will you do?
Quick.
LFT is seem to be okay. Even the synthetic function is normal. Albumin is also 4.4. So nutritional status also seems fine. On ultrasound also there was no cirrhosis of the liver, no parenchymal changes noted. So the next imaging I would go ahead with the contrast and CT scan. After seeing the RFT, if the creatinine is normal. Creatinine, electrolyte both normal.
Okay. So what do you want to do now? Now triphasic CT.
CT.
Okay. What is triphasic? What are the three things? Timing?
Arterial, portal and planes film, the plane non-contrast phase, arterial phase and portal and venous phase. So arterial.
When do you do this arterial phase? What time after giving the contrast? How many
Arterial
seconds?
is how many seconds?
10 to 15 seconds is the
10 to 15
is the arterial, and 30 to 40 seconds is the portal phase, and 60 to 70 seconds is the delayed phase. So this is the non-contrast phase.
No. Somebody wants to correct.
Sir,
Arterial phase and porto.
No, he is not correct. I mean,
arterial phase will be 18 to 30 seconds, sir.
Yeah,
Portal
18
venous
to
phase will
30.
be 65 to 70 seconds.
but it's too early to do a
Delayed
portal
venous
venous
phase,
phase in that. It's very early.
Porto venous is usually 90 seconds. 60 to 90. Yeah.
So you won't get that early. You
That
don't
early.
get proper. Okay.
So there's no mass lesion seen, no calcifications or any other significant changes like ascites seen in the on the non-contrast phase. So
What is that? There is something at the hilum? Anything is there? Go up. What is that? Nothing is there.
Stomach.
So that is normal. Liver, what you are seeing there. It's normal.
There is some calcification.
There is some calcification, no? It's not normal.
That's the one, yeah. What is that?
the cystic spaces which were mentioned on the ultrasound, I think probably correlates with that. Internal cystic spaces in the tumor.
So what is that? It is a calcification or something? It's a plain CT, no?
Plain CT.
So plain CT was seeing something which is a calcified there.
There is another calcified below when you come down.
Do you want to comment at this point of time, or you want to see the other?
See the other phases as well, sir.
Yep.
So
you can tell that.
So you have seen something in the plain CT. There is something there.
arterial
Okay.
next one.
Something with cystic spaces with some calcification. Okay. Still it can be HCC?
Can be, sir. Can be.
Can be.
So now you see. Yep. What is it? There. Yeah.
Totally different thing has come out now.
You can use the pointer and tell
What is what?
what is what.
Scroll करना थोड़ा सा.
You can ask, he'll move. You want to go up or down?
So there's a enhancing lesion here, and there's another lesion here, probably 2 lesions. Scroll.
Could you tell us what segment we are talking about, or what side of the liver? You know,
The left lobe of the liver, this
Yeah.
one will be in segment 3, sir.
Yeah.
And
because at your level, it doesn't look nice saying
So where
the liver.
What is this you are saying? The other lesion. It enhancing?
no, it's not non-enhancing. Non-enhancing, but with internal cystic spaces. So
Is it same
heterogeneous.
density as the liver that what you are seeing there? The lesion?
So this one. So it's
It's
this
same
one
or
is
little hyperdense compared to the rest of the liver?
it's almost isodense. Only the cystic spaces, the walls of the cystic spaces are enhanced.
Oh, you were talking about the other lesion, above one.
This one, yeah.
Okay, that is almost same like what was
It's
in the
almost
brain.
isodense.
Okay, this other lesion.
This
down?
one is hyper enhancing, sir.
It's enhancing.
Enhancing.
Okay.
Enhancing as compared to the.
You want to comment something on the liver? Liver, I mean, is it normal?
Scroll.
What are the left lobe? Are you happy with the left lobe? What you are seeing there?
Left lobe
surface is
surface is okay, sir. There is no retraction or any parenchymal changes or any irregularity of the surface, and left lobe seems to be a bit small.
Okay.
But the
okay, go to the next phase. What is it?
The caudate lobe also seems to be okay, not hypertrophied. So
yeah, okay. So your left lateral is atrophied.
atrophied. Here there is a washout of the contrast in this venous phase. So still both the lesion, the previous lesion with the cystic spaces is also showing decreased enhancement as compared to the rest of the liver in this phase.
That are never enhancing, no?
Not enhancing, but in this phase it is even less enhancing than the rest of the liver.
Okay. So where is that lesion now? Which segment, like sir was asking, which segment of the liver?
Segment 3 and scroll, Danish.
No,
Scroll,
I'm talking
scroll.
about this other, not the cystic one.
Scroll. Up. It's in segment 3, sir. Segment 4B.
It's 4, no? Not
4B,
3.
4B.
The segment 3 is almost
It's
atrophied.
on this side, it's segment 4B.
Okay.
So there's actually one lesion in segment 4B and the other one seems to be from the segment 3 or.
Okay. You said caudate lobe is normal. Where did you see the caudate lobe?
Can you point out?
You point out the caudate lobe.
Here, this one, sir.
Where?
Between the portal vein and the IVC, this one.
No.
It doesn't seem to be hypertrophied because the background of HBV will expect there can be a cirrhosis, but doesn't seem to be like that.
Okay. So what do you think it is now?
So it's a HCC, liver as well, most likely HCC. In the background of chronic hepatitis B, but no underlying cirrhosis as per the imaging. But still, I would like to rule out portal hypertension with clinically significant portal hypertension.
How would you rule out clinically significant?
Endoscopy, sir.
Endoscopy.
Varices.
What else?
Do you want to see anything in this CT?
Imaging.
What is there anything in this CT which can tell there is portal hypertension?
There are actually no collateral seen. Like
You want to see the spleen size, portal vein size?
Portal vein is normal.
Portal vein is normal.
There. Size is normal.
Portal vein seems to be normal, sir.
Okay, it doesn't seem to be that.
We have to see the
but
size
if you go near the
exactly,
hilum. Okay. Fine.
If you got splenomegaly with low platelet, what does it mean?
Hypersplenism, and that is also a left-sided portal hypertension. So that is a clinically significant portal hypertension.
And
but,
what is the third one when you measure the direct pressure?
Direct pressure,
in the
HVPG.
portal vein?
Yes.
Okay?
Yes, sir.
So these are the three things to absolutely rule it out. Okay?
Yes, sir.
So this you are talking about HCC. What do you think about the other lesion?
Is it same or is it a different lesion?
Same or different?
Seems to be a different lesion, sir.
Yeah, seems to be different. CT report is
Probably it looks like I don't know. I feel it's some atrophic lobe with all. What is the report?
It's not very difficult. It's a gallbladder with stones.
Yeah, GV stones.
It went there. But it's
And
beyond
did it-
segment.
What was mentioned in ultrasound gallbladder? What was mentioned in ultrasound regarding gallbladder?
Okay. What is?
Was not seen.
What the report? Gallbladder
Could not be evaluated.
Could not be evaluated. Okay. CT report. We have the CT report. Yeah.
So liver is enlarged with atrophy of the left lateral segments and mild surface nodularity is present. No HBRD, lobulated lesion in segment 5 and 4B. And tiny non-enhancing areas also noted in the lesion. 6 by 5 by 4 by 0.7 centimeters. The lesion is also indenting over the hepatic segment of the IVC with suspicious minimal invasion. Abutting D1, D2 with no gross invasion. So,
next slide.
Portal vein is prominent, 12.5 mm. And, gallbladder multiple small calculi 6 to 7 mm size. Spleen is enlarged, no other things. So we definitely like to rule out clinically significant portal hypertension.
So how will you rule out what test you want?
We already saw the platelet count which was normal, so the next modality would be an endoscopy.
Endoscopy, yeah.
What is this impression they have given? CT?
Impression was of HCC.
HCC. Okay.
So there is no varices on the upper GI scopy. And, so we have a case of HCC in the segment 4B5 with no background of cirrhosis or clinically significant portal hypertension of size 6.5 by 5.5 centimeter.
But there is surface nodularity is there. Okay.
There was mild surface nodularity, yes, but it was also not picked up on ultrasound like.
So when does this varices develop? What pressure it requires to develop a varices? Portal pressure?
More than 10, more than 12, sir.
More than 12, they bleed.
More than 10, more than 10.
10 is the one, no?
10.
If you have portal pressure of more than 10, then varices come. More than 12, they bleed.
Risk of bleed.
So the pressure may not be high, but still patient may have cirrhosis. Hmm. Okay. So what will you do? She is hepatitis B positive. You have a lesion now. What will you do now?
We'll stage the disease according to BCLC staging, and the performance status was 0 and 6 centimeter single lesion with no any vascular invasion. I mean, there was suspicious involvement they have mentioned on the report, but the IVC seemed to be okay on the scan. So with no vascular invasion, this thing. So early stage A. Early stage A lesion, sir.
What will you do?
So
early stage A without clinically significant portal hypertension. That's what you're saying.
Yes, sir.
Okay. What will you do?
So
what are the treatment options that you have?
the options we have are resection, then
transplant.
Transplant.
So
But
what do you want
this
to do
was
here?
more than 6.5 centimeter, the lesion. This was more than 6.5 centimeter. So and
so that's what will you do?
so I would prefer a resection for this patient.
Prefer resection.
Resection.
What resection?
Left lateral, left hepatectomy. Extended left hepatectomy.
Extended left, because this segment 5
Segment
is involved.
4B and 5 are involved. So
Okay. Do you think did you see the liver volumetry then?
What? How much remnant liver volume you would like to have?
So now when you do extended left, what are the segments that are going to remain now?
So segment 6 and 7.
Okay. So did you see the liver remnant?
So I'll like do a volumetry before resection.
Do no?
The plan would be a extended left hepatectomy, but volumetry will be definitely necessary. And if we are thinking on the background of cirrhosis, because there was surface nodularity, then we'll check the since the bilirubin was normal.
How much of bilirubin is normal?
Since this is a major resection, we would like to check ICG R15 retention rate as well.
What will you check?
ICG retention rate, ICG R15.
Okay.
So if that is less than 10%, then it can undergo a major hepatectomy.
How much of the liver remnant you want to have in this patient?
More than 40%.
Could you reduce the size of the lesion by some method?
TACE, can do a TACE and stage.
How much on an average TACE cost and how much tear will cost? On an average, which is more costlier, TACE or tear?
Tear will be costlier. sir.
Costlier. Double, triple, 5 times, 7 times, 10 times.
So it depends on what you use. What do you use in tear?
Yttrium 90 beaded spheres.
How much does it cost? That's what Sir is asking.
This is, that is a way of checking whether you have been involved with the patient or not. Whether it's a bookish knowledge or a practical
TACE
knowledge.
will usually cost around 3 to 4 lakhs. TACE.
3 to 4 lakhs,
3
okay.
to 4 lakhs. I'm not
Tear,
exactly sure
Tear?
about tear.
3 times.
I'm not aware about tear, sir.
See, in Gangaram it cost 1 to 2 lakhs is stays, and tear will cost about 10 lakhs. So it's nearly 5 times more, 6 times more.
Okay. Any questions, doubts to be cleared?
Sir, one of my doubt is this patient will not list for transplant because already cirrhotic background under extended transplant criteria.
See, is it B, child's B, A, B, C? What is it? A na? A may he doesn't have a clinically significant portal hypertension. You know, just to be sure, you can directly check the pressure. If it is less than 10, then it is automatically, you know, child's A. And then you have a look at liver volume. And if it is pretty good, then okay.
But transplant center will definitely put in for the transplant.
For the transplant.
This guy will go for transplant.
So for this patient, do
There's
we start?
hepatitis B, no? Hepatitis B.
Yeah.
Under background cirrhosis, likely to have, we don't know, multifocality, we don't know. So there is more chance of developing.
What else would you like to do
Anti-
before you do the surgery?
Antiretroviral, should we start antiretroviral therapy prior to surgery in this patient?
That you can.
So,
And what are the
what
other
level?
staging tests you will do?
That you'll have to look at again the
PET
DNA.
CT.
all that.
Either you will do a PET scan
CT.
or you do CT thorax with bone scan, because you want to rule out lung mets, rule out bone mets. Okay, one of the two is fine. PET scan or CT chest with bone scan. Okay, that is important.
The thing is the AFP is less actually. That's one positive thing. Okay. Any other questions?
What was the size of the lesion? Will it,
6.6.
will it fit in UCSF criteria? UCLA, na?
If we consider 6.5
6.5 to 6.5.
6.5.
6.5 single lesion.
Single lesion.
Yes, sir.
And 3 lesion
8.5.
8.5.
combined 8 less than 4.5, isn't it?
Yes.
What is a metro ticket?
Up to 7.
With the SCC with cirrhosis, what is a metro ticket concept?
Total
Any number.
Total number of number of lesions plus the size should not exceed 7.
Should not exceed
7.
what?
So number of lesion and size of the largest lesion should not exceed 7.
7.
Uh-huh. And what is Toronto criteria?
Toronto.
Any number? What is Toronto criteria? Lot of centers they are implementing Toronto criteria. What is the Toronto criteria? And what is the thing they look at? Look at the biology of the tumor. Okay. Sorry, yeah. Grade of the tumor. It should not be poorly differentiated. AFP should not be more than 400. Okay. Some of the center they are looking into NLR, neutrophil lymphocyte ratio, platelet lymphocyte ratio, and FDG avidity in a PET scan. How much avid it is. If all those are favorable, any number, any size, they do it.
With the permission, can I make a comment?
Yeah, please.
Regarding this size, it is involved in the segment 5, almost exophytic, and doubtful involvement of segment 4B. Why do you want to go for left extended hepatectomy? You can go for segment 5 resection, maybe segment 4B. That's enough. We don't want to go for left extended hepatectomy.
So there are multiple options are there. You can even think
Sir,
of actually.
what sir is saying is you can take a
something like
particular
a
segment
local
and
resection.
local resection with 1 centimeter margin.
Exophageal almost.
I mean,
Simple.
And if probably his left lateral lobe was normal, you can even think of central hepatectomy
Central
also.
hepatectomy also. Very
But this
common,
is
yeah.
very small left lateral lobe actually, so it doesn't make any sense in going for that actually.
Very complicated things.
Yeah.
Another thing is, the previous case, gallstone was there, limy bile was there, neck was thickened. Usually, the first diagnosis I will think consider carcinoma gallbladder, being common in that location more than the pilar cholangiocarcinoma. And carcinoma gallbladder involves this one to cause always the engagement, always the carcinoma engagement, everything. And one should go for always diagnosed laparoscopy also before that. It will be rarely operable. And another thing is regarding the cholangitis, sir, ascending cholangitis is common with incomplete obstruction, not the total obstruction.
Yes.
So periambulatory growth, you will get more ascending cholangitis rather than the complete obstruction. Thank you.
Yeah. So usually that's what. So wherever that ampulla actually is partially obstructed, you get there. Okay, fine.
Any questions from, any comment from any other faculty? And any question from the students? Done?
Yeah.
Okay.
If no
Thank
questions,
you.
thank you, sir. We'll close this session. And to tell you more about hepatocellular carcinomas, we have Dr. Vivek, our interventional radiologist. So we'll continue with the HCC.
So I think the case was, the discussion was regarding the HCC. I'll just show the quick loco-regional therapies in HCC. So I'm Dr. Vivek here. I'm from the Department of Interventional Radiology. So coming to the BCLC 2022 update, I think this slide or this image has been seen by I think most of the residents and all of us regarding the HCC, where the HCC is, the staging is from 0, A, B, C and D. So what we do is actually, I'll just summarizing this slide. What we do is any HCC which comes at any stage, think of whether it comes, whether we can do a transplant or a resection, because that is more curative intent. And if there are more advanced HCC like C, then think of stage migration. That is the new concept in BCLC 2022, where you migrate it from right to left of the HCC. Like from a stage C, you try to do stage B, and from stage B, do some therapies and try to do it whether the patient becomes fit for resection or the transplant. So coming to this, first we take the size of HCC in 3 major aspects, that is less than 3 centimeter, 3 to 5 centimeter, and 5 to 7 centimeter, and more than 7 centimeter. So if it is less than 3 centimeter, think whether it is resectable, and if the patient undergoes resection, that would be the best. But due to most of them are cirrhotics with high portal hypertension and with high HVPGs, then we come into role where we do the loco-regional therapies. So coming to the loco-regional therapy, these are minimally invasive, where we do 4 loco-regional therapies, that is ablation, TACE, combination therapies, and TARE or radiotherapy. Coming to the ablation therapies, radiofrequency ablation and microwave ablation, ideal for all the HCCs and even in NETs and even in the colorectal metastasis, which is less than 3 centimeter. So any HCC which is less than 3 centimeter, with a curative intent, you do the ablation, and the overall survival at 1 to 3 years is similar with the microwave ablation and RFA and the surgical resection group. So this is the one of the studies which has shown the effectiveness of the resection versus the radiofrequency ablation. Again, I'll just run through it because there is shortage of time. And coming to the radiofrequency ablation, there are 2 types of ablation. One is radiofrequency ablation, where we use an alternating electric current, and a RF electrode is usually put into the target lesion with the grounding pads. So what happens in radiofrequency ablation is the coagulation of the tissue ions, which causes the frictional heating and causes the coagulative necrosis and the cell death at 60 to 100 degrees Celsius. So coming to the challenges in the radiofrequency ablation, as you can know, because here what happens is the impedance is there, it causes the local tissue charring, which increases the impedance and the resistance for the conduction of the heat, and there is a heat sink effect which happens when the lesion is close to the portal vein or a biliary duct, or if there is any venous structures. And some of the challenges in our ablation is a difficult window where there is a subdiaphragmatic lesions where we cannot effectively ablate, or those lesions which are closer to the heart. And even the subcapsular and exophytic lesions will be little difficult for us to ablate. And coming to the microwave ablation, the similar technique, but what happens is a faster ablation where we use a oscillating microwave field is used, where there is a continuous realignment of the water molecules and ablate it. So coming to this, one good thing of microwave ablation is it overcomes the heat sink and the tissue impedance challenges of the radiofrequency ablation, and which are lesions which are closer to vessels can be effectively ablated with the microwave as compared to the radiofrequency ablation. But again, many studies have shown there is no difference in the local recurrence or the progression between the radiofrequency ablation and the microwave ablation. But one thing is, one difference between the microwave ablation and the RFA is, some lesions which are more than 3 centimeter is much better than the radiofrequency ablation. That is the single tumor. What happens in this is, there is a lower local tumor progression over the RFA. In this large study of 450 patients where they took between all the lesions which is less than 5 centimeter, there is much better ablation zones which are happening in the microwave ablation when compared to the RFA. So this is the one systematic review and the meta-analysis between the RFA and the microwave ablation. And coming to the ablation therapy, so this is the first thing where any lesion less than 3 centimeter, you go for the ablation therapy if the patient is not fit for resection or the transplant. So, or if you want some time for the transplant, or if you want some downstaging tumor and with a curative intent, you can go for the ablation therapies. And some complications, the major complications are less than 1%, and the complications which we can see is the bleeding, portal vein thrombosis and hepatic infarction. And sometimes biloma, bile leaks and strictures can happen, and these are more frequent in microwave because it's a stronger ablation and more in the central lesions which are closer to the major bile ducts. And sometimes, very rarely, we have seen an abscess post ablation as well. And some of the extrahepatic complications are pneumothorax, sometimes a subcapsular subdiaphragmatic lesions we can go through the pleura, and which can do a pneumothorax, hemothorax, and a bowel injuries can happen in the exophytic lesions. So just to show this, this is one of the case which we did a HCC in the segment 8 of the liver, which was about 2 into 1.7 centimeter. As you can see here, this is the HCC here. I think, yeah, this one. It's a T2 weighted image. As you can see here, we can see even the ascites. This is the fluid which is appearing bright on T2 weighted image. And the patient was having ascites. Ascites is not a contraindication for doing ablation because we are still ablating the tract up to the capsule, so bleeding chances are less. And this is in the arterial phase, you are seeing an enhancing lesion in the segment 8 of the liver. And this was in the post-microwave ablation. You do the microwave ablation and we call all the patients after 1 month with a repeat MRI to look for the response. And you can see here there is the complete zone is ablated. Usually, one rule of ablation is you take 10 mm as the extra margin for the effective ablation. If it's a 2 centimeter lesion, do an ablation zone of 3 centimeter. If it's 2.5, try to do a 3.5 centimeter of the ablation zone. So this is the post-microwave ablation after 1 month. So coming to, there are some other newer modalities. I think these can be asked as a theoretical questions, whether cryoablation, laser ablation and irreversible IRE is done. IRE is usually done in the non-thermal ablation, which are closer to the larger bile ducts. And usually this happens to a non-thermal ablation by creating pore in the cell membranes. So even we are not doing it, but in some centers in India are doing it. So coming to the combination therapy. So this is a newer thing which is not discussed in many of the textbooks, but these for the lesions between 3 to 5 centimeter. So what to do for the next lesion? So now we finish the lesions up to 3 centimeter. Between the HCCs which are between 3 to 5 centimeter, we are doing TACE with microwave ablation, which is called the combination therapy. So what happens in this? Again, coming to the TACE, TACE is still seen as a palliative treatment. But when you do a TACE with the microwave ablation, we are still doing it with a curative intent up to 5 centimeter lesions. So what is the mechanism behind it? So what happens is you do the TACE first and then you add the microwave ablation after 48 hours. So the theory is this. So what happens is this increases the mutual therapeutic effects. So once you do the TACE and then you do the ablation, once is because of the lipidol accumulation, you can see the tumor much better in the ablation, and because you have already done the embolization, the local microperfusion is less. So that reduces the heat sink effect or the perfusion related cooling, because already the arterial supply is cut off to the tumor. So that causes a more effective ablation zones. And also another theory which is proposed is we use lipidol in most of our conventional tests. So this lipidol causes a stronger heat conduction and increases the edema. So that also causes a much effective ablation in the microwave ablation. So this just to show one case. So this you can see here. This is in the segment 7 lesion, which is 3.8 into 3.4 centimeter. You can still argue that can we just do an ablation alone? But because it is subdiaphragmatic, closer to the diaphragm, an effective ablation, more aggressive ablation can cause complications. So for this lesion, we went ahead and did a TACE first. As you can see here, we took an access and this was a tortuous course. And I'll come to the TACE next as to what we use. This is just an example here. So we did a TACE first for the lesion, and microwave ablation was done for the same lesion after 48 hours. And you can see the lesion here after 1 month. So this is the pre-ablation. The top one is the pre-ablation and the pre-procedural MRI, and this is the post-procedural MRI. You can see there is no diffusion restriction. In the arterial phase, there is no enhancement, and just as a venous phase, you can see the complete necrosis of the lesion which is there in the segment 7. So still with a 3 to 5 centimeter, so this lesion was treated with a curative intent. So this was the same patient. So the AFP was 1654, and after that the AFP came down to 5.5 after 1 month. So again a curative intent, and call these patients every 3 months for the follow-up, first 3 months, and then if it is not there, if there is no lesion, then call the patients after 6 months. So like this. So coming to the TACE. So what is TACE? TACE is a treatment where we deliver the chemoembolic materials via the tumor feeding arteries to induce the tumor necrosis by selective ischemia and the anti-cancer drug effects. So one is we are inducing an ischemia, and also we are putting a chemotherapeutic agent via a tumor feeding artery. So there are two types of TACE. There is a conventional TACE and a depth TACE. In conventional TACE, infusion of the chemotherapeutic agents and the etherized oil we first inject, followed by the embolization of the feeding artery with either a PVA particles or the gel form. And in the depth TACE, injection of the DEB loaded with the DEB, which is drug-eluting beads, which is loaded with the chemotherapeutics into the tumor feeding artery. So this is the HCC hemodynamics. See, you can just see this pictorial representation where in a dysplastic nodule to the moderately differentiated HCC, where there is a tumor feeding artery and the drainage is happening with a hepatic vein sinusoid. But as you can see, when the dysplastic nodule progresses towards the HCC, the drainage is mainly taken, the hepatic vein sinusoidal drainage is gone, and you can see the capsule comes off, and usually the drainage happens with the portal vein sinusoids. So here what will happen with this hemodynamics actually helps us in doing a TACE, where we give a chemotherapeutic agent which is mixed with the lipidol, so through the artery, and we keep giving it till it reaches the portal sinusoids, and that causes the effective ischemia of the HCC. So coming to the TACE again, where we do TACE. So coming to one is the size criteria, I already told where we do. So this is the second criteria, where all the BCLC B stage right from the first slide. So intermediate stage HCC you can offer TACE, non-surgical candidates, and those lesions which are not amenable for the percutaneous ablation. And again in a multinodular multifocal HCC you do TACE in those patients who have a preserved liver function, no vascular invasion, and no extrahepatic spread. And here again we can say if the liver function is very deranged, you don't offer any loco-regional therapies, and that would be either a systemic therapy or a immunotherapy is also not offered because they also need a child day. So you do a best supportive care. If there is a vascular invasion, you go for radioembolization, and if there is no vascular invasion, you can effectively treat with the TACE. And those patients who are awaiting for liver transplant, you can still do a TACE and give some time for them to go for a liver transplant. So the ideal candidates would be this for TACE, that is a child Pew score of B8 and less. So more than B8 you usually don't do TACE. A size of less than 7 centimeter, a single lesion, and if there is multiple lesions, it's 4 to 5 lesions. And again there are multiple gradings like ALB grading, so many other CTP scores and all. So ALB grade is what we see, where there is a grade, it's a negative scoring grading. So grade 1 is minus 2.6, grade 2 is between minus 2.6 to minus 1.3. And only two objective criteria, only the albumin and the bilirubin is taken for the ALB grading. And these are the lesions where we don't do TACE. So what are the exclusion criteria for TACE? So exclusion criteria is again a multinodular bilobar involvement with more than 50% liver burden, and very marked AFP elevations more than 10,000. If the AFP is more than 5,000, 10,000, we usually don't take, because again there is a poor prognosis. If there is a very large vascular invasion of portal vein tumor thrombosis, and again a very bad liver function. If there is ALB grade of 2 to 3 and a poor hepatic reserve, we usually don't do TACE. So again, there are multiple studies as to whom to do TACE, whether to do TACE in child B and child C. This is again another study where this showed what happens. So again, the post-TACE survival is inferior in child B and child C, obviously because their more deranged livers are there. So they don't survive as well as the child A patients. So coming to the pre-treatment imaging. So what are the treatment imaging which you have to see? Either you do a triphasic CT or a triphasic MRI in order to detect the number of the lesions, and CT also helps us in doing the arterial anatomy of to look at the feeders and also the extrahepatic feeders if there are any. So you can just see this as they might ask, so tumor size and growth, number of tumors, tumor distribution, vascular invasion. Sometimes you also have to look at arterioportal shunts, and is there any bilioenteric anastomosis, or if there is any biliary stent. Celiac trunk and hepatic artery anatomy has to be mapped with the CT, and if there is any parasitic tumor supply, that is if there are any extrahepatic feeders. Most of the times we see either from the inferior phrenic artery or the adrenal arteries, or sometimes from the colonic arteries in the exophytic lesions. So you have to see these imaging before going for the TACE. So in conventional TACE, the basic is you mix a chemotherapeutic drug with the lipidol followed by the embolic agent into the feeding artery, and these are the chemotherapeutics which is used. That's the doxorubicin and the cisplatin, and the lipidol acts like a carrying the drug. It also acts as an embolizing agent, and lipidol has one special effect where it has a selective HCC property. It is a tumor seeking agent where it selectively goes into the HCC. Again, the multiple mechanisms are told, like whether there is a tumor membrane pump which takes the lipidol towards the tumor and not to the regular hepatocytes. And again, the HCC doesn't have Kupffer cells, so the lipidol stays there for a longer time. Lipidol doesn't get metabolized, and a gel form. And finally, you inject the gel form into the feeding artery to induce a ischemia. And the newer thing is the depth TACE. Again, depth TACE is, we don't prefer that much depth TACE in our institute. But these are the drug-eluting beads are mixed with the doxorubicin, and they are injected into the tumor. One good thing of depth TACE is a larger tumors can be taken care with the depth TACE because we can give a larger amount of doxorubicin. Again, doxorubicin, the limit for the Indian patients is around 50 mg. We don't give more than 50 mg in a single session. So here with the depth TACE, we can use up to 75 to 150 milligrams mixed with the 100 to 300 micrometer particles of the drug-eluting beads. So what happens is the reduced systemic toxicity can be seen with the depth TACE, and where the multiple sessions can also be done with depth TACE. So again, I'll just show this. So this is the tumor. As you can see, this is a conventional angiography. You do an angiography, selectively go to the tumor feeder, and this is the tumor blush which is seen, and start injecting selectively from the tumor feeder a mixture of the doxorubicin and the chemotherapeutic drug. So here there were 2 lesions, and this was a smaller lesion and one more thing is, you can see this can be asked, this you can see in X-ray or even in the CT. There is a dense uptake of lipidol for this lesion, whereas not such great uptake of lipidol in a smaller lesion, because again the tumor feeding artery is very small here. So in this lesion, you go and we did an ablation for the smaller lesion as well, and this is the follow-up after 3 months. So this is a complete necrosis which is there. And I'll come to the radioembolization. So now we have finished the ablation, we have finished the combination and TACE. So where to do the radioembolization? Radioembolization is preferred in those patients where the tumor is more than 10 centimeter, at least in the Indian setup, because it is quite expensive. I think the questions were asked because it's around 12 lakhs for the radioembolization, or whether if any HCC is seen to have a vascular invasion. So a liver confined HCC, again you don't offer tear for an extrahepatic spread where it's an unresectable disease due to the poor hepatic reserve and poor performance status and comorbidities. You offer tear, and this is the thing. So one is the larger tumors more than 10 centimeter, portal vein tumor thrombosis. Again, in portal vein tumor thrombosis, one thing is VP1 to VP4. I think most of you already know it. Usually the tear is offered only up to VP3 because if the tumor is invading into the main portal vein, then you cannot do an effective radioembolization. And again, radioembolization can be offered as a bridge for the resection or the liver transplant, because one good thing of radioembolization is once you do radioembolization, the contralateral lobe hypertrophies. So this is again the FLR increases, and you can do a the surgeon can usually resect the treated lobe. So again, I'll come here. So 1 second. So again, there is a newer thing where you do a combination therapy for most of BCLC stages where there is an advanced HCC. You treat them with both radioembolization as well as immunotherapy, provided the liver function is good. So they say that immunotherapy and radioembolization is better than radioembolization alone. So again, what are the basics of radioembolization? So here what we do is an intra-arterial injection of the microspheres. So these are yttrium-90 is the radioisotope which causes the radiotherapy. This is used. Again, there are so many things. There are two other drugs also which are used in radioembolization, like iodine-131 and rhenium-18. We are not using iodine-131 because that requires isolation, because the patient starts to emit radiation. So the patient has to be isolated for 5 days and all like that. So here we prefer yttrium-90, and rhenium we don't have much experience. And these radioisotopes are mixed with microspheres, like either a glass-made theraspheres or a sursphere. These are the microspheres which are mixed with yttrium-90, and millions of those microspheres are injected from the tumor feeding artery. So concept is same: enter into the tumor feeding artery and inject these drugs. But in TARE, one thing which I would say is we usually do it in 2 stages. That is, one is the macro aggregated albumin angiography, and then we actually inject the Y90. So why we do this angiography in the stage 1? In stage 1, what we do is an albumin, technetium labeled albumin is injected from the tumor feeding artery, which behaves very similar to the Y90 microspheres. The particles behave very similar, but it doesn't have any radioisotope. With this, we can calculate 3 things. One is the Lungshan fraction, one is the tumor to normal liver uptake, and based on this, we usually select and decide whether we should proceed for Y90 injection or not. Usually the Lungshan fraction is 20% is the cutoff criteria, and tumor normal liver uptake should be more than 4:1. That is, more of the drug which we give should go to the tumor, and it should not go into the normal liver parenchyma. So this is just one case which I am showing here. So this is actually, you can see the diffusion restriction, and you can see the portal vein tumor involvement up to the right portal vein is involved, and this is an ill-defined lesion in the right lobe of the liver, and the tumor thrombus is extending into the segment up to the right portal vein. So we consider this as a VP3 tumor thrombus. So here you go and inject the Y90 microsphere. So we calculated, and Lungshan fraction was less than 20%. In fact, it's around 9%. So, and then you inject Y90. You can see the Y90 is effectively distributed along the tumor and the portal vein tumor thrombus. And this was the resolution of the tumor thrombus post-TARE. So from the BCLC-C, he became a BCLC A stage. So this patient, this is called as a stage migration, and this patient underwent transplant and he's still doing well. So this is the effectiveness of the TARE, and the usefulness of the TARE is from a patient who is from BCLC-C, he underwent a curative intent after some time. After a month, he underwent transplant after this CT. So this is the radioembolization. So to summarize, these are the 4 broad therapies of loco-regional therapies which we can offer in HCC. Any doubts? Is there? How much time is there for next for?
You are okay with this? You want to ask anything about
anything
HCC?
in loco-regional therapy?
We will move on to the next.
Okay, I will sure. I will.
You want to ask any questions? Any doubts? Clarifications? Yeah, please come.
Yeah,
come to the mic. Come.
Yeah, that was a good question. So usually up to 7 centimeter lesions we can tackle with a single session of TACE. If it is more than 7 centimeter, again what happens is a larger tumor we cannot keep injecting lipiodol, because lipiodol, another one thing which anyone can know is the limit of lipiodol in a single session is 12 cc. What happens if we give more lipiodol? Usually it can go into the pulmonary circulation and cause some either a brain stroke or a pulmonary embolism. So we usually limit to 12 cc of lipiodol. And that's why if there is any remaining feeding artery which is there, you do a second session within the next 3 weeks. So we can do up to 3 sessions. We have done for a large lesion up to 3 sessions of TACE as well. So like 2 sessions gap is around 3 weeks.
After HCC intervention, we'll go to some diagnostics. Dr. Tarni is our radiologist. So she will talk about rectum first, pancreas, and then rectum, imaging in pancreas and rectum. Be a little more interactive, watch, learn. This is for you for exams. Almost everybody will get 1 or 2 CTs.
Good evening. So I have 30 minutes for CA pancreas and CA rectum. So I will have to run through, but I'm going to cover very limited portion of CA rectum and basics of CA pancreas. So the next 8 to 10 minutes for CA pancreas. So what baseline imaging we need is pancreatic protocol CT, mandatory. There's no shortcuts. What it means is that we do a plain CT, and following plain CT we give IV contrast, and at 40 to 50 seconds after giving IV contrast we acquire the axial CT sections and then reconstruct in coronal or whichever plane we want to look the lesion at. And following this pancreatic phase is mandatory, because in this phase, as you can see in the top image, the normal pancreatic parenchyma is enhancing very well, while this lesion, which is hypo-enhancing, is standing out in the background of a well-enhancing parenchyma. As opposed to the lower image, where this venous phase, you can't see the lesion separately from the tumor, from the background parenchyma. So imagine if this lesion was only 1 centimeter or less than 1 centimeter, maybe even 2, and is completely intraparenchymal, and you do only venous phase, you 100% miss this lesion. So for that reason, when a suspected CA pancreas case is there, you must order for a CA pancreatic protocol. And a venous phase can be done so that the veins are evaluated better, and also we look for liver lesions better in the venous phase. Now this is an example of a case with chronic calcific pancreatitis. We see that there are calcifications in the pancreatic head, there's ductal dilatation, there's also a small cystic area which could have been because of the prior pancreatitis or maybe tumor, we do not know what it is. In this particular image, you could argue that it could be a dilated CBD proximal to this also. But we are not seeing a clear-cut lesion. We can see that the duct is getting cut off here, while there is some pancreatic calcifications here, but we can't see a clear lesion on this CT. So we did an MRI in this case. As you can see, on T1 weighted MRI, we see that the normal parenchyma, this bit here, this area is the normal parenchyma, the one with the red asterisk, which looks bright on T1 weighted MRI. While this hypo-intense solid looking area, that is the tumor, and this is also a tumor associated cyst. So sometimes when MRI can be used as a problem solving tool, but it's not the mainstay imaging. And for some reason, if you cannot give iodinated contrast or CT is contraindicated, absolutely contraindicated, then you can do MRI, and please include T1 weighted MRI and post contrast imaging also. So this is the first example I've shown is a very easy case. You have a good chunky normal pancreas in the background and you saw a hypo-enhancing lesion. But in most chronic calcific pancreatitis cases, we don't have that. We don't have a well-enhancing background parenchyma. We have lot of calcifications. We have duct dilatation, side branch ectasia. All these complicate the recognition of a small pancreatic adenocarcinoma. So in this case, we see this is a CCP case, this dilated duct, there's almost no parenchyma outlining the duct. There are chunky calcifications in the head, little, maybe tiny bit of parenchyma outside the calculus-filled duct over there. And I can't see any soft tissue mass in this case. This patient came back for follow-up only after 2 years, and after 2 years we can see that there's a lot of soft tissue. Had we seen this CT as the first imaging, we can say that there's atrophic pancreas, we can say that there's some ductal dilatation, calcifications. This could potentially be even acute on chronic pancreatitis with fat stranding, right? But we saw in the previous CT there was no parenchyma to be inflamed, absolutely no parenchyma, and all this is new, additional new mass with enhancing biliary wall thickening causing biliary stricture. So having a background, previous comparative CT, especially in CCP or high risk cases, is extremely important. So if you do have that, please always send it to the radiologist. And if there are prior diffusely scattered calcifications, a new mass can disperse those calcifications. So if you see entire pancreas, like in tropical pancreatitis, entire pancreas filled with calcifications, and there's an area of soft tissue where there are relatively no calcifications or calcific free zone, then also you suspect a CA pancreas. So briefly about resectability, to simplify, I'll just go to one table also for want of time. So we call a CA pancreas resectable if there is no contact with artery. When I say artery, I mean celiac artery, SMA and common hepatic artery. GDA doesn't count. In CA head of pancreas cases, GDA doesn't count because it comes out in ripples. And for venous involvement, if the tumor is in contact with, not in contact or in contact with less than half the circumference of the vein, it can still be considered resectable, not borderline resectable, resectable, provided there is no contour irregularity of the vein or thrombus. So no contact with artery, less than half contact with vein, no thrombus and no contour irregularity. Borderline resectable is, first let's see the vein. If there's more than half circumference is involved in the vein, or there is a thrombus or irregularity. But the vein should be, you should be able to reconstruct the vein. So this is a kind of a gray zone, because what might be reconstructible for one surgeon or one institution may be slightly different from another institution. So you take it depending on where you are working, and if a reconstructible vein is involved, even if it's more than 180 degree, that is still considered borderline resectable. For artery, if arteries are in contact with the tumor by less than 180 degree, that is SMA or celiac artery or any variant artery, if they're in contact with less than 180 degree, then it's still considered borderline resectable. If it is, we're talking about common hepatic artery in CA head of pancreas, it can be completely encased, 360 degree encased, but as long as it's a resectable segment or reconstructible segment, it is still considered borderline resectable. What do I mean by reconstructible? Let us say a centimeter long segment of CHA is circumferentially engulfed, but there is distal short stump and there is also proximal short stump away from the celiac trunk bifurcation that is not involved. You can reconstruct. So it is still considered borderline resectable. Everything else goes into the unresectable category. So anyway, this we have covered. So most of these resectable, some of these resectable, and almost all of borderline resectable go for neoadjuvant therapy. Now what happens after neoadjuvant therapy? We do a repeat imaging to see how the patient's tumor is doing. So if the CA99 is stable or reduced, if the tumor is stable or reduced, and if the patient is doing better clinically, there is no overt signs on imaging to say progression, either metastatic or local, you discuss in an MDT and then patient goes for a resection. So very often, especially in CA head of pancreas, post-neoadjuvant therapy, the fine what we call as fat stranding increases around the vessels. The perivascular cuffing or perivascular soft tissue stranding increases. The subtle increase in previously involved area, but subtle increase in fat stranding doesn't count as progression. It just counts as post-neoadjuvant therapy effect. This is for borderline resectable and resectable cancers after neoadjuvant. And what about the previously unresectable cases? Those also go for neoadjuvant therapy, maybe with a palliative intent, maybe with a curative intent. The intent may change in a small subset of patients. So after unresectable cancers undergo neoadjuvant therapy, you may consider surgical resection only in highly specialized centers if there is significant reduction in tumor markers, if there is definite clinical improvement, and again no progression on imaging. But again, the patient should be counseled that we do not know if this is going to be curative, long-term curative benefit or not. Now, before all this, whether or not your radiologist knows, whether or not your radiologist reports, I think this is something you should all be aware of looking at every CT scan. Do not go by report. Surgeons should be able to read at least the basics of the CT scan. So this is a case where common hepatic artery is coming directly from the aorta. I've shown you reconstructed images just because it's easy to show in a single image. But all these anatomical details you need to be able to make out on the baseline axial or coronal sagittal CT scans. And this is an example where the right hepatic artery here is taking off from the SMA. superior mesenteric artery. In such cases, this right hepatic artery is usually retroportal in location. It takes a retroportal course before it reaches the hepatic hilum. Now, this may seem like it's unrelated. This is a patient with median arcuate ligament syndrome. There is no celiac trunk. Celiac trunk has become completely narrow. All these are aneurysmal dilatations from the collaterals which are coming up from SMA, and this is a median arcuate ligament syndrome. So all these may lead to profuse bleeding during surgery if you do not know that this finding is there beforehand. Now, this is not a well-known or a not, it's more of an under-reported entity. We've actually done a study where this was present in 2.5% of all CT scans. Just random CT scans with or without pancreatic pathology. But only 4% of those cases were reported, were even mentioned in the reports. Why? Not because we don't know, some of us don't know, but mostly because there are thousands of normal anatomical variations in all CT scans throughout the body, and a radiologist is not going to sit and report all of those every day because that's just a waste of time. But of course, if it's a pancreatic lesion or a periampullary pathology and potentially going for Whipple surgery, then yes, it should be reported. But please bear in mind that some of your radiologists may not be routinely doing this, so look for them yourselves. Last, this is a 3D reconstructed image of a small pancreatic lesion with respect to the arteries and veins. Now, this all looks very beautiful, very appealing, and it is easy for young surgeons to orient themselves to spatially where the tumor is with respect to arteries and veins. But I absolutely never look at it, because this is not what we rely on for resectability or anatomy. This is more for surgeon's eyes than for radiologist's eyes. Let me just put it that way. Okay, so I'll stop with the pancreas now. We'll move on to maybe time for 1 or 2 questions if you have. Okay. Okay, going on to CA rectum. I don't have the time. Okay. So you all know the T staging in CA rectum. T1 is when there is no involvement of muscularis. T2 is when there is involvement of muscularis propria. T3 is when there is tumor extending beyond muscularis propria into perirectal soft tissues, which is essentially the mesorectal fat. T4 is when the tumor extends either into the pelvic peritoneal reflection, which is T4A, or surrounding solid organs or pelvic floor musculature, which is T4B. Now, with that, we'll so there is one consensus panel meeting in 2021 which kind of mentioned, it's not yet incorporated into TNM staging, may never be, but it mentions that let us say we have a mesorectal fascia and there's a pelvic sidewall fat beyond it. There is no solid organ, there is no pelvic floor musculature, and the tumor may directly extend beyond this mesorectal fascia into the extra mesorectal fat, let's just say fat or soft tissues. That may also be considered as T4B, but it's not yet in the TNM staging. Now, this endorectal ultrasound, as you know, will be useful in differentiating the early rectal cancers as T1 versus T2, where US does much better than MRI. We often fail to recognize whether muscularis is involved, especially in polypoidal rectal tumors. And PET-CT may be used when you're looking for metastatic workup, but never for local disease staging. And mandatory sequence in CA rectum imaging is a high resolution 2-dimensional T2 weighted MRI. That's it. That's absolutely mandatory, nothing else. It's a high resolution imaging. We use a small field of view, only small part of the pelvis that we need to see is imaged, and it's a 2D sequence. We do not want 3D sequence. And this is done without fat suppression and without contrast. Diffusion is also useful, I'll come to that later, and additional sequences mainly to assess for coexisting pathologies in lymph nodes and rest of the pelvis. So when there is, first we acquire the sagittal images. As you can see, there's this tumor in the mid and upper rectum here. Now, once sagittal images are acquired, then we acquire the axial perpendicular to it. It's not true axial sequences that we acquire. Axials are always perpendicular. So if there's a very subtle tumor, the technologist may miss it or may not realize where the tumor is, and this axials may not be appropriately acquired, especially if it's not done during the daytime in the absence of a abdominal radiologist. So in those cases, there will be some recall of these patients. So axials are required perpendicular to it and coronal in the plane of this red line here. This is because only when the axials are acquired perpendicular, we can assess the true extramural spread of tumor. We have to measure the extramural spread, especially in T3 cases, to be able to tell whether it belongs to T3A, T3B, C, D. Okay. This is your mesorectal, the resection donut, and the yellow here kind of is what corresponds to what tissue you are going to remove in your total mesorectal excision. That incorporates the rectum, and depending on how low the rectal tumor is, the margin proximally and distally, the entire mesorectal fat, including the lower mesorectal cone, surrounding lymph nodes, and inferior mesenteric artery, where you ligate it off. So normally on a rectal MRI, normal rectum, these are the layers of rectal wall. So inner this bright layer is the submucosa, submucosa together, and this dark layer here is the T2 hypointens muscularis. Surrounding that is the mesorectal fat. Mesorectal fat can be of variable thickness depending on whether it's in the upper, mid, lower rectum, anterior or posterior, and to some extent based on the visceral fat of the patient. And this mesorectal fat is enveloped by this very thin line of fascia that is called the mesorectal fascia, that becomes your CRM. And outside that is the extra mesorectal soft tissues, pelvic side wall, lymph nodes, other pelvic organs. Again here demonstrating that this is the mesorectal fascia. So if you have lymph nodes within the mesorectal fascia, they are all within coming out in your surgery. But if there is a lymph node here, that is an internal iliac node that is outside, which you cannot remove and must be addressed by radiotherapy prior to surgery. And yeah, so this is an example to show you why we do not give any rectal gel prior to doing the MRI. So you see, you want to, when there is a tumor that is going into the mesorectum, you want to see how much it has gone beyond the rectal wall for again T3 substaging. And you also want to know from the outer edge of the tumor, what is the distance to CRM. Distance to CRM, you keep hearing this word, right? Because CRM involved or not is based on the distance to CRM. Now, in the same rectum, if I have distended it with rectal gel so that I can see the tumor better, what happens? This entire fat is just getting compressed. So, the distance to CRM may be artifactually reduced. It looks as if CRM is involved or threatened when maybe it is actually not. So rectal gel is not advocated routinely in patients for rectal cancer MRI. Now this is low, mid, high division. Low rectal cancers is anything from anal verge up to 5 centimeter. Now remember, your anal verge is not my anal verge. I meant the surgeons and the radiologists. So your anal verge is where you see the dentate line. The radiologist sees at the lower edge of the external anal sphincter. So there is going to be 2 to 3 centimeter discrepancy sometimes depending on length of anal canal in each patient. Now you need not follow this. Each institution may have their own ways of dividing into low, mid and upper rectum. That's fine as long as radiologist understands surgeon and the surgeon understands the radiologist. Now some more anatomical landmarks. This is the pelvic peritoneal reflection. So this is the uterus in this patient, that's the rectum. To show the peritoneum better, I had to take an image, one sagittal image off center. So this thin line here is the pelvic peritoneal reflection lining the pouch of Douglas. So now why is this important? Because below this level, this fat here is all the mesorectal fat. Above this level, this is the peritoneal fat. So when you are removing the circumferential resection margin is this here till here. Beyond that there is no mesorectal fascia. So if there is a tumor here, there is no concept of is mesorectal fascia involved or not. There is concept of peritoneum involved or not. So that's the reason it's important to identify whether this where the pelvic peritoneal reflection is. Now it's fairly easy to identify the anterior pelvic peritoneal reflection, but what happens is, look at this lateral image here. This is anterior, this is posterior. This shiny glistening area is outlined by the peritoneum. while this raw looking area is what was the mesorectal fascia or the mesorectal fat right now. So anteriorly the peritoneum dips lower down and it goes up covering the rectum obliquely. So as we trace on axial sections, as we trace from lower to mid to higher, more and more circumference of the rectum is covered by peritoneal reflection. So much so that the upper rectum may be completely covered by peritoneal reflection. Like I said again, the upper limits of this peritoneal reflection, especially laterally and posteriorly, are not easy to depict on MRI. So it is an understanding or a presumption based on how the anterior one is dipping and may be going up. So if there is a tumor involving this part of the rectum, there is no CRM is considered as not applicable. So when you see that, just understand that it's probably in the it's probably in the peritonealized segment of rectum. Now this is a lower rectal tumor. It's a polypoidal tumor, but there's definitely an extramural involvement here. Can you see the small component outside the wall where there's breach in the muscularis layer and it's extending out. Now, is it involving anal canal or is it confined to the lower rectum? So the anatomy, the level where we call it anorectal junction on MRI is the upper border of puborectalis. Upper border of puborectalis on coronal imaging is this, and this is the levator ani muscle. So anything that is confined to just above that is only lower rectum. And the distance from anorectal junction to the lowest portion of rectal wall involvement we usually mention as a mandatory thing. And if it is extending below this green line, it is considered as anal canal involved. Now, nowhere can MRI differentiate between squamous cell carcinomas and adenocarcinomas. So if there is a tumor involving anal canal and rectum, and we do not know the histology yet, we report it as presumed adenocarcinoma arising from the rectum involving anal canal. So the staging, let us say I call it T3BN0 disease of the lower rectum, later it comes out as squamous cell carcinoma, it's okay. You can mention in the chart that is presuming adenocarcinoma. So you can restage the disease after the histology. Now one more important thing to remember is, you probably know from your surgical specimens that the mesorectal fascia doesn't come all the way till anorectal junction. It stops short. It stops short and stops short by about a centimeter or so. I think I have a image somewhere, sorry, okay. Stop short by a centimeter. So, for example, in this case, the centimeter is somewhere at the level of tumor. So, mesorectal fascia is ending there. Here, the 1 centimeter below that is a bare area. It's a mesorectal bare area. So, below that level, at approximately that 1 centimeter height level, if tumor is going beyond the rectal wall, it is considered as involving the resection margin. CRM is not equal to mesorectal fascia there, but it is involving resection margin or it is considered as the superior extension of the intersphincteric plane. So this danger triangle, or we also call it the danger triangle, when it is involved, you know that the intersphincteric plane is involved, so you may not be able to do a routine APE, you will have to do probably a ELAP. Okay, so one example why I told you that between T1 and T2 tumors, it's very difficult to differentiate, especially in polypoidal tumors, where I do not know if the inner fibers of muscularis are involved or not. So I may call it T1, I may call it T2, depending on whether I feel it's getting tugged or partial thickness are involved, but EUS is always needed. Now this is an example of a T3, very obvious T3 lesion. This is the signal intensity of most of the rectal tumors, somewhat similar to that of muscularis, slightly higher maybe, and there is a definite extension of tumor contiguously outside into the mesorectal fat. Now depending on how much it is extended beyond the expected location, for example on an axial plane, this here would be the expected level of outer border of muscularis. So from here till here I measure the distance. If it is less than 1 mm, it's considered T3A, 1 to 5 T3B, 5 to 15 is T3C, and more than 15 is T3D. For example, here, this is a T3A tumor. This tumor here is very hyperintense on T2. So, hyperintense tumors on T2 mean either signet ring cell carcinomas or mucinous carcinomas. So, mind you, not all mucinous carcinomas are T2 very bright. Not all signet ring cell carcinomas are T2 very bright. But if this finding is there, it's either of those, either mucinous or signet ring cell carcinoma, which anyway have poor prognosis and poor response to radiotherapy. Now, if this tumor, this is a T3B tumor where it's extending just a few millimeter beyond the expected outer border of muscularis. Can you see that this dark, slightly dark contour is interrupted from here to here? So that's where the advancing edge of the tumor. Now, when I have to measure the distance to CRM, I have to measure from the outermost advancing edge of the tumor till the mesorectal fascia. So, red is not the distance to CRM, red is the extramural spread, while the other distance would be the distance to CRM. Now, between T2 and early T3, there are some diagnostic challenges. So, you see this is a tumor here, nearly circumferential. There is some fuzziness or fat stranding out around the tumor between maybe 3 and 7 o'clock position, but it's not exactly of the tumor signal intensity. So sometimes it's very difficult to make out, is this just peri-tumoral reaction of fats, just edema, or it's true invasion. So in such cases, the report may be T2/early T3. The early T3 can be, technically if this is tumor, it can be T3A or T3B. So early T3, when I say, it can be T3A or T3B. So it's given as T2 or early T3. As long as these tumors are in the mid or upper rectum, it doesn't really change much in terms of management. But in lower rectal tumors, it becomes a bit of a problem. Now these are examples of very locally advanced cancers, where here this upper rectal tumor is involving the peritoneal reflection, definitely infiltrating peritoneum, and so it is T4A. And this mid-rectal tumor is infiltrating the vaginal vault and cervix here, and this is T4B. Now, there is also something called extramural vascular invasion. So now when the tumor is extending from the rectal wall contiguously into the lumen of a mesorectal vein and distending the vein. So same signal intensity as of the tumor, contiguous extension from the tumor and distension of the tumor. These are the three criteria. And then that is called extramural vascular invasion positive. This is extremely important because it's an independent poor prognostic factor and has a high risk of either synchronous or metachronous tumor metastasis. Again, so this is the distance to CRM concept. When it's 1 to 2 mm, it's considered as threatened. And when the distance on MRI is more than 1 millimeter, it's a very reliable predictor for surgical negative margins. So this is yellow line here is the distance to CRM, and red is the extramural spread. So we have this case here where it is involving the mesorectal fascia. It's touching the mesorectal fascia. This is considered CRM involved. How about here? The tumor is here. It's not touching the mesorectal fascia anywhere. But is CRM involved? Not involved. Involved, hands up. Maybe 7. Uninvolved? 0. Okay. So why involved? This lymph node is touching. Is this a positive lymph node or just reactive lymph node? It's large, so it's involved. Round, large. Okay. More than round, large, the most important finding in this case is very bright. Normal lymph nodes are not very bright. This is bright, even brighter than the tumor. So it is mucin containing lymph node. Normal lymph nodes don't contain mucin. So this is a definitely involved lymph node. But although the main tumor, primary tumor is not involving CRM, the definitely positive lymph node is involving CRM. But please remember this. Now, when a lymph node is involving CRM, you must remember to look for whether that involving lymph node has very irregular margins, which means there's extranodal spread starting to happen. If it has irregular margins, or it's a tumor deposit again which has irregular margins, then it is much more likely that pathologically CRM is involved than when you have a smoothly marginated lymph node touching the CRM. Again, this is conceptual. In a report, I cannot give paragraphs for each finding. So most of the time this will not be mentioned. It will be as T2 hyperintense positive looking lymph node or suspicious looking lymph node involving CRM. So either way, this patient would go for a neoadjuvant therapy, so that's not an issue, but try to understand the concepts of it. Now, till now, I think we have kind of, okay, so this is another example. Is the CRM involved, not involved? Again, involved, raise your hands, please. 1 or 2. Not involved? one or two, most people don't know. The reason CRM is not involved in this case is because it's an upper rectal tumor and the extramural component is outside, probably above the level of mesorectal fascia, where mesorectal fascia ends and peritoneum begins. So no mesorectal fascia involvement, but probably peritoneal infiltration. That's a trick question, sorry about that. Okay, we'll go move on. So nodal staging is more difficult. Till now everything is kind of black and white or grey, but from nodal staging it's a little difficult on MRI. Why? Because we count the number of suspicious lymph nodes. N1 is up to 3 lymph nodes. N2 is 4 or more. But what are these lymph nodes? Normally also there are lymph nodes, right? And every enlarged lymph node is not positive. Maybe more so in CA rectum, because when there is ulceration and there's fecal matter filled with bacteria, there will be some amount of inflammatory lymphadenopathy even around the tumor, which may even have PET uptake. So every PET uptake lymph node, every slightly enlarged lymph node is not positive. But there is no way to prove or disprove until there's a surgical specimen. So there are some morphological criteria that we've come up with to call them suspicious or not. So depending on these are the criteria. When there's either irregular margins or indistinct margins, or within the lymph node itself there's heterogeneous signal intensity, or like the mucin containing tumor lymph node that we saw earlier, or rounded. So how many of these criteria should the lymph node fulfill depends on the size of the lymph node. So if a lymph node is either more than 8 mm, it is always considered as suspicious. Or if lymph node has mucin, it is always considered suspicious. But if lymph node is between 5 to 8 mm, we need that lymph node to fulfill 2 malignant characteristics, 2 of these at least. So each of these lymph nodes we need to see in all 3 planes, cross-refer all 3 planes. So on films, it's impractical or impossible. You need to see it on a system where you cross-refer and look at each lymph node and assess all these criteria. If it's less than 5 mm, it need to fulfill all 3 malignant characteristics. As you can imagine, in a small less than 5 mm lymph node, it's almost very difficult to see all these features. So that is when we count those lymph nodes under these. Otherwise, we do not count those lymph nodes. So if you have a report where it says multiple small lymph nodes seen in the mesorectum N2, just take it with a pinch of salt. Now, I mentioned earlier when we were talking about sequences, the diffusion weighted imaging is also one of the mandatory sequences other than the T2. Why? Because diffusion weighted imaging, without going into in-depth, it just tells us that there is viable tumor or cellular area. Okay, so this tumor here is bright on DWI, and this is like an inverted map of the DWI, and it should be dark on ADC. When it's bright on DWI, dark on ADC, we call it diffusion restriction. So if your radiologist is calling it diffusion restriction, he or she would have looked at these 2 images. So when we need this sequence on the baseline MRI, why? Because post-neoadjuvant treatment, other than the T2 weighted MRI, we also look at DWI to assess for residual viable tumor. So hence we need to know baseline what degree of restriction it is having, whether the entire tumor is restricting or not. Some mucinous tumors don't, most mucinous tumors actually don't. So we need to have a baseline for comparison. Now I kind of have decided not to go into neoadjuvant because there's no time. So this is the protocol of reporting that we have. In a very systematic or a point-wise manner we do describe. At the end of the report, again, we tell whether tumor is circumferential, hemicircumferential, low, mid-rectum, distance from anorectal junction, CRM involved or not, EMVA involved or not, and if there's any infiltration of the adjacent viscera, any lymph nodes, whether they fulfill any suspicious or size criteria, and other, of course, MRI stage, assuming it is adenocarcinoma, and any coexisting findings. Thank you.
Thank you. Yeah, please. Take the mic.
Ma'am, if we have a less than 5 mm lymph node, then all the 3 criteria are irregular, borders and round. So how our lymph node irregular also and round also?
Irregular or fuzzy margins, round and heterogeneous signal intensity. It can still be round and have fuzzy margins. Round doesn't mean margin, round means shape.
Two questions, ma'am. How would you distinguish between a post-neoadjuvant mucinous change in the lymph nodes?
That's a question for I would expect from a radiologist, but yes, please.
Second question is, according to you, what is the role of contrast? Because no guidelines mention current role. When would you prefer to use a contrast and when would you not?
Okay, clearly he's coming from a center where they do a lot of CA rectums, because these are the two common diagnostic difficulties. So mucinous tumors, I've shown one of the mucinous tumors are very bright on T2 most of the time, but they also do have interspersed areas of intimate gray areas amidst the white. Now post-neoadjuvant, when a cellular mucinous tumor becomes acellular mucin, it's just mucin pools, no cells. So that becomes purely white, but it's very easily said than recognized. So different tumors, baseline may be completely white, in which case there is no way to differentiate acellular from cellular mucin, and we always will end up giving tumor regression grade 4, tumor regression grade 5, and pathologically it is TRG1. So mucinous tumors, it is a challenge, I would say at least 70 to 80% of the time. And there is no better way to assess. There is also a Choi criteria to assess, but those are also relying on the signal differential signal intensity of hyper versus gray areas. So that also has the same limitation. Your second question about contrast. So baseline imaging, contrast is not indicated. So there are some centers, especially overseas, where they do perfusion imaging to assess the perfusion parameters pre-treatment. But as of now, guidelines, there is no role for routine contrast at loco-regional staging. Post-neoadjuvant chemoradiotherapy, there are a few papers which say that it could potentially tell us whether about the tumor biology. In such case, if that is the way to go about, then we'll need a pre-treatment perfusion imaging also to compare it with post-treatment. So it is still under research. I would not advocate it routinely. However, I find it helpful when there are coexisting fistulas, background Crohn's or IBD. These are the scenarios where I find it extremely helpful to differentiate the margins of tumor from and margins of fistula. Fibrosis looks very dark. So we saw the muscularis layer and the tumor, right? So if I have to scale the grayness, submucosa is bright. Next is the tumor signal intensity, somewhat bright. Next is the normal muscle, slightly darker. Fibrosis is dark, very dark. Then comes the hair and bone. So not as black as our hair, but somewhat. Fibrosis is dark, so it doesn't have the baseline tumor signal intensity. Always comparison with baseline helps. And sometimes even within fibrosis, you may have tiny dots of brightness on T2 itself. Then that is considered as tumor regression grade 3. That means there is still some visible but small macroscopic tumor. If T2 doesn't help, diffusion will help. Diffusion may pick up the bright spots, in which case it is still tumor regression grade 3. I'm sorry, I didn't cover the post-neoadjuvant. Sorry, can you repeat that? Can't be differentiated, okay? No. So, mucinous tumors do not typically show diffusion restriction. They're bright on DWI, they're bright on ADC. So that doesn't help either. If they happen to show some degree of diffusion restriction baseline, then yes.
Then we can compare.
Then we still can't conclude, because the entire tumor may not show diffusion restriction. They may still be viable tumor without diffusion restriction.
Can we use contrast, and will there be difference in
No, contrast doesn't help either, because they'll all be hypoenhancing lesions. Both cellular mucin and acellular mucin will be very hypoenhancing. So as of now, there's no great way. We end up doing PET and MRI post-treatment. So together, we kind of give an estimate, but nowhere close to the accuracy that we would want.
And the criteria for node, is it same for mesorectal as well as pelvic nodes?
Criteria for?
Nodal involvement, involved nodes.
Huh?
Is it same? It's same for both mesorectal and pelvic nodes, or is it?
Oh, no. Lateral pelvic lymph nodes. Oh, sorry. I didn't cover that either. Lateral pelvic lymph nodes have different size cutoffs. 7 mm for internal iliac nodes. And the size criteria only apply to lateral pelvic lymph nodes. No morphologic criteria. The exception being if the mucin containing tumors. Having said that, if I find a grossly irregular lymph node in the internal iliac group, although on paper morphologic criteria do not apply, why should there be a very, very irregular lymph node in the internal iliac group? Not physiologically. So I do mention that. And those are counted for your N1, when you're counting up to 3 or more than 3, the loco-regional lymph nodes are counted.
Any more questions? Okay.
Thank you.
Thank you, Tarni. Trying to make sense of a very difficult topic in a short time. Thank Vivek for that wonderful intervention. They will be around. If you have any questions, you can ask. Otherwise, we'll close this. We can all proceed to have your dinner. Tomorrow morning, make sure you get up early. Get ready, have your breakfast, check out, and come here by 8:15 positively.
I took the pen. Thank you.